Hello, welcome friends. Welcome to the grand test discussion of the grand test 2.0 of FMGE, which was held today. I'm sure you must have aced it, rocked it, and I'm sure you will rock it after 4 weeks also, जबकि तुम्हारा major exam है, right? So let us start with the first subject, and that is my subject, and that is pediatrics. All the questions of pediatrics were very easy, I'm sure, and everybody must have enjoyed doing the questions as they were super duper easy. So चलो फटाफट discussion शुरू करते हैं. So the first question was, So the first question which was there was, just a minute, some glitch over here. A 13-year-old boy was evaluated for short stature with normal height of parents. Just a minute, do it again, discard, just do it again. Okay, so the first question was, a 13-year-old boy was evaluated for short stature with normal height of parents. After reviewing his past records, his birth weight and birth length was found to be appropriate. However, his skeletal maturation and timing of puberty was delayed. What would be the probable diagnosis and growth velocity as per the above scenario? Okay, so the options given were constitutional growth delay with decreased growth velocity, familial short stature with decreased growth velocity, constitutional growth delay with normal growth velocity, or familial short stature with normal growth velocity, right? So these were the options given. Now first let us see what was the diagnosis we made on this kind of history when we get. So the most important thing what we had to see was that his skeletal maturation and the timing of puberty was delayed. What does this convey? This conveys to us that the bone age is less than the chronological age. So bone age is delayed and the puberty is also delayed. So basically we have to make our choices between two diagnoses as per the given choices. Either it is familial short stature or constitutional growth delay, and we all know that in familial short stature, bone age, we know this, bone age is equal to height, is equal to height age is equal to chronological age, right? So height age, not, so we'll write it again, bone age was, just a minute. So in familial short stature, what we see is that the bone age is decreased as compared to, is equal to chronological age. So this is what we know, and in constitutional growth delay, bone age is decreased as compared to chronological age. So because of this, as given in the question that the bone age is delayed, definitely the choices containing familial short stature and this is definitely out. So our diagnosis is basically constitutional growth delay. Now what about the growth velocity? You should know that the growth velocity is normal both in constitutional short stature and in constitutional growth delay and in familial short stature. In both these conditions, the growth velocity is normal. So the correct option over here would be constitutional growth delay with normal growth velocity. Sometimes you might be asked by giving these charts. So they will give you any of these charts and they will ask you that what is the diagnosis. So the same concept has to be carried forward over here also. So here on the charts, if you see, for a given age, the bone age is definitely delayed as compared to the chronological age. You can see it on the charts that the bone age is delayed as compared to chronological age. So definitely this chart is of constitutional growth delay, and here the bone age, the triangle is representing the bone age, very nicely given over here. So here the triangle is coinciding with the chronological age. The target which is marked, target like lesions marked over here, is the chronological age, right? Yes. So since here bone age, in this chart bone age is equal to chronological age, so we know we are talking about familial short stature over here. So by means of charts also you can make a diagnosis. What other differences do you see on the charts, or where you have to pay attention is over here. If you see here in constitution growth delay, ultimately the child is going to attain his normal stature because he is going to cross the centiles later on and attain his normal height. But in familial short stature, he would continue to remain below the third centile, will all reach his genetic potential, because anyways his genetic potential is low because of the short stature of the parents. So he would never cross the centile. So this is again another very important differentiating feature between familial short stature and constitutional growth delay. Yes, so very good. Everybody has answered it correctly. Good. So Anil Chaudhary, yes, you've given the correct answer. And at least I am trying. There is somebody called at least I am trying. Yes, that person has also given the correct answer. Karishma Chaudhary, yes, you are correct. So this is how you differentiate on the basis of charts also that I was trying to tell you. Okay, so let us move on to the next question. A mother brought her child to pediatrics OPD for developmental assessment. As soon as they reach the OPD, the pediatrician sees the child to be doing the activity shown in the picture below. What is the appropriate age at which this milestone is achieved? So the options given were 3 months, and then 6 months, and then 8 months, and then 9 months, right? So what is shown in the picture? Can anybody tell me? Waiting for your answers. Anybody? Yes, so somebody has answered correctly. This is nothing but mirror play. क्या हो रहा है यहाँ पे? Mirror play हो रहा है. The child is enjoying his image in the mirror, and this comes by 6 months of age. Of course, a 7-month, 8-month-old child will also do the similar things, but 6 months of age में सबसे पहले mirror play देखा जाता है. The child enjoys his mirror image. That is what is referred to as mirror play. So the correct answer over here, yes. Dr. Lala Prakash has given correctly. Anil Chaudhary, very good. At least I am trying. Everybody has given the correct answer. Yes, the answer is 6 months of age, right? So the answer is, just a minute, yes. So 6 months of age was the answer. What else the child does at 6 months of age? I thought of, just augmenting your knowledge or making you remember tidbits like these. So at 6 months of age, what you see over here is stranger anxiety. So this is the father of the child, and somebody is trying to take the baby away from the father. So this, see the, the face, what is very evident from his facial expression that he is not very happy. So stranger anxiety is one thing that we see at 6 months of age. What else do we see is, yes, if the child is kept in the prone position, then the child supports himself on extended forearm. So this is also a 6-month-old baby. Yes. Then this is the child, taking everything to his mouth, takes the biscuit to his mouth, takes the toys to his mouth. So the mouthing occurs at this age, and this occurs because, this is the time when the tooth eruption would start, and because there is intense itching in the gums, so the child has this kind of behavior. So this is also seen at 6 months. What else is seen at the 6 months is the characteristic grasp. If you can see, this is the palmar grasp or the ulnar grasp, whatever you want to call it, palmar or the ulnar grasp. So this is also classically seen at 6 months. This is how the grasp development begins. And then we have next is the mother, the child enjoys the company of the parents. So he is playful with the father, he is playful with the mother. So this is seen at 6 months. If you see at the language development, yes, the monosyllables would start beginning, he would start speaking monosyllables like ba, da, ka, anything like this by 6 months of age. So this is all what is seen at 6 months, which you need to remember. Of course, there is a whole lot of development to be remembered, but this is the way we will remember, by remembering small things at one go, right? Yes, so everybody's answered correctly. I am very happy. At least my subject, you people are very good at. I am very happy with that. Okay, so let us move at the next question. A role play was organized in a school demonstrating the benefits of breastfeeding as a part of co-curricular activities during the World Breastfeeding Week week. Which of the following statements regarding breastfeeding are true? So first of all, I hope everybody knows World Breastfeeding Week is celebrated between 1st to 7th August, and every time there's one theme or the other, and you know, for the past few years, it has been, the World Breastfeeding Week has been aligned with the Sustainable Developmental Goals because of the, you know, in a bid to promote good health among the growing children. So this is what something you should know about the World Breastfeeding Week. Anyways, let us see the options. So infants who are breastfed have a higher IQ than infants who received other types of milk. I guess this is correct. Then breastfeeding should be initiated in a perfectly healthy child with no anatomical problems within 4 hours of birth. No, this should be within 1 hour or as soon as possible. Both the options are correct. So this is not a correct option. Then breast milk contains lactose, which aids in calcium absorption and promotes the growth of lactobacilli, a healthy bacteria in the colon. Yes, very true. Then the protein content of the breast milk is high as compared to animal milk. Of course, this is a wrong statement. So I think we have got two statements wrong over here, second and fourth. Let us see more. Exclusive breastfeeding should be continued for 6 months. Of course, this is the norm. And since 88% of breast milk is water, a breastfed infant does not need any additional water even during the first few months of life and even in the summers. So this is also a correct statement. So barring statement, I think 2 and 4, rest all were correct. So let us see what are the options given, and we had to choose the correct statement. So the correct statements would be, yes, option number D, that is 1, 3, 5 and 6. Yes, so these were the correct options. So 1, 3, 5, 6 are the correct options. Rest, the second and the fourth options were wrong. So let us see what were those options and why were they wrong. As you know, the protein content of breast milk is very low. It is 1.1 gram per 100 ml. This is the low protein content, and this is lowest among the cow's milk, human milk and the buffalo milk. If you see the protein content of the cow's milk protein content is around 3.2 gram per 100 ml, and for buffalo it is even more, that is around 4.3 gram per 100 ml. And see, this is the beauty of the nature, that the low protein content of the breast milk, remember it that way, the low protein content is because the nature does not want additional solute load on the immature kidneys of the neonate. So that is why the protein content is less. However, the carbohydrate content is very much high. It is around 7.4 gram per 100 ml, and that is what is important for the growth and for the ensuring the satiety of the child, right? So therefore the protein content of the breast milk is high is a wrong statement. Yes, right. Okay, then breastfeeding should be initiated as soon as possible. So that was an incorrect statement. Then infants who are breastfed have higher IQ. That is a very much correct statement, because you should know the breast milk contains omega-3 and omega-6 fatty acids, which are absolutely essential for the development of the brain, for laying down the neural network. So that is why they are supposed to be having higher IQ later on also. And of course, the breast milk contains 80 to 88% of water, so nothing else is needed. Exclusive breastfeeding means only the supplements if required, namely vitamin D if we are talking about a term infant, or maybe iron supplement if we are talking about a preterm infant. So these are the two supplements which we usually give along with breastfeeding, and this would be still considered as exclusive breastfeeding, and water is not to be given, right? So this is one slide, you should know this is the comparative study of, everybody must be having this, human milk, cow's milk and buffalo milk. What is important, as I was telling you, the protein content, of course the carbohydrate content is very high, and very importantly, which I wanted to highlight over here, and you have to remember because it's very important from your MCQ point of view, is the vitamin C content. Amazingly, the vitamin C content of human milk is very high, while children who are kept on cow's milk or buffalo's milk, obviously whenever we take animal milk, that is boiled, and boiling destroys the vitamin C content. Already the vitamin C content is very low, and above that, if we do boiling of the milk, the vitamin C is destroyed. So therefore vitamin C is is not deficient in human milk, but of course it will be deficient if the child is kept on boiled cow's milk or buffalo's milk. Very true. Dopamine has given the answer over here that vitamin D and K are the two important vitamins that are deficient in breast milk. And how do we make up for it? Vitamin K routinely is given as an IM injection to every child who is born, and we start vitamin D supplementation right after the birth, and the supplementation continues till good amount, good period of time. Not only the first year, we continue it beyond the first year also. And the supplementation of vitamin D, the dose is around 400 IU per day, 400 international units per day, which is increased to 600 IU beyond first year of life, right? So this is it. Yes, so very nice. Everybody has given the true statement, and Dr. N. Kumar has written proper true, false, true, true, false. Very good. I am very happy with the response I am getting. Okay, so let us move forward with the next question of pediatrics. A survey was conducted among various low socioeconomic areas across the country to determine the children who are suffering from protein energy malnutrition. During the survey, a child with the features depicted in the figure was seen. Which of the following statement is false about the following child? So you can see there's a picture given, and somebody will tell me the diagnosis. Just looking at the picture, we know what is the diagnosis. But let us first see the options. So options were: the main sign of the above disease is severe wasting. There is presence of characteristic monkey faces and baggy pants appearance. The child needs adequate amount of proteins and calories. Affected children with this disease, what we have made the diagnosis looking at the picture, is apathetic and irritable and has a poor appetite. Very true. So Dr. Lala Prakash, Doc, dopamine, yes, they are giving me the correct answer. The picture tells us that this child is suffering from marasmus. Very, very true, right? So what are the features which are not of marasmus? Because that is what is asked over here, that which is the false statement of the following, right? So of this, yes, the main sign of the above disease, severe wasting, is there, and it is characterized by absence of edema. Edema, if present, would be seen in kwashiorkor. We all know this, right? And why is monkey faces seen, or a old man appearance of the faces? Because of the loss of buccal pad of fat. And baggy pants appearance is because of the loss of gluteal pad of fat. So why baggy pants? Because there will be loose folds of the skin in the buttock region, and that would be seen when there is loss of the gluteal pad of fat over there, right? And this is very akin to somebody wearing a baggy pant. Everybody knows baggy pants has a loose kind of fit. And the child needs adequate amount of both proteins and calories. Yes, very true. But the false statement over here is the D option. Very true. Everybody is answering it correctly. Dr. Lala Prakash, Dr. Anil Chaudhary, dopamine, Dr. N. Kumar, they have written the correct answer. Yes, the correct answer is D. Why? Because the children of marasmus, the only saving grace in these children is the presence of voracious appetite. Yes, that is why the recovery is faster in children suffering from marasmus as compared to children suffering from kwashiorkor. The problem in kwashiorkor is, yes, they are apathetic, they are irritable, and they have poor appetite. And because of that, rehabilitation measures are very slow in case of kwashiorkor. But in case of marasmus, they have a voracious appetite, we know this, and they are alert. And that is why if you institute rehabilitative measures correctly and slowly as it is recommended, then they come back very nicely. The prognosis is excellent, right? So that is it. The C is not false, Dr. N. Kumar, because these children need good amount of proteins also. It is not that they are replete with proteins. Please remember this. So they need calories as well as proteins. Please remember this. So this was deliberately good. You have pointed out C statement is not false in case of marasmus. They require both proteins and calories. Similarly, in case of kwashiorkor, it is said that the protein deficiency is more than calorie deficiency, but when we rehabilitate the child of kwashiorkor, then we would give protein as well as calories. There you would not say the child would be given only proteins because he is having edema. So please don't carry a wrong message from here. The child would be requiring both protein and calories, right? Okay. Do we supplement? Yes, Dr. Swayam is asking, do we supplement protein as well? Of course, we have to supplement proteins also. If you don't supplement proteins in this child and just give calories, this child will go on to a state of kwashiorkor. Please remember that. So, both proteins and calories have to be supplemented. Anyways, thus loss of fat and the calorie deficiency is definitely more in case of marasmus, and the protein deficiency is more in case of kwashiorkor, but overall both proteins and calories are deficient in both the cases. Please remember that. Right? Yes, Anil Chaudhary is saying loss of muscle mass. Of course, that is because that indicates that the child is protein deficient. Very true. Okay, then let us move on to the next this thing. Yes, dopamine, you are right. They ask, so some favorite topics are always there. PEM would always come, immunization would always come, growth and development would always come. So these are the favorite topics, and you should brush them up very thoroughly before attempting or going for your last exam, right? Okay, then a 5-year-old boy is brought to pediatrics OPD with chief complaints of restlessness and irritability due to ongoing episodes of loose motions. On examinations, he had sunken eyes with dry mouth and tongue, skin pinch goes back slowly, and child was extremely thirsty. How would you classify the dehydration, and what would be the appropriate management of the same? So options: some dehydration, provide oral rehydration solution; some dehydration, admit and provide IV normal saline; some dehydration, admit and provide IV ringer lactate; no dehydration, reassure and send back home. Okay, so how do we assess the hydration status of a child? This child has come to us with diarrhea, loose stools. We know he must or he might or might not be having dehydration. So how do we assess? So first of all, we have to see the general condition. If the child is restless, irritable, he falls in some dehydration. If he is obtunded, if he is comatose, obtunded, not in his true self, then he falls in severe dehydration. And if he is normally, behaving, then he comes in no dehydration. Then what about the eyes? Of course, the sunken eyes, they can be an indication of moderate to severe dehydration. That means some and severe dehydration. There is no word as moderate in dehydration. Either we have no dehydration, or we have some dehydration, or we have severe dehydration. So sunken eyes would come both in some and severe dehydration. Then we have to see the dry tongue and the mouth, the condition of the mouth and the tongue. Of course, the dryness would tell you that comes in some or severe dehydration. Then skin pinch, if going extremely slowly, that would come in severe dehydration. If the normal skin pinch is there, then no dehydration, and slowly then would come in some dehydration. And finally, if you ask me which is one most important parameter which will help you decide the management of this child, is the thirst. If the child is thirsty and drinking fluids, then this comes in some dehydration. If the child is not accepting fluids and has weak pulses, would be coming in severe dehydration. And if the child is drinking normally, then would come in no dehydration. So thirst is very, very important. Most of your questions would be solved by looking at this: extremely thirsty and the general condition of the child. If general condition of the child obtunded, then please go for severe dehydration. But in this case, looking at the collection of the signs and symptoms, the child is most likely comes in the category of some dehydration. And we know there is a plan A, plan B and plan C. We all know this. In plan A, what do we do? Plan A is just again ORS and home management. And then plan B, we have to give ORS at the rate of 75 ml per kg per day. And then plan C, we have to start the child on IV fluids. The preferred IV fluid is RL with 5% dextrose. That is the preferred IV fluid over here, right? If it is not available, then simple RL or NS can also be given, right? So this is how, and here the rate would be 100 ml per kg per day. So we know this plan A, plan B, plan C, and since the child in the question comes in the category of some dehydration, so we will go with the ORS. Along with the ORS, we also have to give the maintenance IV fluids, that is the daily requirement also. So daily requirements we all know to calculate by the Holiday Cigar formula. Everybody knows that formula, that for 10 kg, less than 10 kg, we give it is to be divided. How do we give? In less than 10 kg, it is 100 ml per kg. Then 10 to 20, we give 50 ml per kg, and then more than 20 we give 20 ml per kg. So, by this we calculate the daily requirement, and this all has to be given to the child, but orally. Very important is orally. We resort to IV plan only in plan C, and the plan C would be instituted when the child lands up with severe dehydration. We know this, right? Yes. So, very important. Yes. Somebody, Dr. GMM is writing thirst ORS. Very good. If the child is thirsty, give ORS. That is very much logical. That is how you are going to remember. You will not start IV fluids in this child, which is the plan C. So, yes, the correct option is the option A. Everybody's answered correctly. Dr. GMM, Lala Prakash, Dr. Lala Prakash, Dr. Anil, Dr. Karishma, Dr. Swayam, very good. It is some dehydration. Provide oral rehydration solution because the child is thirsty, will be accepting, and usually this 75 ml per kg is given over a period of 4 hours, and usually at the end of 4 hours, if the dehydration is still there, then again we give orally only, and if the dehydration has corrected, then you just go with the maintenance IV fluids, and also very importantly supplement the ongoing stool losses. That is very important, you have to keep in mind. The ongoing stool losses have to be supplemented. Ongoing stool losses, right? They have to be supplemented at the rate of 5 to 10 ml per kg per stool. So, that has to be, otherwise the child will again land up with dehydration if you don't supplement the ongoing stool losses, right? Okay, so this is what was required of this question. Let us move to the next question. A child presents with complaints of recurrent episodes of lower respiratory tract infections and steatorrhea. He underwent lab investigations which revealed pancreatic insufficiency. Sweat chloride levels were found to be high, more than 60 milliequivalent per liter. Which of the following disease follow the same mode of inheritance as the disease which the child has? So, tell me, what are we looking at? Yes, so let us look at the first options: Noonan syndrome, Marfan syndrome, ataxia telangiectasia, or von Willebrand disease. So, we know when you have a combination of GI symptoms with respiratory symptoms, at least at your level, you can take one risk and go straight away for the diagnosis of, we all know, cystic fibrosis. So, we are dealing with the disease which is known by cystic fibrosis. We know here the mutation is on CFTR gene, that is cystic fibrosis transmembrane conductance regulator gene, and this is defective, because of which the secretions become very thick and tenacious. They obstruct the airways and they lead to recurrent lower respiratory tract infections, especially in the form of bronchiolitis and pneumonias, right? So, that is what is there as far as the respiratory tract symptoms go. Of course, in GIT the child would land up with pancreatitis and many other symptoms also, right? Now, what is asked over here is the mode of inheritance. We know cystic fibrosis has a autosomal recessive mode of inheritance. So, which other disease among the following four have autosomal recessive mode of inheritance? We all know it goes by the name of ataxia telangiectasia. The rest three disorders by default are autosomal dominant mode of inheritance. You have to remember Noonan, Marfan and von Willebrand disease have autosomal dominant mode of inheritance, while ataxia telangiectasia has autosomal recessive, very similar to your cystic fibrosis, right? So, of course, there are many mnemonics available to cram up the autosomal recessive and the autosomal dominant and the X-linked recessive disorders that you have to remember, because this is again one of the very favorite questions which keeps on repeating in your various exams, right? So, this is was what was asked from you. Okay, now let us move on to the next question. A workshop was organized in a medical college to demonstrate. Okay, before this, yes, everybody's answers it very clear, very correctly. So, we have Dr. Swayam, Dr. GMM, then Dr. Lala, Dr. Veera Kohli. Okay, so maybe Virat Kohli is answering over here. Dr. Mukesh Kumar, Dr. Anil Chaudhary, everybody is going for the correct answer. Dr. Dopamine, very true. So, let us now move on to the next question. A workshop was organized in a medical college to demonstrate the steps of neonatal resuscitation, in which an intern was performing the chest compressions on dummy of a baby, to which the instructor pointed out that one of the steps was wrong. Which out of the following would have been pointed out by the instructor? So, let us look at the steps. Chest compression should be performed by a two thumb technique. When performing chest compressions on a newborn, pressure is put on the lower third of the portion of the sternum. Thumbs should be lifted from the chest during compression and release. The carotid or femoral pulsation should be monitored periodically to assess the effectiveness of chest compression. Of course, we know here the incorrect thing which the intern was doing is that thumbs should be lifted. Thumbs should not be lifted while performing chest compression. They should be in contact with the lower third of the sternum. That is one very important, rule to be followed during neonatal resuscitation. So, the correct answer over here is C. Few things about chest compression. We all know chest compressions, they come in the in the protocol of neonatal resuscitation when the child's heart rate falls below 60 even after effective positive pressure ventilation. Very important thing over here is effective positive pressure ventilation. What do you mean by effective positive pressure ventilation? Is a positive pressure ventilation which is resulting in chest rise. Very importantly, if the chest rise is not occurring because of positive pressure ventilation, then we don't start with chest compression. First you have to do ventilation corrective steps. They have to be done, and we all know the ventilation corrective steps. We all know the mnemonic, it is MR SOPA. So, that has to be done. Yes. And because of this, so MR SOPA has to be done, that is the ventilation corrective steps. Even after doing ventilation corrective steps, that means now we are achieving the chest rise, and now 30 seconds have passed with doing positive pressure ventilation with an effective chest rise, but the heart rate has dropped below 60. Then comes the role of chest compression. So, you are often trapped in your exam by this question, wherein they will give you a neonate who has come, you are happen to witness a delivery and the neonate's heart rate is 40 beats per minute. What will you do? Don't fall into the trap of chest compression. You will always first start with positive pressure ventilation. Remember this, right? So, positive pressure ventilation will come first. Even after effective positive pressure ventilation, if the heart rate stays below 60, then you go for chest compression. After 60 seconds of chest compression, even if the heart rate stays below 60, then you go for the medications, that is epinephrine. You may also require the need for volume expanders like normal saline, right? So, this is what was required. Okay. Right. So, now let us move on to the next question, and that is an infant presented with low grade fever, headache, symptoms of the mild upper respiratory tract infection. The clinical image is given below. This viral infection is associated with all of the following complications except. So, let us look at the options: arthralgia and arthropathy, aplastic crisis, ITP or Guillain-Barré syndrome. So, what is the diagnosis over here? Can somebody tell me? Okay, somebody wanted to know. Okay, can somebody tell me what is the diagnosis over here? Yes, so this is a classical slap cheek appearance. Yes, Dr. Swayam has answered it correctly. Parvovirus infection is there. Parvovirus B19 is the virus responsible for this disease, and this disease goes by the name of erythema infectiosum, right? Erythema infectiosum, and this is also known as fifth disease. I hope everybody knows this, and parvovirus B19 is the culprit. You should know parvovirus B19 has lots of complications. Usually the erythema infectiosum starts as a prodromal period where the symptoms are in form of low grade fever and a low grade upper respiratory tract infection along with headache, right? And then comes the rash, the erythematous rash on bilateral cheeks, which soon spreads to the trunk and involves the proximal extremities, and this rash stays there for 2 to 3 weeks. But during these 2 to 3 weeks, this macular rash undergoes central clearing and assumes a lacy reticulated pattern. So, you should be knowing this. This is how the rash progresses in erythema infectiosum, right? Okay. So, what are the complications? Parvovirus B19 is notorious in causing aplastic crisis, especially in children who have chronic hemolytic anemia. You should be knowing this. Chronic hemolytic anemia, namely something like sickle cell anemia, or somebody suffering from pyruvate kinase deficiency, or some child suffering from hereditary spherocytosis. So in these disorders, especially if there is an underlying disorders like these in some children, if they get parvovirus B19 infection, then they land up with aplastic crisis. Very, very important. Why? Because parvovirus B19 has specific tropism. Tropism means affinity for the cells of the erythroid linkage. You should know this, and preferably at the pro-normoblast stage. We know we usually learn the stages in our pathology. There's a pro-normoblast stage and a normoblast stage, and then the final reticulocyte stage. So in this pro-normoblast stage, that is the stage at which parvovirus B19 strikes, and that is why these children, they have a tendency to land up with aplastic crisis. Of course, arthralgia and arthropathy is also seen, and idiopathic thrombocytopenic purpura is also seen, and what is not seen is GBS, that is Guillain-Barré syndrome. Guillain-Barré syndrome is seen more often as a complication of either mumps, usually with mumps infection it would be seen, or Zika virus infection. Zika virus is not very much prevalent in our country, but of course these are the two infections where you would see GBS as a complication, but not with parvovirus B19. Other complications of parvovirus B19 which you need to remember is the child might might land up with myocarditis. The child might land up with this thing, hemophagocytic syndrome, even that may occur. And in pregnant women, the pregnant women have a tendency to develop hydrops fetalis if they suffer from infection with parvovirus B19. So then you should remember all these complications, but of course GBS usually is seen either with mumps, remember this, or is seen with Zika virus infection, right? So these two you have to remember. Yes, this is also known as slap cheek appearance. So everybody's answered correctly. Good going. I am very happy. So Dr. Medico has also joined us. Dr. Akash has joined us. Dr. White Things, very good. Veera Cole has also joined. No, he was already there. And Dr. Cheela has also joined. Yes, this is also having a slap cheek appearance. That is very, and every time you get a question from this, so please do this part of your infectious disease very thoroughly. Surely you will get a question from here. Okay, so now let us move on to the next question, and that was a 5-month-old baby has a respiratory rate of 58 per minute, chest in drawing, baby has not been able to feed for the last 10 hours. What is the best management? And the options were prescribe oral antibiotics and follow up after 2 weeks, give the first dose of ampicillin and Genta and refer them urgently to the hospital, reassure mother that it is just a cough and cold, do nothing, and refer the baby to a tertiary care center. Okay, so what do we do in this case? So what do we see over here is a 5-month-old child baby having, very importantly, tachypnea and chest in drawing. So this is rapid breathing. Now the question arises, when do we call rapid breathing? I'm sure you all must be knowing these criteria, but let us revise once more. So in less than 2 months of age, the respiratory rate more than 60 per minute is tachypnea, is rapid breathing, right? Fast breathing in other words. Then 2 to 12 months, this cutoff is more than 50 per minute, and 12 months to 59 months, that means 5 years, this cutoff is, rapid rate is more than 40, rapid respiration is more than 40 per minute, right? Of course. So definitely this child is having chest in drawing and tachypnea. So because of this and very importantly, this child actually comes in the category of pneumonia. But then very importantly, the child has not been able to feed also for the last 10 hours. So that means this is one. There are general symptoms or signs which are not very good, and that is, one is the child not taking feed. So if the general condition also tells us that there are some ominous sign present along with the fast breathing and chest in drawing, then this child lands up in the category of very severe disease or severe pneumonia, whatever you want to call it. And then in that ways, or in that category, what do? We have to urgently refer the child to the hospital. But before referring, you have to give a shot of parenteral antibiotic or even oral antibiotic if the child is can take orally, but definitely in very severe pneumonia, because the heart respiratory rate is so much, you would not be wanting to give oral antibiotic, but yes, there is an option of even giving oral antibiotic. Oral Lamoxi can be given, but a preferable would be giving a first dose of Ampygenta, that is a parenteral antibiotic, and referring the child to the hospital. What about other options? Reassure the mother that is just cough and cold. Of course, this is not just cough and cold, because the child is having chest indrawing and tachypnea, which shows us that this is a lower respiratory tract infection. That means involvement of the lungs has taken place. So this is just not cough and cold. Do nothing and refer the baby. Of course, that is not to be done, and oral antibiotics are not enough for this child. So yes, everybody has answered this again correctly. I am very, very happy. Dr. Pasha has joined us, Dr. Akash Fulzile, Dr. White Things, Viral Kohl. This is severe pneumonia, and Dr. N. Kumar, Dr. Bharat Patel, Dr. Doc is also saying B option. Of course, this is severe pneumonia, in which we will give the first dose of antibiotic and refer the child to a health center, to the hospital, right? Okay, so this is the classification. We already know the classification is somewhat different in less than 2 months, where you have very severe disease or severe pneumonia, local bacterial infection, or severe disease or local infection, unlikely. But anyways, we are dealing with a 5 months old child, so this is the classification where you have either no pneumonia, pneumonia, or very severe pneumonia. Very severe disease, we call it either very severe disease or we call it severe pneumonia, not very severe pneumonia, right? And this is how we have to measure, where we have to manage this child. And as far as the danger signs goes, yes, this child had a danger sign, and that is what placed him in very severe disease or severe pneumonia, and that is what requires the child to be referred to hospital after giving a shot of antibiotics, right? So we know this, right? This is under the ARI control program. Okay, so good. Okay. So laryngomalacia, why will you say laryngomalacia versus severe pneumonia, doc? No, this is not laryngomalacia. Laryngomalacia children are usually do not land up with severe kind of disorder. Please remember, it's a upper respiratory tract involvement, and usually this child will present to you in the OPD with complaints of stridor. That is the main presenting complaints in laryngomalacia. While severe pneumonia might, stridor might be there in severe pneumonia also, but there will be the other things also. But usually in severe pneumonia, there would be chest indrawing also, very, very important. Chest indrawing tells you that the child is using accessory muscles of respiration, right? So this is not laryngomalacia. Laryngomalacia is more or less not an acute, it is not an infectious disease, and it's never an emergency like this, right? Okay, then next question, let us do that. An infant presents to OPD with recurrent episodes of UTI. Mother gives history of poor urinary stream with dribbling. Which investigation can help in underlying diagnosis? Is it MCU? Is it ultrasound, urine culture, or DMSA scan? The moment you see three things, over here 3 things are there which will help you arrive at a diagnosis. Okay, yes, so this is basically poor urinary stream with dribbling and recurrent episodes of UTI. So when you see things like these 3 things together, the first thing that should come to your mind is PUV. Please remember this. Posterior urethral valves is there, and the correct the diagnosis, the diagnostic investigation which will help us arrive at this correct diagnosis is MCU. You know this, micturating cystourethropy, that has to be done. That will show us the posterior urethral valves, the kinking at the level of posterior urethral valves. So MCU is the answer over here, right? Yes, so everybody's answered correctly. Good going. Dr. Pasha, Dr. Lala Prakash, Dr. N. Kumar, Dr. Mukesh Kumar, very good. So I'm very happy, at least my subject has been taken very well. Okay. Now let us come to, so this is the MCU picture showing you. So this, if you can appreciate this, what is this? This is the dilatation of the posterior urethra, and this is the portion of the posterior urethral valve. So the part of the urethra proximal to the posterior urethral valves that is dilated, that is what is seen over here, and of course this is the bladder. So that is how this MCU would look like. Please remember, sometimes they may give you this pic and ask you the diagnosis, giving you the relevant history. So you should understand, and you should try to remember and understand what is given in this picture, right? Okay. Now let us come to the next option. Okay. A neonate is born with a small head, small eyes, sloping forehead, cleft lip and palate, post-axial polydactyly, bulbous nose. What is the diagnosis? Okay, so diagnosis: Down syndrome, Edwards syndrome, Patau syndrome, or the Turner syndrome. So what do you see over here as given in the question? Of course, the child is having bulbous nose, that is very evident. Cleft lip is very much evident over here, and you can see the polydactyly both in the feet, and in the hand. In both places you can see polydactyly, right? And what else you can see? You can see hyperteliorism also, and you can see the sloping forehead, right? And although the ears are not visible, otherwise this syndrome also has deformed or malformed ears are also there, right? And the most common congenital heart disease what you see with this syndrome is VSD, ventricular septal defect. What am I talking about? Of course, I am talking about Patau syndrome. So, Patau syndrome we all know is trisomy. This is trisomy 13, right? Edwards syndrome is trisomy 18. We all know this. Down syndrome is trisomy 21. And Turner syndrome has the XO phenotype, and this is seen in girls, right? So, this you should be knowing. So, every time they will give you one or the other syndromic question, you should know the features of common features of common syndromes, very importantly, right? So, in Edwards syndrome, what will be given in the question that will help you clinch the diagnosis? Microcephaly would be there, and very importantly rocker bottom feet, and of course they can also give you VSD as a part of the congenital heart defect seen in Edwards syndrome also. So, VSD is seen in Edward also, right? Remember, the commonest heart defect in Edward is VSD. Again, in Patau is also VSD. In Turner's, can anybody tell me what is the commonest heart defect seen in Turner syndrome? Okay, I am waiting for someone to answer. Till then, I will just leave it like this so that I answer you later. Then the commonest heart defect seen in Down syndrome is, I will write it down over here. Yes, this is endocardial cushion defect. So, this is endocardial cushion defect, and over here the commonest heart defect seen in Turner syndrome is bicuspid aortic valve. Remember this, bicuspid aortic valve. So, this is the commonest. No, Dr. Pasha, I was expecting this, that is why I asked this question deliberately. It is not coarctation of aorta. Remember this, coarctation of aorta is the second commonest heart disease seen in Turner. If they ask you the commonest heart disease seen in Turner syndrome, it is bicuspid aortic valve. Remember this always, right? It is not coarctation of aorta, is not the most common. That is why I asked you deliberately, right? Yes, so Dr. Swayam has answered very correctly. It is endocardial cushion defect for Down syndrome, and many others have also answered. Dr. Lala Prakash has answered, and Dr. Akash also has answered bicuspid aortic valve. Yay, you are on my team. Of course, the coarctation of aorta people will also come in my team listening to this information, that it is from now onwards you will say bicuspid aortic valve as the commonest congenital heart defect seen in Turner syndrome, right? So, you should be knowing Down syndrome. I'm sure everybody would be knowing the cardinal signs. So, there would be endocardial cushion defect, there would be sandal gap, that is gap between the first and the second metatarsal, there would be clinodactyly, there would be single palmar crease, and there would be duodenal atresia, Hirschsprung's disease, annular pancreas. So, you know, atlantoaxial in dislocation. So, these are all the common features of Down syndrome. Turner's, we all know, there would be, it would be seen in a girl with a shield chest and wide space nipples, and then the child would be the girl child would be having webbing of the neck, low hairline, cubitus valgus, increased carrying angle of the arms, and would be having streak gonads or streak ovaries, right? So, these are all common features of Turner syndrome, of course, and today you have learned that it is bicuspid aortic valve as the commonest congenital heart defect. Yes. Okay, so now let us move forward to the next question. A 1.5-month-old male baby was brought to emergency with severe congestive heart failure with clinical features of left ventricle dysfunction. On examination, baby was tachypneic but pink. Upper limb pulses were well felt with weak femorals. On chest x-ray, there was mild cardiomegaly. All of the following are correct regarding the clinical condition except. So, rib notching can be seen classically in infants. Lower limb blood pressure are higher than the upper limb blood pressure. Pre-subclavian coarctation is more common, and all of the above are correct. Incorrect, sorry. So, of course, we know what are we talking about? We are talking about coarctation of aorta, right? So, coarctation of aorta, you know, there is a kink in the aorta, because of which there is problem in the supply to the descending aorta. So, there are two varieties, we know this, right? So, let us see what are the two varieties over here. So, let us assume if this is the arc of aorta, right, and this is the your pulmonary trunk, and then you have the, okay, let me draw this again, 1 minute. So, we have the arc of aorta over here, and we have the pulmonary trunk over here, and then we have something like ductus over here, and then we have the three. So, usually what happens is the arc, the commonest location for the coarctation of the aorta is the juxtaductal. Juxtaductal means just at the place where the ductus goes and attaches to the aorta, right. So, this is the commonest location of the coarctation of aorta, and you know, otherwise there are two types of coarctation of aorta, preductal and postductal. It all depends on when the child is symptomatic. If the child is symptomatic in the newborn period or right after the newborn period, then most likely we are dealing with the preductal coarctation. And if the child is totally asymptomatic during the newborn or the infancy or the toddler period and becomes symptomatic during the adolescent period, then you know we are dealing with the postductal coarctation, right. So, this is the these are the two types of coarctation. Now, what we are dealing with right now, the question given over here is the preductal type of coarctation, in which the child would be symptomatic in the first month or maybe in the coming 6 to 8 weeks of life, right, with features of congestive cardiac failure. Now, given over here rib notching, remember in many of your books it is very clearly written that rib notching is not visible before 6 years of age, and in your standardized textbook it is written rib notching is not visible before 10 years of age. So, this is a wrong statement, right. Then lower limb blood pressures are higher than the upper limb pressures. Of course, lower limb pressure would be lower. You should know the dictum in a newborn, if femorals are well felt, then coarctation is reasonably ruled out. So, if the coarctation is there, the lower limb blood pressures are going to be lower than the upper limb pressures. Now, what about the pre-subclavian coarctation? Of course, I told you it is the juxtaductal or the place where the ductus comes and attaches onto the aorta. That is the most common site of coarctation, and it is not the pre-subclavian coarctation, right. So, therefore, all the above three are incorrect, right. So, the correct answer over here was D. Please remember, rib notching is not seen. Most of you have answered. For first time I am seeing a wrong answer over here. Sorry for that. I think Dr. N. Kumar, it is not A. Dr. Taurachand Sahu, it is not A. So, all the three options were incorrect. So, the correct option here would be the D option, where all the options are incorrect. Please remember this, right. Okay, then other than this is the classical X-ray showing you rib notching. If you can appreciate, this is the rib notching, this is the rib notching, again this is the rib notching over here. So, usually seen in the inferior border of the ribs, and why? Very nicely shown. This is the intercostal artery, which has become so tortuous because of the giving out collaterals, and that is why the rib notching is seen. So, rib notching, remember, is not seen in infancy. It takes years to develop and usually seen by 6 to 10 years of age, not before 6 years of age at any point of time, right. Then this is your classical 3 sign seen on an over penetrated chest X-ray film. So, that is very much visible over here. And then of course, on a esophagus, on a barium swallow, you can see the reverse 3 sign, or you also call it the E sign. So, either the E sign, and this is because of the impingement of the coarctated portion of aorta on the barium filled esophagus. So, you get to see the E sign or a reverse 3 sign, right. So, these are all the important signs over here. The correct answer here was D. All the 3 options were incorrect, right. Okay, so let me move forward. A 3-year-old male child presents to pediatric OPD with hypertrophy of the calf muscles and wasting of thigh muscles. Goward sign was positive. All of the following are associated with this illness except. So, inheritance is autosomal recessive. Dilated cardiomyopathy is usually associated with this illness. Intellectual impairment may occur in 1/3 of the cases. After the calves, the next most common site of pseudo hypertrophy is the tongue. So, remember over here, what is the diagnosis we are dealing with? we are dealing with the diagnosis of Duchenne muscular dystrophy. Very true. And if you see Duchenne muscular dystrophy, that is how the clinical scenario will be given to you. Now, we know that the inheritance of Duchenne muscular dystrophy is X-linked recessive. It is not autosomal recessive. So, of course, the false statement here would be yes, Dr. Swayam Sharma has answered it correctly. DMD is X-linked recessive. So, therefore, the false statement is A. Now, what about the B statement? Dilated cardiomyopathy is seen, but it is usually not seen before 10 years of age. That you have to remember. Intellectual impairment usually occurs, and why? Because the dystrophin gene mutation is also expressed not only in the skeletal muscle but also in the cardiac muscle, number one, also in the brain and also in the retina, you know. So, these are the 3-4 places where dystrophin gene mutation is expressed, and therefore we see the clinical effects in form of intellectual impairment because dystrophin gene mutation is expressed in the brain also. You have to remember this. And after the calves, the next most common site of hypertrophy very truly is the tongue, and the third most commonest site is the muscles of the forearm, that is namely brachioradialis. Remember this. So, the three, first is the calves if we write, then is tongue, and then is brachioradialis. Remember that ways, right? Okay, so the correct answer over here is that inheritance is autosomal recessive. That was a false statement. What other features? So, this is the classical Goward sign shown to you, just in case if somebody doesn't know, you should know. Remember, Goward sign is not specific to Duchenne. Very, very importantly, Goward sign can be seen in any proximal myopathy. Of course, with the clinical scenario given here, we are summing up together and making a diagnosis of Duchenne, but always remember Goward sign is not specific to Duchenne. Another thing is the calf pseudo hypertrophy that you can appreciate over here. Yes. Then another feature of Duchenne, very importantly, usually missed by children, is the valley sign. So, what is the valley sign? You can see there the central fibers of the deltoid, they are pseudo hypertrophied, and so are the infromedial fibers of the infraspinatus. Both of these are hypertrophied, while there is wasting of the muscles of the posterior axillary fold, and this is what is known as valley sign when the child is made to stand in such a position. So, these are all the features of Duchenne which you should be knowing, right? Okay. So, now let us move on to the next question. A 17-year-old boy presents with high-grade fever with decreased oral intake and yellowish discoloration of skin for the past 3-4 days. Past history is suggestive of similar episodes of yellowish discoloration of skin off and on. Important over here is off and on. On examination, icterus is seen and lab investigation reveal predominantly unconjugated hyperbilirubinemia. But liver enzymes are found to be normal. What could be the probable diagnosis? So, options were Rotor syndrome, Gilbert, acute viral hepatitis, or Dubin-Johnson syndrome. Very importantly, let us mark off the incorrect. Unconjugated hyperbilirubinemia means your Rotor and Dubin-Johnson is totally out of question, because you should know in Rotor syndrome and Dubin-Johnson we get to see conjugated hyperbilirubinemia, very important. And secondly, you should know in Dubin-Johnson they will usually give the history of also the black pigmentation of liver would be found. That is very characteristic of Dubin-Johnson. So, this is again one differentiating feature for Dubin-Johnson. What about acute viral hepatitis? Acute viral hepatitis would never present to you with normal liver enzymes. Remember this, the liver enzymes would be grossly elevated. So, again this is not acute viral hepatitis. So, if you just strike off like this, what is left is Gilbert. But anyways, you should know things about Gilbert. Yes, very others will have, yes, Dr. Swayam has answered correctly, and Dr. Swayam, you can also add on that the liver enzymes would be grossly elevated in acute viral hepatitis, as I just mentioned, right? So, Gilbert, by by striking off the other options, you can arrive at a diagnosis of Gilbert. But anyways, I am telling you one thing which you have to remember. In Gilbert, you will get to see intermittent jaundice, you will get to see recurrent jaundice, there will be recurrent episodes. So, you can see off and on past history the child has been having similar episodes, and usually these episodes usually come around the adolescent age. Although the defect is there since childhood, it is a autosomal recessive condition where there is underactivity of UDP-GT system. You know the UDP-GT system, uridine diphosphate glucuronide transferase. So, this enzyme system is underactive, preventative is not working to its full potential. So these people are usually symptomatic beyond the adolescent age or in the adult age, and where they will land up with jaundice whenever there is stress. Either there is stress, or there are periods of fasting, or there are periods of some intercurrent illness is going on. In girls, even with the menstrual cycles, they may land up with jaundice. I have a very close relative who has Gilbert syndrome, who was diagnosed with Gilbert syndrome, and this guy was doing his MBBS. He's also a doctor. During his every examination, every prof examination, he used to land up with jaundice and garner sympathy. So then this way, Gilbert is good also, sort of. Anyways, nothing is required, no investigation, nothing, no treatment is required, just supportive care, that is what is required. So that is one thing good about Gilbert, and does not, predispose the child or the adolescent to any other malignant kind of illness in the later life. So that is Gilbert for you. Okay, so what about Crigler-Nazar? Somebody, Dr. Medico was asking me, what about Crigler-Nazar? Crigler-Nazar, remember, there are two varieties. The Crigler-Nazar type 1 is highly, it is lethal, and usually the children, they present to you with unconjugated hyperbilirubinemia and would require exchange transfusion. The levels are very high, reaching 30 milligram per deciliter, and usually lethal. And this is because of the absence of UDPGT activity, Crigler-Nazar type 1. Crigler-Nazar type 2 is because of the, again, underactivity or incomplete absence, not total absence, but incomplete activity of the UDPGT activity. So some kind of activity is still there, which can be enhanced by giving phenobarbital. So Crigler-Nazar type 2 is still okay. Usually the levels are not very high, and in Crigler-Nazar type 1 and type 2, both the times, the child would present right in the newborn period with unconjugated hyperbilirubinemia, not in the adolescent age group. Please remember that. And when the child presents with Crigler-Nazar type 2, there we give phenobarbital, and the child, is pulled off excellently out of this hyperbilirubinemia, because phenobarbital induces whatever is remaining of UDPGT system and helps to clear off the jaundice. So that is what is about Crigler-Nazar. So I hope Dr. Medico has got his answer right. So that is it about this. So the correct answer over here was Gilbert syndrome. Now finally, I think this is the last question for pediatrics. So open vial policy is followed in all except. So the options were pentavalent vaccine, OPV, hepatitis B vaccine, and Japanese encephalitis vaccine. Okay, so open vial policy, I hope everybody knows that this was introduced around, I think, 2016, if I am not wrong, and this was because to reduce the wastage of the UIP vaccines covered under UIP, Universal Immunization Program, and the policy was that you can use certain unused vials or incompletely used vials even after opening up till 28 days from the time of opening. That is what was open vial policy. Now important is open vial policy is observed in what all, that is that is what is asked over here. So in what all open vial policy is being followed. So remember, in all the T series vaccines. So what do you mean by T series? So it can be a DPT, it can be TT, it can be TD, of course not rotavirus. Rotavirus is not included. Please exclude rotavirus over here. It can be hepatitis vaccine in wherever your T is coming. So in all these T series vaccines, open vial policy can be followed, number one. But then there are certain conditions that have to be fulfilled. So we will look at those conditions later on. First, let us remember the name of vaccines. Of course, in your OPV vaccine, IPV vaccine, pneumococcal conjugate vaccine, and Hib containing pentavalent vaccine, in these also open vial policy can be followed if those certain conditions are fulfilled. Very important, those certain conditions should be fulfilled. Then only we can use these incompletely used vaccines up till 28 days from the time of opening. Now important is in which vaccines open vial policy is not followed. Very importantly, you have to remember, open vial policy is not followed in, let us see, BCG, it will not be followed, in measles containing vaccine, measles MMR, and of course in Japanese encephalitis vaccine. In these three vaccines, the open vial policy is not followed. And one more important vaccine over here is, if you remember, yes, your COVID vaccine. Even COVID vaccine, it was, I was part of the COVID vaccination. It was done in my hospital right from the time it started. At that time, we were doing COVID vaccination in our hospital, and it was a strict advisory. We were first trained for it that COVID vaccines have to be discarded even if the doses were left after 4 hours of opening. Remember that. So same goes even for BCG and measles. In BCG and measles, you should know that usually, you discard this within 4 to 6 hours. So somewhere it is given 4 hours, somewhere it is given 6 hours. So usually it is better to follow 4 hours. Within 4 hours of reconstituting it, this is a freeze dried vaccine. These both are freeze dried vaccines, have to be reconstituted with a diluent. So they have to be discarded if the doses are left. We are talking about the multi-dose vials. And of course, even Japanese encephalitis vaccine has to be discarded within 2 hours of its reconstitution. So this is what has to be kept in mind as regards with open vial policy, right? Okay, so let us see this. So these are 28 days. This is the maximum time for which you can use these vaccines, and these are the conditions that should be fulfilled. That the expiry date should not have been passed. They should be stored under appropriate cold chain. Vaccine vial septum should not have been submerged in water or should not be contaminated. Or even if you see this vaccine in a vaccine carrier where the water is there, then too you have to discard this vaccine. Aseptic technique would have been followed for withdrawing the vaccine doses, and the VVM must not have reached its discard point. So if these conditions are fulfilled, then only you can follow the open vial policy with the T series vaccines and the PO vaccines. PO is PIO, that means pneumococcal conjugate, IPV and OPV vaccines. So PO vaccines and T series vaccines. So I think, yes, of course. So everybody's answered it correctly. Of course, D, yes, Japanese encephalitis, good going. Dr. Phoenix, Dr. Bharat Patel, Dr. Veera, Dr. N. Kumar, Dr. Gajendra Chauhan, Dr. Manoj Sharma, yes, he has also included COVID, very good. Dr. Karishma, Dr. Manoj Sharma, everybody is correct. And Danish 1331, Dr. Manoj Sharma is writing, yes, that is the strain which we use for BCG, right? So I hope you enjoyed this pediatrics discussion. So bye for now, and keep MCQing. Let MCQ be become the verb of your life. Verb means VERB. So keep MCQing. Your exam is in just less than 4 weeks. The countdown has begun. All the very best to you, and I'm sure you will rock it and ace it. Thank you so much. Thank you.
Hello students, so now we'll be starting with the radiology part of today's mock test. The radiology questions were pretty straightforward and all of them were from topics taught in the class. Now the first question, a 29-year-old male underwent a routine health checkup as part of his company's annual policy. He had no specific complaints and no history of smoking or alcohol consumption. An ultrasound examination of his abdomen revealed the following findings. What is the most likely diagnosis? So the patient is asymptomatic. Patient underwent just a routine health checkup, so he does not have any complaints, right? So the options given are cholelithiasis, gallbladder polyp, cholesterolosis and adenomyosis. Now in this given image, what do we see? So this right here is the liver and this right here is the gallbladder. And in the gallbladder, towards the fundus of the GB, we see this echogenic mass attached to the fundus of the GB. Now, what are the pointers that we see in this image? So, first of all, it is in the non-dependent position. It is in the non-dependent position. That is, it is not lying down. It is hanging upward. So, if it was a stone, it should be lying somewhere here if it was a stone, right? But it is hanging upward, so it is not a stone. And also, what do we see? That there is no posterior acoustic shadowing, right? So all these two things, that is presence of a dependent position and presence of a posterior acoustic shadowing, would have suggested it to be a GB stone, that is cholelithiasis. But since it is in a non-dependent position and no posterior acoustic shadowing, so the answer here will be a GB polyp. Now, what is cholesterolosis? So cholesterolosis, you might have heard from another name, that is adenomyomatosis. Adenomyomatosis of gallbladder, and what it essentially is is that there are small cholesterol granules in the wall of the GB. So first of all, with cholesterolosis, what we would have seen? We would have first seen it to be multiple, and characteristic artifact that we see with adenomyomatosis is comet tail artifact. Comet tail artifact. So here in this image, we see that it is a single lesion in the GB fundus, and there is no comet tail artifact also that we see. So the answer is not cholesterolosis. The answer here is a GB polyp. I hope this was clear. Now, second question, a 42-year-old female underwent a total thyroidectomy for papillary sea of thyroid and presented to with oncology OPD with elevated levels of thyroglobulin. So, post thyroidectomy in a CA thyroid patient, if patient presents with increased thyroglobulin, we suspect a recurrence. And there was also a palpable lesion in the left cervical region. So, there is a cervical lymphadenopathy also. She underwent a repeat imaging study and was diagnosed with a recurrence of primary tumor. As we rightly said, the oncologist decided to go for systemic radiotherapy for further management. Now, which of the following radioisotopes is utilized for the same? It is a one-liner question. The question itself was a little lengthy, but it is a one-liner question of which radioisotope of iodine is used in systemic radiotherapy. Now you have to remember this one. The answer here is iodine 131. Okay, iodine 131 is used in systemic radiotherapy. Okay, you have to remember this, and it is a beta and a gamma emitter. Now iodine 123, where is it used? It is used in thyroid scans. It is used in diagnostic thyroid scans. For example, hot nodule versus cold nodule. Iodine 125, where is it used? So it is used in brachytherapy. It is used in brachytherapy. And iodine 127, so it is a normal isotope of iodine. It is not used in radiotherapy. It is stable. It is nuclear stable radioisotope. So I hope this was clear about the various radioisotopes of iodine. Now, question number 3, a 40-year-old male presents with chief complaints of increased stool frequency and occasional blood in the stools. On stool examination, the fecal calprotectin levels were raised. Now, this fecal calprotectin levels, this is used to differentiate between an inflammatory diarrhea versus an IBS or an irritable bowel syndrome. So remember, fecal calprotectin is increased in IBD and also in ileocecal TB. Okay, so right now we have these two differentials in mind. So further, he underwent a CT enterography. Now remember, CT enterography is used whenever you are suspecting a bowel pathology, be it a small bowel or a large bowel pathology. For example, inflammatory diarrhea, for example, infective diarrheas, where you want to evaluate bowel, you do a CT enterography and not a normal CCT. So the CT enterography revealed, what did it reveal? Multiple long segment circumferential bowel thickening. Okay, so the buzzword here is a long segment stricture. Okay, and which segment of the bowel was involved? The ileal loops were involved, and there was an associated mesenteric fat proliferation. Now, additional cues that are given in the question are enlarged lymph nodes in the mesentery, but they are homogeneous. Okay, so these are three keywords that are present in this question. First is a long segment stricture. Second is presence of ileal loops. And third is presence of homogeneous and large mesenteric lymph nodes. Now, all these pointers point to Crohn's disease. Okay, so answer here is a Crohn's disease. Now, in ulcerative colitis, what happens? Ulcerative colitis predominantly involves the large bowel only. It starts from the rectum and goes on proximally. So, it's a proctocolitis. Okay, that is, it affects the large bowel only. Crohn's disease can affect any part of the gut, can affect the large bowel, small bowel, duodenum, stomach, even esophagus. So any part of the bowel, more commonly ileum. Ileum is the most common bowel part that is affected, and characteristic involvement is that of a long segment stricture. Okay, long segment stricture is seen in Crohn's disease along with multiple skip lesions. Multiple skip lesions. Now, in intestinal tuberculosis also, any part of bowel can be involved. So, how would you differentiate between Crohn's disease and ileocecal TB? So, in ileocecal TB, the cecum is more commonly involved than ileum, and characteristically, the IC valve is more commonly involved in intestinal TB. Regarding the length of the stricture that is involved, it is a short segment stricture in intestinal TB. Short segment stricture. Okay, and there are necrotic mesenteric lymph nodes. There are necrotic mesenteric lymph nodes. Okay, so if you see short segment stricture plus necrotic mesenteric lymph nodes, you have to tick mark ileocecal TB in this answer. Okay, now celiac disease, what is the involvement? So it causes small bowel diarrhea. Okay, remember it causes small bowel diarrhea. And what do you see on imaging? You see jejunal ileal fold reversal. Okay, so what does it mean? So jejunum typically has a feathery appearance and ileum has a featureless appearance. This appearance is reversed in celiac disease. So this was again a quick revision of the various imaging appearances of commonly asked bowel pathologies for your entrance exam. Now coming to question number 4, which of the following is the correct match of irradiation units? So first is exposure dose. So exposure, what is the unit? The SI unit is coulombs per kg. It is the SI unit. Okay, what is the conventional unit for exposure? All those of you who have seen Chernobyl would rightly remember that exposure is measured in Röntgen. Okay, now absorbed dose. For absorbed dose, is Gray the correct radiation unit? Yes, it is. Remember the mnemonic ABG rad. ABG rad. Okay, Gray is the SI unit and rad is the conventional unit. Okay, for equivalent dose, Sievert is the SI unit and REM is the conventional unit. For radioactivity, Sievert is not the option. Okay, it is not the option. Radioactivity is measured in becquerels. Okay, so the answer here is D. Now coming on to the next question, a patient presents with abdominal pain and distension. An X-ray was taken which showed dilated bowel loops as given in the image. Identify the segment involved. Now, so we know that it is a case of intestinal obstruction and we see dilated bowel loops. So first of all, is it a small bowel or a large bowel? Now, what do we see here? We see complete septae in the dilated bowel segment. It is going from one wall to the other. So this cannot be a large bowel. Remember, in large bowel transverse colon, we see Haustrae and they are incomplete septae. They are incomplete septae. So it is one of the small bowel loops. Now duodenum is very small part, so it will somewhere be located in the upper abdomen, very high up near the stomach bubble. Now amongst jejunum and ileum, remember ileum is present in pelvis. Okay, so it would somewhere be located here. And jejunum is the one which is located in the upper abdomen. So these are jejunal loops. Okay, so the answer here is jejunum. Now coming on to the next question, a 60-year-old male was brought to the emergency department with slurring speech, unilateral weakness and difficulty in walking. So all these are symptoms suggestive of an acute stroke. Now in emergency, a diagnosis of stroke was suspected and the patient underwent a non-contrast CT. So whenever you suspect an acute stroke, you have to undergo an NCCT, that is the investigation of choice in an acute stroke. That is the next step of investigation as well. Why do we do a non-contrast CT? Because we want to differentiate between a hemorrhagic stroke and an ischemic stroke, because the management of both of them are very, very different. Now, which of the following is not a sign of an acute ischemic stroke? Right. So first is an hyperdense MCA sign, loss of insular ribbon sign, hypodensity in the basal ganglia region, and D is large hemorrhagic area within the frontal lobe. So in an acute ischemic stroke, you will not see any hemorrhage. So answer here is D. This is not a sign of acute ischemic stroke. Presence of hemorrhage does not tell you that it is an ischemic stroke. You have to do an other line of management, mainly BP control. So all first three A, B, C are signs of acute ischemic stroke. What is a hyperdense MCA sign? So in a hyperacute stroke, let's say 1 to 6 hours after the onset of stroke, the clot that is present in the middle cerebral artery appears hyperdense. So this is a hyperdense MCA sign. That is, you can see the clot in the middle cerebral artery. Now, second is a loss of insular ribbon. Now, in this image, on the right side, you see that the insular ribbon is very well seen, whereas on the left side, the insular ribbon is not so seen because of loss of gray-white matter differentiation, which is characteristic of acute ischemic stroke. Now, C option is hypodensity in the basal ganglia region. Now, how does it look like? So, it looks like this. So, on the left side, you see it is a normal looking basal ganglia. So, you see the caudate nucleus, you see the lentiform nucleus. Whereas in the right side, what do you see? You see that there is this hypodensity in the basal ganglia region. This is also a sign of an acute ischemic stroke. Okay. And finally, large hemorrhagic area will suggest an hemorrhagic stroke and not a ischemic stroke. Now, moving on to the next question. It was an easy question, a straight line question from PET. Which of the following statements regarding PET is true? Okay, so we want to mark the correct option. So, PET uses X-rays to create images of the body? No, it uses gamma rays. Okay, PET only detects anatomical structure of the body? No, in fact, it detects functional structures. All those areas which are metabolically active and which take up FDG. Now, PET measures metabolic activity in the body. Yes, it measures metabolic activity. All those areas which are metabolically active, for example, rapidly dividing cells of intestine, brain, myocardium, and cancer, they rapidly uptake the radioactive isotope, that is FDG, and they light up on PET. So, answer C is correct here. And let us look at the option D as well. PET is a non-invasive procedure that does not require the use of contrast agent. So, in PET, you do give a radioisotope, and also most PET are now accompanied by PET CT, and PET CT in CT you do give an iodinated contrast as well. So, among these four, option 3 is the best answer. Okay. Now, 40-year-old man with the more recent onset cyanosis and long history of dyspnea presented to the OPD. The chest radiographs demonstrate significant pleural thickening and calcification, particularly involving the diaphragmatic pleura. Okay, so the buzzword here are pleural thickening and calcifications. And which part of the pleura? The diaphragmatic pleura is more commonly involved. What is the most probable diagnosis? Now, the options given are cold worker pneumoconiosis, silicosis, asbestosis, and siderosis. So, we are talking about an occupational lung disease, right? So, amongst these, which is the occupational lung disease which causes pleural thickening and calcification? Again, it's a one-liner answer. It is asbestosis. Okay, all others do not cause pleural thickening and calcification in the early diseases. Now, cold worker pneumoconiosis causes progressive massive fibrosis. Okay, and here also upper lobe is more commonly involved. Now, silicosis has multiple small nodules. So, it is a reticulonodular disease. It is a reticulonodular disease. And which part of the lung, upper lobe or lower lobe? It is upper lobe which is more commonly involved. Asbestosis is also a reticulonodular disease, but here lower lobe is more commonly involved. And apart from that, you get pleural thickening and calcification. And which is the cancer which is associated with asbestosis? It is mesothelioma. Okay. Now, siderosis is hemosiderin deposition in the lung. It can either be primary or it can be secondary. Now, secondary, most common causes of secondary pulmonary hemosiderosis is mitral stenosis. Okay, it usually occurs secondary to mitral stenosis, and here also middle lobe and lower lobe are more commonly involved. Okay, so answer here is asbestosis, and this was a brief capsule and a brief revision of the various occupational lung diseases. Now, question 9, which of the following disorders characteristically has a feature like the one shown in the picture below? Now, the options are scurvy, rickets, osteomalacia, and Paget's disease. So, we are talking about a metabolic bone disease. Very, very important topic for your FMG entrance. Now, it is a spotter that is shown here. So, remember, whenever you will be shown an image of a knee, okay, image of a knee, usually a scurvy would be the option, the answer. In rickets, characteristically a wrist or a hand X-ray is given. In osteomalacia, usually a lower limb X-ray would be given. In Paget's, usually pelvis or a skull X-ray would be given. Now, in this given image, we see characteristic features of scurvy. Now, what are these features? So, first here we see is, what do we see here? First, we see Wimberger's ring sign. Wimberger's ring sign. So, this is nothing but a sclerotic rim around the epiphysis. Now, below that, we see this white line of Frankel. Just below the white line, we see this radiolucent tremor field zone. Okay. Also, we see this spur, this bony outgrowth at the metaphysis. This is the Pelkin spur. Okay, this is the Pelkin spur. Another important sign in scurvy are pencil point cortex, very thin cortex, pencil point cortex. You see that the bony cortex are so thinned out. Okay, they are so thinned out. So these are the various signs that you see in scurvy. Now in rickets, what do you see? You see cupping, splaying, and fraying at metaphysis. Okay, and in Paget's disease, usually you will be given a pelvis or a skull X-ray. You will see some sclerotic and some lytic lesions within the pelvis and the skull. So metabolic bone disease, very important topic for your FMG entrance. So the last question from radiology, a 23-year-old female patient presents with recurrent UTI and pain in the abdomen. An X-ray KUB was done in view of the above mentioned complaints and is shown below. Now, what is the most likely diagnosis? So whenever a recurrent UTI is present and you are given an image which shows a calculi. Now, what is this type of calculi? It is a large calculi and it is involving more than 2 calyces in the left renal fossa, and it is associated with a recurrent UTI. So all these point towards a staghorn calculus. Right. Now remember, for cholelithiasis, that is stone in the GB, the investigation of choice is an ultrasound, because GB stones are not radio opaque. Okay, they are radiolucent. For pyelonephritis, the investigation of choice is a CECT, that is a contrast enhanced CT. And an emphysematous pyelonephritis, also the investigation of choice will be a CECT. Okay. Now, in staghorn calculus, just a brief summary about staghorn calculus. So, what is it also called? It is also known as Struweit stones. Okay. And what are they made up of? They are triple phosphate stones. Triple phosphate. Okay. So, magnesium, ammonium, phosphate stones are Struweit stones, and they are produced by urease producing bacteria. Now, what are these bacteria? These are Proteus, Klebsiella, and Pseudomonas. Okay, so all these bacteria produce urease and are responsible for Staghorn calculi, also known as Struve calculi. So this was briefly about the radiology questions that were asked in this mock test. Thank you.
Hi students, I hope you had a good grand test. Now what were the questions from anesthesia and emergency medicine? Let us discuss. The first question, a 55-year-old male patient presents with syncope, that is loss of consciousness. On examination, the heart rate is 55 beats per minute and rhythm is irregularly irregular. His blood pressure is 80 by 60 mm of Hg and his ECG is shown below. What is the treatment of choice? So let us don't go into complexity of the question. Let us make the question as simple as possible. Patient has heart rate less than 60 beats per minute. That is, patient has bradycardia. Now, bradycardia, if patient had a sinus rhythm, I would have called bradycardia, but the rhythm was irregularly irregular. So it's bradyarrhythmia. And the bradyarrhythmia is symptomatic. It is producing symptom. So as I told you, that if a patient presents with symptomatic bradyarrhythmia or symptomatic bradycardia, then we have to treat it. If this bradyarrhythmia or bradycardia was asymptomatic, we didn't have to treat it. We would just have to observe the patient. But here we have to treat it. And the first drug, the treatment of choice in bradyarrhythmia is atropine. Okay. So what is the treatment of choice was the question. First was A was observation and regular follow-up. Well, if it would have been asymptomatic, well, that would have been the answer. But blood pressure was less, so it's symptomatic. Then administration of atropine. That's the best option, I think, for this patient. Administration of amiodarone. Amiodarone is not used in bradyarrhythmia. It's used in tachyarrhythmia. It's an antiarrhythmic. And initiation of beta blocker, well, again, it is used to control the heart rate. So answer is administration of atropine. So this was the first question. The second question. Using procedural sedation, a 55-year-old male was scheduled for bronchoscopy, right? For a 55-year-old male had to get a bronchoscopy done under sedation, okay? What are the common drugs which we use for sedation? Benzodiazepine and let's say opioids combination. So here also patient was given some medication which resulted in chest wall rigidity, poor spontaneous ventilation, high peak inspiratory pressure during manual ventilation, and saturation drop. Opioids most commonly implicated. So patient was given for sedation and opioid. An opioid which resulted in chest wall rigidity, poor spontaneous ventilation. Any opioid can cause respiratory depression. So morphine, oxycodone, fentanyl, codeine, anything can be the answer. But here, chest wall rigidity, the most commonly chest wall rigidity is seen with which of the following opioid? The answer, it can be seen with few of the opioids, but what we have to select, answer has to be fentanyl. Fentanyl is very typically causes chest wall rigidity. Morphine has also reported, but morphine not as common as fentanyl in causing chest wall rigidity. So because of chest wall rigidity, there was a high peak inspiratory pressure during ventilation. So answer is fentanyl. Okay, I hope you have done it right. The third question, the anesthesiologist planned to administer propofol for induction to make the patient unconscious and for maintenance of anesthesia for a minor surgical procedure to a 50-year-old patient. Which of the are correct? Which of the following statement is false about propofol? That is all correct except. So which of the following statement is false? So the question is on the properties of propofol. The first, the greatest disadvantage of using propofol is to decrease arterial blood pressure. Yes, propofol is cardiovascular unstable. So it causes hypotension. It can cause hypotension. So first option is correct. Propofol is cleared rapidly from plasma through both redistribution and rapid metabolism of liver. Immediate return of consciousness happened with propofol because of redistribution, and it is also cleared very fast, right? Its metabolism is very fast. So this is also right option. Propofol has rapid onset, correct, within 30 to 60 seconds, and short duration of action, again correct. We have to give infusion of propofol for its maintenance. Got it? It causes respiratory stimulation. Well, it's an anesthetic agent. All anesthetic agent causes respiratory depression. So this is the wrong option. So it would have been true for any anesthetic agent. They are respiratory depressant. Got my point? Okay. So fourth question. image-based question. The image of a needle was given, as you can see, and they asked, what is this needle used for? Well, this is a 2-His needle which is used for epidural. How to differentiate between an epidural needle and a spinal needle? Well, as you can see in the epidural needle, we have markings on it, 1 centimeter markings on it, gradations on it. So this is an epidural needle. This is 2-His needle. Okay, so remember, this is 2-His needle. Okay. Fifth, according to American Heart Association, which would be used to monitor an intubated adult patient during CPR. Well, the question was that in ACLS, what monitor we have to use in an intubated patient. See, in ACLS, every patient, intubated, non-intubated, has to be attached ECG for rhythm analysis. According to rhythm, we manage the patient. But once the patient is intubated, one monitor is mandatory, and that is capnography. So capnography, this capnography gives us a lot of information. It tells us about the adequacy of chest compression, right? It tells us about whether the tube has gone into trachea or not, and it has a prognostic value also. It tells us whether we have to continue the CPR or not, and it also gives us an early indication of return of spontaneous circulation. So capnography has a lot of role in management of a cardiac arrest when we are doing the CPR of the patient, right? So it's a recommended monitor by ACLS. So these were the 5 questions which was asked in anesthesia. I hope you have got all the 5 questions correct. Thank you.
Hello, welcome students. So let us discuss few important questions from dermatology. Okay, so we'll be discussing all these important questions, and if you have any doubt, you can directly type in the chat box. So let us begin with this dermatology session. So in this first question, you can see that they are asking that which of the following statement is not true. Now this is something which is very important, that in exam sometimes you miss this not. Okay, so remember, not true means they are asking for false statement. Okay, so not true regarding cells acting as slow adapting touch receptors. Now all of you know that in skin there is one slow adapting touch receptor, and that is Merkel cells. Okay, so they are talking about Merkel cells. So here slow adapting touch receptors are Merkel cells, which are present where? In stratum basale. So we have to find out the false statement. So the first option is they are seen among basal keratinocytes. Yes, true. And they contain desmosomes. So this is a true statement. This is a correct statement. They are abundant in the fingertip, so they carry touch sensation. So they are abundant in the fingertip. Rarely these cells become malignant. Yes, this is true, because there is one carcinoma which is known as Merkel cell carcinoma, and that is due to malignancy of these cells, but this is very, very rare. And these cells respond specifically to fast vibration and deep pressure. Now this is a wrong statement. This is a false statement. So this will be the answer. So answer will be D option. Why? Because this carry touch sensation. This is a touch receptor. These are also known as touch cells, and the vibration and the deep pressure, this is carried by Pacinian corpuscles. And where these Pacinian corpuscles are present, they are generally present in deep dermis. They are present in deep dermis. Okay, so that's why the answer here is D. Now here you can see the image. This is the image of Merkel cell. Now these Merkel cells are present where? They are present in the lowermost layer. So if, let us consider, this is stratum basale. So in stratum basale, if you find these keratinocytes, in between you will find these Merkel cells, as you can see here, and they are connected to this Merkel or the tactile disc, which is again connected to the sensory neuron. So this touch sensation is carried. Okay, so this cell is also known as Merkel Renver cell or tactile epithelial cell, and as I told you, it can lead to a very rare carcinoma where the proliferation of these cells increases, and that is known as Merkel cell carcinoma, also called as neuroendocrine carcinoma. And remember that this is attached to the surrounding keratinocytes via desmosome. So here you will find desmosome, unlike melanocytes and Langerhans cells. So melanocytes and the Langerhans cells, they generally are not connected via desmosomes, but these Merkel cells does possess desmosomes. So this is also one important point to remember. Moving on to the next question, here they are saying that which of the following is true regarding the duration of telogen effluvium. Now all of you know that telogen effluvium is a hair disorder where after a particular stress, which can be in the form of pregnancy, typhoid fever, even COVID-19 infection, or any road traffic accident or any stressful condition, 3 months later the hair fall starts, and this excessive telogen hair loss is known as telogen effluvium, and this is a non-scarring type of alopecia. That is, the hair loss which has occurred can be recovered. Okay, so this is the condition they are talking about, and they are asking what is the true statement. So let us see these statements. First of all, they are saying that hair shedding lasts for several years continuously. No. Okay, so what happens that the phase of hair cycle is anagen, then catagen, and then telogen. Due to any particular stressful condition, few anagen hair follicles, they enter into telogen phase, and this telogen phase lasts for 3 months. So these hair follicles start falling off specifically after 3 months, and this hair fall do not continues for many years, because after that stress, excessive hair loss after 3 months occurs. So this is a wrong statement. It typically resolves within 3 to 6 months after triggering event. Yes, correct. It starts after 3 months and within few months it starts recovering as well. So this is the true statement which they are saying. Then hair shedding is intermittent and occurring only on certain days. No. As I told you, this specifically occurs after 3 months. So within that duration of like 1 week, all the hair fall occurs. Okay, so this is not intermittent, it is continuous, and within a few weeks or days, this whole hair fall starts and aggravates. So this is again a wrong statement, and it primarily affects women and rare in men. So in studies it has been found that there is no such correlation that it will occur more in women. Almost the ratio is 1:1. Okay, so it can occur and affect both individuals. So there is no gender differences. So here the correct answer is the option B. Here I can show you one image. This is a patient of telogen effluvium, and when this patient came to us, she was having these patches. And remember that this is not a specific patch like alopecia areata where you will find complete hair loss, but due to excessive hair loss you will find that the density have reduced and there is thinning of the hair follicle in these areas where the excessive hair loss has occurred. Okay, so you can see sparse here, there is decreased density, and after treatment the patient have recovered. Now remember that supportive treatment is needed here because this is a self-limiting condition, and within a period of 3 to 6 months this spontaneously resolves, but we need to give supportive treatment. And here in the same patient you can see there is good recovery. So this is a temporary type of hair loss and not a permanent type of hair loss, and that's why we call it non-scarring alopecia or non-cicastaceal type of alopecia. Moving on to the next question, here they are saying that 45-year-old female presents with multiple raised skin colored wart-like growths. So wart-like growths on genital area. She reports that these growths appeared several months ago and have increased, so it is continuously increasing. Based on the clinical presentation, what type of HPV stain is most likely to cause this in this patient? Now this is a very clear-cut question. They are saying wart-like growths and they have mentioned HPV stain, so that's why they are talking about, and the area involved is genital. So these are anogenital warts, and I suppose all of you know the answer here. You can type the answer in the chat box, please. Yes. So Dr. N. Kumar is typing C and Dr. GMM is typing B. So can you tell me the answer here? These are which warts? These are anogenital warts, and anogenital warts are caused by HPV subtypes 6 and 11. HPV subtypes 6 and 11. If both are given in separate option, here you can see there is only one subtype mentioned, but if both are given in separate option, then 6 more than 11. So the answer will be B. Yes, so Dr. GMM, yes, you are correct. The answer is B. Okay, and not C. I don't know why most of the students are getting confused here. Surbhi, Gajendra, they are typing C. So remember that here they are talking about anogenital warts and not cervical carcinoma. Okay, so remember anogenital warts commonly caused by HPV subtype 6 and 11. If you remember, I told you one mnemonic in my classes also. If you want, I can repeat that mnemonic here. So here you can see that this is rough warty growths which are present over anal and genital areas. Sometimes they can be dark in color as well. So I told you one mnemonic, DSP SLEB. Okay, so DSP, Deputy Superintendent of Police, is working so nicely that he's celebrity now. Okay, so DSP SLEB. So deep plantar wart is caused by HPV subtype 1, superficial plantar wart by HPV subtype 2, plain wart by 3, common wart by 4, epidermodysplasia veruliformis by 5, laryngeal wart by 6, and butcher wart by 7. Now remember that this 6 is also for anogenital warts. Okay, so the same subtypes cause anogenital warts as well as laryngeal warts. Okay, so that's why the answer here is 6 and not 16 and 18, yes. So N Kumar is typing, yes, 16 and 18 is for cervical carcinoma and not here. They are talking about genital warts, which is caused by HPV subtype 6 and 11. This is very important. So many times this question have been asked, okay. Now the next question, question number 4, they are saying that a 50-year-old man presents with 6 months history of a rash on his elbows, knees and scalp. So see, the sites involved are extensors. So extensors are being involved, like elbow, knee, scalp is involved, characterized by erythematous plaque with silvery scales. Very, very important, silvery scales. So silvery white scaling is feature of psoriasis. Yes, and we know that psoriasis generally involves extensors, and that's why the site involved are elbow, knees, scalp. He reports family history of similar lesions. On physical examination, the affected area are sharply demarcated and there is no evidence of scaling, pustules or blisters. So they have said scaling is present. Okay, so there is evidence of scaling, pustules and blisters are absent. And which of the following is the true statement about the clinical features of the given disease? Okay, so which of the following is true statement? So they are talking about which condition? Yes, they are talking about psoriasis, because psoriasis occurs over extensors. Here the lesions are plaque, that is, and they are erythematous and they have scaling. So all these features are present, that is well demarcated erythematous plaques with silvery white scaling over extensors. Now they are asking the true statement about psoriasis. It is always itchy and painful. No, this is not a true statement, because sometimes it can be asymptomatic and this is generally not painful. Okay, though sometimes itching might be present, but it is not a necessary condition. It tends to appear on face and neck. No, I told you the common sites are extensors like knee, elbow, back, scalp. Sometimes palmoplantar psoriasis occurs over palm and sole. Sometimes inverse psoriasis can involve flexural areas like umbilicus or axilla, but face and neck is not a common site. They are usually well defined with silvery scales, correct. So they are well defined erythematous plaque with silvery white scaling, and they typically associated with fever, not necessarily, but remember that there is one type which is known as guttate psoriasis, and this guttate psoriasis is commonly seen in children. And this occurs after upper respiratory tract infection. So this is one rare type of psoriasis which is known as guttate psoriasis, which can be associated with streptococcal upper respiratory tract infection. Though generally the patient have history of sore throat, upper respiratory tract infection, but their fever might be present. But this is not a typical finding. This is an atypical finding which is seen in a rare type, that is guttate psoriasis. So that's why this statement is also false. So that's why the answer is C here. You can see the images as well. This is a patient suffering from psoriasis, and in this patient what you can notice that extensors are being involved, like elbow involvement is there, knee involvement is there, scalp involvement is there, and what you can see over these areas, you can see this well demarcated erythematous. Erythematous means red in color. So well demarcated red plaque. Plaque is a solid raised area which is horizontally more and vertically less. So it is something like this solid raised area. So this solid raised area is present. This erythematous plaque is present, and this erythematous plaque is present over all these sites, and they are having what? They are having this silvery scales, silvery white scaling, as you can see, very characteristic scaling which is seen in psoriasis. Now the next question, what mechanism is seen in xeroderma pigmentosa? Xeroderma pigmentosa. Now xeroderma pigmentosa is a very rare condition. 1 in 1 lakh individual you might find this condition, and this is a genetic condition which presents with skin manifestation. So this is known as genodermatosis. This is autosomal recessive condition, and why it occurs? It occurs due to defect in DNA repair mechanism, that is nucleotide excision repair defect. So this is due to nucleotide excision repair defect. Okay, इसको समझ लेते हैं कि देखिए, आप अगर धूप में जाते हैं और आपकी स्किन में अल्ट्रा वायलेट रेडिएशंस की वजह से कोई डिफेक्ट हो जाता है, ठीक है, तो क्या होता है, हमारी बॉडी उसको रिपेयर कर लेती है। लेकिन इन पेशेंट्स में वो रिपेयर मैकेनिज्म का डिफेक्ट होता है, वो रिपेयर नहीं होता, एंड अगेन द पेशेंट गोज इन द सनशाइन एंड अगेन दैट यूवी रेडिएशन causes defect. Okay, so in normal skin the defect get repaired, but in their skin, the patient who are suffering from xeroderma pigmentosa, in their skin this defect do not get repaired. So what happens, that continuous damage starts occurring. So in patients में क्या होता है, they will come very early age and they will have lot of lesions over exposed areas due to this photosensitivity or the damage to the ultraviolet radiation. So when damage occurs, what happens, that over their exposed areas like dorsum of the hand, face, V of the neck, they will have lot of freckles. So lot of freckles start developing initially, and gradually due to excessive UV radiation damage, these patients can also present with carcinomas like squamous cell carcinoma. Okay, and as I told you, there is photosensitivity. So these patients have lot of photosensitivity, photophobia, and the skin damage. So you can see the image here. This patient, her whole skin is having lot of freckles. Okay, so freckles are very common, but there are few freckles which are occurring over sun exposed areas. But here you can see that whole skin is covered with freckles, and initially these are in the form of freckles, but gradually you will find that patient start developing malignant tumors like squamous cell carcinoma, skin pigmentary changes like in the form of freckles as I told you, and patient have lot of photosensitivity. So ultraviolet radiation is causing lot of harm, and this harm is not getting repaired because of the mutation of the genes which are required for nucleotide excision repair. So all these are the features, and sometimes later patient may have neurological degeneration, due to which patient can have low IQ, or patient can have neurological defect in the form of patient can present with seizures and other neurological findings. So I hope this session was useful for all of you. These were the questions from dermatology. Thank you very much.
Hello and welcome to the orthopedic session for this grand test. Just 5 questions are there in the grand test, and starting with the question number 1. Alright, a 16-year-old male presents with a progressive left knee pain. Now, because this question is related to the tumor, and as I told you multiple of the times, that every time you are going to get a long question related to the tumor, the first thing they will be providing is the age, 16-year-old. Alright, just by looking at the age, you can rule out at least 1 to 2 options. Now, if you look at the options like osteosarcoma, so it cannot be ruled out because it is the tumor of first decade of life, primary osteosarcoma. Then osteomyelitis, obviously this is something that we have to read the question and then we'll come to the conclusion. Ewing sarcoma, yes, to some extent it cannot be ruled out because early second decade of life is the age group in which Ewing sarcoma is usually happening. And then finally chondrosarcoma. Now look, chondrosarcoma is a tumor of elderly, like 40, 50, 55, 60 years of age. As a result of which this chondrosarcoma can be easily ruled out just by looking at the age of the patient. Alright, so presents with the progressive left knee pain. That means they probably are asking about the tumor which is around the knee joint. That means distal femur proximal tibia could be involved. For the past few months, now he noticed swelling and the limited range of movement in the left knee. On physical examination, there is a tenderness over the distal femur. That means distal femur pathology is there and a palpable mass. Now this palpable mass goes in the favor of a tumor. Alright. Now X-ray shows the Codman triangle, and the moment you see the word Codman triangle, you already are aware of the diagnosis for this particular condition. In osteosarcoma, there is a periosteal elevation which gets calcified in the triangular form known by the name of Codman triangle. So by the time you read this word Codman triangle, it must hit you that the question probably they are asking about is osteosarcomatous tumor, and rest of the things which are provided in the question previously, if it goes synchronized with this, then probably the answer for that particular question is osteosarcoma. Now 16-year-old, yes, because it is a second decade tumor, so it goes in the favor. Around the knee joint, that means distal femur is likely to be affected, then it goes in the favor of osteosarcoma. Now if you further continue with the question, that the CT scan of the chest reveals osteoblastic metastasis, and the most common organ for receiving these metastatic lesions from the osteosarcomatous lesions are the lungs. So lungs are the most common site to receive the metastasis. Obviously the second most common site is the bone. That means bone to bone metastasis that happens in osteosarcoma. So by the time you have completed the question, you already know or already aware that the topic you are dealing with is osteosarcomatous tumor. Alright. So this was a straightforward, simple question. Majority of the time what happens is that, in case of a very long question, very large question, majority of the time the last 2 lines are having the answer for that particular question. There is something which is specifically linked to that particular topic is provided in the last 2 lines. So if you are not very much sure by reading the first 2 to 3 lines in that particular question, then the last 2 lines are probably having the answer which is directly linked to that particular option. Okay. Now, which of the following statement about the Jaipur foot is correct? What do you mean by the term Jaipur foot? For example, if the limb is amputated and it has to be fitted via prosthesis, so the terminal prosthesis is a Jaipur foot. One of the terminal prosthesis is a Jaipur foot. Now Jaipur foot, there are several of the things that you should be aware of related to this particular topic, that is Jaipur foot, is that it is made up of rubber. And because it is made up of rubber, it is having several advantages. Advantages in the sense that it is least expensive. Alright, it is least expensive. Because it is not made up of the carbon fiber, so it makes it least expensive. Although there are several advantages associated with this particular foot. But because it is made up of latex or the rubber, it is having the advantages that it is very less expensive kind of a prosthesis. That is point number 1. Now point number 2 is that rubber is moldable, and because of this moldable quality of this prosthesis, the terminal prosthesis, inversion and eversion of the foot to some extent is possible. So if the patient is made to walk on irregular surfaces, irregular terrain, so the foot will get accustomed to those irregularities because of the moldable characteristic of the rubber. Alright. So inversion and eversion to some extent is possible. Third point, majority of the laborious activities in our country requires squatting, and squatting requires some amount of dorsiflexion adjust at the level of the ankle joint. So that dorsiflexion, although the foot is not going to get dorsiflexed by itself, but the basic adjustment where the patient can sit squat, or the patient can squat because of the adjustable dorsiflexion at the level of the foot is also a possibility. So what they are asking is that which of the following statement is correct. So which of the following statement are related to the Jaipur foot is correct. So cost is very high, this is incorrect. Barefoot walking is possible because it is made up of rubber, you can very easily walk, and most of the time because it looks like a normal foot, so you can easily walk barefoot also. Restricted mobility, no, there is no restricted mobility because of the rubber characteristics that we have already talked about. Then dorsiflexion is absent. As I told you, that foot by itself is not going to get dorsiflexed, but that adjustable movement is a possibility, and squatting is possible in a patient who is having this Jaipur prosthesis applied in the form of the terminal one. Alright, so hopefully you get the statement, or hopefully you get the idea of this terminal prosthesis for this particular question. Alright, yes, true, the B is the answer for this question. Next one is the question which is related to the Merrill criteria. Merrill criteria is for, majority of the time what happens when you sit in the examination hall and when you are in front of your screens. So there is something which related to the topic, and you will jump on to the conclusion that possibly it is the criteria for that particular topic. So it is a very confusing kind of a thing, which majority of the time students marks the wrong answer. Merrill criteria is not for making the diagnosis of the pathological fracture. Alright, it is for the prophylactic fixation of the pathological bones. So Merrill criteria is basically for the prophylactic fixation of the pathological bones. Now just try to understand the basic structure of this one. Imagine this is a bone and there is a tumor which is making the bone pathological. Now because of this tumor, the possibility of this bone to get fractured is easy, and so it is defined as a pathological fracture. So Merrill criteria is not for categorizing the bones into a pathological type of bone. No, it is decided whether you go for prophylactic fixation or not on the basis of this criteria, that is Merrill criteria. So yes, you have answered the question as A. So this is the confusion that we were talking about. No, it is not for the diagnosis of the pathological fracture. Prophylactic fixation of the pathological fracture. Just try to understand. What is Merrill criteria? Basically, Merrill criteria is incorporating some points, and those points are given as 1, 2 or 3 points. Now, these points are based on, first of all, the size of the tumor, alright, then the pain which is associated with it, then the location of the tumor, alright. Now, size or the site of the tumor, like if there is an involvement of less than 1/3 of the width of the bone, then 2 is the point which is given if there is an involvement of 1/3 to 2/3 of the width of the bone. 3 is the point which is provided if there is an involvement of more than 2/3 of the width of the bone. Imagine if this is a bone and there is a tumor which is involving, or any lesion which is involving more than 2/3 of the width of the bone, so 3 points are to be provided in that particular case. Then pain. If the pain intensity is low, then 0.1 is given. If the pain intensity is moderate, that means in between the two, so 2 points are given. But if the pain intensity is severe, alright, the condition is extremely painful, then 3 points are provided. Alright, so these are the points which are given. Then comes the location. If the upper extremity is involved, that means if there is an involvement of the humerus or the radius ulna, then in case of upper extremity involvement, 1 point is provided. If there is a lower extremity involvement, then 2 points are provided. But if there is a peritrochanteric involvement, like if this is the head of the femur, neck of the femur, greater and the lesser trochanter, so this region near about the trochanteric region of the proximal femur, if this region is involved, then 3 points are provided. And finally comes the type of the lesion. The type of the lesion. The type of the lesion could be, one, it could be osteoblastic. If the lesion is osteoblastic, then 1 point is provided. If the lesion is mixed, then 2 points are provided. But if the lesion is osteolytic, then 3 points are provided. So based on these, the scores is calculated, the score is evaluated. And based on this score, if the score comes out to be less than 7, then fixation is not required. If the score comes out to be more than 8, more than or equal to 8, then you have to go for prophylactic fixation, because the risk for the pathological fracture is too high. The risk for this bone to get fractured is very high. So hopefully you get the idea of what exactly this Merrill criteria is, and Merrill criteria is for, alright, it is for the prophylactic fixation of the pathological bones. Next question is that for which of the following condition the splint is used. Now this is something which we have talked multiple of the times. Whenever you are provided with any splint image where two shoes are connected by a bar in between, so you have to identify this splint as a Dennis Brown splint, and this Dennis Brown splint is used in, or Dennis Brown splint is indicated in case of congenital talipes equinovarus, that means CTEV abnormality. Alright, Dennis Brown splint is used in the management of CTEV once all the deformities are overcorrected in order to prevent the recurrence. This is something which we have talked multiple of the times, like, alright. So don't get the impression that Dennis Brown splint is used to correct the deformities of the CTEV. No, it is used to prevent the recurrence of the deformities that you have corrected by the Ponseti method. So that is the indication where the Dennis Brown splint is used, and it is used after the correction is done, is used till the age of walking, when the child starts walking, because after the child starts walking, the DB splints has to be replaced by a CTEV shoe. So hopefully everything is clear related to this particular question also. Like so many times this question has been asked, and they are asking this question very commonly today also. Come to the next question, that a 24-year-old woman presents to the emergency department after the motor vehicle collision with the pain, weakness and ecchymosis in her right upper extremity. Now, you know, if there is a pain, there is weakness as well as some of the bruises which are present. So possibly there is a significant injury which has happened to the upper extremity. Now she can make a fist, but there is a marked decrease in the grip strength. The grip strength is difficult, although she can make the fist. The midshaft humerus fracture is observed on the X-ray. Which structure is most likely injured? You know, when you make up the thumb up sign, this sign, that means all the nerves are normally functional. When the patient is able to do the thumb up sign, then all the nerves are possibly functional. Now the patient is able to make the fist, it means that the flexion of interphalangeal joint of all the 4 fingers are normally affected, are normal. Alright, but the grip strength, the strength of the grip also requires the metacarpophalangeal extension to some extent, and this metacarpophalangeal extension is a feature of radial nerve injury, and in case of midshaft of the humerus fracture, there is a possibility of this medial nerve injury also. Alright, so the midshaft humerus fracture is observed on the X-ray. The patient is having a difficulty in the grip strength, so possibly the patient is suffering from the radial nerve injury. Alright, as it is again said that if there is a flexion of interphalangeal joint of all the 4 fingers is possible, and the patient is able to flex all the 4 fingers, that means the flexor pollicis, this flexor digitorum profundus, flexor digitorum superficialis, both of them are normally functional. Alright, and both of them are supplied by the median as well as ulnar nerve. So possibly the answer for this particular question goes in the favor of the radial nerve. Alright, so hopefully this session was of help in order to identify the questions and mark the answers related to this particular grand test. All the best for your examination. Thank you very much.
Hi students, welcome to your next session after the completion of grand test this morning. And in this session we are going to talk about or rather discuss the questions of forensic medicine. Okay. So I can see a lot of students are online. First of all, welcome to all of you, and if at all at the end of the session I am going to miss to wish you, then let me begin this session by wishing first of all a very best of luck for your forthcoming examination. Right, let's begin this session. Okay, and yeah, I can see there are few names that I would like to call out, like Vishnu I can see on the screen, Shubham, Vishnu, Dr. N. Kumar, Vicky, GMM, and so many other names also. I don't want to miss any of your name personally, but then it will be too taxing, right? So let's begin this session and let's take question number 1. Question number 1 is: a 45-year-old patient underwent a surgical procedure performed by a general surgeon. Okay. Following the surgery, the patient experienced complications. He believes that the complications resulted from doctor's negligence during the surgery and decides to pursue a civil negligence case. The onus of proof lies with. So if you see in the question, it's kind of a very straightforward question. What is being asked in the question is the proof, the onus of proof. The onus of proof, which is also called as the burden of proving, okay, or you can say the liability to prove, right? Already I guess some of you are going to give answers on the screen right now. Bhargavi is saying B, Lala Prakash is saying C, maybe some more people will end up giving answers, but let me explain. What exactly are we talking here? See, whenever a case reaches in the court of law, whatever is being alleged by the complainant, okay, the burden of proof says who will prove the allegation, right? The burden of proof means who will prove the allegation. So what is the allegation in the matter? If you look in the question, the allegation is doctor's negligence. And who is alleging that doctor could be negligent? It is the patient who is alleging. So just consider this scenario in your mind, and now think, if a patient has moved to the court of law alleging that the doctor has been negligent in the treatment of the patient, who do you think has to bring the proof, whatever proofs are required to prove the negligence of the doctor? Definitely doctor doesn't have to do it, because why would doctor prove himself to be negligent? Okay, so from the option doctor is out, right? Which is the other party in the court of law against the doctor? And that is patient himself. So who has the burden to prove the negligence? It is patient. Correct answer is option number B, as given by many of you. Some of you have said C, but just consider, if I am one of the doctors who has been alleged that I have been negligent in treatment of a certain patient, the patient has already dragged me to the court, I would defend myself against the negligence. I don't have to prove my negligence. The patient has to prove my negligence. If the patient is unable to prove my negligence, then my defense becomes imperative. My defense becomes solid. If the patient is able to prove my negligence, then I have got opportunity to successfully defend it. If I end up defending it successfully, even then the negligence charges against me shall be dropped. This is how it runs in the court. Okay. Now taking the example of this question, let's understand one simple philosophy of the court of law, right? When we say court of law, and we are talking about criminal matters also. Right? In the court of law, in criminal matters like grievous injury, murders, abduction, so many other different crimes are there. Who has the burden of proof? In criminal matters, the burden of proof lies with the party who is alleging the charge, and that party is called as prosecution, right? That party is called as prosecution. So, remember, in criminal matters the burden of proof lies upon prosecution. In the negligence cases the burden of proof is on the plaintiff, because in civil cases the party who is alleging the charge is not called as prosecution, it is rather called as plaintiff, and plaintiff is the patient himself, right? Let us move to, yeah, great, GMM said correctly, prosecution. Let us move to question number 2. Which of the following is not a reason to conduct prenatal test under PNDT Act? This act is also called as PCPNDT Act. Preconception, Prenatal Diagnosis of Sex and Techniques Act. Basically, the hallmark of this act is to prohibit any kind of procedure or diagnostic modality which can detect the sex in prenatal time period, or which can help in selection of sex in preconception time period, right? So, understand this concept very clearly. In our country, you cannot select the sex in preconception time period, that is, even if it is a case of IVF or any other artificial insemination kind of scenarios where assisted reproductive techniques has been applied, sex selection is not allowed. Then once the patient has conceived, sex detection is not allowed, right? But then leverage is given in the act itself towards doing certain diagnoses which are essential, which will reveal the sex of the fetus also, because those diagnoses will be important in the progression of the pregnancy for detection of any genetic abnormality or ailments or XYZ, right? So, this question is regarding that if you have to do a certain diagnostic modality, what are the indications? So, those indications are also given in the PCPNDT Act, and a lot of students have answered the concept very correctly. I can see that the correct answer is, if there is a woman who is 32 years of age, pregnancy, because this age in PCPNDT Act is not 32, it is above 35 years. So, what PCPNDT Act says is that women who are more than 35 years and they conceive, there are high chances of acquiring any genetic abnormality in the growing fetus, and in that scenario a lot of diagnostic modalities may have to be performed to see the genetic well-being of the fetus, and in the process sex of the fetus will be detected. So, if that is the situation, PCPNDT allows those diagnostic modalities to be done. Similarly, PCPNDT allows the diagnostic modality to be done in cases of 2 or more spontaneous abortions in the past. So, if there is a history of 2 or more spontaneous abortions, PCPNDT allows diagnostic modalities to be done which can detect the sex of the fetus. Pregnant woman or her spouse has a family history of mental retardation or physical deformities, you can use diagnostic modalities which are otherwise not allowed in the PCPNDT Act in normal pregnancies. Exposure to potentially teratogenic drugs, yes, you can do them, okay. And apart from this, any kind of pre-existing genetic disorders in the family also. Even in this scenario, the diagnostic modalities will be allowed which are normally banned by PCPNDT Act to be done in a pregnant females. Right, let us move to question number 3. A forensic pathologist performs an autopsy on the body of a deceased individual's skeletonized body to determine the cause of death. As a part of examination, the doctor examines the pelvic region to identify any distinguishing features that can help differentiate a male and the female pelvis. Okay. Which of the following is the distinguishing feature of the female pelvis? So, question again is a very straightforward question. What you will find very peculiar in these kind of questions, the question has been picked up from the section or chapter of identification, is that this kind of a question which asks you about the anatomical differences between male and female pelvis, it is a very repetitive question. And what is the importance of this repetition is that in spite of it being very redundant, very repetitive, this question ends up showing in examination again and again and again and again, which means that somehow for the exam maker, the knowledge of difference between male and female pelvis by a student is of importance. Okay. So, my recommendation is that whenever you are preparing for any of your exam, this is one area of, you can say, anatomy or forensic anatomy that you should not miss revising. As far as this question goes, let us tackle. The question is simply speaking, distinguishing feature in favor of female pelvis. Okay. Subpubic angle is V-shaped, option number 1, that is wrong because subpubic angle is U-shaped in female. Narrow and deep great sciatic notch, which is wrong because in female the deep greater sciatic notch is shallow and wide, or you can say wide and shallow. Third is more broad and deep pre-auricular sulcus, that is the correct answer. Literature says 82 to 94% female pelvises has deep and broad pre-auricular sulcus. So, very important distinguishing feature in female pelvises as compared to male pelvises. So, of course, the fourth is also going to be wrong. The fourth is ischial tuberosity is inverted and obturator foramen is large and oval. This is wrong. Ischial tuberosity is everted in females and obturator foramen is triangular and small, not large. Okay. So, these are some critical differences between male and female pelvises. Unfortunately, that is one of my recommendation is that mug it if you require it. Even if you require to remember it, mug it, because 4 marks are very important marks in examination, right. Let us move further. Question number 4. A 72-year-old man is found deceased in his apartment after several weeks of being unattended. Upon discovery, the body appears to have undergone significant changes, including formation of waxy. Okay. So, important point is here is waxy soap-like substance on the skin. Which of the following statement is not true regarding this condition? So, the first thing after reading the question is that we need to formulate the diagnosis, or you can say we need to distinguish what is the body looking like. And this waxy soap like substance is nothing but adipocere formation. Okay. I am looking at this screen right now also. Yeah, some of you have started to give the answer to this question. First of all, this is adipocere formation, also known as saponification. What happens in adipocere formation is hydrolysis and hydrogenation of body fat. Okay, hydrolysis and subsequent hydrogenation of body fat. As a result, waxy or soapy structures, because when fatty acids are generated in the body, they combine with ammonium and chloride ions in the body to form soap. Okay, that is why it is also called as saponification. So now we have confirmed that this is a decomposition by the way of saponification or adipocere formation. Now let us see the options which are given in the table. The first is usually occur in cold and damp environment. The first option itself is the wrong option. Why? Because it does not happen in cold and damp environment, it happens in hot and moist environment. Okay. It occurs primarily in areas with high fat content such as subcutaneous tissue. That would be a correct option, because as you have already seen, it is basically hydrolysis and hydrogenation of body fat. So, wherever body fat is present in abundance, it will start to happen there earlier. It may limit the invasion of microorganisms of the body. Yes, it does. So, that is a correct option, because it takes up lot of water from the body, which is required for water for hydrolysis. Okay. So, microbacterial proliferation is limited to a large extent. Generally associated with distinct odor, yes, the odor here is sweet. Okay, as compared to putrefaction, which tends to have a foul odor, adipocere tends to have a sweet odor. So, it is a decomposition that is not odorless. Putrefaction has foul odor, adipocere has sweet odor. Mummification, which is the third variation, it does not have any odor. So, mummification is odorless. Right. So, let us go to question number 5. Which of the following statement is false regarding dry drowning? Okay. Again, a very straightforward question. So, let us see what exactly is dry drowning. Dry drowning is a atypical kind of drowning. Right, and the atypicality in dry drowning is that although there is a live person who has fallen into the water and he dies because he has fallen into water, but his tracheobronchial tree does not contain large amount of inhaled water. Normally, when people who are alive, they fall in water and they inhale water, they die of drowning. That is the normal methodology of drowning, called as wet drowning. But sometimes when people fall in water, as the water starts to enter into their larynx, people develop laryngeal spasm. As a result, water does not enter into their tracheobronchial tree, but then they still die of that laryngeal spasm effect. That is called as dry drowning. Okay. And that is how finding in dry drowning is atypical, because they are not going to get lot of water in lungs, that is in the tracheobronchial divisions. Okay. But what happens to that laryngeal spasm that has happened, due to which the person has died? Once the person die, after death the muscles will relax, so spasm will go away. So, as a result, after death some amount of water will enter into the tracheobronchial tree passively, not actively, because he is no more actively breathing, but that it depends upon how much time the body remains in water, right? But that passive ingestion of water into the tracheobronchial tree is not going to be as massive as it happens in normal wet drowning when the person is breathing actively. Okay. So, even if you get water in tracheobronchial tree, that is minimal, not because it is not by an active ingestion or inhalation process, not ingestion, I should say inhalation process, right. With this information, what do we get is that in dry drowning, the cause of death is laryngeal spasm, and this laryngeal spasm gets relieved in dead body, right. Now, let us see what we have to see. We have to find the false statement, right. So, first is diatom's test is negative. Second is during autopsy neither the mucus plug nor the laryngeal spasm can be demonstrated. So, both seems to be correct statement because there is no active inhalation of water. So, diatoms may not come positive. Yes, the laryngeal spasm will get relieved, so we may not find it in post-mortem time period. Third is water does not enter lung because of laryngeal spasm, that is the true statement. Seen in alcoholics due to drowning in shallow pool, it is not necessary, as I have told you earlier. The false statement is option number D, because it can be seen in normal people who have fallen into even deeper collection of water. The idea is laryngeal spasm caused by the water attempting to enter the larynx. Okay. So, option number D is a false statement. Okay, let us move further. Shubham has a question. I think I missed this query regarding the previous question. Let us go back, and he says, Shubham says, but question में not true पूछा है, so answer तो A ही रहेगा ना. Yes, answer. Yes, Shubham. The answer to question number 4 is A, because उसमें not पूछा है. Correct. Let us go back to question number 6 now. Which of the following statement regarding vagitus utrinus is true? See, again, this is a question based on a term which is coined. So, to answer this question correctly, we have to understand what is vagitus utrinus. Vagitus utrinus is nothing but the sound of fetal cry, and fetal cry means fetal inhalation, right. When fetal birth happens and the fetus cries, it makes sounds and he inhales, right. So, fetal respiration is the fetal cry. So, vagitus utrinus is the sound of fetal cry during the process of birth before the fetal head comes out of vagina inside the uterus itself. That is why it is called as utrinus. Okay. So, vagitus utrinus is nothing but as given in option number A. It refers to the cry of the newborn in the womb itself, in the womb of the mother, right. There is another word which is similarly associated with it. That word is called as vagitus vaginalis. Vagitus vaginalis is fetal cry when the fetus is being delivered into the vaginal canal. So, the cry happens in the vaginal canal. Okay. So, vagitus utrinus is fetal cry in the womb, vaginalis is during the passage through vaginal canal, right, before the fetal head has come out of the maternal vagina, right. So, correct answer is option number A as given by lot of students, which is absolutely appropriate. Next question. A 32-year-old male was admitted to hospital following an acute organophosphate poisoning. So, in the question itself, it has been given, it is a case of organophosphorus poisoning. Despite the initial treatment, the patient condition worsened over the next 24 hours. Okay. He developed weakness and paralysis of cranial nerves. So, weakness and paralysis of cranial nerves, neck flexors and proximal limb muscles, along with respiratory distress and signs of autonomic dysfunction. What is the most likely diagnosis? Now, a patient of organophosphorus poisoning, we are going to discuss it. I am discussing it till the time you give answers. Okay. When we talk about organophosphorus poisoning, of course, whenever we read it either in pharmacology or medicine or forensic medicine, we read through the diagnostic modality of organophosphorus poisoning, that is the muscarinic effect, commonly denoted by a mnemonic called as sludge, SLUDGE, salivation, lacrimation, urination, defecation, gastrointestinal hypermotility and diarrhea, along with the pinpoint pupil or meiosis, right. There are some more important complications associated with organophosphorus poisoning. Few important ones are lacryuria. Chromo means color, lacry means tear and uria means flow. So, flow of colorful tear, in this case the color is red. So, in few percent patient of organophosphorus exposure, there is emission of red color tear. Okay. Then second is intermediate syndrome. What happens in intermediate syndrome? It is a situation of paralysis of small muscles of body. So, paralysis of small muscles of body, right. And third is delayed syndrome, but more appropriately it is called as delayed onset of polyneuropathy, right. Intermediate syndrome, which involves paralysis of small muscles, commonly muscles which are innervated by the cranial nerves like eyelids and facial muscles. So, when they are going to be paralyzed, what will happen? There will be inability of the patient to open the eyes, so drooping of eye muscles, difficulty in lifting the neck, flexors of the neck are affected. Intercostal muscles, if they are affected, the person is going to land up in respiratory distress or insufficiency. That is exactly what the patient is showing. So, correct answer in this case is nothing but option number C, intermediate syndrome. Okay. Intermediate syndrome seen in organophosphorus poisoning. This intermediate syndrome which is seen in organophosphorus poisoning, or the symptoms of these intermediate syndrome, it is most commonly seen within the first week of poisoning, right. Most of the patients show that small muscle paralysis in the first week of poisoning, and as you can see in the question, it is given, it is seen after the end of the first day itself. And delayed syndrome is commonly seen in 4 to 6 weeks post poisoning or post exposure, which means delayed syndrome is something which will be seen in a patient who has been sent home after a complete treatment, because 4 to 6 weeks post exposure is about month or month and a half. So, patient most likely would have gone home. Okay. And in delayed syndrome, what is involved is paralysis of big and bulkier muscles of body, most commonly lower limbs. So consider if a question is thrown to you stating that there has been a patient who has been successfully treated after moderate to severe exposure to organophosphorus poison, and you have sent him home, and 4 weeks later he presents back to you in OPD for review, and now he complains that he is unable to walk. The more he walks, the more tired he gets. He's not able to lift his leg. So what is happening? Delayed syndrome is happening. Okay. So that's what we wanted to discuss in the question. Remember, chromolacryuria, intermediate syndrome, delayed syndrome. Right. Question number 8, a very forensic medicine kind of question, right? Because this is one question which is dealing with section of IPC. The question is, if a person consumed some intoxicated drugs to suppress his mental faculty and committed rape, then he should be punished. This is given under which section of IPC? Now, what is very important in this question is to realize self-willful intoxication, because he has consumed certain compound or drug or intoxicant to depress his mental faculty, which means it is a scenario of self-willful intoxication. And what do we talk in the class when we talk about IPCs is that there are two very important IPCs, section 85 and section 86, which talks about intoxication. Section 85 says involuntary intoxication is not punishable. It is not punishable means if the person is intoxicated involuntarily and after that in the intoxicating state he commits any crime, he is not responsible for that crime, but it will be the onus of the person to prove that involuntary intoxication in the court of law. Whereas section 86 says voluntary intoxication, then whatever you do, you will be treated as a normal person, right? So, in the question it is clearly mentioned that the person has voluntarily intoxicated himself, which means according to section 86 of IPC, he will be punished for that crime. And two people have given correct answers. Well done, Vishnu and Lala. Prakash has given absolutely correct answer for the same. Let us move to question number 9, our penultimate question. A 45-year-old male working in an ordnance factory came in contact with chemical substances in the factory. He developed an acute painful corrosive lesion with yellow necrotic second to third degree chemical burn emitting a garlic like odor. So, one of the important clincher here is garlic like odor, and then of course ordnance factory is a clincher. Then few days later he developed tender hepatomegaly, that is one important thing. Jaundice is because of the hepatomegaly and probable liver cell failure. Bleeding at multiple sites because vitamin deficiency, clotting factor deficiency because of the liver disease, and flapping tremor, hepatic encephalopathy. What is the likely diagnosis? So many clinchers are given in the question, but I would still suggest, even for those people who haven't read toxicology well, the most easy clincher in the question is given in the first line, which is ordnance factory. Ordnance factory produces explosives, right? Firearms, explosive, and which compound is highly inflammable, because that is one compound which is going to be used in explosives predominantly, and that compound is phosphorus, right? White phosphorus. And so garlic like odor also becomes important because phosphorus tends to have garlic like odor. Now the question becomes simple. The main organ of target of white phosphorus is liver, and all the findings which are given are supportive of acute phosphorus intoxication. Correct answer in this case is nothing but option number B, as given again by many students and particularly by Divyan also, who has written white phosphorus in the option itself. Great, well done. Good going. And now we come to the last question of our series. It says 21-year-old girl was killed by smothering by her boyfriend at the residence. Later on he suspended the body from the ceiling with rope to mimic hanging. Okay. So, basically what we are looking at in this question is a case of post mortem hanging, right. All the following findings can be seen except. So, all you need to do is to read 4 options, and you need 4 options, and into see which of the 4 options does not favor a post-mortem hanging. Ideally that option should be favoring an ante-mortem hanging. Okay. So, ligature mark around the neck, it can be seen in post-mortem hanging, because in peri-mortem time period if you hang someone, ligature around mark can be seen around the neck. So, that is not a problem. La facie sympathique, now that is something which cannot be seen in post-mortem time period. Why? Because la facie sympathique is an ante-mortem phenomena. What happens in la facie sympathique is that the knot of the hanging rope, it puts pressure on the cervical sympathetic trunk on one side of the neck wherever that knot is present, and that pressure causes the ipsilateral side eye to remain open and the pupil dilated after death. That is la facie sympathique, which is an indicator of an ante-mortem hanging, which has been asked in NEET PG examination many times as an indicator of diagnosis of ante-mortem hanging. Okay. So, that is not possible. So, that is the wrong option. Correct answer is la facie sympathique will not be seen. Rest of the options are post-mortem staining is like glove and stocking distribution. Yes, because in hanging the body is erect after death. So, post-mortem staining is seen in hands and feet, that is called as glove and stocking distribution. Scratch mark on the body of boyfriend. Yes, while the boyfriend may be smothering the girlfriend, she could scratch in resistance on the body, commonly may be seen on the back of the boyfriend. So, even that is possible. Great. So, in this way we kind of eliminated all the other non possibilities. Even though somebody not knowing what la facie sympathique is, you can eliminate the possibility and still come to the first best correct answer. Okay. With that we come to the end of discussion of these 10 questions. Hopefully the questions were informative for you, and many of you would have known something regarding the questions previously, and this discussion may end up giving you some more addition to your information which already coexist with you. Right. With that I will take permission to go away, but not exactly away, I should say permission to part at this point of time, and we will see each other very soon, probably in our next YouTube discussion. Right. Bye, take care, keep your preparations hard the way you have been doing it, and again best of luck for all the forthcoming examinations. Bye.
मेरा फ़ोन साइलेंट है ना. Okay. Okay, guys, I'm audible. Okay, so good to see you. A lot of students are there. Okay, so first let me have a doubt here. I think there was a doubt. Can you just explain cognizable and non-cognizable offense? Okay, so I think Sumit sir would have explained this better, but let me try this, understand this. Cognizable offense are those like where police can arrest a person without giving any warrant. So most of the, I can say, dangerous crime like a murder, or I can say rape, or I can say a drug dealing, so I can say dowry deaths. So these are cognizable offense, remember. So I think Dr. GMM, I made your doubt clear. For cognizable offense means where there is no need to get a warrant from the court, you can straight away arrest the person. And in a non-cognizable, first you should get a warrant, then we can try to find out the person. Okay, so good evening everyone. So now we'll discuss medicine questions. So I hope so I could give you some information. Okay, I have also created a forensic doubt. Okay, coming back to the first topic, let us see how many of you can answer. Now understand the pattern in this. You can see in medicine you will see a lot of questions in exam. They'll ask you like a clinical based question. So let's start with the first question. So I know like you already know the diagnosis by seeing the case, because this type of question they always ask in exam. Good evening everyone. So first is a 35-year-old young female. That's the biggest hint in the MCQ. So young female present with a rash involving the nose, cheeks, as shown in the image. So with this reading, the first thing that comes into your brain is it could be SLE, right? Okay, then what you can see, there is fatigue, joint pain. So there is fatigue, joint pain. So patient is having fatigue, joint pain. Laboratory test reveals positive anti-nuclear antibody. So ANA is positive. So second hint in the MCQ is ANA positive. So understand this, whenever you are solving a question in like can say an MCA screening exam or PG exam, this clinical case you have to read, you have to make your provisional diagnosis in one shot. So question they are asking, what is most specific antibody for the given condition? Simple. So just try to understand this. It's simple, like we have anti-Smith antibody that is most specific. So answer for this question will be anti-Smith antibody. This is the most specific antibody. So I know like most of you have correct this answer. So let me say anti-Ro. Anti-Ro antibody, this is seen in a patient with Sjogren syndrome. But remember, anti-Ro antibody is also seen in a neonatal SLE. It is also seen in neonatal SLE. And anti-Smith antibody, this is specific for SLE. Specific for SLE. But there is one more antibody that we commonly routinely do in practice, that is called anti-dsDNA. So just I am writing here, anti-dsDNA, this is an antibody. This is not only sensitive, it's also specific. So it is both sensitive, this is specific, and remember this will also correlate with disease activity. Means a person who is having like high titers of this antibody, they will have I can say a poor prognosis. Means जिनकी बॉडी में इस एंटीबॉडी का टाइटर बढ़ा हुआ मिलेगा, उस SLE को ठीक करना बड़ा मुश्किल होता है. So remember this will also correlate with disease activity. This will also correlate with disease activity. Clear? Okay, coming to ANA. ANA, remember ANA is most sensitive for SLE. So a question exam में आता है, they ask you this question like which disease you cannot diagnose without ANA positivity. So it is sensitive for SLE. But remember ANA is like a screening test in most of the rheumatology conditions. Suppose अगर आप सस्पेक्ट कर रहे हैं जॉगरन सिंड्रोम, स्क्लेरोडर्मा या कोई भी रूमेटोलॉजी कंडीशन, तो पहला टेस्ट क्या कराते हैं? आना. सो आना इज स्क्रीनिंग एंटीबॉडी. इट इज स्क्रीनिंग एंटीबॉडी इन रूमेटोलॉजी. सिंपल. सो आना का मतलब है आना है तो रूमेटोलॉजी है. सिंपल. एंटी आरएनपी, द फुल नेम इज एंटी U1 RNP, एंटी U1 राइबोन्यूक्लियोप्रोटीन. So this is seen where, ये कहाँ मिलेगी, कौन बताएगा? Okay, अखिल, विष्णु, गजेंद्र, try to answer. Phoenix, try to answer. Here you will see anti-U1RNP, this is seen in a disease where you will have both features, like we have feature of both SLE as well as some other autoimmune disease, means two or more autoimmune disease in a single person. इसको बोलते हैं mixed connective tissue disorder, MCTD, sorry, mixed connective tissue disorder. So that's in this what we find this anti-U1RNP. Okay, so just let me write here all the antibodies which we know. So this is like a summary. So just let me write ANA. Then I am writing anti-dsDNA. Then I am writing anti-Smith. Then I am writing anti-Rho, anti-La, anti-centromere, okay, anti-P, anti-U1RNP. Okay, then we have anti-topoisomerase, anti-Jo1, then I can say we have AMA, anti-mitochondrial antibody. और कौन कौन से पूछते हैं, they ask you anti-endomysial, anti-TTG, TTG is tissue transglutaminase. Then they can ask you anti-LKM, anti-LCA, anti-SMA. Okay, then they can ask you like Priyanka, Aska, Priyanka, Aska. Then they can ask you anti-CCP, cyclic citrullinated peptide. So these are the important antibodies which from this you will get one MCQ in exam. So just you can take a screenshot of this or you can write it anywhere, very very important. Okay, so ANA, this is, I can say, sensitive for SLE. It is most sensitive antibody for SLE. Anti-dsDNA, this is sensitive, plus I can say this is specific, and I told you this will correlate with disease activity. Correlate with activity. Anti-Smith, come on, this is specific for SLE. Specific for SLE. Okay, I want to add one more, anti-stone. Anyone? Give your participation. Where you will see anti-stone? Batao. Anti-stone, where is it? It is seen in drug-induced SLE or drug-induced lupus. Drug-induced SLE. Anti-Rho. Anti-Rho you will see in Sjogren syndrome and neonatal SLE. Anti-Rho को और क्या बोलते हैं? SSA. SSA means Sjogren syndrome A. Anti-La. Anti-La is seen in Sjogren syndrome. So this anti-Rho and La, basically they are for Sjogren syndrome. Anti-centromere. Anti-centromere we see in a patient with Crest syndrome. Anti-P. P for Pugly. P for Pugly. P for, let me write here, Pugly. So this is responsible. P for psychosis. So P for Pugly in Hindi, psychosis in English. So remember, this is responsible for psychotic features in SLE. Psychotic features in SLE. Okay, they also ask you sometime like which are responsible for neuronal feature. For example, understand SLE patient, if she's having dementia, delirium, or CNS manifestation, that is due to anti-glutamate antibody. But if they ask you psychotic features, that is due to, means she's having hallucination, delusions. U1RNP. U1RNP, this is seen in MCTD. MCTD is mixed connective tissue disorder. Then they can ask you like anti-topoisomerase, this is seen in systemic form of sclerosis. We call it systemic sclerosis. Systemic sclerosis. Anti-Jo1, dermatomyositis and polymyositis. These are two like inflammatory myopathies. ये बताओ, अरविंद कुमार, स्वराज, अखिल, विष्णु, गजेंद्र चौहान, फिनिक्स, GMM, राहुल वर्मा, लाला प्रकाश, try to answer this. बताओ. AMA, anti-mitochondrial antibody. Anti-mitochondrial, come on, come on. Where you will see anti-mitochondrial, कौन बताएगा? Anyone? कोई तो बताओ. Anti-mitochondrial antibody, where you will see. This is seen in a condition called PBC. PBC means primary biliary cirrhosis. It's an autoimmune condition that affects your extrahepatic, mainly your intrahepatic bile duct. Anti-endomycin, anti-TTG. Anti-endomycin, anti-TTG, these are antibodies which we see in a patient with celiac sprue. Anti-LKM is liver kidney microsomal, anti-liver cytosolic antibody is smooth muscle actinin. These are antibody we see in a patient with autoimmune hepatitis. देखो पी अंक का काफ़ी सारी वास्कुलाइटिस में मिलता है, बट हियर आई वांट टू आस्क यू लाइक अबाउट विच GIT कंडीशन. सो रिमेंबर इट इज सीन इन अल्सरेटिव कोलाइटिस. आस्का is anti-Saccharomyces cerevisiae antibody. It is seen in Crohn's disease, and some association with ASCA is seen in a patient with Behcet syndrome. And anti-CCP, this is the investigation of choice in a patient with rheumatoid arthritis. So मैंने अभी जो आपके सामने लिखा, this is one question in this attempt, believe me, because exam के बाद I'll do the recall session, then I'll show you the same screenshot. So it's very very important. Clear? Okay, आगे चलें. Okay, so let's move to next question in front of you. Try to answer this. 28-year-old pregnant female. Pregnant है. History of SLE. Present for routine prenatal care. Laboratory tests reveal the presence of anti-phospholipid antibody. So now whenever I read this question, so मेरे मन में diagnose बन गया, this is Apla syndrome. And Apla syndrome, that is due to SLE or due to other condition, we call it secondary Apla syndrome. So question is, which of the following is most commonly associated with this? So whenever we see this topic Apla syndrome, like be it in gynecology or in medicine, ये दोनों जगह पढ़ा जाता है topic. So understand this, in Apla syndrome, the main feature of Apla syndrome is, you have to remember, like here patient will have 3 or more recurrent abortion. Or it could be sometime a preterm birth of baby, or sometime it could be like a patient is having. So there should be, I can say, history of any vascular issues. Like history of vascular issues means it could be pulmonary embolism in past, or I can say history of DVT, history of brain stroke. Along with this, you will see that there should be positive antibody. Antibody कौन सी होती है Apla syndrome में? We have anti-cardiolipin. Lupus anticoagulant, and anti-beta-2 microglobulin. Beta-2 glycoprotein, sorry. Now understand this. अब पेशेंट को क्या हो रहा है? जनरली रिकरेंट अबॉर्शन हो रहा है, बार बार अबॉर्शन हो रहे हैं, मिसकैरेज हो रहा है. So that is a hallmark feature of the disease. So remember, gestational diabetes is a separate disease. It is having no relation with Apla. So means a patient is absolutely normal. Whenever like she is becoming pregnant, she is diagnosed with diabetes. जैसे ही pregnancy हुई, उसके बाद diabetes हो गई. So इसके लिए हम क्या करते हैं? For this we do OGTT, oral glucose tolerance test. Now understand, in Apla syndrome you can get premature delivery generally. Premature delivery हो सकती है. There could be like recurrent miscarriage, or there could be like stillborn baby. So ectopic नहीं होती. Ectopic pregnancy is not seen. Premature delivery is possible, लेकिन preterm labors are usually not seen. So miscarriage जो बार बार हो रहे हैं, that could be due to placental abruption, because placental abruption, you can see this is a hypercoagulable state, and placental abruption is due to a clots formation or hypercoagulable state. So I know many of you have marked the answer preterm labor, but that is not correct. इसकी जगह अगर premature delivery होती, then I could be thinking of that option, but it is placental abortion that is leading to recurrent miscarriage in the patient. Clear? ओके गजेंद्र एंड कुमार विष्णु, कोई बात नहीं, गलती यहाँ पर हो गई, वहाँ नहीं होनी चाहिए. इज क्लियर? ओके, लेट्स मूव टू द नेक्स्ट वन. ओके, लेट्स सी अनदर वन. 35-year-old पेशेंट, फिर से SLE, known history of systemic lupus erythematosus, present with progressive dyspnea. Progressive dyspnea, तो पेशेंट की सांस फूल रही है. Then you can notice like this patient is having chest restrictive pattern on pulmonary function test. So there is restrictive pattern. Restrictive pattern means if you see FEV1 FVC ratio, that is I can say that is normal. वो कम नहीं हो रहा है. In obstructive you will see that is reduced. Then you can notice chest imaging reveals a significant decrease in lung volume. Significant decrease in lung volume, but normal parenchyma finding following is what is the most common diagnosis. Okay, let's say this question. Okay, so in SLE what we can see, पहले इसको आपको पता होना चाहिए SLE के अंदर lungs के अंदर क्या क्या features आते हैं. So if you know these things, what are the features of SLE in lungs? So SLE patient in lung, remember they can develop pneumonia. They can develop pneumonia, or we can say like a non-specific interstitial pneumonitis, that we call an SIP. Then SLE patient, they can develop ILD-like picture, interstitial lung disease-like picture. And they can develop a complication called shrinking lung syndrome. Shrinking lung syndrome. ओके, पल्मोनरी एम्बोलिज्म कोई हाइपरकोगुलेबल स्टेट नहीं है, कोई एट्रियल फिब्रिलेशन की हिस्ट्री नहीं है, सो दैट इज़ अनलाइकली. सो पल्मोनरी एम्बोलिज्म इज़ नॉट सीन. पल्मोनरी एम्बोलिज्म कब हो सकता है? व्हेन SLE is with Apla syndrome. Otherwise in simple SLE it is not given. Any history of like pregnancy is not given. So embolism is unlikely. Now biggest hint in the question is you can see restrictive pattern. और restrictive pattern तो सब में मिल सकता है in ILD, in shrinking lung syndrome. So restrictive pattern is seen, right? And then you can see like a decrease in lung volume. Then see the next hint. Normal parenchymal findings. Okay, see once again. अगर lung में fibrosis होती, if it could be pulmonary fibrosis, then there could be ground glass opacity, there could be fibrosis in the interstitium. So कहीं ना कहीं fibrosis दिखती. There could be attenuation, right? There could be fibrosis. So pleural effusion तो कहीं से कहीं तक नहीं है, पानी तो नहीं बढ़ रहा, right? You cannot see. There is no pleural effusion. So this is like a case what we call the shrinking lung syndrome. And how we make a diagnosis of shrinking lung syndrome? Understand this. Whenever you see like normal parenchyma, means कोई fibrosis नहीं है, फिर भी lung volume reduce हो रहे हो और restrictive pattern, this is what we call the shrinking lung syndrome. And they ask you like one liner पहले पूछते थे, आजकल उसी को clinical case बना के पूछ रहे हैं. So understand that shrinking lung syndrome is nothing, it is where you can see lungs become squeezed, but there is no as such fibrosis, but still patient will have restrictive type of pattern. Am I clear? तो आपको याद रखना है shrinking lung syndrome that is seen in SLE. Okay, अब सारे lungs अलग अलग टाइप के lungs पढ़ लेते हैं. So let me say who can answer. What is blast lung? Blast lung, or I can use the term shock lung. What is black lung? Then I can say shrinking lung. So understand this, blast lung, shock lung, we call this as ARDS, acute respiratory distress syndrome. That is your blast lung or shock lung. Black lung is pulmonary coal worker pneumoconiosis. It is due to coal. And shrinking lung, this is seen in SLE patient. This is seen in SLE patient. So these are the different types of lung manifestation which you have to remember. Any doubt? आगे चलें. लाला प्रकाश, गजेंद्र एंड कुमार, विष्णु. ओके, सो अगले क्वेश्चन पे चलते हैं. सो यू हैव इन फ्रंट ऑफ यू. अब देखो आपको भी ऐसे क्वेश्चन को सॉल्व करना है द वे आई एम डीलिंग विद दिस क्वेश्चन. सो जस्ट लुक एट द क्वेश्चन केयरफुली. फर्स्ट हिंट इन द MCQ इज एज. तो 50 साल का है पेशेंट. तो पेशेंट इज 50 year old. Then you can say clinic complaint of fatigue, weakness, pale skin. So fatigue, weakness, these are like non-specific finding, but pale skin is a good hint. So pale skin is a good hint that they can ask you in exam. Right? Now understand, they are asking you a question like there is laboratory investigation reveals low hemoglobin. Hemoglobin kam hai. So there is low hemoglobin, low serum iron, low transferrin saturation and normal to high ferritin level. Normal to high ferritin level. Past patient is having history of rheumatoid arthritis. So again, this is a very good hint in exam. History of rheumatoid arthritis for the past 15 years. 15 years means that's a long history. Following is most likely cause of anemia in this patient. Okay, अब इसको देखो पहले just try to understand this. Rheumatoid arthritis is a condition which is an autoimmune condition. So understand, in rheumatoid arthritis you can see patient can develop different manifestation. So what patient can develop? There are all three types of anemia possible. So what are these all three types of anemia possible in rheumatoid arthritis? Understand, rheumatoid arthritis initially patient will have iron deficiency anemia, because understand this, whenever patient is diagnosed with a chronic condition, they will eat less, there is nutritional deficiency, there can be some blood loss, and sometimes you can see like old people, they have GI hemorrhage, they have poor nutrition absorption. So iron deficiency is common. Then whenever disease is chronic, then remember this anemia will become AOCD, anemia of chronic disease. And in rheumatoid arthritis, the treatment of choice, the drug that we use is methotrexate. So whenever you are using methotrexate, you know methotrexate is dry hydrofolate reductase inhibitor. So methotrexate जैसे आप दोगे ये फॉलिक एसिड को कम करेगा, तो इसीलिए हम क्या करते हैं, methotrexate के साथ में फॉलिक एसिड का सप्लीमेंट देते हैं. So methotrexate will cause folic acid deficiency. So that's why patient can also develop folic acid deficiency anemia, and folic acid deficiency anemia is megaloblastic. Clear? अब मेरी बात ध्यान से चलो, ध्यान से सुनो, whenever I see this, iron deficiency is microcytic. AOCD is normocytic. Folic acid deficiency, folic is macrocytic. So rheumatoid arthritis में you can get all three types of anemia. और अगर patient Indian है, non-veg नहीं खाता, Indian female है, then B12 deficiency can also be seen. So whenever you see this question, they are asking like what is the diagnosis. So first try to understand this. Let us not rush into this question. Hemolytic anemia ये नहीं होगा. This I have ruled out. Why I have ruled out? I know. Okay, I agree with the answer. Your answer is correct. But मैं कुछ और बताना चाह रहा हूँ. Hemolytic anemia, you will see they will give you some hint like there will be increase in reticulocyte count, or they can give you like increase in bilirubin level. So ऐसे कुछ hint नहीं दिया हुआ है. Or they can give you increase in the level of LDH. Or what else they can give? They can give you like patient is having low haptoglobin. So ऐसी कोई hint तो नहीं दिख रही. So that is not the answer. Now B12 deficiency भी नहीं है, because there is no vegetarian history, there is no usage of methotrexate, तो folate भी नहीं है. So answer is either A and C. So what I want is, I want you to remember there are three differential which you should keep in mind. First is iron deficiency anemia. Second is AOCD. And third is sideroblastic anemia. Sideroblastic anemia. So all these are microcytic anemia, right? All these are microcytic anemia. So in all these three, what you will see MCV value will be less than 80. So understand, sometime we have to be sure, like these are those questions जो आते हैं तो आते हैं, नहीं आते तो नहीं आते. So these are very straightforward questions. So we have to differentiate three parameters. First is called that is stored form of iron. That stored form of iron is called serum ferritin, right? So you can see this is serum ferritin, stored form. Then we should remember TIBC, total iron binding capacity. So you can see here TIBC, that is transferrin saturation is given. Then we can say serum iron. So just try to understand this and draw this once with me and once without me. आपको दो बार बनाना, you will never confuse. And listen to me. First statement which I am writing here is iron deficiency anemia में सबसे पहले body से store की कमी होती है. That is why in treatment we give 500 to 1000 extra iron to replenish the store. सबसे पहले store कम होता है iron deficiency anemia में. So सबसे पहले क्या गया? Store. First thing to decrease is store. That is serum ferritin. And always remember this statement, like whenever I use the word serum ferritin, this ferritin will be inversely proportional to TIBC. तो TIBC कैसा होगा? जब ferritin कम हो गया तो TIBC बढ़ जाएगा. So पहले store जाएगा, फिर serum का iron जाएगा, serum iron is reduced. Clear? Now understand, sideroblastic anemia इसके उल्टा होता है. It is iron overloaded state. Iron ज़्यादा है लेकिन use नहीं हो पा रही है. So more iron in the store, more iron in the serum, and this ferritin will be inversely proportional to TIBC. Simple. Now coming to AOCD, understand this. Anemia of chronic disease, इसमें क्या होता है? So sideroblastic, I can say this is like iron overloaded state. And ID, I can say first to decrease will be serum. First to decrease will be serum ferritin. That is store form. And anemia of chronic disease, it is like nothing. It is like COVID में जो lockdown हुआ था. So that same lockdown is going on into your body. Means body is having a lot of iron, but chronic inflammation will release hepcidin, that is a regulator of iron metabolism. Then they will release the macrophage, and these macrophage, what they will do? These macrophage, they will trap and bind all the iron in the store. So सारा का सारा iron store में जमा हो गया, store से बाहर नहीं जा पा रहा है, और फिर यहाँ पर क्या हो गया? ताला लगा दिया. So entire iron is bound in the I can say store. So store form तो बढ़ जाएगा, store form will be more. And I told you ferritin will be inversely proportional to TIBC, and serum iron will be reduced. Now let us see what it is written. I have written here serum iron is decreased, TIBC is decreased, and ferritin can be increased. So let us see this here. You can see low transferrin saturation, which means your TIBC. Then you can see low serum iron and high ferritin level. So this is a case of AOCD, anemia of chronic disease, right? Okay, it's good like you have diagnosed this in one shot. अच्छा लगा, because ऐसे question बच्चे नहीं कर पाते हैं. This is one of the difficult questions. So remember, just practice this once. तो क्या याद रखना है? Iron deficiency always first to decrease is store. Anemia of chronic disease, सारा का सारा कहाँ हो गया? Lockdown. And then remember, sideroblastic, iron overload state. Am I clear? Okay, so coming to next one. Try to understand this question. Okay, पहले आंसर बताओ, उसके बाद आगे बात करेंगे. What you can see first, if you see this image, what you can see when they are highlighting the image, so you can see spherical RBCs. Spherical RBCs are called spirocytes. So when I see this image, I can say spirocytes. These spirocytes, where you will see ये वाले जो arrow पर दिखा रहे हैं, these are spirocytes. Spirocytes, you can see the most common cause is AIHA, autoimmune hemolytic anemia. This is most common cause. Then it can be seen in a condition called hereditary spirocytosis. So these are two case-based scenarios. Now they are asking you a question like, now see, let us see the question. A 25-year-old female present to emergency department with fatigue, jaundice, splenomegaly. Fatigue, jaundice, very very important. Jaundice आ गया, देखो jaundice means, मैंने भी क्या बताया थोड़ी देर पहले, मैंने भी बताया था, just I told you, when there is increased bilirubin can manifest as jaundice. और RBC टूट रही है तो स्प्लीन का साइज बढ़ेगा. So these two are giving you hint like it's a hemolytic anemia. Family history is positive, means father had similar disease. It means it's a genetic condition. So अब देखो AIHA is not a genetic condition, तो diagnose मिल गया मुझे HS, hereditary spirocytosis. AIHA is acquired. AIHA is autoimmune condition. Peripheral blood smear I have shown in the figure. Then an osmotic fragility test is in condition will show which of the following changes. So that is the question which they are asking. अब इसको देखो एक बार. What is this osmotic fragility test? So you have to remember this test. So in this test, what we can see, you can see like normal range. So whenever we put isotonic saline, so there are some RBCs, some RBCs which are fragile RBCs, some RBCs which are fragile RBCs, and some RBCs which are rigid RBCs. Fragile RBCs, then we have rigid RBCs. These fragile RBCs, whenever you put these RBCs in isotonic saline or hypotonic saline, they will swell and they will burst. So whenever you see like a patient is having fragile RBCs, where we see in a patient with hereditary spirocytosis. So this is first type of RBCs, and this is second type of RBCs. We call them normal RBCs. So normal RBCs means they will also allow water to go inside them. They will swell after a particular time, then they will burst after a particular time. But if you see fragile RBCs, they will burst quickly. And rigid RBCs, these are seen in a patient with thalassemia, and sometime in a patient with even with sickle cell anemia. So for exam purpose, you have to remember thalassemia. Now when you see this graph, they can also ask you, like nowadays exam is becoming more difficult, they can also ask you this graph. So in this graph you can see any RBCs which is osmotic fragile, this will shift the curve. This will shift the curve to the right side, right? So any RBCs which is osmotic fragile, this will shift the curve towards right side, and any RBCs which are I can say which are strong, which are rigid, they will shift the curve toward left side. So no shift is seen in normal RBCs. So let me just write this. No shift you will see in normal RBCs. Then I can say bimodal distribution. This is very rarely seen. Like it's very rarely seen, like with a condition called hereditary elliptocytosis. Then if you see like shift to left, right? The shift to left, this is seen in a patient like who have thalassemia and who have sickle cell anemia, and shift to right you will see in hereditary spirocytosis. So this is something which you have to remember. So correct answer for this question will be shift to right. Am I clear? Shift to right. So what you have to remember, this test they ask in exam. So let me just write this in front of you. The question they want to put in front of exam is, this is like a little difficult question, but they ask you is test, the full name is Nest-Troft test. Nest-Troft test, this question have been asked multiple times. Nest-Troft test is naked eye, single tube RBC osmotic fragility test. Nest-Troft test. This Nest-Troft test we use for two conditions. This is used in the screening purpose. It is used in screening of I can say thalassemia, and it is used like in diagnosis of hereditary spirocytosis. Hereditary spirocytosis. So these are the two questions which previously came in FMGE exam. That's why they are important. Nest-Troft test, naked eye single tube RBC osmotic fragility test. Okay, when I talk about hereditary spirocytosis, understand they ask you few more questions. What are other tests? How we make a diagnosis? So remember. So here you will see spherical RBCs. So this is mainly a defect of ankyrin. So mainly it's a defect of ankyrin. Then remember here you will see a classical feature, like patient will have increase in MCHC. Then treatment of choice for this condition will be splenectomy. And to make a diagnosis, like we can do some other tests, like nowadays the best is what we have is what we call eosin 5 melamide test. We call this eosin 5 melamide test. Then we can also perform ECTA cytometry, and treatment of choice will be splenectomy. So these are the MCQs that they ask in hereditary spirocytosis. Okay, coming to next question, just try to answer this. Okay, this question is again a big question. So this is, I am just trying to adapt to these bigger questions. So let us try this one. 60-year-old male, age is important, with chronic history of abdominal pain, heartburn and dyspepsia. So whenever I see this question, so I will write something in my brain. I will write GERD. It could be GERD. An upper GI endoscopy done to look for underlying pathology. So now what we can see in upper GI endoscopy, no evidence of any peptic ulcers. No evidence of any peptic ulcer means peptic ulcer disease have ruled out. But there is reddish mucosa extending proximally from GE junction into esophagus. So look at this. This is here you can see a reddish mucosa. So here from GE junction, this is your GE junction, gastroesophageal junction, and from here this is moving upwards. So what you can see this is lower 1/3 of esophagus, and this lower 1/3 esophagus GE junction, what we have discussed, what we have studied this could be Barrett. So I am writing a question mark, it could be Barrett. Barrett esophagus, most common site, it could be GERD. But GERD, remember, GERD is something which all of us can have, right? When they have given you like a pathology slide and everything, now let's see. Biopsy of this area. Do you do biopsy in GERD, normal GERD? No, we don't do. Which showed finding in the given below. Following is true regarding this condition. Again, a good question. Try to answer this. They are asking me the true question. First, try to answer. Lala, N. Kumar, GMM, Devil Killer, Gajendra Chauhan, Phoenix. Try to answer. Come on, guys. Come on. कोशिश तो करो. तो मैंने डायग्नोस बना दिया आपका. इट कुड बी Barrett esophagus. नाउ डोंट अफ्राइड ऑफ दिस बिगर क्वेश्चन. बड़े क्वेश्चन से बस आपको क्या याद रखना, जो आपको याद है. जितना आपको याद है उतना मुझे याद है. Barrett is having risk of adenocarcinoma. Am I right? Barrett में आगे जाके एडिनोकार्सिनोमा की रिस्क होगी, तभी तो बायोप्सी करेंगे. So it's a case of adenocarcinoma. It could be like a Barrett converting into adenocarcinoma. Now understand this. Now you can see सर ये पैथोलॉजी की स्लाइड समझ में नहीं आ रही है, मुझे भी नहीं आती, बट क्वेश्चन तो समझ में आ रहा है ना. लुक एट द क्वेश्चन केयरफुली. सो okay, let us see option. Finding high grade dysplasia mandated further intervention. So option 1 is telling you कि अगर high grade dysplasia आ रहा है. Dysplasia high grade कब बोलते हैं? जब न्यूक्लियस का साइज बड़ा होता है, when nucleus size is bigger, तब आपको आगे इंटरवेंशन करना है. ऑफ कोर्स करना चाहिए. सो दिस इज अ ट्रू स्टेटमेंट. आई एम राइटिंग अ ट्रू, राइट. उसके बाद लिख रहा हाई डोज पीपीआई ऑलमोस्ट ऑलवेज कॉजेस रिग्रेशन ऑफ म्यूकोसल एबनॉर्मलिटी. हाई डोज पीपीआई से आप क्या ठीक कर सकते हो? यू कैन ट्रीट GERD, यू कैन ट्रीट GERD, यू कैन ट्रीट जोलिंगर-एल्सन सिंड्रोम. लेकिन एक बार एपिथेलिया कन्वर्ट हो गया, एडिनोकार्सिनोमा हो गया है, तो पीपीआई से कुछ ठीक नहीं होगा. पीपीआई को क्या बोलोगे? बाबा जी का ठुल्लू. कुछ ठीक नहीं होगा पीपीआई से. पेशेंट इज एट इंक्रीज रिस्क ऑफ स्क्वेमस सेल. देखो ये तो गलत स्टेटमेंट है. पेशेंट इज एट रिस्क ऑफ एडिनोकार्सिनोमा ओनली. सो दिस इज नॉट द आंसर. गोल्ड स्टैंडर्ड इन्वेस्टिगेशन इज बेरियम स्वॉलो. ये तो बिल्कुल समझ में नहीं आया क्वेश्चन. अंडरस्टैंड दिस. गोल्ड स्टैंडर्ड इन्वेस्टिगेशन. सो जस्ट आई एम राइटिंग. अगर गोल्ड स्टैंडर्ड की बात करी जाए, so gold standard test for GERD, this will be your 24 hours pH monitoring. GERD में तो आपको pH मॉनिटर करना पड़ेगा. और अगर कैंसर की बात करी जाए, और इफ़ यू आर सस्पेक्टिंग ऑफ Barrett कैंसर में कन्वर्ट हो जाता है, then कोई भी कैंसर के लिए द गोल्ड स्टैंडर्ड इज ऑलवेज बायोप्सी. Am I clear? So गोल्ड स्टैंडर्ड इज बेरियम स्वैलो, और बेरियम स्वैलो तो गोल्ड स्टैंडर्ड एक्लेशिया के लिए भी नहीं होता. दैट इज जस्ट इनिशियल इन्वेस्टिगेशन. तो दिस इज नॉट द आंसर. तो ट्रू स्टेटमेंट इज ओनली ए, कि अगर आपको आगे जाके इफ यू आर गेटिंग हाई ग्रेड डिस्प्लेशिया, देन यू शुड ऑलवेज फॉलो दिस, यू शुड ऑलवेज डू बायोप्सी इन दिस पेशेंट. Am I clear? ओके. सागर, गजेंद्र, GMM, तोरा साहू, ऋचा, सुरभि, फिनिक्स, लाला प्रकाश. आगे चलें. समझ आया? क्वेश्चन सिंपल था. इट वॉज एन ईजी क्वेश्चन. अगर इसी पर घूमते रहोगे कि स्लाइड समझ में नहीं आ रही, तो ये तो नहीं आती किसी को भी समझ में. सम चेंजेस इन एपिथेलिया यू कैन सी हियर, दैट्स इट. बट अगेन the clinical history is enough to make a diagnosis and to treat the patient. Okay, then this is a question which they ask from forest classification. So simple question है ये भी. Actually this topic is something which they are routinely testing in exam. So let us see this question what they are asking. A 40-year-old male who is a chronic alcoholic, chronic smoker with 3 episodes of hematomesis, 3 बार खून की उल्टी हुई है since morning. Patient also had complaint of epigastric pain for last 1 week. एक हफ्ते से पेट में दर्द हो रहा है. He has been taking diclofenac almost daily for the back pain for the last month. तुम मुझे डायग्नोसिस बताओ. His hemoglobin came to be 10.2. Initial basic management is done and is taken for upper GI endoscopy. Following is not true about the risk of rebleeding without intervention. So first tell me the diagnosis. Diagnose बताओ. I am asking you to make a diagnosis. So understand this, whenever you are doing practice, you should make a diagnosis. Diagnosis is very, very important. दवाई कोई भी दे लेता है. हिंदुस्तान में दवाई फार्मासिस्ट भी देते हैं, BHMS, BMS, लेकिन डायग्नोस सब अच्छा नहीं बनाते. That is what you are studying MBBS and that is what you should be proud of. So diagnosis करना एक आर्ट होता है. So this is like a patient is having peptic ulcer, right? Or it could be gastritis. एंड पेशेंट जब 1 महीने से पेन किलर खा रहा है, NSAID, डिक्लोफेनाक इज NSAID, दिस इज NSAID इंड्यूस, दिस इज NSAID इंड्यूस. एम आई क्लियर? और बाकी रिस्क फैक्टर साथ में क्या है? क्रोनिक अल्कोहलिक है, क्रोनिक स्मोकर है. तो दीज आर एडिशनल फैक्टर्स. तो दिस इज द डायग्नोसिस. अब NSAID की वजह से गैस्ट्राइटिस हो रही है या पेप्टिक अल्सर, दैट अल्सर इज ब्लीडिंग. वो अल्सर ब्लीड कर रहा है और उस ब्लीडिंग की वजह से क्या हो रहा है? पेशेंट का हीमोग्लोबिन कम हो रहा है. Am I clear? So diagnosis clear. So once you know this thing, now you should know like whenever there is a GI bleeding, in this case what we see forest classification. So ये आपको पढ़ना है. So understand this. These are based on endoscopic appearance. Suppose in endoscopy you will see like any active bleed, then there is 90% chance of rebleeding. If you see like in a patient who is having oozing of blood, some oozing is there, endoscopic finding ka classification is what we call this forest classification. Oozing of blood, then there is 10 to 14% chance. Non-bleeding vessels are visible, 50% chance, that is called 2A. Then adherent clots are visible, then there is 33% chance. And you see like a flat spot, we have 10 to 25% chance, and clean base only 3% chance. So let us apply this forest classification in our option here. Look at the screen. Suppose if I say adherent clot, अब मुझे बताओ adherent clot in this ulcers, how much chance they have? Adherent clots covering the ulcer base have around 30% risk of bleeding. So adherent clot you will see they are having 33%, 33 almost close. So this is a correct statement. So I am writing C for correct. They are asking not true. Flat pigmented spots covering the ulcer base will have about 10 to 20% risk of rebleeding. So you can see flat pigmented spot, 10 to 20, 10 to 25, almost same. So again, this is also a correct statement. A clean base ulcer is associated with very low risk of bleeding. So clean base, very low risk, that is 3% is very low. This is also correct. So these three are correct statement. Risk of rebleeding is about 90% if there is oozing of blood from the ulcer base. If there is oozing, there is only 10 to 14%. 90% seen whenever there is active arterial spotting. Is it clear? So correct answer for this question will be D. So I don't know why, but this is the topic like which once in a 3-4 year this topic they ask in FMGE exam. So that is like about forest classification of because this is like a topic you have studied in surgery as well. So this is very important. They sometime ask you a question on this topic. Simple. Okay, आगे चलते हैं. A 56-year-old man with history of chronic alcoholism presented with steatorrhea. Steatorrhea means when your stool fat content is more than 7 gram. Means fatty stool. 56 की एज है, एब्डोमिनल पेन हो रहा है, chronic alcoholic history है. On CT abdomen pancreatic calcification is seen. Pancreas में calcification हो रहा है. Diagnosis of chronic pancreatitis was made. As an intern posted in emergency, you suggested octreotide. As it mimics the action of hormone X and will reduce the pancreatic secretion and possibly patient pain. What is X? So I think this became now a pharmacology question. Am I right? So कुछ नहीं, क्वेश्चन बस आपसे ये पूछ रहा है कि octreotide कैसे काम करता है. So it resemble which action, which hormone? बताओ. Easy है? Yes, it is a somatostatin analog. somatostatin analog. So we have octreotide and lanreotide. These are somatostatin analog. So this is like this hormone X will be. देखो सिंपल क्वेश्चन को बड़ा कर दिया अननेसेसरी. क्या पूछना क्या चाह रहे हैं? व्हाट दे आर आस्किंग व्हाट इज द मैकेनिज्म ऑफ एक्शन ऑफ ऑक्ट्रेओटाइड. सिंपल. व्हाट एल्स दे कैन आस्क यू, दैट इज मोर इम्पॉर्टेंट. और क्या पूछा जा सकता है आपसे? दे कैन आस्क यू व्हाट आर अदर यूजेस ऑफ ऑक्ट्रेओटाइड. सो ये आपको याद रखना है. 5 प्रॉब्लम 1 सॉल्यूशन. ऑक्ट्रेओटाइड वी यूज in a patient with gastrinoma. It is used in a patient with gastrinoma. Octreotide we can use in a patient with glucagonoma. Octreotide we use in carcinoid syndrome. Also octreotide we use in esophageal varices, and remember, just I am writing in bracket, in bleeding varices. Those esophageal varices which are bleeding, जो bleed कर रही हैं, in treatment of varices, in bleeding or I can say in treatment. Prophylaxis में आपको beta blocker देना, that's proper role. And fifth is octreotide we can also use in acromegaly, very very important. Clear? तो याद हो जाएगा. Octreotide, so we have these other uses: gastrinoma, glucagonoma, carcinoid, esophageal varices, acromegaly. Am I clear? And sometime like the CLD patient, they can develop hepatorenal syndrome. So just this 4 and 5 varices, and I can say HRS. HRS is hepatorenal syndrome. So hepatorenal syndrome में भी क्या होता है? Bleeding, esophageal bleeding होती है, इसलिए हम इसको यूज़ करते हैं. That more or less same condition, but they can ask you in different way as well. So Ashutosh, Gajendra, Lala Prakash, Manju Prasad, am I clear? This is about octreotide. Am I clear? Okay, so आगे चलते हैं अगले क्वेश्चन पे. लेट्स गो टू द नेक्स्ट वन. देन व्हाट वी हैव 15-year-old boy presented to medicine OPD with complaint of diarrhea for the last 6 weeks. 6 हफ्ते से डायरिया हो रहा है. So whenever you see like it's a patient having diarrhea from last 6 weeks, so this is like chronic diarrhea. So diagnose बन गया chronic diarrhea. देखो एक्यूट डायरिया जनरली कैसे होता है? इन्फेक्शन से होता है. 90 to 95% केसेस में एक्यूट डायरिया इन्फेक्शन से होता है. यस, डॉक्टर मिट्रॉइड टर्लीप्रेसिन भी यूज़ करते हैं. टर्लीप्रेसिन एंड ऑक्ट्रेओटाइड बोथ आर यूज्ड हियर. दोनों यूज़ करते हैं. जो अवेलेबल है बोथ आर इक्वली प्रेफर्ड इन esophageal varices and HRS, hepatorenal. In this we can use either octreotide और टर्लीप्रेसिन. दोनों यूज़ करते हैं. और अगर सपोज आपने ऑक्ट्रेओटाइड ट्राई कर लिया, टर्लीप्रेसिन ट्राई कर लिया, उसके बाद भी ब्लीडिंग नहीं रुक रही है, देन यू विल सेंड अ पेशेंट टू लाइक अ गैस्ट्रोसर्जन फॉर एंडोस्कोपिक वेरिसियल बैंड लाइगेशन. उसके बाद आपको क्या करना है? बैंड लाइगेशन. ओके, कमिंग टू दिस फ्लक्चुएटिंग बाउल फ्रीक्वेंसी. स्टूल वॉज ग्रीसी. ग्रीसी है, चिपचिपा है, स्टिकी है, फाउल स्मेलिंग है, फ्लोटिंग ऑन वाटर. पानी में तैर रहा है. पानी में कब तैरेगा? जब फैट होगा, फैट कंटेंट होगा. तो स्टीएटोरिया भी है. His skin was dry and lusterless. ये तो डायरिया की वजह से हो जाती है. ड्राई स्किन. Hair thinned out, again that's a sign of, these are signs of dehydration, and became a golden brown color. Following option is true regarding chronic diarrhea. Right? Okay, now understand. So पहले देखते हैं इसको. First option in this question is secret diarrhea is large volume water diarrhea which relieves on fasting. इसको समझो एक बार. Secretory diarrhea fasting से relieve नहीं होता. Right? This is something like it will continue even in fasting. Is it clear? इसकी जगह जो osmotic diarrhea जो होता है, that osmotic diarrhea, that will stop with, that will relieve with fasting. So this is not a correct statement. Then what we have, then we see NSAID should be avoided in patient with secret diarrhea due to large colorectal villus adenoma. Okay, इसको देखो एक बार. Now understand, अगर कोई colorectal cancer है, colorectal cancer क्यों होते हैं? They are because of more expression of COX-2 gene. Right? COX-2 gene का over expression होता है. और अगर आप NSAID देते हो तो NSAID क्या होते हैं? COX-2 inhibitor. तो अच्छी बात है, देना चाहिए. So NSAID should not be avoided. In fact, we should give. So कई बार colon cancer में remember what we give? We give aspirin to prevent colon cancer because aspirin is irreversible cox inhibitor, and aspirin is NSAID. So this should not be avoided. Steatorrhea is defined as by stool fat more than 11. No, it is defined as when stool fat is more than 7, not 11. So these three are wrong statement. Indians are more prone to have lactase deficient diarrhea compared to white population. That is correct. This is correct. So remember, Indians are more prone for this thing because like we have some sort of disaccharidase deficiency and we have huge consumption of milk. So we have more population. That's why if you see like our population number wise also we have more cases. But other options are wrong in this. So remember, this is very very important. So remember, steatorrhea, stool fat more than 7%. Okay, अगले क्वेश्चन पे चलते हैं. अब तुम बताओ डायग्नोसिस फर्स्ट. 40-year-old female present with progressive muscle weakness. 40 साल की फीमेल है, प्रोग्रेसिव मसल वीकनेस. कैरेक्टरिस्टिक स्किन रैश, स्किन पर रैश आ रही है. एलिवेटेड क्रेटिन काइनेस लेवल. तो फर्स्ट इन द एमसीक्यू इज CK और आई कैन से CPK, क्रेटिन फॉस्फोकाइनेस, ये बढ़ा हुआ है. एंटी-Jo1 एंटीबॉडीज बढ़ी हुई है. तो डायग्नोस तो बन गया आपका. What is the diagnosis? Okay, दे दिया diagnosis. Dermatomyositis is given. Following is not a feature. So in dermatomyositis, so this is the diagnosis, dermatomyositis. You will see some of the skin manifestations. तो वो क्या क्या manifestation होते हैं? Okay, so understand. In dermatomyositis, what are the skin changes? So let me write those skin changes. क्या क्या मिलेगा patient को? First thing you will see, like patient will have a rash that is seen in an area जैसे जहाँ female shawl उड़ती है, for example यहाँ पर, right, in the I can say left or right border, I mean upper border of breast, then you can see in the scapular area. So यहाँ पर shawl उड़ते हैं, उसको बोलते हैं shawl sign. Second, you will see like patient will have a rash here in the V area, जहाँ पर V neck t-shirt पहनते हैं, so we call this V sign. Third, these patients they will have rash in the sleeves area, जहाँ पर sleeves होती हैं हमारी, we call the sleeve sign. Simple है. The shawl उड़ते हैं, shawl sign. V neck t-shirt, V sign. Sleeve पहनते हैं, sleeve sign, sleeve sign. Then these patients you can see like they will have a rash. Orbit के पास एक rash होगी, उसको बोलते हैं heliotropic rash. Heliotropic rash. What else? You will notice like they will have papules, they will have a rash in the knuckles. तो उसको बोलते हैं Gotron papules. Gotron papules. Then if you see like their nails will have this some I can say नाखून के पास थोड़ी थोड़ी capillaries बढ़ जाएंगी. We call this periungual telangiectasia. But this is non-specific. ये और भी जगह बढ़ता है. What are more specific is Gotron papules and heliotropic rash. These two are more specific. Then lastly I can say like these patients, अगर आप देखोगे इनके हाथ एकदम टाइट हो जाएंगे like a mechanic. So we call this mechanic's hand. Mechanic's hand. So these are all MCQs of dermatomyositis, which is a condition that is due to anti-Jo1 antibody. So let's see now. Periungual telangiectasia होता है, yes. Mechanic's finger, yes. Gotron's papule, yes. Salmon patch नहीं होता. So it is like Salmon patch is a type of nevus. So Salmon patch is not seen. Clear? So answer will be A. Okay, 45-year-old male with a diagnosis of Burkitt lymphoma. 45 ईयर में बुर्किट लिम्फोमा ज़्यादा कॉमन तो नहीं होता, लेकिन अब क्वेश्चन में बना दिया उन्होंने तो हो सकता है. इट्स लाइक रेयर इन दिस एज ग्रुप. एमएच डिपार्टमेंट में आया. देखो सबसे बड़ा हिंट इस क्वेश्चन में है एमरजेंसी डिपार्टमेंट. ऑन्कोलॉजी, इन ऑन्कोलॉजी पेशेंट रेयरली कम टू इमरजेंसी. There are generally two main oncological emergency. First is SVC syndrome, superior vena cava syndrome, and second is tumor lysis syndrome. Is it clear? For the initiation of chemotherapy, on the second day of chemotherapy, patient develop acute renal failure. दूसरे ही दिन acute renal failure. Laboratory investigation were done and a diagnosis of tumor lysis syndrome was made. क्वेश्चन में पूछा है एक्सेप्ट, जो आप हर बार एग्जाम में नहीं देखते. इट्स वेरी वेरी इंपॉर्टेंट. यू शुड सी ऑल एक्सेप्ट. फिर से देखो क्वेश्चन, एन कुमार फिर से देखो. एक्सेप्ट पूछा है, what is not seen in tumor lysis syndrome. So remember, in tumor lysis syndrome, you will see increase in all ions. सब कुछ बढ़ेगा एक्सेप्ट कैल्शियम. बस आपको ये लाइन याद रखनी है. ऑल विल इंक्रीज एक्सेप्ट कैल्शियम. तो देखो, अगर मैं आपसे बोलूँ फॉस्फेट बढ़ेगा, बिल्कुल बढ़ेगा. देयर विल बी हाइपर फॉस्फेटेमिया. अगर मैं आपसे बोलूँ पेशेंट का यूरिक एसिड बढ़ेगा, तो देयर विल बी हाइपर यूरिसीमिया. अगर मैं बोलूँ सोडियम भी बढ़ेगा, तो देयर विल बी हाइपर कैलीमिया. तो सब कुछ बढ़ रहा है कैल्शियम को छोड़ के, खाली कैल्शियम कैसा होगा, कम होगा. सो व्हाट यू हैव टू रिमेंबर इज ओनली हाइपोकैल्सीमिया. बस मेरी एक लाइन याद रख लो, ओनली हाइपोकैल्सीमिया, रेस्ट ऑल हाइपर. बाकी सब बढ़ेगा. सो पेशेंट इज हैविंग मल्टीपल इलेक्ट्रोलाइट इम्बैलेंस. यूरिक एसिड बढ़ गया है, पोटेशियम भी बढ़ गया है. इसी वजह से क्या हो रहा है, दैट बिकॉज ऑफ दिस पेशेंट हैविंग AKI, एक्यूट रीनल फेलियर. अब क्या आंसर होना चाहिए? हाइपोकैल्सीमिया होगा, यस. हाइपरफॉस्फेटेमिया, यस. हाइपरयूसीमिया, यस. हाइपोकैलीमिया नहीं होगा, हाइपरकैलीमिया होगा. So just remember this line, only hypocalcemia, rest all other hyper. Next thing they ask you, like whenever you see a patient with tumor lysis syndrome, तो जैसे ही आपने कीमोथेरेपी चालू करी, like some tumor cells they will degrade. So this will lead to electrolyte imbalance. So tumor lysis syndrome में अगर पेशेंट को सपोज पोटेशियम बढ़ा हुआ तो आपको ठीक करना है, फॉस्फेट बढ़ा हुआ आपको फॉस्फेट बाइंडर देने हैं, कैल्शियम कम है तो आपको कैल्शियम ग्लूकोनेट देना है. So just I am writing here, whenever there is more phosphate, what you will do, you will give phosphate binder. If it is due to, I can say, low calcium, तो क्या दोगे? कैल्शियम ग्लूकोनेट. और if patient is having more potassium, then we can use some diuretics. स्पाइनोलैक्टोन नहीं देना है, उससे तो और बढ़ेगा. तो वी कैन यूज डायरोसेट, वी कैन यूज इंसुलिन, वी कैन ऑल्सो यूज कैल्शियम ग्लूकोनेट इन द सेम कंडीशन, वी कैन यूज बीटा एगोनिस्ट. सो हाइपरकैलेमिया बहुत कुछ करते हैं. वी कैन ऑल्सो यूज के बाइंडर्स. तो ये तो क्वेश्चन हो गया इलेक्ट्रोलाइट का, वो आपसे नहीं पूछते. व्हाट दे आस्क यू इज ट्यूमर लाइसिस सिंड्रोम में अगर यूरिक एसिड बढ़ा हुआ होता है, इफ यूरिक एसिड इज इंक्रीज इन ट्यूमर लाइसिस सिंड्रोम, देन व्हाट यू विल डू. रिमेंबर इन दिस कंडीशन एलोपिरिनॉल, योर फेवरेट, फेबुक्सोस्टैट, योर नेक्स्ट फेवरेट, ये दोनों काम नहीं करते. इन दिस केस वी आर यूजिंग रेस्केस नाम से एक इंजेक्शन आता है, उसको बोलते हैं रेस्ब्यूरिकेस. सो वी हैव टू यूज रेस्ब्यूरिकेस और पेग्लोटिकेस. सो नॉर्मल गाउट में इसको कब देते हैं? व्हेन इट इज रिफ्रैक्टरी टू अदर ड्रग्स. इज इट क्लियर? सो रेस्ब्यूरिकेस, राइट? Okay, so understand this hypocalcemia, Dr. Metroid, whenever you see hypocalcemia in ECG, what you will see prolongation of QT. So अगर hypocalcemia होगा तो QT prolongation आएगा ECG में. Clear? Okay, coming to next, 55-year-old male present with fatigue. 55 साल का है. Fatigue, splenomegaly, pancytopenia. Fatigue है, splenomegaly, pancytopenia. Peripheral blood is given below. Cytometry analysis demonstrate expression of CD11C, CD25, CD103, CD123. So flow cytometry के हिसाब से आपको पूछा गया है, and this image is given. So what is the diagnosis? So let us see this image. Here you can see these are like some hairy outgrowth. ये जो बाल जैसा दिख रहे हैं, so what we call this hairy cell leukemia. So diagnosis for this case is hairy cell leukemia. Why? Because hairy cell leukemia में these flow cytometry markers are positive. Right? अब देखो clinically like fatigue, splenomegaly, pancytopenia, this can be seen in any CLL, any ALL. So based on these two flow cytometry finding and this, we can say hairy cell leukemia. So remember, hairy cell leukemia is having some properties like this is a tumor which will have hair-like growth in tumor cells. And these hairs, remember, these hair-like outgrowth, these hairs can compress or these can obstruct when you do bone marrow aspiration. So sometime you can see dry tap in bone marrow aspiration. Next MCQ that they ask is like this hairy cell leukemia, these are positive for a dye called TRAP. TRAP is tartarate resistant acid phosphatase. So कैसे याद रखना है? TAP and TRAP. And fourth is like remember it's a non-Hodgkin lymphoma. It is a B cell non-Hodgkin lymphoma. ये भी क्वेश्चन पूछते हैं. It is a B cell non-Hodgkin lymphoma, and how you will treat this? So we treat this by giving a drug called cladribine. So CLL and BRAF mutation, and it is due to BRAF mutation. So understand this. CLL, it is not a CLL, so that is not the answer. CLL is having 13q deletion, but again based on this flow cytometry findings are not for CLL. Hairy cell leukemia and 13q deletion, no. So answer is hairy cell leukemia, and it is due to BRAF mutation. So ये आपको कुछ point है which you have to remember for hairy cell leukemia. Am I clear? And remember in CLL what we give? We give brother of cladribine. That brother is called fludarabine. Very very important. तो यहाँ पर ट्रीटमेंट में क्या देना है आपको? फ्लूड्राबिन. Is it clear? So this is about the this question. Coming to next one. थोड़ा जल्दी करते हैं. 58-year-old lady present with emergency room with complaint of breathing difficulty for last 2 days. She has become drowsy but arousable on loud voice command. Oxygen saturation by pulse oximetry is 82. Bilateral polyphonic bronchi on auscultation. She has been on regular medication for diabetes, mellitus and coronary artery disease for the last 10 years. She started oxygen therapy along with supportive treatment. ABG is done. So basically it's the question on ABG, you have to remember. So देखते हैं ABG में क्या दिख रहा है. pH is moving in. pH normal pH is 7.35 to 7.45. So आप देखोगे pH कम हो गया. Normal PCO2 is 35 to 45. So these are the normal values. This is normal pH and this is normal PCO2. So PCO2 आप देख रहे हो बढ़ गया. Right? अब इसको देखो, understand this. When pH and PCO2 they move in opposite direction, reverse direction, then disorder is respiratory. Right? It is respiratory disorder, and pH is acidic, so it's a case of respiratory acidosis. So diagnosis हमें मिल गया, it's a case of respiratory acidosis. So respiratory acidosis means this option is ruled out, this option is ruled out. अब बचा A और C. Right? Now understand, now if anion gap is given, तो आप देख रहे हो bicarbonate, right? If you see bicarbonate, तो bicarbonate is coming 33. अगर bicarbonate 33 आ रहा है, means it is coming close to normal range. It is increasing. Bicarbonate बढ़ रहा है, it means kidneys are doing some compensation. Is it clear? So it is not a plain respiratory acidosis, kidneys are doing compensation with metabolic alkalosis. So that is about this ABG. The answer will be C. Okay, basket weave appearance in glomerular basement membrane on electron microscopy. So Alpert syndrome, it's simple. It is Alpert syndrome, will have basket weave appearance. Basket weave, दलिया जो सिंड्रेला की दलिया होती थी वैसा पैटर्न होता है. PSGN, okay, so let me write all the findings. सारी में एक साथ finding because in glomerular nephritis generally they ask question on biopsy findings. So एक बार हम सारी finding पढ़ लेते हैं. Okay, start करते हैं. Cola color urine. Coca-Cola colored urine. Then they can ask you decrease C3. Decrease C3, or they will ask you low complement. Then they can ask you like a patient is having starry sky pattern. Starry sky pattern. Or they can ask you like subepithelial hump. Subepithelial hump. Or they can ask you lumpy, bumpy appearance. Lumpy, bumpy appearance. Second, they can ask you like patient will have, I can say basket weave pattern. Basket weave pattern. Third thing they can ask you like patient is having crescents formation. Then they can ask you IgA deposition, or they can ask you like mesangial deposits. IgA deposits or IgA deposits in mesangium or mesangial infiltration. Then they can ask you tram track appearance. Tram track appearance. or wire loop lesion or full house effect. Full house effect. Then they can ask you like patient will have a normal glomeruli, normal in light microscopy and immunofluorescence, and loss of food process in electron microscopy. Loss of food process with high linosis. Then they can ask you like patient is having spike and dome pattern. So these are the patterns that we see in glomerulonephritis. यहीं से question पूछते हैं. Let's start. Cola colored urine, low complement, starry as sky, subepithelial hump, lumpy, bumpy. These are MCQs of PSGN. Basket weave you will see in Alport syndrome. Crescent formation we see in RPGN. IgA deposit, mesangial proliferation we see in a patient with IgA nephropathy. IgA nephropathy also called as Buerger disease. Tram track we see in a patient with MPGN. Wire loop lesion, where we see wire loop lesion we see in a patient with lupus nephritis, that is called SLE nephritis. And most common is type 4, this type 4 is called DPGN. Normal in light microscopy, loss of food process in electron microscopy. So these are the things we see in patient with minimal change disease. With hyalinosis or sclerosis, this is seen in a patient with FSGS. Spike and dome pattern we see in a patient with MGN. So these are the pattern. Okay, one more I missed, that is we call this basement membrane disruption. Basement membrane disruption, and this basement membrane disruption is seen in a patient with good posture syndrome. So these are all the findings of different types of glomerulonephritis. That's very, very important. Clear? So again, it is in front of you. Take a screenshot or write it in a piece of paper. This is second MCQ which is surely coming in your exam. Very, very important. आगे चले. Okay. Next, see a 42-year-old male present to the hospital after being involved in a car accident. कार एक्सीडेंट हो गया ड्यू टू फॉलिंग अस्लीप वाइल ड्राइविंग. अब देखो गाड़ी चला रहा है, गाड़ी चलाते चलाते सो रहा है. ही सस्टेन्ड माइनर इंजरीज. ही रिपोर्टेड हिस्ट्री ऑफ फॉलिंग अस्लीप. देयर इज हिस्ट्री ऑफ फॉलिंग अस्लीप ड्यूरिंग मीटिंग्स एट वर्क एंड हिज स्पाउस विटनेस एपिसोड्स ऑफ एपनिया ड्यूरिंग द नाइट. BMI 38. टेकिंग टेलमिसार्टन फॉर हाइपरटेंशन. व्हाट इज द मोस्ट अप्रोप्रिएट मेथड फॉर डायग्नोस दिस कंडीशन? पहले मुझे डायग्नोस बताओ. रिचा, लाला, गजेंद्र एंड कुमार, बताओ डायग्नोस बताओ. व्हाट इज द डायग्नोसिस? मोटा आदमी है, BMI 38 है, रात को सोते हुए सो नहीं पा रहा है, सांस फूल रही है. दिन में क्या हो रहा है? गाड़ी ठोक दी इसने. सिंपल. इन द मॉर्निंग गाड़ी ठोक दी, दिन में सो रहा है. बीवी बता रही है कि रात को भी सांस रुक जाती कभी कभी. तो क्या है ये? व्हाट इट इज? कम ऑन डॉक्टर मेट्रॉइड, GMM एंड कुमार, फिनिक्स, जल्दी बताओ जल्दी. What is the diagnosis? I'm waiting for your answers. What is the diagnosis? So this is a case of, come on, anyone? कोई तो बोलो. Come on. Yes, this is a case of OSA, obstructive sleep apnea. So what is obstructive sleep apnea? Understand, it is cessation of breathing. या तो रात को सांस रुक गई, और fall in oxygen saturation, that is hypopnea, कम हो गई, right? So we call this apnea hypopnea index. So कैसे diagnose करते हैं इसको? apnea hypopnea index, AHI index. तो patient को OSA है, that's clear. So, अब देखो Epworth sleepiness scale. Question they are asking, what is most appropriate method to make a diagnosis? So many of you are knowing, like diagnosis of this condition is called a polysomnography. Polysomnography. A polysomnography means it's sleep study. So ऐसे में क्या करता है, like we send a team of experts those who are expert in sleep study, like some of them are like they do a course after MD physiology, some are like they are like a non-medical course, they are like assistant to the doctor. So what they do, they go to patient house, patient के घर पर जाते हैं रात को, अब पेशेंट को सुलाते हैं, उसके चेहरे पे उसके पूरे like इलेक्ट्रोड लगाते हैं, then we monitor this. So for this, what is important, we do this in the place where patient is more comfortable. So generally we do this at home. Average sleepiness score is a prognosis score. It's like a questionnaire. So ये आगे जाके prognosis पता करने के लिए होता है, diagnose करने के लिए नहीं. Contrast CT of neck and chest. CT neck और chest तब कराओगे जब when you are suspecting some tumor or some mass. Home sleep apnea testing. देखो थोड़ा सा क्वेश्चन को घुमा दिया, पॉलीसोमनोग्राफी कहाँ करते हैं, घर पे तो करते हैं. So this is the answer. ABG you will do like in a variant of this, we call this obesity hypoventilation syndrome. तो उसमें कर सकते हैं, बट क्वेश्चन को थोड़ा सा घुमा दिया, यहाँ पर ABG कराने की जरूरत नहीं है. So it is polysomnography or how we make a diagnosis, home sleep apnea testing at SAT. So Gajendra and Kumar Phoenix Pradhan क्वेश्चन को सिर्फ थोड़ा घुमाया है, polysomnography की जगह क्या दे दिया है, home sleep apnea testing. So this is like you can see level 1 पे क्या करते हैं, EEG, EOG, EMG, पोजिशन, हार्ट रेट, एयरफ्लो, इन सबको चेक करते हैं. लेवल 2 पे होम स्लीप अपनी स्टडिंग करते हैं, दैट इज़ लैबोरेटरी में नहीं होता है. लेवल 3 पे क्या करते हैं, यू कैन सी वील मेंटेन 4 चैम्बर्स लाइक 4 चैनल्स लाइक हार्ट रेट, रेस्पिरेटरी मूवमेंट, SpO2, एंड लेवल 4 लाइक वी डू ओनली SpO2. तो HSAT इज नथिंग, इट इज़ होम एट होम. दिस लेवल 2, 3, 4 वी डू एट होम. सो ये आपको नहीं पढ़ना है, जैसे मेम्बर इट इज़ नथिंग, क्वेश्चन सिंपल था, उस नाम चेंज कर दिया, पॉलीसोमनोग्राफी की जगह क्या दे दिया, they have given HSAT. Okay, a person with a history of 30 years working in cardboard. मुझे पता है सब लोग ये गलत करोगे, इसलिए पहले मैं बोल रहा हूँ, आई एम गिविंग यू वार्निंग. फर्स्ट ट्राई टू थिंक अ क्वेश्चन केयरफुली. कार्डबोर्ड पेपर देख के बैग सोर्सेस मारना नहीं, लो मैंने पहले लगा दिया, ये आंसर नहीं. नाउ मेक योर आंसर. आई एम सिटिंग हियर फॉर 2 minutes. यू ट्राई टू आंसर दिस. ओके कम ऑन. रिचा, गजेंद्र एंड कुमार फिनिक्स, बताओ फटाफट क्या होगा. बैग सोर्सेस जो तुम सोच रहे हो वो नहीं है. वो क्यों नहीं है, क्योंकि बैग सोर्सेस में प्लूरल थिकनिंग नहीं होती. अब आगे चलो. कार्डबोर्ड देखा, पेपर देखा, बैग सोर्सेस मारना है मैं. am I right? फिनिक्स सेम थिंग आई टोल्ड, मैंने यही तो बताया ना, बैग सोर्सेस नहीं है ये. क्या होगा डायग्नोसिस. अरे ये तो मना ही कर रहा हूँ ना मैं, इट इज़ नॉट द आंसर. अब देखो, नेजोफेरेंजियल कैंसर तो कहीं से लग नहीं रहा, ऑल्दो कैंसर कैन ऑल्सो अकर इन कार्डबोर्ड इंडस्ट्री, बट दे आर आस्किंग यू ब्रेथलेसनेस एंड कफ. X-ray showing mottling. X-ray is mottling. Mottling you can see in any pneumoconiosis, but this pleural thickening, there is pleural thickening, that is suggestive of asbestosis. Basinosis is seen in cotton or textile industries. Is it clear? So bagasosis could be the answer, but remember bagasosis के अलावा even asbestosis can occur in many industries. Asbestosis can also be seen in a patient with cardboard industry. Pleural thickening is not seen in bagasosis. आगे चलते हैं. पेशेंट प्रेजेंट विद पेन इन राइट हाइपोकॉन्ड्रियम. राइट हाइपोकॉन्ड्रियम में अगर पेन हो रहा है तो या तो वी आर टॉकिंग अबाउट आइदर लीवर और गॉल ब्लैडर. ब्लड इन्वेस्टिगेशन AST 22, ALT 27. व्हाट इज द डायग्नोसिस. बिलिरुबिन इज 5, ALP इज 200. व्हाट शुड बी इनिशियल इन्वेस्टिगेशन. बताओ पहले, ट्राई टू आंसर दिस क्वेश्चन. ओके, वी आर टेकिंग मोर टाइम, जस्ट लेट मी क्विकली फिनिश. देखो इसको फटाफट. राइट हाइपोकॉन्ड्रियम में प्रॉब्लम है, AST ALT नॉर्मल है, इट मीन्स लिवर इज नॉर्मल. पेशेंट शराब नहीं पी रहा, राइट, पेशेंट नॉट अल्कोहलिक, AST ALT नॉर्मल, वायरल की हिस्ट्री भी नहीं है. ALP इज रेज्ड, ALP is raised and bilirubin is raised, it means there is some sort of cholestasis occurring in the body. So body में cholestasis हो रही है. So question they are asking, what is the initial investigation. Best नहीं पूछ रहे. Initial means you want to see any gallbladder stone तो नहीं है, कोई cholangitis तो नहीं, cholecystitis तो नहीं. सबसे पहले क्या कराओगे, अल्ट्रासाउंड कराओगे. हेपेटाइटिस A and D मार्कर्स इसमें अभी नहीं कराने. हीडा स्कैन बहुत लेट कराते हैं, सीटी बाद में कराओगे. सीटी इवन इट्स अ गुड टेस्ट बट बाद में कराना, पहले क्या कराना, अल्ट्रासाउंड. दैट्स द क्वेश्चन. रीड द क्वेश्चन केयरफुली. Okay, next, road traffic accident victim present to symptom of loss of pain and temperature on the left side, loss of vibration proprioception motor function on the right side. ये क्वेश्चन बार बार आप देखोगे हर ऐप में, हर बुक में क्यों आता है, बिकॉज दे वांट यू टू नो व्हाट इट इज. दिस इज योर GBS, राइट. So in GBS what you will see contralateral pain and temperature, and you will see like ipsilateral, there will be ipsilateral vibration proprioception. This is a case of Brown-Sequard syndrome. Clear? सबका easy है. Okay, coming to next one. A soldier after marching for 50 km in hot 40 degrees Celsius climate present with dehydration and profuse sweating. What is next appropriate step? So एक सोल्जर है, 50 किलोमीटर चलने के बाद पसीना छूट रहा है, गर्मी में है. So it could be like an impending heat stroke. So I can say this could be a case patient जिसको आगे जाके it could be impending heat stroke. Impending heat stroke means अभी heat stroke आया नहीं है. It can occur. It is a stage before to a heat stroke. इसको बोलते हैं heat exhaustion. This state is called heat exhaustion. So whenever you are having a patient with heat exhaustion, अब देखो suppose करो you are not knowing this topic, even I am not knowing this topic, still we will mark the correct answer. Put the limbs in ice water bucket. इसको ice ठंडी बर्फ में डाल दो, डालोगे? तुम खुद बताओ, डालोगे? नहीं डालोगे ना. इन्फ्यूजन ऑफ कोल्ड सलाइन. डू यू गिव कोल्ड सलाइन? मीन्स नॉर्मल सलाइन को पहले फ्रिज में रखो, चिल्ड करो, उसके बाद फ्रिज से निकाल के IV चढ़ा दोगे, करोगे? सलाइन है, चिल्ड बियर थोड़ी है. एम आई राइट? तो सलाइन का इन्फ्यूजन तो नॉर्मली होता है. इंजेक्शन ऑफ क्लोरप्राज़िन, दिस वी कैन यूज़ अगर पेशेंट को कोई और सिम्टम हो, right, like dizziness or you can say some rash, allergy, something like that. Nothing is there. देखो क्वेश्चन तो जो भी था लेकिन ऑप्शन बड़े फुद्दू थे. यू कैन सी ऑप्शंस आर प्रीटी मच सिंपल. एम आई क्लियर? तो आइस वाटर बकेट डाल दो, कोल्ड सलाइन चढ़ा दो. सो व्हाट वी गिव इन दिस केस अंडरस्टैंड हीट एक्सॉशन, हाउ वी मैनेज, वी विल लाइक गिव कोल्ड वाटर टू ड्रिंक टू पेशेंट. पेशेंट को पीने के लिए ठंडा पानी देना है लेकिन ठंडा सलाइन नहीं चढ़ाना है. एम आई क्लियर? Then we will like put a wet cloth immersed in normal water. उसके बाद पेशेंट के ऊपर रख देना है और थोड़ा सा फ़ैन ऑन कर देना है, या फिर अगर पेशेंट को AC में ले जाओ आप, अगर AC है वहाँ पर तो. So that is a heat exhaustion. So answer will be D. Simple. Options were pretty bad. Okay, coming to next thing, what you can see a 50-year-old man visit outpatient department complaining of tiredness and back pain. That wasn't with physical exertion. No significant medical history. Upon examination, his hemoglobin level is 10.9. So आदमी के हिसाब से hemoglobin कम है. Then you can see like additionally his serum calcium levels are elevated. MCV is 98, means it's coming in the normal range. X-ray is having this finding. So you can see punched out lesion. In X-ray what we can see, punched out lesion. Now you can see sir, these findings we also see in other diseases. So remember hyperparathyroidism will have cotton wool spot in X-ray. In X-ray of skull. But just seeing the question, if you see the question like there are कैल्शियम बढ़ा हुआ है तो कैल्शियम लेवल्स आर एलिवेटेड. देन यू कैन सी लाइक हीमोग्लोबिन कम हो रहा है. सो दीज आर फाइंडिंग व्हिच वी सी इन अ पेशेंट ऑफ मल्टीपल माइलोमा. सो आंसर इज मल्टीपल माइलोमा. देन रिमेंबर इन पैजेट दिस इज ऑल्सो यू कैन सी सम चेंजेस इन द बोनी मैनिफेस्टेशन इन द स्कल. तो बट दीज आर मोर क्लासिकल, दीज आर कॉल्ड लाइटिक बोन लीजन. इन लैंगर एंड सिस्टियोसाइटोस ऑल्सो यू कैन सी लाइक होल्ड पैटर्न, थोड़े से होल जैसे मिलेंगे. तो बट रिमेंबर सीइंग द हिस्ट्री इट इज़ अ केस ऑफ मल्टीपल माइलोमा. These are osteolytic lesion. Okay, आगे चलते हैं. A child from low socioeconomic status is brought with complaint of fever, abnormal behavior from past 2 months. Right? Okay, कोई डाउट? हीट स्ट्रोक में और क्या ट्रीटमेंट कर सकते हैं? देखो अगर पेशेंट को स्ट्रोक हुआ है तो नाउ सीइंग द पेशेंट, इफ पेशेंट इज हैविंग लाइक हीट स्ट्रोक तो आपको उसको क्या करना है, यू हैव टू गिव नॉर्मल सलाइन टू पेशेंट. Right, you have to give proper bed rest to patient. You have to, if patient can't drink, give him cold water to drink, right? Or we can means temperature को cool रखना है, because there is profuse sweating, patient is having heat, so in that case we have to treat. तो symptomatic treatment ही करना है आपको, कोई अलग से treatment नहीं करना है. Sometimes some patient like they develop hypotension, dizziness, giddiness, तो आपको just symptomatic treatment ही करना है. Okay, let's see. child has been on ultrasensorium for the past 1 week. On examination, neck rigidity is seen. Lymphocytes है, glucose 32 है. So remember normal CSF glucose. Normal CSF glucose कितना होता है? So remember this is okay. You can ask in your doubt also. I'm seeing your chat box. Try to ask your question the doubt. So normal CSF glucose. This is 2/3 of blood glucose. So अगर मैं blood glucose को 100 मान के चल लूँ, नॉन डायबिटीज पेशेंट की बात कर रहा हूँ मैं, then this could be 66.66 और I can say in simple language 60 to 80 मिलीग्राम पर डेसीलीटर. अब ग्लूकोज 32 आ रहा है. ग्लूकोज मीन्स बैक्टीरिया लव ग्लूकोज. तो ये बैक्टीरियल मेनिंजाइटिस है बिकॉज बैक्टीरिया ग्लूकोज को खा जाते हैं. सो इट इज़ नॉट वायरल, इट इज़ नॉट फंगल. अब टीबी इज़ अ बैक्टीरिया, निशर इज़ अ बैक्टीरिया. इन अदर बैक्टीरिया रिमेंबर यू विल सी नंबर ऑफ न्यूट्रोफिल्स. बाकी बैक्टीरिया में न्यूट्रोफिल्स का नंबर ज़्यादा होगा, टीबी में लिम्फोसाइट का नंबर ज़्यादा होता है. सो दैट इज़ वाई आंसर विल बी ट्यूबरकुलर मेनिंजाइटिस. सिंपल. So question is simple. Just let me make this once again. They can ask you question on CSF opening pressure. Opening pressure. Then they can ask you question on protein. They can ask you question on glucose. Glucose means CSF glucose. And they can ask you which type of cells. Which type of cells are increased. So generally ऐसे question आता है. So understand we have mainly 3 different meningitis. We have mainly 3 different meningitis. So first is called bacterial, and bacteria mostly they resemble fungal. So bacterial fungal generally same ही होती है. Just fungal will be more common in immunocompromised patient. Then it could be viral, it could be tubercular. So now listen to me very carefully. इसको बिल्कुल tough नहीं, it's very simple. Protein pressure सब में बढ़ेगा. It will increase in all. So protein and pressure will increase in all. Simple. Bacteria love glucose. Bacteria glucose को पसंद करते हैं. So bacteria they will eat all the glucose. So bacterial meningitis में ग्लूकोज कैसा होगा? कम हो जाएगा. टीबी बैक्टीरिया कम हो जाएगा. वायरस में कैसा होगा? नॉर्मल रहेगा. वायरस में मेन सेल्स, द मेन सेल्स इन वायरल meningitis, these are your lymphocytes. In TB also these are lymphocytes, but in bacterial it is neutrophils. Neutrophils we call them PMN. PMN means polymorphoneutrophils. So this is something which you have to remember. Easier. और ये वो चीज़ है something which always they ask in exam. Very very important question. इस टाइप के क्वेश्चन हमेशा एग्जाम में आते हैं. Very very important. ओके आगे चलते हैं. फर्स्ट मार्कर टू बी रेज इन अ पेशेंट विद एक्यूट हेपेटाइटिस बी. सबसे पहले क्या होगा? मैंने बताया था SCE. सो फर्स्ट मार्कर दैट इज इंक्रीज HBS सरफेस एंटीजन. सिंपल. First marker that will increase is surface antigen. Very very important. ये तो सिंपल है. Okay. Following biopsy is pathognomonic for diabetic nephropathy. Most common finding that we see in a patient with diabetes glomerulosclerosis that will be diffuse. ये सारे diabetes की manifestation है. Most common will be diffuse, but remember most specific को ही हम क्या बोलते हैं? पैथोग्नोमोनिक. This will be nodular, and these nodules are called Kimmelstein-Wilson nodule. Kimmelstein-Wilson nodule. So this is very very important. Clear? ओके आगे चलते हैं. ऑल ड्रग्स आर यूज टू प्रिवेंट वेरिसेल ब्लीडिंग एक्सेप्ट. बताओ इसका आंसर. ऑल ड्रग्स आर यूज टू प्रिवेंट वेरिसेल ब्लीड एक्सेप्ट. सो प्रोपेनोलोल, नाडोलोल, कार्बिडोलोल. अंडरस्टैंड? प्रोपेनोलोल, नाडोलोल, कार्बिडोलोल, दीज आर यूज्ड टू प्रिवेंट. These are used in prevention. And octreotide, this is used in treatment. It is used in treatment. Am I clear? तो बीटा ब्लॉकर को आप प्रिवेंशन में यूज़ करते हो, ऑक्ट्रोटाइड को ट्रीटमेंट में यूज़ करते हो. ओके अगले क्वेश्चन पर चलते हैं. फॉलोइंग ड्रग्स शुड बी अवॉइडेड इन पेशेंट विद हिस्ट्री ऑफ रिकरेंट एपिसोड ऑफ पेनफुल स्वेलिंग इन एंकल एंड बिग टोज विच आर एलिवेटेड बाय NSAID. अब ये दिस इज अ ट्रिकी क्वेश्चन. आई होप many of you have marked this wrong. So it's a tricky question. Understand this question. Now understand, cyclosporin is I can say a drug which is having immunomodulator action. So this is avoided in gout patient because it can increase uric acid level. Pyrazinamide भी uric acid को बढ़ाता है. Even diuretics we avoid. Why? Because diuretics, if this will suddenly remove all the uric acid out of your body. Thiazide तो आपको देने ही नहीं है. Furosemide is also avoided. Now coming to this question जो आपने नहीं सोचा था, like even I told you every time is aspirin should be avoided. So understand, normal जो aspirin की गोली आती है that is 75 mg in India and it go up to 300 mg that we use as a loading dose in cardiology. Same tablet in US this will come in 81 mg. 81 mg की आती है US में and this will be 320 mg bigger tablet. So this is like a dose of aspirin in India in USA. So like why I'm writing, because Harrison has US based books, so वहाँ पर आपको दिखेगा कभी 320 mg or 81 mg, so don't confuse. So understand these doses like from 75 to 320 I can say, in these doses like if you give aspirin, this will have a urate retention property. Is it clear? So remember in these doses, in dose में क्या होगा? There will be increase in uric acid. That is something which you have to remember. इस dose में aspirin उतना effectively काम नहीं करेगी. But if you give this in higher doses, this will be like a drug which can help to treat symptoms of hyperuricemia. In higher doses, aspirin will have urate lowering properties. Is it clear? In higher doses means like I can say 600 mg or 500 mg or more. It will have urate lowering properties, means this will lower the uric acid. अब देखो सारे क्वेश्चन तो हमारे सही तो नहीं हो जाएंगे, सारे कंसेप्ट तो आने जाएंगे, कुछ क्वेश्चन मुझे डिफिकल्ट डालने पड़ेंगे. तो जस्ट व्हाई आई हैव एडेड दिस क्वेश्चन टू नो, टू टेल यू दिस कॉन्सेप्ट. एम आई क्लियर? तो मेरी बात ध्यान से समझो. लाइक वेन एवर यू गिव अ पेशेंट साइक्लोस्पोरिन, पायराजिनामाइड और फ्यूरोसेमाइड, these are the drugs like which I can say these can increase uric acid. But if you see high dose salicylate, like these will have like in this range, this will increase uric acid because this will be like urate retentive effect. We call this urate retentive range. But in higher doses, this will reduce. So high dose can be given, right? So this high dose can be given. But practice में नहीं देते हैं, क्वेश्चन पूछते हैं, कॉन्सेप्ट पूछते हैं. That's why I'm telling you this. Okay, this is easy one. 50-year-old man present to your clinic for mass trial checkup on routine investigation. Find the fasting blood sugar is 116. Fasting is 116. Postprandial blood sugar. HbA1c. So these are the three values which I tell you to remember. So fasting, अगर मैं आपको बोलूँ fasting blood sugar is coming in this range. If fasting blood sugar is less than 100, postprandial I can say this is coming less than 140, right? And HbA1c is coming less than 5.6. This is called normal. This is for normal people. If fasting, suppose if fasting this is more than 126, postprandial is more than 200, and HbA1c is more than 6.5. इसको बोलते हैं डायबिटीज़. अब इसके जो बीच का आएगा मीन्स 100 to 125, 140 to 199, 5.7 to 6.4. This is what we call this pre-diabetes. Pre-diabetes or impaired glucose tolerance. Now look at the screen. Fasting कितना दिया? 116. Postprandial given 140. So this is coming exactly in the range of pre-diabetes. This is again a very important topic. बार बार एग्जाम में पूछते हैं. Okay, which type of memory is associated with the ability to remember a specific event in terms of time and location? Okay, इसको देखते हैं एक बार. So when I say long term memory, so long term memory के दो types होते हैं. Understand this. First is what we call this explicit memory. Explicit memory. Second is implicit memory. Explicit is also called as declarative memory, right? And implicit is called as non-declarative. Now understand, this explicit memory, अगर आप देखोगे, this explicit memory, this is of two types. One is called episodic memory, and second is what we call a semantic memory. Similarly, this non-declarative memory, this is again of two types. So either it could be due to your skillful memory, we call this skillful memory, or it could be due to I can say we call this a priming or conditioning. Priming. Now understand, episodic memory is something, what we call this eventful memory. So it is memory of event. Event means any good or bad event that is having some influence in your life. And semantic memory, this is based on fact, place and person. Fact, place and person. Am I clear? Now understand, skillful memory is something which we acquire throughout our lifetime. That is based on your procedure, your skill. Procedural. And priming is based on conditioning. Conditioning means it could be like classical conditioning, like experiment which was given by I can say Pavlov. So that Pavlov, what he said like he was feeding a dog with a piece of meat, and he did this for a few days. He noticed like dog is having salivation. तो जो हम आप काम करते हैं वो काम अपने आप फिर होते रहता है. जैसे सुबह उठना अपने आप, कई बार बिना अलार्म के उठ जाते हैं, बिकॉज हमारे पेरेंट्स अब उठते आ रहे हैं तो अपने आप उठ जाते हैं वो लोग. दैट इज कंडीशनिंग. सो दिस Pavlov हैव गिवन क्लासिकल कंडीशनिंग. And second is Skinner. Skinner said if you want to modify or if you want to improve performance in a person, either reward them or punish them. So that this experiment is called operant conditioning. These are two types of conditioning. ये दोनों क्वेश्चन आपके साइकेट्री में पूछे जाते हैं, क्लासिकल कंडीशनिंग एंड operant conditioning. Now understand, if they ask you क्वेश्चन क्या पूछा, आप देखते हैं एक बार क्वेश्चन को. Ability to remember specific event. So any type of eventful memory, any good or bad event which is having a remarkable influence in your life, that is what we call, उसको क्या बोलते हैं, eventful memory. For example, if I ask you like the day you got married, the date of your marriage, or the date of your I can say first date, or you remember your date of graduation, then some of you will remember this 30th July. That is a date which is having a remarkable influence in your life. ऐसी कोई तिथि जो आपकी लाइफ बदल दे, और वो अभी तिथि, दैट डेट इज नाउ 30th July. Is it clear? And memory based on fact, place, person means capital of India. If you ask me like who is Prime Minister of India, then that is a fact. Suppose if I ask you like हम हर जगह अपनी date of birth लिखते हैं, so your date of birth, we remember our date of birth because that's a fact for us. But your date of birth could be an event for your father. It could be a bad event or a good event. So any good or bad event. Is it clear? So that is called, this type of memory is called episodic memory. Am I clear? Okay, so let us see, this answer will be ability to remember a specific event in terms of time and location. That is called episodic memory. Clear? Okay, then understand this. Next question is which of the following is not true about spasticity? So which of the following is not true about spasticity? Understand this. Spasticity, this is something which is velocity dependent. This is something that you can see, this will sudden release after reaching maximum, but this will mainly affect upper limb flexors, not extensors. So this is a not true statement. Other option, these are true statement, this is true statement. So remember, this will not affect upper limb extensor, this will affect upper limb flexors and lower limb extensors. That is something which you should know. Am I clear? Most common gene mutation associated with hemochromatosis, this will be C282Y. C282Y, that is basically a type of HFE gene. So HFE gene prototype is C282Y, that is most commonly seen with hemochromatosis. This is something which you have to remember. Am I clear? Okay, आगे चलते हैं. Then they can ask you a question like a person with hematuria and generalized edema. एक पेशेंट को हेमाचूरिया हो रहा है, जनरलाइज्ड एडिमा हो रहा है. abdomen is suspected to have glomerulopathy. On microscopy, you can see these cells, what it is. Okay, so understand this. This you can see these cells, what we call them acanthocytes. So just remember a 45-1 rule. 45-1 rule means 40% of, if you see, dysmorphic RBCs, 40% of dysmorphic RBCs, and if you see this 5%, if you see like this is what acanthocytes, and if you see one single RBC cast, so any one is present, 45-1, then this is called, this hematuria will be glomerular in origin. It is due to glomerulonephritis. Am I clear? It is due to glomerulopathy. Okay, we should be moving little fast. I think we had a big discussion. So this is like what you can see, bright red cells is that we can see in any hematuria. Beta 2 microglobin, and this we see in a patient with amyloidosis. And waxy cast, bright red cells we see in hematuria. In any hematuria you can see this bright red cells. Waxy cast we can see in CKD patient. So here it will be acanthocyte, that is telling you about glomerulopathy. Okay, coming to next question, that is, which of the following is not true about conus cauda syndrome. So what question they are asking, which is not true about conus cauda syndrome. So understand, loss of anal reflux, K-plaque distribution. Where we see K-plaque? कौन बताएगा मुझे? Where we see K-plaque distribution? बताओ. Where we can see K-plaque distribution? Okay, can you answer, guys? Try to answer. बताओ. Where we see K-plaque distribution, we see in a patient with syringomyelia. Syringomyelia, we see K-plaque distribution, right? Then they are asking you like loss of anal reflux. Where we see loss of anal reflux? Loss of anal reflux, or I can say saddle anesthesia. Where we see this loss of anal and bulbocavernous reflux, we see in a patient with conus medullaris syndrome. So here what we can see like patient will have saddle anesthesia, that is a feature of conus cauda syndrome. Am I clear? Any doubt in this? Okay, coming to next question that they ask in exam. 57-year-old have been brought up by family members with runs of irrational behavior where she has not able to understand anyone's command or any written language. On examination, she had rather fluent but non-sensual speech with poor repetition, paraphasic errors, and lack of comprehension. There are no motor deficit or sensory abnormality. Following describe the most likely syndrome. So global aphasia, you will see everything. Since you can see here, it is like a fluent. So since she is having fluent aphasia, so that is a case of Wernicke's aphasia. Am I clear? So this is like about the discussion. So come on, one more question. 40-year-old male with history of smoking and drug abuse present to emergency department, generalized body ache. Doctor duty order an ECG which showed ST elevation. Upon retaking history, which of these history examination features have the lowest likelihood of association with MI? So understand, they are asking you all these are features of MI, but what is telling you least likely chance of MI? So understand this. MI that is with diaphoresis, so all these are having association. So remember, any person who is having MI, that is addition to left arm, this is having maximum association. MI can be with nausea, vomiting. So we sometime with diaphoresis, what we call this angina equivalent. So that is having a classical association, and it can be with nausea, vomiting. But remember, MI pain also we can say it's a pressure type of pain. But this pressure type of pain, remember, it is having the least chance of having MI. So I repeat my statement, these all are features of pain, MI pain, but this is called a less likely thing. This is like a, you can see a flow chart given in RSM. So less likely chance is pressure, that is less association when compared to others, even though it's a feature of MI. So with this we'll conclude the session. I have taken huge time, so I think your other subjects discussion is still on the pipeline. So let us discuss those things. Thank you so much. Keep working hard. Bye bye.
Welcome friends, now we discuss psychiatry. First question which was asked, mini mental status examination is used to assess, that is MMSE. There are 30 questions in MMSE, 30 questions are there. Point it out, many times questions are asked and they try to confuse between MSc and MMSC. I write here MSc, that is mental status examination. A question was asked in FMG that mental status examination is used to diagnose psychiatric illness. Means in psychiatry we diagnose psychiatric illness by mental status examination. What is the status of the mental health? Okay, by MSc. In mental status examination there are multiple points. Those are general appearance and behavior, affect, speech, thought, perception, affect. But MMSC is different. MMSC, yes, I write MSc to diagnose psychiatric illness. But MSc is having 30 questions to screen cognitive decline, higher mental function, cognitive decline. Yes, just like dementia. 30 questions are very simple questions, just like what is the date, what is the year, what is the season. If a person is not giving answer of these such simple questions, then he might be having dementia. And when out of 30, yes, if score is 23 or less than 23, we suspect dementia. This question has been asked. So 23 or less than 23. So MMSC is used for cognition. Got the point? Now, next question. 45-year-old male present to his psychiatrist with symptoms of persistent sadness. First symptom is sadness, loss of interest in activities. Second symptom, loss of interest, feeling hopelessness. Third symptoms, past 6 months. He also mentioned thought of death and recurrent suicidal ideation. You know, if a person is having depressive symptom and suicidal ideation, the diagnosis is severe depression. Okay, in this question, psychiatrist diagnosed him with major depressive disorder. Severe depression is there. You all know question has been asked in mild depression. We start with CBT, cognitive behavior therapy plus exercise. In the same way, question was asked, there is a pregnant woman having mild depression, what you will prescribe, CBT or SSRI? Definitely CBT. Yes, mild depression, CBT. Now, severe depression, we use antidepressants. You can see antidepressants are chosen. There are so many antidepressants, you know. Antidepressants are chosen partly on side effect profile. This question has been asked so many times. Recent update. Previously we used to say that yes, this is synopsis 11th edition, this is 12th edition. The only word which is changed is partly. Means previously we used to say antidepressants are chosen on the basis of side effect profile. Now we started saying antidepressants are partly chosen on the basis of side effect profile. Means other parameters are also considered. Yes. So in this, which of the following is not? Point out. Yes, answer is yes, Patel. Surbi, you have given correct answer. Patel, yes, change your answer. SSRI, yes, it is antidepressant. We will give. Tricyclic antidepressant, yes. Monoamine oxidase inhibitor, these are yes antidepressants. And atypical antipsychotics are not traditionally used. What is the significance of atypical antipsychotics? I will discuss shortly. For the time being, yes, this question is potential question and latest update. You know that in depression there is decreased serotonin, question is asked. Decreased norepinephrine, question is asked. Decreased dopamine. Okay. So if you increase serotonin, norepinephrine or dopamine, symptoms will recover. That's why SSRI, selective serotonin reuptake inhibitors, yes, used as antidepressant. Serotonin, norepinephrine reuptake inhibitor used as antidepressant. Norepinephrine, dopamine reuptake inhibitors used as antidepressants. Tricyclic antidepressant, MAO inhibitors and atypical antidepressants, these are common antidepressants and these are chosen partly on the basis of side effect profile. Let me tell you one example, mirtazapine. Mirtazapine has sedative potential. So if a patient is having depression and so much of disturbance in sleep, we can prescribe mirtazapine. Okay? Now, atypical antipsychotic can be given in treatment-resistant depression. What I said, treatment-resistant depression, if two antidepressants are not improving the patient, then you can give low dose of atypical antipsychotic as augmenting agent. Augmenting agent, this question has been asked in modified form. Yes, low dose antipsychotic. Low dose antipsychotic augment the effect of antidepressant, means this is not the treatment, it is improving the effect of antidepressant, augmenting the effect of antidepressant. So used as augmenting agent, not the treatment. Okay, not commonly used. So answer is D. Now next question. Yes, a patient with personality disorder present with pattern of disregard for and violation of right of others. Please do give answers. As well as lack of remorse for their actions. Which of the following personality disorder is most likely present? All these personality given in the options are, all these personalities are cluster B personality disorder. Cluster B personality. Okay. Cluster B personality, yes, include histrionic personality. How you will remember histrionic personality? You remember Rakhi Sawant, Poonam Pandey, you will never forget. Yes, they want to be center of attention. Yes, you must have seen Mikka history of Rakhi Sawant. Okay. Dramatic and exaggerated emotions they have. Behave in sexually seductive way, use physical appearance. All these things I am not saying, it is written in the books. So histrionic personality is different in this question. Yes, they have given violation of rights of other, disregards. Okay. Let me give you example of Salman Khan for this question and antisocial personality disorder. Yes, you can remember by Salman Khan. So many cases are there. Unlawful behavior. No regards for the right of others and violation of them. Means if you want to remember the symptoms of antisocial, remember Salman Khan. I don't say that they are having this personality disorder, but you will remember forever. Yes, no regards for the rights of other and violation of them. Yes, the person who is living on footpath, they have their own right and he violated. Lack feeling of guilt. काला हिरन मार दिया उसके बाद भी गिल्ट नहीं आया. No empathy. Yes, don't learn from past mistakes. इतनी सारी girlfriend, so many girlfriend left him, but he never learned how to make girlfriend happy. Extreme sense of right, substance use disorder. So in this question, they have given disregard, violation of right of other, no lack of remorse for their action. The answer is B. Okay. Yes, pattern of disregard and violation of rights of other, lack of remorse of their action. Answer is yes, antisocial personality. Yes, narcissistic personality, they boast about him, excessive self-importance they have, belief about being special and talented. Yes, Narcissus was a person who saw his image in water and fell in love with him. Okay. They have fantasies of unlimited success and power, low tolerance to criticism. Okay. Narcissistic personality. Fourth option, borderline. Frequently asked question, borderline, multiple line. Many times you will find that there is a girl, she is having multiple linear scar mark over forearm, she is having impulsive behavior. Yes, impulsive behavior means on small issues she cut her wrist. Okay, self-injurious behavior, splitting, black and white view. What does it mean? Question is asked. In borderline personality, these persons see either best or worst. Suppose a girl having borderline personality met you in the morning and started saying, you're the best person I have ever seen, now we are friends. In the evening, she called you. Yes, you did not pick the phone. She started saying, you're the worst person I have seen in my life. Yes, means either best, either worst. Breakup. Means unstable relationship. Impulsivity is there, emotional instability is there. When there would be so much of instability, yes, chronic feeling of emptiness would be there. Yes, treatment is dialectal behavior therapy question. Yes, remember borderline self-injurious behavior, बार बार इंजरी करेगी तो मर सकती है, मरना मतलब डाई, so mnemonic बन गया डाई. Okay, borderline, multiple linear scar mark, narcissistic, yes, special talented. Yes, unlawful behavior. In this question, clear cut given that unlawful behavior is there, violation of rights of other is there. Okay, no remorse for their action. Yes, don't learn from the past mistake. Okay, clear? Next question. Yes, long clinical question, commonly asked topic, schizophrenia. In schizophrenia, they usually give long clinical question and you will find answer very simply. Let me discuss. 23-year-old male brought to psychiatric clinic by his family due to concerning change in his behavior and thinking pattern. He believes that people are plotting against him, spying on him, trying to harm him. Delusion of persecution. This is delusion of persecution. Yes, the patient also experience auditory hallucination, hearing voices that criticize and threaten him. Yes, auditory hallucination. So first symptom, delusion of persecution. Second is auditory hallucination, typically accompanied by social withdrawal, impaired functioning, decline in personal care. These are seen in schizophrenia. So if two symptoms are there, definitely diagnosis would be psychotic disorder. So paranoid personality disorder can't be the answer. In paranoid personality disorder, there would be no hallucination. Conversion disorder, this is different entity. You will find there sometimes there is sudden blindness, sudden loss of vision, sudden seizures, pseudo seizures. Yes, means physical symptoms, all investigation are normal. That is conversion disorder. So can't be answer. Severe depression with psychotic symptom. In this, depressive symptoms are not given. So answer is paranoid schizophrenia. Answer is paranoid schizophrenia. In paranoid schizophrenia, there is delusion plus hallucination predominantly. According to ICD-10, schizophrenia was classified in different types. Paranoid schizophrenia, catatonic schizophrenia, hebephrenic schizophrenia. But according to ICD-11 and DSM-5, these subtypes have been removed. Now, paranoid schizophrenia, hebephrenic schizophrenia, these terminology has been removed, but even now questions are being asked. Okay. So answer is paranoid schizophrenia. Clear? Which of the following is not an impulse control disorder? This is recently asked topic, recent change in the classification. Kleptomania, impulse control disorder. Pyromania, intermittent explosive disorder. Yes, these are impulse control disorder. According to ICD-10, trichotillomania was impulse control disorder. But according to ICD-11 and DSM-5, trichotillomania is obsessive compulsive and related disorder, OCRD. So answer is D. Answer is D, trichotillomania. Let me summarize. Impulse control disorder, ICD-11, kleptomania, pyromania, intermittent explosive disorder, compulsive sexual behavior disorder. Means ICD-11 trichotillomania is not impulse control disorder. Okay. Thank you.
Hello students, very good evening. How are you? So as you know, I am Dr. Sarabjit, your ENT faculty, and I am here to discuss the questions. So hello Dr. Surbhi, Dr. Lala, Dr. Gajender, Dr. Rucha, I hope you guys are there listening to me. Am I audible, loud and clear? Please give me a thumbs up in the comment section. I'm reading all the live chat that you are there, that you are sending me. And I'm going to discuss the questions. Now I believe that you already have the explanations in the app for all these questions. So my motto over here will be to conduct a doubt session for all these questions and the related topics. So we'll go very quickly because we have a detailed explanations there that I myself have gone through and written them. So let us just go through a doubt session. Let's go by the questions. So some of the questions they were asked in the part 1 and some which were asked in the part 2. So let's go to the questions which were first asked in the part 1 of the paper. So 70-year-old patient presented with decreased hearing in both the ears which slowly progressed over the last few years. A Peyton audiometry was done, which revealed bilateral sloping curve. Okay, so you know bilateral sloping curve. 70 years is the age of this patient. Bilateral sloping curve signifying presbyacusis. So diagnosis of presbyacusis is there given to you. You know, signifies everything that is there should be in presbyacusis, old age, bilateral sloping curve. Which are the following parts of the inner ear has been affected in this patient? So you know we have the FMGE exam, and the next after that we have the next exam in December. So a lot of integrated questions will be asked. So I have tried to integrate the questions over here. So this is an integration between two topics. Which two topics? First topic is presbyacusis as mentioned over here, right? So presbyacusis, we know about presbyacusis, this bilateral sloping curve. So what do we mean by bilateral sloping curve in Peyton audiometry? Bilateral sloping curve means that there will be, you know, there will be less hearing loss in lower frequencies and more hearing loss in higher frequency. That's the meaning of the sloping curve. So bilateral means both the ears are affected in presbyacusis, right? So that means which frequencies are affected? Yes, the frequencies which are affected are the higher frequencies. And then the second concept is the frequency localization in cochlea. Now this concept of frequency localization in cochlea, this was given by von Beckezy, was the final one who gave the traveling wave theory. So that was a traveling wave theory, and von Beckezy won a Nobel Prize for this traveling wave theory. And this traveling wave theory, we know that the 20,000 hertz, the higher frequencies, they are heard more at the base, and the lower frequencies, they are heard at the apex, right? Okay, so you know higher frequencies are heard at the base, lower at the apex. So which frequencies are being affected? The higher frequency. So therefore the answer is at the base of the cochlea is the one which has been affected, right? Any doubts that you have in this question? If no, then I'll go forward, okay, and if there will be any queries, I'll take them at the end if any queries are left, right? Now let's go to the second question. 38-year-old patient. So let's keep on highlighting the important highlights over here. 38-year-old patient presents with bilateral nasal obstruction, anosmia, and hyponasality of voice. He also complains of facial tenderness in the cheek area. On examination, multiple bilateral small nasal polyps are seen. Okay, so multiple bilateral small nasal polyps are seen. What is the most likely site of obstruction by these polyps? So what is the diagnosis? What is the diagnosis over here? You see patient is having chronic rhinosinusitis, there is tenderness in the cheek area, patient is having anosmia, patient is having hyponasality of voice, there is nasal obstruction, bilateral. So diagnosis being pointed over here is bilateral ethmoidal polyps. Okay, bilateral ethmoidal polyps, that's the diagnosis being pointed over here. And where do they you know block? So most common site of obstruction is in the middle meatus area, right? So right Surbhi, right Gajendra, right Lala, no doubts. So these are the bilateral ethmoidal polyps, you know. You can see the endoscopy of one side. So these, the most common site of blockage is the middle meatus. Remember the OMC that I have taught in my lectures, osteomeatal complex. Osteomeatal complex, that's the place where we have the draining of maxillary sinus, we have the draining of frontal sinus, and we have the draining of anterior ethmoids. So that's the place, you know, one is blocked. If the polyp is coming from one of these, it can lead to even pansinusitis. So this is also very important. Let's go to the next question. A 55-year-old female has been diagnosed with nasopharyngeal carcinoma that has spread to the sinus of Morgagni, right? So here there is a spread to sinus of Morgagni, right? Which of the following structures will be affected due to the spread in the sinus of Morgagni? So, you know, sinus of Morgagni, let's first study the sinus of Morgagni. So, you know, there is a space over here. If you look at this photograph, that's what I have taught in the start of the pharyngeal wall. There is a space over here, this space between the skull base and the upper border of superior constrictor. This space, this is known as sinus of Morgagni. there is a anatomical space over here. And what structures pass through sinus of Morgagni? So we have the mnemonic is palate, and that mnemonic stands for, ascending palatine artery, then levator villi palatini, ascending pharyngeal artery, and eustachian tube. Okay, so these structures, they are the one which will be affected whenever the sinus of Morgagni is involved. Okay, so let's look with this information. Let's look in this. So we have the ascending palatine artery, which is the branch of facial artery. Okay, so this is involved. We have which of the following structures will be affected. So this is the structure which will be affected: glossopharyngeal nerve, stylopharyngeal muscle, rectolaryngeal nerve. These one will not be affected. So answer is the ascending palatine artery. That's a branch of the facial artery. Right, friends? Okay. So let's look at the next question. All of the following are true about ranula except. So what is a ranula? So this is a photograph of a ranula. What is a ranula? So ranula is an extravasation cyst. Okay, it is formed by the secretions, salivary gland secretions. Which gland? Sublingual gland. Right? So it is because of, secretion, it rises from the sublingual gland. It's an extravasation cyst. How do we, treat it? We can treat it by two ways. One is by excision, surgical excision. Other is by marsupialization. That also we can do. It can extend into the neck. Yes, this is also true. So this is true, this is true, this one is false. Okay, it does not arise from the submandibular gland. That is the answer in this question. Right? Okay, if it extends into the neck, it is known as plunging ranula. Okay, so this will be known as plunging ranula. Right. The next question over here: a patient presents to your OPD with a complaint of stridor following total thyroidectomy. Guys, I'm going fast and I'm not seeing, you're answering, you're commenting over here, that's very good, but I'm not seeing many queries. So if I don't see queries, I believe that you are understanding the question and the explanation. You are well versed with the topic, but if you are not, please write your doubts, please write your queries. I'll slow down there and I'll discuss that topic in detail. Right? Okay. So a patient presents to your OPD with a complaint of stridor following total thyroidectomy. All right. So total thyroidectomy has been done and there is a complaint of stridor. The speech is normal, no history of aspiration. On endoscopic examination, the vocal folds are found to be in the position shown below. So let's look at that image. So what do we find? They are both in the paramedian position. There is some gap over here, but you can see that they both are in the paramedian position. So bilateral paramedian position, and that means that they are having bilateral abductor cord palsy. Okay, so bilateral abductor palsy. That means which nerve is affected? Which nerve is damaged? Answer is recurrent laryngeal nerve. Bilateral recurrent laryngeal nerve. Right? So that one is damaged. So the following is true about managing this condition. What do you have to do? What do you have to do? You have to do type 2. The treatment is, yes friends, treatment is type 2 thyroplasty or lateralization of the vocal cords. Okay, so that is the answer over here. Lateralization of vocal cords. You can see that both are in the midline. They are in the paramedian position. So problem is airway. So you have to lateralize it. Okay, even if you haven't read the vocal fold palsy, you can see that they are in the midline and you have to pull them apart to improve the airway. Right? So bilateral recurrent laryngeal nerve palsy, remember, most common cause is thyroid surgery. Patient has stridor, but the voice is good. All right, and this is what is mentioned over here in this question. There is no aspiration also. Right? Now vocal folds lie like this in the paramedian position. Right? Okay, treatment. First you have to make an airway. Patient is having stridor, so you have to do tracheostomy, and then followed by that you have to do type 2 thyroplasty. That is lateralization of the vocal folds. Right. Narrowest part of the infant's airways. We know that the infant's airway is funnel shaped, whereas the adult airway is tubular. So, which is the narrowest part in the infant's airway? The subglottis, right? Okay, so let's look at some differences. Infant larynx is funnel shaped, whereas adult is cylindrical or tubular. So, subglottis is the narrowest part in neonates. Infant larynx is situated a little higher also at the level of C2 to C4. Okay, so therefore neonate is able to breathe and suck milk at the same time. And now the epiglottis is long, floppy and narrow, right? And if it becomes a little soft, it becomes omega shaped and it causes stridor during inspiration. We call that condition as laryngomalacia, right? Okay, next question over here. A mother brings a 2-year-old child to your OPD with complaints of fever, stridor, barking cough and difficulty in breathing for 2 to 3 days. Which of the following is not true about the condition he is suffering from? So, you see, 2-year-old child and barking cough, on top of it stridor, right? What diagnosis do you have? Barking cough, the diagnosis is clear, croup. Acute laryngotracheobronchitis, LTB, right? We know it is caused by parainfluenza virus type 1 and 2. So, this is true. What you have to find out? You have to find out which of the following is not true. Okay, so be sure what is asked in the question. So, it is caused by parainfluenza virus. Yes, that is okay. Thumb sign is seen. No, thumb sign is not seen. Thumb sign is seen is acute epiglottitis. What we see over here is steeple sign, right? Males are more commonly affected than females. Symptoms are because of involvement of subglottis. You see, you have a critical answer over here, right? So that, this is the answer that you were looking for. Very, very important. So everything else becomes right. This is the one which is wrong over here. Okay, so remember, what do we see in croup? We see steeple sign. So narrowing of the airway. Which part is most commonly narrowed? The subglottis, right? So that is why we have this steeple sign. So the other points are also correct. Just wanted to show you this steeple sign, and this is asked in the exam. This X-ray is asked quite a lot of times in the exam. So very, very important X-ray. Okay, which of the following does not contribute to the formation of nasal wall? Let's look at the nasal wall. So we have two nasal walls, external and internal. The one the examiner is talking about is the internal nasal wall, and this nasal wall we know is formed by the lower edge of the upper little cartilage, inferior turbinate and septum. In between them we have this nasal wall or the nasal valve area, and there is an angle over here also. This angle has to be more than 10 to 15 degree, otherwise it will lead to nasal collapse, right? And remember, this nasal valve area, this is the narrowest part of the nasal airway. 50% of the nasal airway resistance is because of this part only, right? Okay, so let me take you back to the question. Which of the following does not contribute to the formation of nasal valve? Now you know that the inferior turbinate is there, the upper little cartilage is there, nasal septum is there. So what is not there? Yes, middle turbinate. That is our answer, right? Okay, let's look at the next question. Patient with blowout fracture has decreased sensation over the cheek. So which are the following nerve injury? So blowout fracture, the floor of the orbit is gone. The content are hanging in the maxillary antrum. You have that teardrop sign, right? Now, which nerve will be affected? So you know which nerve is coming from the floor? Infraorbital nerve. That is why you will have decreased sensation over here at the cheek, anesthesia in this place. So which nerve is affected? Yes, we have seen it. Answer is infraorbital nerve. This was a straightforward question. Okay, just based on anatomy. So interior question, start from ENT, go to the anatomy, right? Okay, patient is using chymicetin solution for atrophic rhinitis. Which of the following is not a component of this solution? So very interesting question. Chymicetin solution is quite commonly known in ENT, and this solution is used for atrophic rhinitis. So you know, atrophic rhinitis, whenever we talk about the medical treatment, we know about alkaline nasal douching. There you can give 25% glucose in glycerin. We can give antibiotics, vitamin D and estradiol. All right. Now there comes a chymicetin nasal solution. Now this solution consists of antibiotic chloramphenicol, Okay, vitamin D, it consists of vitamin D, it consists of estradiol. Right, chloramphenicol, vitamin D and estradiol. All three of them together, and this is used in atrophic rhinitis. Right, okay. So let's go back to the question, which of the following is not a component? So you can see chloramphenicol, estradiol, vitamin D, they are component. Sodium bicarbonate is not a component. Sodium bicarbonate, as you can see in this over here, it is a component of, alkaline nasal douching solution. Okay, not a component of the chymocytin solution. Right, okay. Now the questions which were asked in the part 2. Before I go to the part 2 questions, 5 questions are left. We have done the 10 questions. Any questions, any queries that you have, guys? Yes, I'm waiting for you to write in the comment section. Any queries that you have? No? Alright, so then let's go to the part 2 and then we will take the queries all one together at the end. 50 years patient presented with slow progressive sensorineural hearing loss. Okay, 50 years patient presented with slow progressive sensory hearing loss on the right side. On the examination of the external auditory meatus, there is decreased sensation on the posterior superior side. Decreased sensation in the EAC posterior superior aspect. Right. Gadolinium enhanced MRI was done and showed a solid intensely enhancing nodular mass with the intracanalicular component leading to the widening of the internal acoustic meatus. So, this is how the MRI, the radiology people give us the diagnosis, they give us the description, and this description is the description of vestibular schwannoma. Okay, canalicular means which canal? Intracanalicular, which canal? Internal acoustic meatus or internal auditory canal, IAC. So the radiologist is talking about the IAC over here. So this is a vestibular schwannoma. Okay, this question is a question of vestibular schwannoma. Now, absence of sensation in the posterior superior wall of EAC in this patient is known as. So let's look at it. I have taught you this at 2 places. One when I was teaching you vestibular schwannoma. Second, when I was teaching you EAC nerve supply. So let's look at the EAC nerve supply. Anterior superior we know is auriculotemporal. Anterior inferior we know is Arnold's nerve. Posterior and we have a cuff reflux in syringing. That's because of Arnold's nerve. Posterior inferior I told you is C3, not very significant. Posterior superior is supplied by 7th nerve, and if this is absent, it is known as Hitzelberger sign. Okay, so therefore the answer is choice C, that is Hitzelberger sign. The remaining A, choice A was Brown sign. So Brown sign, choice B was pulsation sign. Okay, so these are the signs which are seen in glomus tumor. They are not seen in vestibular schwannoma. Okay, and this answer was particularly about loss of sensation in the posterior superior aspect of EAC. So that is, Hitzelberger sign. Right. Okay, next question. A 30-year-old lady presents to ENT OPD with complaints of vertigo whenever she rolls and wakes up from bed in the morning. Vertigo lasts for less than a minute and recurs while working in the kitchen when she tries to pick something from the upper shelves. Which of the following maneuver is used in the diagnosis of this patient? So, what's the diagnosis? She rolls and gets up in the word. Vertigo due to change in position. Friends, at your level, only one diagnosis is there. Positional vertigo, only one diagnosis. Okay, and the diagnosis is BPPV, benign paroxysmal positional vertigo. Remember, in the exam, whenever positional vertigo is asked from you, your only diagnosis is BPPV. And at your level, you only have to talk about BPPV of posterior semicircular canal. Okay, no other canal. That is what you have to talk about. Okay, that is what is there in the undergraduate course. Right? And what is the method used to diagnose it? Answer is Dick-Solpike. What is the method used to treat it? That is Eplase. Okay, Applause, this, this I've kept the Applause over here. This photograph is many a time asked in the exam. Okay, so Kelvin has asked me, can you demonstrate the Applause maneuver? It's a PYQ. So this is the Applause maneuver. Step 1. Okay, so let me take it back. So step 1 over here is patient sits, right? Okay, these are different steps. As you can see, patient is sitting. You turn the head 45 degrees to one side. Right, this is what you do in Dick-Solpike. So suppose I'm testing for right side, I turn the head 45 degrees to the right side, and then the patient is made supine, right, with the head hanging beyond the edge of the head, beyond the edge of the bed. So that's your first step, right, over here, from here to this position, right, and now the patient is looking at the right upper corner of the room. Patient has vertigo, patient has nystagmus, that confirms patient has VPPV. You have done Dick-Solpike. And then, this part is Dick-Solpike maneuver for diagnosis. And then you don't bring the patient back. You continue with Applause. So what you do is, patient is looking at the right upper corner. Now you turn the head and make the patient look at the left upper corner. Okay. So that is, this was right upper corner of room. This is left upper corner of room. This is when we are treating for right side BPPV. Okay, so let's say we are treating for right side BPPV. And then you turn the entire body by 90 degrees. So patient is looking at left lower corner of room. All right. And finally, you bring the patient back to sitting position. So now the patient comes to sit on the other side of the bed. Right. So this is your Applause maneuver. You can also see the first part, which was your Dick-Solpike maneuver. So both the maneuver are seen in this one photograph only, and they can come as your questions. Right. Next, a 22-year-old patient presented with the following ear finding on otoscopy. So what do you see on otoscopy? So otoscopy, you can see a central perforation. Right. And tympanoplasty surgery is planned. Okay, so of course, we do tympanoplasty. In this case, we will do maryngoplasty, type 1 tympanoplasty. Which of the following is the most commonly used graft for this surgery? So we know for tympanoplasty, the most commonly used graft is temporalis fascia. Now, why do we use temporalis fascia? Because of two reasons. One, it is present in the same incision, right? The second is that its consistency is same as the consistency of tympanic membrane. In fact, when we operate and if we have used temporalis fascia after a few months, not even years, after a few months, when you see the results, you can't even say that the patient has undergone any surgery. Especially, if you have done a transcanal surgery or a endural surgery, there is no scar visible, there is minimal scar or no scar visible, so you cannot even tell that any surgery has been done for this patient. Right? Okay, let's go to the next question, which is the following is false regarding eustachian tube. Quite a simple, straightforward question, because this is not a next exam. This mock test was for FMGE exam, and you will get a few straightforward questions as well. Okay, image-based questions will be there, clinical questions will be there. Few of these straightforward questions will be there, but in the next exam, all the questions will be the clinical questions. All right. So yes, also known as pharyngotympanic tube. Yes, eustachian tube connects oropharynx to middle ear. No, that's wrong. It connects nasopharynx to middle ear. It is 36 millimeter in length. Outer 1/3 is bony, inner 2/3 is cartilaginous. Right. So the answer over here is choice B. All right. And we have one more question left. This is a good clinical question. Right. A 35-year-old patient who is under chemotherapy. So very important, who's under chemotherapy treatment for acute lymphoblastic leukemia, complains of severe pain in the right ear. All right. So patient has severe pain in the right ear. On examination, the angle of mouth has deviated to the left side. The right nasolabial fold is absent. The right-sided eye closure is incomplete on effort. Forehead wrinkles are also absent. So what is the examiner saying to you? There is right side pain, and all this shows that there is right facial palsy. There is right facial palsy. Okay, what else? On ear examination shows a greenish black discharge coming from EAC along with granulations in the right EAC. So what is your diagnosis? You know, immunocompromised patient. Why immunocompromised? Because patient is undergoing chemotherapy. Right now patient status is immunocompromised. And facial palsy, ear discharge, severe ear pain, granulations in the EAC. Granulations is a very, very typical sign. Okay, granulations. So this points towards the diagnosis of malignant otitis externa. Right? Okay. Now it is caused by Pseudomonas aeruginosa. So that is a true statement. Most commonly affected nerve is facial nerve. Yes, that's a true statement. Seen in immunocompromised individual. That's also true statement. Radiotherapy is the treatment of choice. Yes. So Sunil, Lala, they say, okay. Treatment of choice is not steroids. Treatment of choice, Sunil, you are wrong over here. Treatment of choice is ciprofloxacin. Okay, we have specific anti-pseudomonal antibiotics, but over here treatment of choice is ciprofloxacin. Please note down, that's an important question. It can come in the exams as well. Right? So these were the ENT questions that we gave today. They are clinical questions, all from different topics covering ear, nose, pharynx and larynx. And the idea was to give you a feel of how the real exam is going to be. All right. I hope the paper was not too tough or it was not too easy. You got the real feel of what it was. We are also coming with the CBOT, where you can actually go to an exam center. On the next Sunday, you can go to the exam center. You can have that feel, you know, that anxiety is there in the students, you know, on the day of the exam, on that stage fright. So we want to remove that. So we have especially arranged for CBOT centers in Delhi, and you can guys go and register for that. It's totally free of cost. You don't have to pay anything for it. So just register for that CBOT program. So that will be a mock test, but inside the exam hall on the computer, and you can assess yourself. You know, you can access your stress response as well. So that's an extra effort that we have taken. All right. So that you can have that real feel. So I request all of you to take advantage of such an opportunity which is being provided by Alan. Register yourself before 4th of July, and you can have that registration number and everything. You will be given the admit card to go in the center and give that mock test. And best of luck. Okay, GSE and technetium scan for diagnosis. Okay, so Meeta is asking a question, right? So question is, you know, diagnostic investigation of choice in this case is technetium 99M, right? Technetium 99M bone scan, that is the diagnostic investigation of choice, right? Whereas gallium scan, GA67, this is the prognostic investigation of choice, right? Okay, thyroplasty and vocal fold palsy, that's a topic in itself, beta. But I'll just say that there are 4 types of thyroplasty, type 1, 2, 3 and 4. So just remember, 1 and 2 are opposite to each other, 3 and 4 are opposite to each other, right? That's clear. Okay, so one is medialization of the vocal folds. What are you doing? You are bringing them together. 2, we discussed just now, lateralization of the vocal folds, right? So remember, 1, you are bringing them together, 2, you are taking them away. Okay, 3 and 4. How do you remember 3 and 4? So 3 is used to treat puberphonia, 4 is used to treat androphonia. Okay, 3 is used to treat puberphonia. Puberphonia means female-like voice in males. Androphonia means male-like voice in females, right? So remember these 4 things, right? The answer for thyroplasty and vocal fold palsy, especially the thyroplasty, will be done for you, right? Okay, detail, you'll have to go to the video and watch it. It's a half an hour, 45 minutes video. I've given everything, explained everything in detail over there. So we'll end the session over here, not extending it too much. Best of luck, guys. I hope that you all crack this exam. This is going to be the last FMG exam. So give your best. We have another 28 days left, 27 days left now. So give your best, put in everything, whatever you have, and just crack this exam. Thank you.
Hello my dear friends, a very warm welcome to all of you in this PSM session, and let's discuss some of the important topics through questions which are expected to come in your upcoming FMGE exam. The first question is from home-based postnatal care, HBPNC. In home-based postnatal care they are asking what is the number of visit which will be done. And in such type of question, you have to look whether they have given the weight of the child or not. If weight of child is not given, then we do 7 visit in case of hospital in case of home delivery, and we do 6 visit in case of hospital delivery. Okay, and here in this question weight is not given and they are asking institutional vaginal delivery. So the delivery is in hospital and weight is not given, so we will choose the option C, 6 visit on day 3, 7, 14, 21, 28, 42. But if they have given that weight of child is less than 2.5 kg, in that case, we will do 4 visit if there is home delivery, and we will do 3 visit if there is hospital delivery. So this 4 visit are on 0, 3, 7, 42, and this below 3 visit are on day 3, 7, 42 if weight is given. So this question was simple, but similar to this question, they also asked one question in NEET exam recently, that in a village people are not eating papaya because they think it can cause abortion and all. So who will visit the home of the mother, screen for deficiency, and refer the mother to higher center? So these are the work of ASA. ASA does home visit, and if she found any disease in mother or child, then she will screen for it and she will refer the mother to higher center. And remembering these days of visit is not so difficult, because if you see the home delivery timing, except 21 and 42, rest 5 are the same which we give in rabies. Kutta kata mein bhi same 5 day hota hai. So that same 5 day is there in case of home based postnatal care also. And through this home based postnatal care, ASA screen disease and refer. So this is the work of ASA. Now, why are we having the visit on 42 day? Why 42 day? Because when we are writing the definition of maternal mortality ratio, which has been asked 3 times already in exams, then in this definition we write that how many death, number of death within 42 days of delivery. So that's why the last visit is on 42 days to count for all the MMR. And these deaths should be due to delivery related causes. Suppose I am a pregnant female, and after my delivery I put my finger in electric short circuit and I died. So will it be maternal death? No, of course not. But suppose after my delivery I am feeling very depressed because everyone is looking on only child care. No one is looking at me. Before delivery everyone was looking at me, giving me very value. So now I feel depressed. I went on the rooftop and I jumped from there and I died. Will you count it as maternal death? Yes. Because postpartum blues, postpartum depression is a delivery related cause. So in this definition, we write number of death here, we write total live birth below, and we multiply it by 1 lakh. Okay? Not by 1000. So do remember this definition, and do remember it is a ratio, because in ratio, numerator is not a part of denominator. Because you can see here we have the numerator of mother and denominator is live birth. और मैं अपनी माँ से आया हूँ या मेरी माँ मेरे से आई है? Of course, mother did not came from the child. Child came from the mother, na? So that means we cannot say that numerator is coming from denominator. Mother is not coming from live birth. They are separate. So just like sex ratio, it is also a ratio, not a rate. Second thing they ask from this part is, they can ask you about, I dropped my pen. So they ask about IMR. They will ask the question in this way, that which is the best indicator of accessibility and affordability of healthcare system. Okay? Accessibility and affordability of healthcare system best estimated by which of the following. So in that case also, IMR will be there. Plus if they ask what is the best indicator of impact of ASA work, that is also IMR. And if they ask what is the best indicator of female condition of a country, again IMR will be the answer. Do remember, infant mortality rate is best indicator of all these 3 things. ASA work, impact of ASA work, accessibility and affordability of healthcare system, and female condition. Why female condition? Because most common cause of infant death in India is premature delivery, delivery before 37 week. And delivery before 37 week occur only if mother is malnourished. So if IMR is high, it means mother are more malnourished. So IMR also indicate female condition. Do remember, this is indicator of these 3 things. Next question, during your posting an emergency after the dressing of patient, in which dustbin will you discard the gloves? So gloves, whether it is normal gloves or in one exam they have asked about acrylic gloves, they will go definitely in red dustbin because they are plastic waste. If they are asking about, let's say they have asked it plastic wrapper of syringe. So plastic wrapper is also plastic, but it is not contaminated with blood. So this is just a garbage. So it will go in black. Then they have asked about doctor prescription. So doctor prescription is also do not have any infectious material on it. So that will also go in black. They have asked about cotton, which will go in yellow. They have asked about the blood bag. So blood bag is made of plastic, but because it has blood which is infectious, so that will go in yellow. But if they ask about urine bag, then urine bag, just like gloves, they will go in red because urine is less infectious and urine bag are very large in number. So we cannot burn them through incineration. This question has also been come that how we discard yellow category waste, in which category we do incineration. So incineration is done for yellow category, okay. And blue, I hope you all know, is for glass and metallic instrument. And then there is white, which we remember for SARP, but along with remembering SARP, it's better to remember 4 things which come under white. One is all the scalpel, surgical scalpel, because it is difficult to remove blade from it, so that will go under it. Then all the suture will go under it. They have asked this question that needle with fixed syringe, so that will also go in white. Suture needle will go into it, suture needle will be sharp and all, and needle with fixed syringe will also go in white. Some question which came. Then they have asked the question that if there is blood spill from HIV patient or any patient, then on the blood spill what will you pour? So on that case we will pour 1% sodium hypochlorite, not 0.5%. 0.5% sodium hypochlorite is used to wipe the surface of the room of the patient. Like if you have to wipe the table or the doorknobs of the COVID patient, then you will use 0.5% sodium hypochlorite. Okay. So these are some of the questions. Do go through it. Next, for Ayushman Bharat, they are asking what is the correct statement. First, Health and Wellness Center for upgradation of CHC and Medical College. No, this is wrong statement, because Health and Wellness Center is for upgradation of 1.5 lakh sub-center and some PHC. They will be upgraded and they will be known as Health and Wellness Center. Then second option, PMJ give 5 lakh per year health insurance after hospitalization for BPL category, both private and government. Do you think it is right? Please give your answer for this question. Asutosh Sharma is asking a question with me that sir B क्यों नहीं हुआ इसमें? B इसलिए नहीं हुआ Asutosh, because it is plastic, so that will go in red. Why not yellow? Because as I was saying, in yellow we do incineration. In yellow we burn it. So if you will burn this many gloves, this many plastic, it will not only produce large amount of pollution but also produce polyvinyl chloride, which can cause liver cell carcinoma. So we don't want to burn this many plastics, this many gloves. That's why we will throw it in yellow. Okay. There is a lot of gloves and lot of plastic waste through gloves. So we cannot burn all that. That's why we are not throwing it in yellow. And that's why we are throwing it in red. Okay, Asutosh, I hope that you are okay. Yes, I agree, Asutosh, that there is blood on the gloves, but still we will throw it in red, because the logic is that gloves are large in number. Second thing is, in this red category also, we first go for autoclaving and then we recycle it. So recycle or just dispose the plastic and then recycle the plastic part. So through autoclaving, if there is any blood on it, it can be removed also. And therefore, even if it is some blood which is not written in the question also, even if it is written some blood, still you will write red only, because in the guideline it is clearly written all kind of gloves contaminated with blood also will go in red. Through guideline we are telling it, it will go in red. Okay. Sir, incineration is up to only for yellow category. Yes, Mita, you are right. Incineration is only for yellow category, and we should remember the 6th thing which go in yellow. In yellow we have first, suppose very simple to remember. Let's say I went out after taking class and I had an accident. So through accident my leg is crushed and you cut my leg and some other nearby part, you will throw it in yellow. Then in that operation blood will come out, that blood or all the liquid waste will go in yellow. You will use some cotton or some the bed sheet where you are putting me after this injury, that will be soiled. So soiled waste will also go in yellow. Then you will use some drug on me, all the expired drugs and medicine, that will go in yellow. You will, after using this drugs on me, you might take some of my blood sample or some other specimen for culture to confirm which drug I am sensitive and not. So all the microbiological waste will also go in yellow. And last is cytotoxic. So what are the 6? Please remember it here. All the anatomical waste, all the liquid waste, all the soiled waste, all the discarded medicine, all the microbiological waste, and last is all the cytotoxic drug. Do remember all the 6, they all go in yellow and we directly burn all these 6. But if they ask, what is the best method of disposal of cytotoxic waste? So for cytotoxic waste or mercury, in both of this, the best method is collect and send it back to manufacturer or recycle. So remember, they have asked it for mercury already. Collect, send it back to manufacturer or recycle. Okay? Yes, very good, Mita. You have correctly written all the 6 things. You are absolutely right. So for this statement, Ayushman Bharat, Tora Chand Sahu has given the answer C and Dr. Rahul Kumar has given the answer D. The correct answer for Ayushman Bharat, definitely it is not BPL category. For BPL category, we have older insurance program, Rashtriya Swasth Bima Yojana, which was under Congress regime, in which 30,000 to 1.5 lakh insurance money was given to BPL category. PMJ, which is a part of Ayushman Bharat. Ayushman Bharat has 2 components. One is Health and Wellness Center, which we just discussed. Other is PMJ. And PMJ is for EWS category, and because in India even the government hospital is not free, so it is for both private and government hospital, EWS category, economically weaker section. And correct answer is by Rahul. Very good, Rahul, you are right. Very good, Surbhi, you are also right. Thank you for replying. I keep replying. Chalo, next question. In a given population, the growth rate is 0. At what phase of the demographic cycle is this population? So this part is confusing. Let's revise it quickly. There are 5 phases. In the 5 phases, it's very easy to remember. First is high stationary, and 4th is also high stationary. 4th is low stationary. Really sorry. So 1 and 4 are high and low stationary. Simple. The last 5th is, this is the way to remember it forever. The last phase is declining. Declining means that people are giving less birth and death rate is more. For example, surprisingly, last year in China, death was more than birth. So declining is 5. And how they ask question from it? One is this question, this type of question which I gave. Second type of question they ask is they will give you the birth rate and death rate, and they will ask in which phase this type of fluctuation occur. So first remember first 3 and 5. First is both are high. Birth rate is also high, death rate is also high. 4th phase is both is low. Birth rate is also low, death rate is also low. And in declining, birth rate become very low. Like in Japan and all other European countries, most of them, they are not producing children anymore. So their birth rate is very low. And death rate is something which can never become very low. It will remain stagnant at low at least. So first remember first 4 and 5, which is easy to remember. Now in phase 2nd and 3, high and low stationary, we have early and late expanding. So other way to remember it is early and late expanding are here, and in early expanding birth rate is high and death rate start decreasing. To remember it better, you can understand it with context of India. Like you must have seen it, heard it from your grandparents that in their time there used to be 7 children, 4 died, 3 lived, 9 children, 6 died, 2 lived, like that you must have heard. So that was the phase of high stationary. India was in this phase before 1930-40, India was in this phase. Till 40-50, India was in this phase. Birth rate was high, death rate was high. Okay? And I think, what do you think? Our grandparents were also high? They can be. I think they were also high. So everything was high there. And after that phase, 1940 and 1950 phase, government hospital came into play and delivery started occurring in government hospital. So death rate start decreasing because maternal and infant death decreased. So death rate start decreasing in early expanding, and after that medical advancement keep on happening. So death rate will decrease further. And in late expanding, India is right now. So right now India is in late expanding, but between 1950 to 1990, I can say India was in early expanding. So in early expanding, birth rate was still high, but death rate started decreasing. And after 1990, birth rate also started decreasing. Okay, so birth rate is decreasing, started decreasing, and death rate decreases further. So for remembering this demographic cycle, you just have to focus on phase 2 and phase 3. Because 1 and 4 are high and low stationary, 5 is declining. First try to remember that, and then 2 and 3. 2 more questions come from it. In which phase growth rate is maximum? So growth rate simply means birth rate minus death rate. And you can see in the phase 2, birth rate is high, death rate start decreasing. So the gap of birth rate, death rate is more in phase 2. So growth rate is maximum in late half of second phase. Late half of early expanding, growth rate is maximum. Second question they ask, in which phase growth rate start decreasing? So after early expanding, birth rate also start decreasing. So now the gap between birth rate, death rate started decreasing. So do remember it, growth rate start decreasing in early half of third phase. Okay. So these are the important points, and with context of India you can remember it. Let's come to the question now. Can you answer the question? Oh, most of you have answered it C, C. Some have answered A, some have answered D. So C, C, D is the most of the answer. Very good. Thank you for replying. They are saying growth rate is 0. And whenever the population is stationary mean growth rate is 0. So growth rate is 0 in 2 phases. Phase 1 and phase 4. That means early high stationary and low stationary are 0 growth rate. Correct answer is low stationary. I have seen it again and again that you think declining have 0 growth rate. No, declining stage have negative growth rate. Because in declining, birth rate is less than death rate. So declining means growth rate is negative. And just wait for 5 to 7 years. I can give it in written that India will also have declining growth rate. And right now India population is stable. And they have asked this question that what is the target total fertility rate? Total fertility rate simply means what are the total child per female. If they ask total child per 1000 female, then it becomes general fertility rate. If they ask total child per female, then it is TFR. So do remember, 1000 word if they use, answer is general fertility rate. GFR means total live birth per 1000 female, and 1000 is GFR. And then they have asked in MCI exam previously, what is the target total fertility rate for India? The target TFR, is it 2, is it 2.1, is it 2.5, is it 3? What is the target TFR of India? we want 2 child per couple, but for 2 child per couple, we want that every female should produce 2.1 children. Why 0.1? Because some children will die after birth. So 0.1 will die and finally it will become 2 child per couple. So target TFR is 2.1. Second point, very important to remember from it, that which came in MCI also, that if we want 2 child per couple, what should be the net reproduction rate? Do remember this point, that if we want 2 child per couple, for 2 child per couple, net reproduction rate should be equal to 1. That means every mother should have 1 surviving live children, 1 surviving live girl child. And if we want NRR to be 1, then couple protection rate need to be 60%. Then couple protection rate need to be 60%. What does it mean? It means if you gave contraceptive to 60% eligible couple, then unwanted children will be less and population will get stable. A very common area of question. Now, Meeta Somaya is saying that she's liking that is my study part, and thank you so much for liking it, and thank you for replying also, very good. Torachand Sahu is giving the correct answer, 2.1 is the target TFR, very good. So there are 4 terms, very confusing, and in just one line we can read all those 4 and we can keep it in mind, very important to revise. One is general fertility rate, other is total fertility rate, third is gross reproduction rate, and fourth is net reproduction rate. Okay. GFR means total child per 1000 female, and only those female can produce children who are between 15 to 49 years. So female between 15 to 49 will of course be there. If I say TFR, it is total child per female. If we think gross reproduction rate, then in case of gross reproduction rate and net reproduction rate, we only talk about girl child. Because nature need girl more than male, of course. Because only girl has this divine power to give birth to new life. So GRR, NRR only talk about girl child. GFR, TFR is total child. Now in GRR, we are writing how many live birth of girl child, live birth of girl per female. And of course, only those female who are between 15 to 49 years. But not all the girl child who took birth survive till old age, till reproductive age. Some die before 15 years also. So if we are subtracting their number, then it becomes NRR. So NRR simply means live birth minus the death which occur, minus age specific death rate for live birth of girl child minus those girl child who die divided by per female. So if you found in the question girl word, then only GRR, NRR will be the answer. And along with girl word, if you also find age specific mortality rate, if you found mortality or death word in the question, then it is NRR. Otherwise, girl without mortality word will be GRR. And TFR is total child per female, GFR is total child per 1000 female. So let me ask you a question here which will make me sure that you understand it or not. The question is that total number of girl child, girl live birth per female, considering age specific fertility rate, is known as, what will you call it? All these 4 options are there. A option is GFR, B is TFR, C is GRR, D is NRR. So what will you call total number of girl live birth per female considering age specific fertility rate? Try to answer it. First thing is, the answer cannot be GFR, TFR, because they are using the word girl, and GFR, TFR is total child. So these two are ruled out. Now, out of GRR, NRR, what is your answer? Dr. Lala Prakash has answered GRR. Okay. And Dr. Lala Prakash is 100% right, because what they are saying is, considering age-specific fertility rate or considering current fertility pattern, if they say, it simply means that they are talking about those female who are between 15 to 49 years. This is the current age-specific fertility rate for India or age-specific fertility trend for India. So if this I ask total child, girl child per female, and they have not used the word mortality, then NRR will not be the answer. And here fertility word was used, not mortality. Unless you see the word mortality with girl child, please do not tick NRR. Okay? I hope these four things are separately clear in your mind. And the good news is the current TFR of India is 2.1. We have achieved that growth. TFR is being achieved. And so the population growth is not a problem for India anymore. Main problem for India is lack of rural development, because of which in urban area we are feeling the population pressure. Okay? Chalo. Now, let's come to question number 5. You visited a sub-center under your community medicine posting. You saw ASA maintaining a register of eligible couple. Which of the following couple will be included under eligible couple? So, eligible couple should always be married couple. Married, yes. See, I told you na, in the last time, a lot of my dear friend have answered NRR, because that question was confusing. But very good, Lala, Rahul, Vaisan and Veera for giving the correct answer GRR. And thank you all of you for replying. Very good. So there is no wrong in the class anyway. You can give whatever comes to your mind. Here, eligible couple means married couple, which should be currently married. Currently means not recently. Currently means where wife has yet not killed the husband or thrown him away, and they are still living together. So married couple in which female is between 15 to 49 years, that are eligible for contraceptive advice. So we call them eligible couple. So what will be the correct answer here? Married couple, age of wife should be between 15 to 49, that is 30 years. Very good, correct. Lala, Surbhi, Meeta, Turachand and Ankit, all of you are right. Similarly, they have asked, what is unmet need of contraceptive? Unmet need of contraceptive. The question was, is it applicable to married couple? Is it applicable to married couple with one child? Is it applicable to any couple, married or unmarried? Or is it applicable to married couple with two child? Answer is, it is applicable to any couple. Unmet need of contraceptive is for any couple who don't want to be pregnant but still became pregnant. Previously, there was a concept of target couple, which was for 2 or more than 2 children, that was target. But now every couple is a target. Even if there is no child and they are married, they are still eligible for contraceptive advice, because contraceptive is not only to prevent the birth, it is also to delay the birth of child. Like suppose after marriage you don't want to have child suddenly, so you can use contraceptive. Okay. Now from this sub-center and PHC part, we all think we remember the population norm, but still we do silly mistake. So do revise the population norm of sub-center PHC. First thing is, ASA is at 1000, one ASA 1000. ASA report to sub-center, which is at 3000 to 5000. Sub-center report to PHC, which is at 20,000 to 30,000. And then they report to CHC, which is 1 lakh plus minus 20,000. Minus 20,000 for hilly area, plus 20,000 for plain area. And always in hilly area people are far apart, so lesser population for hilly area. So this 3,000 is hilly, 20,000 is hilly, 5,000 is plain, 30,000 is plain. Okay, do revise it. Now next question. A pap smear is used as a screening test for cervical cancer. It helps in earlier detection of cancer. X mark in the below image is the advantage given by screening. What is X known as? Okay. What is this X? X means they are talking B to D. What is B to D point? So if you look carefully, B to D is first possible point of diagnosis and usual time of diagnosis. That means BD is the time gap between early screening test and usual diagnostic test. And the time gap between early screening test and usual diagnostic test is known as lead time. So BD is lead time. What is generation time? Generation time simply means time gap between entry of pathogen and appearance of first symptom. Entry and appearance of maximum infectivity. Time gap between entry and appearance of first symptom is incubation period. Time gap between entry and appearance of maximum infectivity is generation time. है ना, मेरे अंदर कीड़ा घुसा और अगले 4 दिन में मैं ऐसा हो गया कि एक छींकूं और 10 लोग बीमार हो जाएं, है ना, मैक्सिमम इन्फेक्टिविटी. This time gap is generation time. And in this question there is no point indicating that. Survival time, perceived survival time is from disease onset till outcome is the survival time. A to E is the survival, definitely. But if they ask screening time is B to C. Try to understand. We cannot diagnose before first possible point. So we cannot diagnose before B. And there is no point of diagnosis after critical point, because critical point is that time at which cancer starts spreading. So after cancer has spreaded, then what is the point of making diagnosis? So we have to diagnose before critical point. That means screening time is B to C. And in one of the MCI question in August 2017, August 2020, that Corona time exam, they have asked this question with screening time. BC they have asked, that was a screening time. So BC is screening, BD is lead time. Now one more question they can ask is there any lead time bias in this question? So lead time bias occur if we did screening test after spread of cancer. Because if after spread you are detecting anything, that detection is useless. So whenever you found first possible point before critical point, like in this question, possible point is before spread of cancer, before critical point, then here lead time bias is absent. Why lead time bias is absent? Because we are doing the screening before critical point. We are doing the screening before spread of cancer. So if you do the screening before spread, there is no lead time bias. If you did screening after spread, then that screening is useless and there will be lead time bias. Okay. So do remember this concept. Very good, Rahul and Turachand and Surbhi and Ankit, you all are right. It is lead time. Correct. So next question. A researcher did a study on the staff of the hospital doing yoga, क्योंकि yoga से होगा, and divided them into male and female. So there are two groups. Yoga saw 30% decrease in risk of infection in person doing it. Which of the following is best result to test the significance of this data? Try to guess it. In this type of question, when we are being asked to decide what is the test, there are 3 simple steps which if you follow, you can easily tell which test to apply. The first step is you have to look whether the data is qualitative or quantitative. If data is qualitative and there is more than or equal to 2 group, in that case we apply chi-square test. Now, how will you know whether the data is qualitative or quantitative? So first thing they might give you is qualitative data is in percentage or proportion. So in any question, if you found the word percentage or proportion, directly answer chi-square. Second thing is If I ask what is my obesity, can you measure my obesity? Is it quantitative or qualitative? So you can categorize my obesity in mild, moderate, severe, but you cannot say that, sir, you are 3.9 obese. And you cannot measure my obesity, you can just categorize it. So whatever we can put into category, that is qualitative data. Qualitative data is categorical. For example, anemia. You cannot measure anemia, you can measure hemoglobin. So hemoglobin, weight, BP, these are quantitative because we can measure it. But obesity, hypertension, diabetes, these are qualitative. Okay. So two ways to find qualitative data. First, if you can only divide it into category. Second, if percentage proportion is given, it is qualitative, and in qualitative we apply chi-square. Now, if the data is quantitative, then you have to see whether in the question they have used the word pre-post or matched. Pre-post data or matched data. If these two words are used, you will apply paired t-test, which is also known as dependent t-test. Okay. For example, let's say you are seeing that I am again and again calling myself pregnant and obese, and also to help me, you found a new drug which you gave on 100 people before, and before giving your anti-obesity drug you measure their weight, and after giving anti-obesity drug again you measure their weight. So if you are comparing before and after data, that is coming from the same people. So that's why it is paired, because it is before and after, pre-post. Okay. And let's say you are giving that drug to 32 kg male in one group, and you are giving the old drug, let's say Orlistat, to another group of same age, 32 year. So here also 32-year male got it, here also 32-year male got it. This is match data. Match means they are similar, and matching is done in case control study always. Before recruiting people, we do matching in case control. So matching, match data word you found pre-post, you will apply pair t-test directly. Now, if there is the data is quantitative and there is two group of participant, then we will apply unpaired t-test, which is also known as student t-test. And it can also be called as independent, because now there is two group. And if there is three group or more than three group, in that case we apply ANOVA, which is known as analysis of variance. Okay. So just apply this step and you can decide. So what is your answer in this question? Very simple. They are giving 30% decrease, and they are decreasing infection. Infection we cannot measure. You cannot say that a COVID patient came, hey, you are 2.9 infected. No. You can only say you are having mild COVID, moderate COVID, severe COVID. You can only categorize it. So it is categorical data, percentage is given, that's why answer is chi-square. Very good. Lala Prakash, Ankit, Surbhi, Altamas Ansari, Vaisur Boy, all of you are right. Torachand is also right. Surbhi is also right. But in the same question, suppose I change the language, then I can create all other options. Let's say in place of measuring infection, suppose I am measuring CRP level, C-reactive protein level, and I am measuring CRP level before and after yoga. If it is before and after yoga, it will become paired t-test. If I am measuring it on 3 group, so 3 group it will become ANOVA. And if I am measuring CRP level on 2 group, it become unpaired t-test or student t-test. So if they say CRP level or hemoglobin level or BP, all these are quantitative, then you will see pre-post word, paired, 2 group unpaired, 3 or more group ANOVA. So in the simple way, you can answer this type of tough question very easily. Okay? I hope it is clear. If it is still not clear, you can ask for more example or something. Okay? Chalo. Next question is, an intern has to study the relationship between ordering food online and development of obesity. Using a case control study, the best study group to be selected. So in a case control, case stand for those in which outcome is present. Control stand for them in which outcome is absent. And in this story, you can see online food ordering is the exposure. and this exposure is leading to the outcome which is obesity. So if the two group is outcome present absent, it become case control. If the two group is exposure present absent, it become cohort. And we can see here they are saying what will be the two group in case control. So case control means outcome present absent. That means case control will have obesity present absent C. But if we have to make a cohort study, in cohort study two groups should be exposure present absent, and therefore in cohort study the two groups should be online food eater or not online food eater. These two group will be for cohort study. So now let me create an example for you, and then let me see whether you understand the concept or not, because this is a repeated question. So let me create a fresh question for you. The fresh question is that this is my faith, that if you do 100, at least 100, more than or equal to 100 PYQ per day for last 30 days, then there is a very high chance that you will pass in your FMG exam. And while doing PYQ, try to do it in 10-10 slot. 10-10 slot means after doing every 10 question, check how much marks you got. Because in this way, there will be an inner competition. If you got 6 in the first 10, you definitely want to score 6 or more than that. Na? So now you will not guess. You will focus in your memory and you will recall the answer from the memory. And this recall is the thing which they want you to do in main exam also. In main exam, they are not testing your intelligence smartness, they are testing your recalling ability under stress. So for last 29 days, not 30 days, now it's 28 days left. So for last 28 days, if every day you are doing recall practice, 10-10 question you are doing, in 10-10 block you are doing and doing 100 more than 100 question, then you will practice recalling every day, and then even under exam stress you will be able to recall. So all those stress, anxiety, they will not affect your result. And plus you all know that 90 to 95% question come from the same topic which has been asked in previous year question. Whether it's NEET or MCI or NICT, topics remain same. So I beg you, I request you that in last 28 days, do not think about anything, just keep doing 100, at least 100 PYQ per day in 10-10 block. I know even after saying it, you will keep revising notes and you will not do PYQ, because while doing PYQ there is mistake, and when we see mistake our confidence gets shaken, and to do the ego defense we don't do PYQ. But get rid of this wrong thing, wrong practice. Please do PYQ 100 per day. If you like it, do it. If you don't like it, still do it, please. That is very good for you if you do it. So doing 100 PYQ per day will definitely will make a student score more than 50%, more than or equal to 55%. They will make you pass for sure. This is my faith, and this I have seen in last 6 years of teaching experience. And you can ask it from your senior also. Doing PYQ from whatever book you have will make you strong. And if you are doing it in app, always after every 10 question check it. And it's always good to do it from book rather than app. And after 10, please check it. So, in a case control study, what will be the two group? What will be two group? Option A, two group will be doing more than 100 PYQ and not doing more than 100 PYQ per day. Okay? Doing more than 100 PYQ and not doing more than or equal to 30. And suppose some students are doing only 20-30 PYQ on their app and not doing 100. So this is the second group, not doing 100 PYQ. So will it be the two group? Or option B, student who pass, matlab score more than 55% and student who score less than 55%, 50 or 55. I think it will give you extra age also, and you should do it. And if you have already done 5 years of FMGE, then please do 5 years of NEET also after doing 5 years of FMGE and revising it. Because 5 years of NEET is only 1000 question, NEET explanations are good, NEET recall is much better, and even if paper come tough, you can be able to cover the clinical question from NEET part. So please do PYQ, first do FMGE and revise it properly. After that, if you have time, go for NEET. So what will be the two group if it is a case control study, B or A? Very good, my dear friend. All of you are right, it will be B, because in a case control, outcome present absent should be the two group. Outcome is passing or failing. Exposure is doing PYQ or not. So this is cohort, option A is cohort and B is case control. Okay. So this type of question can come and I hope you can easily do it. Chalo. If you want more question to practice on such type of topic, do let me know. Next question. If you want to teach how to prepare ORS in an urban slum area, then which method will be used? Whether you want to prepare ORS or teach people how to use condom, or you want to teach people how to use pulse oximeter. In all this thing, the best method is demonstration. Okay. Now, role play is done in case of 10 to 25 audience are there, and we do some act in front of them, not literally role play, and some act we do, and we try to tell them that what wrong practices they are doing and what they should do if someone fall ill, what they should do if snake bite occur. This all thing we can demonstrate by role play. When they talk about focus group discussion, this question has come, how much participant are there? So the participant in FGD is 6 to 12. 6 to 12 participant, they sit in a circle and they try to discuss about their superstition or cultural barrier. Flashcard is used to make people memorize something, and it has picture on it. It can help you in remembering things. Then they can ask question about symposium and panel discussion. In both symposium and panel discussion, 4 to 6 experts speak on a topic. But in symposium, there is fixed order of speaking and audience can ask question at end only. Whereas in panel discussion, there is no fixed order and audience can ask question anytime. So question between expert also possible. So that's why the better one is panel discussion. Then a similar question from this topic came, that which can help us to compare end result. What is done to compare end result of any program? Will it be monitoring? Will it be surveillance? Or will it be evaluation? So monitoring means you are daily looking into some activity. For example, you are in your relationship, every evening your girlfriend or boyfriend is checking your Insta, any message came or not, and whether you downloaded Tinder or not, every day. That is monitoring. Surveillance is close monitoring with feedback. Close monitoring with feedback. So let's say your phone is not being checked, but your password is with your girlfriend or boyfriend. So whoever messages you, your girlfriend, boyfriend automatically know about it. That is surveillance. Your phone is under surveillance. And evaluation means phone is not checked, you are not under surveillance, but after every 2-3 weeks or 1 month, whenever you are in the bathroom, your boyfriend or girlfriend take your phone and check out all the last activity you have done. So evaluation is comparing the end result. End result are compared in evaluation. Okay. I hope it is clear to you. Now, the ideal per capita space for a student is definitely 10 square feet. Second question they have asked from here is that in a school health program, there is which type of desk? There is minus desk. I hope you all know that in every class there should be less than or equal to 40 student. Therefore, one urinal, there should be less than or equal to 60 student. And if you add student and urinal, it becomes 40. So for one latrine, there should be 100 student. Of course, 25% area of the class should be door and window and light should come from left side. But the main thing is that it is a screening program and a school teacher screen student for visual acuity less than 6/9. If it is less than 6/9, they refer the child to higher center. So this question has come that this school health program come under which of the following? Does school health program, do try to answer it, does school health program come under sub-center or PHC or CHC or medical college? Which look over school health program? So, in a school health program, what is happening? Screening is happening. And screening is the thing which is also done at PHC Vision Center. So, school health program come under PHC, okay? Because teacher does screening here. And there are 2-3 new things under school health program updates which you can say. One is that they are celebrating health and wellness day. On Tuesday, they are celebrating Health and Wellness Day. And for that, they are recruiting Health and Wellness Messenger and Health and Wellness Ambassador. Ambassador will be male and female teacher, and messenger will be male and female student. And on Tuesday, in the morning assembly, they will try to motivate student for yoga and meditation. Kyunki yoga se hoga. So this is a new thing under it. Health and Wellness Day on Tuesday for motivating student for yoga. Okay, do remember it. So next question. Viral hepatitis is characterized by all except. I think you can easily answer it. A and E is caused by food and water. So this is correct, but they are asking except. B, C, D are by blood. This is also correct. B, C, D are by water. No, this is wrong. So the wrong is the correct answer, of course. C is the correct answer. Then they have asked that in Hep B vaccine, what do we use? Do we have HBsAg in Hep B vaccine? Do we have HBcAg in Hep B vaccine? Which component are there in hepatitis B vaccine? Do we have HBeAg? Which SCE? Which component is there in hepatitis vaccine? Try to answer. Second they can ask is, which vaccine given to adult? So in adult, we can give 3 vaccines for sure. One is Hep B we can give, one is pneumococcal conjugate vaccine, and other is JE vaccine we can give in adult. Of course, if it is female, we can also give HPV vaccine, human papilloma virus vaccine. But of course, in adult female, we can only give it. And try to answer this Hep B question. Very good, Altama Sansari and Rahul Verma, both of you are right. HBsAg, surface antigen we are using in Hep B vaccine. HBsAg plus DNA we use. So, these days they are asking a twisted question that there is a patient in old age or patient gone through splenectomy. Which vaccine should be given? And so, why old age people or splenectomy patient die? They are immunocompromised, and immunocompromised patient mostly die due to pneumonia. So, we are giving pneumococcal conjugate vaccine in old age and post splenectomy patient. Okay, do remember it. Now, for JE, they have asked this question in just last to last need, that what is the root of giving JE? Try to answer. What is the root of giving JE? So do remember, this MMR and JE both are given by subcutaneous route. Both are 0.5 and subcutaneous. Then they can ask the diluent. In MMR, the diluent is sterile water. In JE, the diluent is phosphate buffer solution. And in MCI, they have asked this question that what is the diluent for BCG? For BCG, the diluent is normal saline. So to remember the 3 diluents separately, you can use this thing that as soon as the child is born, we try to make the life of the child a bit salty. जिंदगी थोड़ी नमकीन बनाना चाहते हैं, तो पैदा होते ही BCG देते हैं. We give BCG at birth, 0.05 ml is the dose till 1 month. And at birth we make normal saline. We try to make the life a bit salty. Then M for MMR, M for mother. And we all know mother love is like sterile water. So MMR, sterile water. No matter how much your mother is angry, just press her leg for 10 minutes and she will melt like ice cream. So MMR, sterile water. And JE, full form is Japanese encephalitis. So JE have P also, Japan, P is there. So JE have phosphate buffer solution. Do remember this. Now, question number 12. Which of the following is correct regarding the most common cancer in men in India? It is oral cavity. क्योंकि ऊंचे लोग ऊंची पसंद मानिक चंद और बोलो तो बोलो जुबां केसरी, है ना. So oral cavity is most common in male. If they ask in place of men, they ask in female of India, answer will be breast cancer. In female of world, again the answer will be breast cancer. And in Park recent edition, they have written this thing that most common cancer worldwide is not lung cancer. This is breast cancer. Why? Because there is a formula, prevalence is equal to incidence into duration of disease. And we all know that breast cancer patient, they survive for very long time. So at any time, if we are measuring the number of people in a population having cancer, breast cancer, because they are having 10-15 years of survival, their duration is more, so total case will always be more of breast cancer. So worldwide it is breast cancer, but if they ask in world male of world, what is the most common? Then in male of world it is lung cancer. Male of India, oral cavity. Female, whether it is India or world, breast cancer. Overall it is again breast cancer. And from this formula they ask this question also, that if a new drug does not cure disease but prevent death from it, it does not cure disease but prevent death. So what will be the effect on incidence, what will be the effect on prevalence? First thing is, whenever they ask the question with drug, in case of drug, incidence remains same, because to decrease the new case we need to do prevention or social change. But because this new drug is not curing and preventing death, so we can think this new drug as drug of BP and hypertension and diabetes. They will not treat hypertension and diabetes, but they will prevent death from it. And as a result of that, a lot of people suffer from hypertension and diabetes for a very long time. And because a lot of people suffer for a long time, duration is more, so prevalence will be more. So in this case, prevalence will increase, incidence will remain same. Second question they can ask from here is that if a new drug cure disease quickly, then what is correct? If it is curing quickly, it means prevalence is incidence into duration, duration is decreasing. So if new drug cure disease quickly, in that case, prevalence will decrease. But as I said, it is only drug and drug do not affect incidence. So incidence again remain same. Do revise these two questions because it has been asked again and again. Chalo, very good. Now, let's move to question number 13. Which indicator detect only acute malnutrition? Can you guess it? When we say weight for age, it means weight of child by expected weight at that age. So we are not dividing weight with age. We are dividing weight by expected weight. And if suppose I am a malnourished child, difficult to suppose, but suppose it. So there can be two reasons of my malnutrition. One is that my mother has not given me food since I was a kid. So that is chronic malnutrition. Second reason is since my marriage, my wife is not giving me food. So that is acute. So I can be malnourished due to any of the two reasons, chronic or acute. Or it can be that both my mother and wife are planning together to keep me hungry. You can see. So that case, it is together. Try to understand this concept. The weight can be low due to chronic malnutrition and or acute malnutrition. So if someone have low weight for age, if it is low, it can indicate both the thing, acute and or chronic. We all know low height for age is chronic malnutrition because that is stunting. stunting. But this factor, weight for height, if it is low weight for height means height is good. So the child has eaten well since childhood. There is no chronic malnutrition. But now he is dried up. So low weight for height is wasting, and this indicate acute malnutrition. And do remember, this is a very common question. What is the criteria for severe acute malnutrition? For SAM child, the weight for height should be less than 3 standard deviation for a SAM child. And along with that, of course, there can be visible wasting or pitting edema, and that can be there. And the mid-arm circumference should be less than 11.5 centimeter, and there should be visible wasting or edema. If these 3 criteria are fulfilled, we can say the child is malnourished. Do remember SAM criteria and this cutoffs. Chalo, now next question. Yes, very good. During a disaster, rapidly classifying the injured on the basis of likelihood of their survival with prompt medical intervention is a part of triage, of course. No doubt, simple question. But do also read what is reverse triage. Reverse triage is done during war, and here we give first priority to green, then red, then yellow. Black is moribund patient, so they can be separated by even the health team. Some student, they ask in the, they are confused in the disaster cycle, and in one of them, say exam 2 question come from it. So do revise the disaster cycle. In disaster cycle, first thing is impact of disaster. And impact. After impact, very simple to remember, there is triple R. And suppose this triple R, they went to MP. They went to Jan to have this, tried different flavors of bhang with bhakti. And so this is the sequence of event you have to remember. First thing they do is rescue and relief. And under rescue and relief, triage is also done. After rescue and relief, they try to make them self-dependent. That is known as rehabilitation. After rehabilitation, they start constructing their house, so that is reconstruction. So rescue, rehabilitation, reconstruction. After that, we do mitigation. Mitigation means decreasing impact of future disaster. And after mitigation, we start doing preparedness for next disaster. And whether you are prepared or not, there will be next disaster. So remember it, triple R, MP. Sometimes we can combine all these 3 R and we can call it recovery. So sometimes they can ask impact, recovery, then mitigation, then preparedness. That can also be there. Okay. So do remember this cycle. All of the following statements are true about lead poisoning except greatest route of lead poisoning is ingestion. No, this question has came in NEET exam. Greatest route is inhalation. Through inhalation it occur. Aminolevulinic acid is a indicator, correct, but along with aminolevulinic acid, coproporphyrin in urine, that is also an indicator. Blue line on gum is Burtonian line, and basophilic stippling is blue color granules in RBC. These 2 things are seen in lead poisoning. And the drug of choice for lead poisoning is EDTA, ethylene diamine tetraacetate. It's very simple to remember the symptoms of lead poisoning by A, B, C, D, E. A for anemia, so there will be pallor. B for these 2 things, basophilic stippling, Burtonian line, blue line on gum, Burtonian line. They can give image-based question from here. C is for tutty tight, constipation. D is for wrist drop, and E is for encephalopathy. All these things occur in lead poisoning. Most common route is inhalation. Which of the following is not promoted by UNICEF? UNICEF, of course, has this strategy GOBI FFF about which they are asking. G is for growth charting, and in the world, the growth charting is done by multi-centric growth research study, where we included children from 6 countries, including India, and that's why the whole world followed WHO growth chart. O is for ORS, B is for breastfeeding, and I is for immunization. What is FFF? So the first F is family planning, second F is female education, and third F is food supplementation. So they have asked this question, food supplementation, that in this there is a program, applied nutrition program, who fund seed and manure for who give fund for seed and manure of applied nutrition program. In applied nutrition program, UNICEF was thinking to start a school garden. Will garden survive in a school? Very difficult. So they started for it, and the funding came from UNICEF. Why? Because food supplementation is a work of UNICEF. So UNICEF funds seed and manure of applied nutrition program. Other than that, they can ask some other funding. So the answer is malaria eradication, of course. Malaria eradication is funded by USAID. USAID give fund for malaria. UNICEF mainly give fund for maternal and child health program. Other than that, they have asked some funding question. Let's revise it quickly. Who fund sustainable development goal? It is funded by United Nations Development Program. Who fund family planning program? So family planning is funded by United Nations Fund for Population Activity. Fund for Population Activity. And UNDP, UNFPA, UNICEF, all three headquarters are in New York. All their headquarters are in New York. Then, who fund TB program? TB program is funded by SIDA, Swedish International Development Agency. Who fund eye program? Eye program is funded by DANIDA. So it can be confusing. How will you remember it? Netradan, eye donation, eye dan, and S for SIDA, S for sputum. So SIDA fund TB, Netradan, eye donation, DANIDA. Okay. So do remember these 6 funding agencies and their work. Which of the following committee is known as Committee of Multipurpose Worker? 3-time asked question, Kartar Singh Committee. Mukherjee Committee is known as Committee on Basic Health Services. Basic Health Services. Srivastava Committee is known as Committee, Mukherjee said that PHC should have basic services. Srivastava is known as Committee on Health Education and Support Manpower. Health Education and Support Manpower. And Srivastava Committee started 3-month internship posting. They also focused on referral service complex and said that there should be reorientation of medical education. Interns should go for 3 months in rural area and should eat from their plate and should participate in village meeting. Bhore Committee was the first committee. This is known as Committee on, this is known as Health Survey. Health Survey and Development Committee. Bhore Committee came in 1946, 1 year before independence, and Bhore Committee said the word social physician. By social physician, they mean that the doctor should go for 3 months in rural area in MBBS, and they should learn about root cause of all the problem of India like caste system and dowry system. So Bhore started 3-month posting in MBBS, Srivastava started it in internship. That is the difference. And Bhore also said we need 1 PHC at 40,000. Okay. Then you can know about 2 more committee. The second is Mudaliar. Mudaliar is known as Health Survey and Planning Committee. So it can look a bit confusing, but not so confusing. In Bhore there is development D, in Mudaliar there is P, and alphabetically A, B, C, D, D come before P. So development is Bhore, planning is Mudaliar. And of course, Bhore means morning also. And so Bhore was the first committee, so early development is Bhore, planning is Mudaliar. Mudaliar also said 1 PHC at 40,000, but Mudaliar also said we need Indian medical services same as IAS. Okay. Last thing which they can ask is about Jangalwala Committee. Jangalwala Committee is known as Committee on Integration of Health Services. And integration of health services is Jangalwala. Then there is one more last committee, high level expert group committee. This high level expert group committee said that by 2.5% of GNP, which India is giving right now and being asked in MCI exam also last time. So by this, we can give universal health coverage. So that's why high level expert group committee is known as Committee on Universal Health Coverage. He gave a roadmap for that. Okay, so do remember these two questions. Committee on Universal Health Coverage is HLEG, and current GNP, gross national product on health, is 2.5%. Now, which is true regarding National Leprosy Eradication Program. So, eradication is when there is less than 1 case per 10,000. But it should not be new case. New case detection rate is measured in lakh. And annual new case detection rate is currently 9.7 per lakh. And do remember, new case detection rate, if they ask what is the best indicator to know whether leprosy program is working properly or not, that is new case detection rate. So it is best indicator of impact of leprosy program. Okay, impact of leprosy program is indicated by that. Now, prevalence rate we want to be less than 1 per 10,000. This is the target of NLIP. We want prevalence less than 1 per 10,000. Okay, new case is per lakh, and it is impact of leprosy, which we detect by new case detection rate. Okay. Then, if the prevalence rate is less than 1 per 1,000, this is the criteria for elimination of not leprosy but neonatal tetanus and filariasis. These two diseases, we call them as eliminated if the case burden is less than 1 per 1,000. Okay. So that is there. And we are not talking about incidence. In case of leprosy, we have to reduce the prevalence rate. Sure. Not incidence. Incidence is detected by annual new case detection rate. So it is prevalence which we have to decrease. Focus on prevalence. Sorry, it was a bit tough question, but it's there. Now, one more thing which is being asked, what is the drug of choice for lepra reaction? So drug of choice for lepra reaction is methylprednisolone. Second question they ask from here is that if a patient have lepra reaction, will you continue giving the leprosy drug with prednisolone, or will you stop the leprosy drug? So we never stop leprosy drug. Methylprednisolone we give plus continue the MDR for leprosy. Continue multiple drug regime for leprosy, MDR for leprosy. Okay. Chalo. Now, chikungunya, which vector transmit? Please answer this question. Who transmit chikungunya? Anopheles, of course, it transmit malaria. Anopheles, let's revise all the questions from this topic. They have asked who have spotted wing. All the student answer Aedes. No, Aedes have spot on leg and body, but not on wing. Wing spotted in Anopheles. And Anopheles breed in clean water. They can give you an image of larva of Anopheles floating parallel to water surface. So Anopheles larva is parallel to water surface. So that means parallel to water surface means Anopheles larva is surface feeder. Anopheles is not bottom feeder, it remains in surface. It is a surface feeder. Correct. Aedes transmit chikungunya. Very good. But along with chikungunya, Aedes transmit 4 other diseases. So one is chikungunya, other is dengue, of course. Then there is Zika virus fever, yellow fever, and Rift Valley fever. So how will you remember it? These two already you know, Zika, yellow, Rift Valley fever. And try to remember it without mnemonic so that you can recall it quickly. And in Zika virus, two things occur. One is microcephaly, other is GB syndrome. And if I am a pregnant lady and I develop Zika virus, then I will deliver a child with microcephaly. Mere londe ki hogi choti mundi. There should be small head in my child. That is in Zika virus. And second is Guillain-Barré syndrome, which occur there. they have asked 3 times who transmit JE, that is Culex. JE, then there is of course filariasis, and last is West Nile fever. So sometimes we get confused between West Nile and Rift Valley. Do remember it through this way, that Culex is known as nuisance mosquito because Culex breed in dirty water. So dirty water it is breeding, and that's why it is transmitting Nali fever. Nile can be remembered as Nali fever. Okay. Mansonai. Mansonai is the last mosquito, black color with very long biting area, and Mansonai transmit only one disease, Brugian filariasis. Okay, and Mansonai breed in root of aquatic plant. Root of aquatic plant. So do remember these 4 mosquito and their illness and their breeding areas. Very commonly asked area of question. Both micro, PSM, they all ask from it. Okay. Now, which of the following is not part of PQLI? So PQLI, you can see here, it is written life expectancy at 1 year. Very simple. PQLI have range 0 to 100. Big range, 4-letter word, so big range, and life expectancy at 1 year is written. So life expectancy at birth is not a part of PQLI. And in HDI, the range is 0 to 1. 3-letter is small, so the range is also small. That had been asked in recent exam only. HDI, PQLI, very common area. And in HDI, we take life expectancy at birth, 1 factor. Second thing we take is per capita income. And third thing which we take in HDI is how many year of schooling is done, mean year of schooling. Okay. But in PQLI, what are the 3 factors? One is life expectancy, second is IMR, and third is literacy rate of adult. So if they ask what is the better socio-economic indicator, answer will be PQLI, because PQLI have IMR, and IMR I have told is best indicator of many things. So that is there. But if they ask what is the best indicator of quality of life, then answer will be HDI. Chalo, next question. You are providing iron folic acid tablet in Anemia Mukt Bharat, which is not a part of the program. So in Anemia Mukt, they have asked this recent question, what is the target? Target is to reduce anemia each year by 3%. Each year we have to reduce it by 3%, do remember. And in Anemia Mukt Bharat, there is 6 into 6 strategy, 6 into 6 into 6 strategy. And but you can say that there are 6 people who will be benefited through 6 method. Bada hi chakka program hai. What are the 6 into 6 strategy? First 6 is that what are the 6 people? Second 6 is the benefit. So we give the benefit of deworming. Second benefit is iron folic acid tablet. Then we try to give fortified food with iron. That is the third benefit. Fourth is BCC, behavior change communication. Fifth benefit is we will be measuring HB digital and we will be doing follow up of high risk mother. And the sixth and last benefit is that Government of India told us to focus on other cause of malaria also. Focus on other cause also. What are the other cause of anemia? That can be fluorosis. Like they have asked in last, dental fluorosis, white plaque on teeth and a high fluorine. So fluorosis can also cause anemia. And then there will be, other than fluorosis, there can be malaria which can cause anemia, sickle cell anemia which can cause malaria. So focus on that. So these are the 6 benefits in this program. That means B12 is not given as a benefit. These are the 6 benefits. Try to remember it. Now, which of the following cannot be used as emergency contraceptive? Chaya, which is centchromane tablet. This is a non-steroidal OCP that we cannot use as emergency OCP. Emergency contraceptive. What is the best emergency contraceptive? IUCD is the best emergency contraceptive because it can be used up to 5 days. Then what is the dose of levonorgestrel in I pill or unwanted 72? That is 1.5 milligram. In OCP, there are 2 types of OCP, low dose and normal dose. Low dose OCP have levonorgestrel equal to 0.15 milligram, and normal dose also have the same levonorgestrel 0.15. So levonorgestrel is same, only difference is low dose have ethinyl estradiol 20 microgram, normal dose have ethinyl estradiol 30 microgram. So the difference is only in dose of ethinyl estradiol. And if you see, IPIL have 10 times more progesterone. IPIL have 1.5 whereas OCP has only 0.15 milligram. Okay, thank you. Next, before going to vaccination camp, you notice which of the following vaccines should be used. So they are giving the image of vaccine vial monitor. We can use those vaccine vial monitor which are having central area light. A is light, B is also, C is also light, but B you can see is same color. So this was in INICT also they have asked this question. If the outer and inner area is same color, you have to discard this vial. Discard the vial if it is same color or darker inner square. If it is same color or darker, we will not use it. Okay. Now, a patient presented with complaint of bleeding gum, subcutaneous bruising, deficiency of which vitamin? Definitely vitamin C is deficient here. Vitamin C is also deficient, and the disease is scurvy. Vitamin C is also deficient in egg. And this question is very common. What is deficient vitamin in milk? Milk is deficient in vitamin K. That's why just after birth we give vitamin K injection. And vitamin D and C, they are present in milk in less amount. They are not, vitamin K is very less amount. So deficient is vitamin K. D and C present in very less amount, but they are present. Okay. So these are something which you should know. Now, if they give the question that a patient have dryness around nose and mouth, what is the deficiency? That is zinc deficiency. Zinc deficiency will have dryness around nose and mouth. See, the point is, I want to revise many questions which are likely to come, so that if you are listening this session, at least 5 to 10 questions should be from the discussion which we are doing in the session only. That is my focus, so I am covering more questions than being given in the exam. Now, measure that can be taken for the prevention of development of risk factor are. Prevention of risk factor. That means risk factor has not yet come. So that means it is primordial. Primordial and primary both are there, then we called it health promotion. And the best example of health promotion is mother and child linkage. They have asked this question. Mother and child linkage or breastfeeding. You understand this or not? For example, suppose I am a lactating mother and I am breastfeeding my kid. So when I am breastfeeding my kid, I am preventing my kid from future risk of diabetes and I am preventing myself from future risk of breast cancer. So both are future risk, that is primordial. Now, suppose I am again breastfeeding my kid, but this time from opposite breast, okay? So this time my breastfeeding is preventing my kid from present risk of malnutrition. If I did not breastfeed my child today, she or he will be malnourished today. So present risk is also there, that means it is primary is also present. So because both are present, so it is example of health promotion. Okay, do remember it. Chalo. Now, how much population is covered in PSC in hilly area? We just discussed 20,000 in hilly, 30,000 in plain. A doctor is teaching medical student how to elicit signs such as knee reflex. So if it is knee reflex thing, it is psychomotor learning. Okay, because this is psychomotor means we are telling the student how to check for reflexes of all the cranial nerves, and we are teaching them something where muscle part is also included, the motor reflex is included, that is why it is psychomotor. And this instrument question, if they ask, what is this instrument? This is kata thermometer. And they have asked in NEET exam, what is the two uses of kata? So kata do measure two things, cooling power of air and air velocity. two thing is measured by Carta thermometer. Psychro word, wherever you will see, psychro simply means humidity. So both Assman psychrometer and sling psychrometer, they both measure humidity. But this is a very common question from our time, that in sling psychrometer they have wet and dry bulb thermometer. So what does wet and dry bulb thermometer measure? So wet and dry bulb thermometer, they will also are in sling psychrometer, so they will also measure humidity. Same thing they will also measure. And then one more thing they can give is globe thermometer, that will be black color globe, without any boundary, best globe. So globe thermometer will measure radiation temperature. Radiation temperature can be measured by globe thermometer. Okay. So there's 29 question, which is best representing the trend of cardiovascular disease. Trend. Trend is best indicated by line diagram. And cardiovascular disease shows secular trend. This question has also come, that which represents secular trend? Line diagram, because it is trend. What is secular trend means? Secular trend means constant increase or decrease in number of cases over a long period of time. For example, of cardiovascular disease cases are constantly increasing in the world. From 1950 to 60 to 70, it is constantly increasing. So it is represented by line diagram. Okay. Then last question, I think. Yes. Which of the following vaccine are given at birth? 3 vaccine, BCG, OPV, Hep B, and for all this vaccine, ASA don't get paid, because ASA work is a motivator, and here the delivery is occurring at hospital mostly, so ASA will be, mother and mother-in-law will be in the hospital. So whom the ASA will motivate? Father-in-law. There is no one to motivate, so ASA don't get paid for it. So these are the 3 vaccine given at birth. These are the questions from PSM. And I truly request all of you to keep doing 100 PYQ per day in 10-10 block. In that way, you will stay positive and you will practice recall very well. My best wishes are with you. Keep rocking. Keep enjoying the life. Hasta la vista. Das ka dhanya. Bye-bye. Thank you so much. Bye. Thank you.
So hello my dear friends, myself Dr. Amit Jain, your biochemistry faculty, and here we will be discussing the questions of the biochemistry section. So starting with the question number 1, which of the following glycosaminoglycan or the mucopolysaccharide determines the charge selectiveness of the glomerular membrane? So guys, the answer to this question is option A, heparin sulfate. Guys, all the GAGs, remember one thing, that GAGs, they are negatively charged. Okay, they are negatively charged and they bind large quantities of water, which makes them mucus-like. So mucopolysaccharides. Okay, so heparin sulfate is the best answer. Hyaluronic acid is found in the joint spaces like synovial fluid. Keratin sulfate is very, very important for what purpose? For the corneal transparency. Chondroitin sulfate is present in the cartilages. Okay. Fine. So moving to our next question. Select the correct statement regarding telomerase. So guys, telomerase is the enzyme which is found only in the 3 types of cells, that is stem cells, the cancer cells, and the germinal epithelium of especially the males. Fine. So telomerase is an enzyme involved in DNA replication? No. So it maintains the length of telomeric ends, right? So telomeric ends have a repeat like, double T, A, triple G. Okay. So that is a length which is decreasing with each replication cycles. We lose the DNA. That's why we age. Okay, because telomerase enzyme is not found in our somatic cells. Clear? It is found only in the 3 cells. So not involved in DNA replication. It is a ribozyme? No. Stem cells have more telomerase compared to germ cells? No. Germ cells have more or the better telomerase activity than the stem cells. Okay, and it is RNA dependent DNA polymerase. So yes, that is the correct statement. This is also called as the reverse transcriptase. Okay, so we also call this a reverse transcriptase. Fine. Moving to our next point. So which of the following is the most abundant RNA? So guys, we have the 3 types of RNA. If we talk about the size, then messenger RNA is the biggest. followed by the ribosomal RNA, and followed by the tRNA. T for the tiniest or the smallest. And as per the percentage in the cell, we have the ribosomal RNA 80%, then which is followed by the tRNA which is 15, and messenger RNA which is just 5%. Okay, so our answer is ribosomal RNA. Moving to our next question. What is the correct sequence of steps in PCR? Guys, PCR is nothing. PCR is simply the replication in test tube. Okay, so remember like this, that how does replication proceed? So replication in the test tube, that's called as the PCR. Fine. So obviously during the replication, what we do? First of all, we separate the DNA, right? That is called as denaturation. Then fix the primer, that is called as annealing, and then chain extension using the DNA polymerase, right? So denaturation, annealing, and chain extension. So that is the 3 steps of the PCR. Moving to our next step, active form of vitamin B5 is, so answer is, guys, coenzyme A. That is the active form of vitamin B5. Okay, and the deficiency of B5 causes the burning feet syndrome, right? Burning feet syndrome. Okay, so that's all about the vitamin B5. Pyridoxal phosphate is the active form of B6, right? And the formation of this pyrophosphate form is prevented by the drugs like isoniazid. Okay, NAD is niacin and FMN is riboflavin. Like FMN is the active form which is found in the complex 1 of electron transport chain, right? And FAD is found in some other enzymes like succinate dehydrogenase. Okay, so that's the active form. Okay, what is the active form of vitamin A for the vision? Remember, that is retinal. Okay, 11 cis retinal. And what is the active form of vitamin D? That is calcitriol. So also remember 125 dihydroxy cholecalciferol. Okay, so these are the active forms. And what is the active form of vitamin B12? Methylcobalamin and the adenosylcobalamin. Okay, so let's move to the question number 6. Which of the following is not a macro mineral? So guys, something which is required in very small quantities, that is called as trace minerals, and copper is one of the trace element or the trace mineral, right? Like we have others, for example, okay, like we can say the iron, okay, etc. So copper. And moving to our next question, gluconeogenesis occurs in which of the following compartments of the cell? So guys, the answer is both cytoplasm and the mitochondria. Okay, gluconeogenesis. So guys, there are, these we can remember using a mnemonic, that is, PUBG. Okay, so PUBG, right? So P for the pyrimidine synthesis, right? So P for pyrimidine synthesis, U for urea cycle, B for actually blood but basically heme synthesis, and G is our gluconeogenesis. Okay, so pyrimidines like cytosine, urea cycle, blood or heme synthesis, and gluconeogenesis. Guys, remember gluconeogenesis also involves endoplasmic reticulum. Okay, the last step is in actually endoplasmic reticulum. Fine. Okay. Now moving to the next question, enzyme deficient in von Gerke's disease. So guys, the answer is glucose 6-phosphatase, that is type 1 glycogen storage disease, that is called as a von Gerke's disease. Guys, glucose 6-phosphatase is also the marker enzyme of endoplasmic reticulum. And guys, deficiency of glucose 6-phosphatase is, it is an enzyme which is common to gluconeogenesis and glycogenolysis last step. Okay, so last step. So that is why both the pathways, that is glycogenolysis and gluconeogenesis, okay, glycogenolysis and gluconeogenesis both will suffer if this enzyme is missing, and that's why this leads to severe hypoglycemia, because these are the only 2 pathways which maintains the blood sugar in the fasting state, right? Okay, and it is also the marker enzyme of endoplasmic reticulum. Fine. D branching is missing in the disease that is called as Cory's. Phosphorylase is missing in the also in the Hertz disease and McArdle's disease, right? Pyruvate kinase is not the part of the glycogen storage disorders. Glycogen phosphorylase is also the rate limiting step of the glycogenolysis. Okay, which of the following is truly related to the energetics of glycolysis? So guys, in the anaerobic glycolysis, 2 ATPs are formed, correct? Anaerobic glycolysis, 4, no. Aerobic makes 6, no, it makes 7. Aerobic makes 2, no, it makes 7, right? So the correct answer is option A. Fine, and that is energetics. Guys, few more energetics that you should know is 1-acetyl-CoA makes how much ATPs? You must know, that is 10 ATPs. And guys, you should know that to convert one lactate or to the glucose molecule, right, to convert the lactate molecules into the glucose molecule, that is gluconeogenesis, how much ATPs are required? 6 ATPs are required. Fine, to make one peptide bond, we need 4 ATPs. And in the urea cycle, how much ATPs are used? 4 ATPs. Okay, so very few questions we have regarding the energetics, right, including glycolysis. Moving to our question number 10. 4-week-old female was brought to the hospital by her parents. Infant appears lethargic, complains persistent jaundice and failure to thrive. Distinct boiled cabbage order, so that is tyrosinemia, right? So guys, the answer is option D. Phenylketonuria has a typical order that is called as a mousy order, right, or the musty order. Isovaleric acidemia has a typical order that is called as sweaty feet order. Fine, sweaty feet order. And maple syrup urine disease has a typical order that is called as the intensely sweet order, or we can also call it the burnt sugar order. Okay, so that has a burnt sugar order, sweaty feet order. PKU has musty order, I told you. Tyrosinemia has a boiled cabbage order, right? So these are the important orders. And guys, in the multiple carboxylase deficiency, that is biotin deficiency. So it's not an amino acid urea. Multiple carboxylase deficiency, the patient has a typical order that is called as a tomcat's urine, right? Tomcat urine order. Okay. So orders are, yes, definitely important. If the percentage of thymine is 28, what is the percentage of C? So guys, always remember the Chargaff's rule where the purines are equals to pyrimidines. So always make a double strand like this. A is equals to T and C is equals to G. So if it is 28, then it is also 28. So that is making 56. Okay. So whatever is remaining, that is 22. So 22 and 22. Okay, so total we have to make 100 na, so that's why like this, right? So answer is 22%. So that is based on the question is based on Chargaff's rule, right? Okay, moving to our next question. The liver can synthesize ketone but cannot utilize due to the deficient enzyme that is called as thiophorase. Okay, so guys, what is the other name of thiophorase is? It is the coenzyme A transferase from the succinyl-CoA to acetoacetate. Okay, so what is the other name actually? It is called as coenzyme A transferase. Clear? So the liver can synthesize ketones, but it cannot utilize them because of the deficient this particular enzyme. Then we have the question number 13, right? Okay, guys, see, there is nothing like a dehydrogenase enzyme. HMG-CoA synthase is the rate limiting step of ketogenesis. This is the enzyme I told you, which is liver is not having that. This is enzyme rate limiting step for cholesterol synthesis. This is for ketone synthesis. This is for cholesterol synthesis. Okay, moving to our next question. Which enzyme is deficient in Niemann-Pick's disease? Okay, so the answer to this question is, guys, sphingomyelinase. So this is these all are important topics, guys. Gaucher's disease, like for example, this is enzyme in Gaucher's disease. This is enzyme in Tay-Sachs disease. So remember, this is for Farber's, but you can ignore it right now. But hexosaminidase A, that is in Tay-Sachs or the Tay-Sachs disease or the Sandhoff's disease A and B. Fine. Incorrect to the fatty acid synthesis. So synthesized in cytoplasm, yes, liver cytoplasm, right? Palmitic acid is a first product, separate MCQ, yes. It is a 16 carbon saturated fatty acid. Synthesis of malonyl-CoA is rate limiting, yes. Guys, name of enzyme is acetyl coenzyme A carboxylase, which converts acetyl coenzyme A to malonyl coenzyme A, right? Thiamine is the major coenzyme, no. Biotin is the major coenzyme. So our answer is D. Okay. Major coenzyme is this. Fine guys, biotin. And acetyl CoA carboxylase is the rate limiting enzyme. Clear? Okay, moving to our next question, which is correct true regarding the glutamate dehydrogenase. See guys, glutamate dehydrogenase is the enzyme which is found in the, let's say, liver, and which release the ammonia in the liver mitochondria. Okay, and this ammonia will be later used by the urea cycle enzymes to make urea. Okay, so what is the special point about this enzyme is that it can use both NADH and NADPH. See, most of the dehydrogenases are dependent on niacin. But which form of niacin? NAD generally. Okay, NADPH is used only by or produced by some enzymes like G6PD, for example. Right, so this is an enzyme which can actually use NAD also and NADPH also. NADH also and NADPH also, right? So PLP is the coenzyme? No, it's a dehydrogenase. So niacin is the coenzyme. Also needs zinc. Ammonium ions are not released. Ammonia is released. Activated by ATP? No, it is inhibited actually by the ATP and GTP. Okay, it is activated by ADP and GDP. Fine. Moving to our next question. Nitrogenous waste from the human body, if they are talking right now. So the best answer is urea, though the uric acid is also the correct answer, right? Uric acid is also found in our urine, right? Okay, so that is also the nitrogenous waste. Why? Because it is made from the purines, right? Like adenine, guanine, etc. So they definitely contains the nitrogen. 3 nitrogen atoms are present in uric acid structure. Not 3, actually 4 nitrogen atoms are present, right? When we draw the structure of the purines, right, we have nitrogen, like these are the various nitrogens which are present. Okay, and the numbering is also done like this: 1, 2, 3, 4, 5, 6, 7, 8 and 9. So N9, N1, N3, N7. These are the nitrogens, right, in the uric acid also. So yes, we can mark uric acid as the second best answer, definitely, but the most common form of nitrogen excretion from our body is urea. That is, what is urea? NH2CO and H2, right? Guys, glutamine, remember one thing about glutamine is that this is very important question also, that this is the most important non-toxic form of ammonia transport in human body, right? What is the use? This is used for ammonia transport. Okay, ammonia transport in the human body. Clear? So next is inulin. So chemically inulin is guys a polysaccharide basically, and it is made of fructose, right? So when the fructose molecules are linked together using the beta 1,2 linkage, okay, beta 1,2 linkage, so that is called as inulin. Okay, and these linkages, the human body don't have enzyme to break these linkages, and that's why the previously inulin was used for the estimation of GFR, because it is a metabolically inert substance which can be given to the body, right, because it is not metabolized. Fine guys. Okay, so thank you so much guys for listening to me. Keep revising and all the best for your exams. Revision is the key to success, don't forget. So keep revising the key points, important points, right? Not the whole theories right now, because we are left with very few days. Thanks guys, bye bye.
Okay, so guys, let's start with this discussion of the GD for the anatomy. I'm Dr. Ankit, anatomy faculty over here in LN. Let's start this discussion over here. So the first question over here asks us about all other derivatives of the second pharyngeal arch except. Never forget the word except over here. So here's the question. The topic over here are the pharyngeal arches, which as we know are one of the most important topics for head, neck as well as the embryology.
So let's see that what are the derivatives of second pharyngeal arch and which one is not over here, right? So let's quickly see over. See, there are 5 arches: first arch, then second arch, then third arch, then fourth arch, and then fifth goes missing out. So we have the 6th arch. So these are the arches. Now, if we talk of the nerve supply, what is the nerve supply of each one of these arch? First arch is supplied by the mandibular division of trigeminal. Second arch by the facial nerve. Third arch by the glossopharyngeal. Fourth by the superior laryngeal, and 6th by the recurrent laryngeal nerve, and these both are branches of the vagus nerve. So here we are dealing mainly with what? We are dealing mainly with the second, that is the 7th nerve or the second arch. So what are the derivatives? So as we can see that it is a facial nerve, which is for the nerve of the second arch. So what muscles does it supply? So we all should know that facial nerve supplies basically the facial muscles over here. Apart from it, its posterior division, as it comes out, it supplies the posterior belly of the digastric. That's one muscle. And also supplies the auricular muscles, which are sort of vestigial in humans. And it also supply the stylohyoid muscle. It also does supplies the occipitalis or the occipital belly of the occipitofrontalis muscle. And finally, inside the middle ear, it also will supply the muscle that is the stapedius. So apart from the facial muscles, it supplies these muscles. So if we go with the options over here, then platysma over here is a facial muscle. It's a facial muscle, though it is present in the region of the neck, but it is actually a facial muscle, right? Stylohyoid, we can see it is supplied over here. Stylopharyngeus is the only muscle that is supplied by the 9th cranial nerve, which is the glossopharyngeal, and therefore it is not of the second arch, but it is of the 3rd pharyngeal arch. So hopefully that comes out to be our best bet. And stapedius, as already discussed, is also present in middle ear, supplied by the 7th nerve. Therefore the answer over here is our option number C. So do remember the topic pharyngeal arch is very important, and all the various derivatives of it. First arch, second arch, third, fourth, and sixth. Fifth goes missing, right? So therefore the answer for this question is option number C, stylopharyngeus muscle. I hope this answers the query. Let's see the next one over here. So if you come to the next question, here's a histological slide which asks us that identify the slide. So collagen fibers are already labeled and the fibroblast nuclei are also labeled. Let's see the options over here. Is it a dense regular connective tissue? So obviously there is collagen fibers, a lot of amount of it, so appears dense. That's right. Is it regular? Appears regular only. The fibers are more or less parallel to each other, so it is probably a regular. Fine. Appears to be option A is the best answer till now. Let us see other options as well. Then they say dense, irregular. So dense is right over here, but irregular, it doesn't fit, right? Adipose obviously is not so much of collagen fibers to be present, and loose areola obviously you can rule it out easily. It's not a loose, it's a dense. So therefore answer over here is our option number A, right? So identify the slide. Don't overthink, don't overdo the questions. Questions sometimes are straightforward. You just have to apply the little bit of common sense or the logical common sense and you will reach the answer, right? I hope this clarifies the question. Let us see the next one over here, right? Again, an image-based question. They're asking to identify the structure or identify the vein over here. If you slightly zoom it, we can see that where the arrow pointing out, an arrow is pointing out towards this particular structure. So they're asking which vein it is. Obviously, we can see that it is taken up from the upper limb. It's taken up from the upper limb, right? It's a medial aspect of the upper limb. That's a lateral aspect of the upper limb. And the veins over here are superficial veins. So do remember that if we go from medial to lateral, we have first letter is B, then comes C. So B is for the basilic vein that is present medially. And then we have the cephalic vein that is present laterally. It appears like a cephalic vein, but let us see all the options. So till now, from the image, we can understand it looks like a cephalic vein. Let's see those options as well. Basilic vein, as discussed, is present medially. So therefore rule out. Basilic vein will be somewhat over here. This will be option number B, basilic vein. Now cubital vein over here is the most common vein taken for taking the sampling, right? For the venous sampling, that vein is taken up. It's present in front of cubital fossa. So slightly enlarge it again. So this is the cephalic vein for C. That's a basilic vein for B. This over here, this particular vein, if I put a black arrow over here, this will be the median cubital vein. Median cubital vein, and this is one of the most important part on the roof of the cubital fossa, and the blood in the median cubital vein is actually going from cephalic to basilic vein. It goes from C to B, right, as we can see over here. So therefore we can see identify the cubital vein also is not over here as the answer. Then we have the axillary vein. Obviously axillary vein will be present in the region of axilla. Point number one. Second point is that as you can see over here, that the basilic vein, as you can see, the basilic vein actually continues into axillary vein. Let us try to understand a bit more of it. So what actually happens is, if you look at the dorsum of the hand, you have a dorsal venous arch, right? Here you can understand the lateral aspect, there is a medial aspect. This dorsal venous arch, laterally it continues upward, as we can already see, this was the cephalic vein. So this will be the cephalic vein. Remember, it's a superficial vein. The medial continuation of it slowly as it ascends up becomes basilic vein. And then it ascends up, then you have the cephalic vein going up, then you have this different color, that will be the median cubital vein. So this, imagine it to be the cubital vein over here, right? Slowly what happens is, the basilic vein, as it ascends up, it receives other veni comitantes or small veins, its size increases. As soon as this basilic vein, right, it enters into the territory of the axilla. Now what's the territory of the axilla? If you take this as the lower border of which muscle? Lower border of the teres major muscle. That's the inferior limit of the axilla. So as soon as this basilic vein enters or crosses the lower border of teres major, remember teres major is attached where? It is attached onto the medial lip of bicipital groove. So you can understand this muscle over here will be attaching onto the medial lip of bicipital groove. So now this vein, basilic vein, now it will become the axillary vein. So this vein over here, some thick vein over here, this will be our axillary vein in the axilla region. Now what about this cephalic vein? What happens to it? Understand over here, cephalic vein is still superficial vein, but it has to drain into the axillary vein. So how does it drain? It pierces the fascia over here. That is another question. That fascia is the clavipectoral fascia. The cephalic vein do enter or do drain into the axillary vein after piercing the clavipectoral fascia. That is another question, right? So this is basically the venous structure of the upper limb, and therefore over here, if we come back to the question, obviously the answer is option number A. So do try to identify the veins over here. Let me show you this image. This is where the cephalic vein is piercing the clavipectoral fascia to enter into the axillary vein, right? Okay. So that's this question. Let us see other questions as well after this. Here is another question from the upper limb, important topic. The question asks us that identify the nerve lesion if the below given hand is at rest. This word is important, is at rest. So the patient is coming to your OPD, and you can see the attitude of the hand. It's like this. There is what is happening over here, the fourth and the fifth digit over here. The ring and the little finger, you can see they are into clawing. There's a clawing of the medial digits. Medial digits are clawing. Medial clawing of hand is over here. So you can understand that the clawing of the hand is due to the paralysis of the muscles, which is lumbricals. So lumbricals normal action is pan holding position, flexion of MCP and extension of the interphalangeal joint. Now if the lumbricals get into the paralysis, then it is opposite action that becomes the clawing of hand. And the medial two lumbricals are supplied by which nerve? That is the ulnar nerve. If we can understand that this over here, this medial clawing is due to what? The lesion of the ulnar nerve that will lead to the medial clawing of hand. Therefore, the answer should be the ulnar nerve, hence it is the answer. This is a very important point. They are saying that the patient's hand is at rest. This is what happened. Now, if the patient hand is normal, right, and we ask the patient to make a fist, right, to make a fist out of it, then if he's only able to make it like this, right, only you can make it like this, and this index finger or the middle finger is not able to fold on itself, this is known as the sign of benediction. So if the question says that identify the nerve lesion, if the below given hand is at this position, if you ask the patient to make a fist, then certainly the answer changes to the median nerve. Answer changes to median nerve. Why? Because that is also, you can remember, pointing index finger. Why? Because these finger, their flexors are not working. So that is a lesion for the median nerve. But in this question, they are saying a rest. So we will go with our answer as the option number A over here. So remember, these both differences, they look quite similar, particularly in the images. So look at this point of it being at rest, or you're asking the patient to make a fist. Okay, so that's a very important point, right? Okay, I hope this answers the question. Let us see another one over here. And the important topic from the abdomen, they're asking us Callops triangle. All must have heard about the Callops triangle in the gallbladder surgeries, cholecystectomies. So asking us which of the following is not a boundary of Callops triangle, right? So understand, here is the liver over here, right? We just try to retract the liver and we try to separate out the gallbladder over here. Imagine this is the gallbladder over here, right? And here is its cystic duct, right? Here is the common hepatic duct over here, and here's the CBD, the common bile duct, the common hepatic duct, and that being the cystic duct, right? Now what happens is that there's duct going on, and to the left of it, there's hepatic artery also as a part of the portal triad. Now this hepatic artery, this is known as a proper hepatic artery. Proper hepatic artery, it divides into the right and the left hepatic, and this right hepatic artery will give off the cystic artery. So imagine over here, we have something like a cystic artery. Remember, it's normally a branch of the right hepatic artery, right? So if you just expand it and if you make a cystic artery over here, and you make a cystic duct and a common hepatic duct, let us label it. This is the, imagine the cystic artery over here, that is a cystic duct over here, that's a common hepatic duct. Then everyone listen carefully, this is the anatomical Calot's triangle. So this over here is the Calot's triangle. This is the normal anatomy of it. Let us see if we have the options like this. So cystic duct, yes, this is yes, this is yes. So upper three options, they form boundary of the triangle. Triangle will only have three boundaries. So automatically that tells us that, okay, option D should be the answer. And yes, it is indeed. But inferior surface of liver is a very close call. If we include the inferior surface of liver as one of the boundaries, and we also include the cystic duct and the common hepatic duct, CD, CHD, and the inferior surface of liver, this suddenly becomes a slightly bigger triangle than the Calot's triangle, and that is known as a cystohepatic triangle. This is known as a cystohepatic triangle or hepatobiliary triangle, you have different names. So remember, Calot's triangle is a smaller triangle compared to cystohepatic triangle, right? And the main content of this Calot's triangle is a small gallbladder lymph node. This gallbladder lymph node is known as the lymph node of Lund, L-U-N-D, lymph node. It's a lymph node of the gallbladder. So remember this basic differences between the different triangles, the Calot's and the cystohepatic triangle. Okay, so ABC are the normal boundaries. D will be our answer over here. Okay, I hope this answers the question. Let us see the next one. Here's the question from the head and neck, a very important topic, the foraminers of the skull. So what structure passes through the marked foramen except, again, don't forget this word except, right? So let us see, imagine what is this foramen. We are looking at a cranial fossa. This is the anterior cranial fossa. This over here will be the middle cranial fossa, and this behind is the posterior cranial fossa. The foramen over here, if you look at closely, then is part of the Ross. What is Ross over here? Ross is, this is the rotundum, that is the ovale, and this smaller one will be the spinosum. That is known as the Ross foramen. So here the arrow is going towards the O, that is the foramen ovale. This is the foramen ovale, that is the rotundum, and below we have the foramen spinosum. All these three foramens are quite important. From the foramen rotundum passes the maxillary nerve. Remember this, V2. The foramen ovale, I hope all of you should remember, passes the structures which are male. The mnemonic is male. And from the spinosum, it is mainly the middle meningeal vessels. The middle meningeal vessels. The artery is a culprit for the epidural hemorrhage. And here also we have the meningeal branch of the mandibular nerve. What is this male over here? Male is a mnemonic, so how to fill it? M over here is referring to the mandibular nerve. A is the artery, which is the accessory meningeal artery. L is the branch of the ninth nerve, that is the lesser petrosal nerve, and E will be the emissary vein. E will be the emissary vein, right? So these are the contents of this marked foramen, male, and these are the four contents of it. Now, answer should be pretty much clear. Let us see the options. We have not yet looked at the options. So this is over here, this is over here, this is over here. So option D will be the answer, that is not passing through the foramen ovale. Then from which foramen does it pass? As we can see, it passes through the foramen spinosum. So try to identify the foramens. Here the oval shaped foramen is known as the foramen ovale, right? And let us see a couple of more foramens. As we are lucky enough to see this question, let us deal with other foramens as well. The foramen over here, the foramen right over here will be known as the optic canal, right? This big one is the foramen lacrum. Normally nothing major passes through it. This over here in the pittus temporal bone over here, this will be the internal acoustic meatus. This big one over here is the jugular foramen, and that is obviously the magnum over here. So few foramens, identifying few foramens and what are the structures passing through it. It's a sort of must-know topic for the head and neck, right? Let's see the next question. Another question from the basic anatomy, that is known as the general anatomy. Identify the plane marked See this image over here, there's a plane which is going from right to left, dividing the body into anterior parts, and we can mark it like this, anterior and the posterior part. So plane like this separating the body into anterior, posterior parts. This plane is known as what? This plane is known as the frontal or the coronal plane. Do remember it. It's frontal or the coronal plane. Right? So there are 2-3 planes over here, frontal or coronal, then there is a sagittal plane, and then there is a transverse or the horizontal plane. Basics. These are the basics, understand. This frontal or the coronal plane, as we can see, divides the body into anterior or posterior parts. Sagittal plane goes like this, divides the body into the right and left parts. Right and left parts. And this transverse goes like this, divides the body into superior and inferior part. That's extra knowledge. So therefore, answer is straightforward. That is a coronal plane over here. Right? I hope this answers the question. Let us see this same thing over here. This coronal plane that is there in the question. This horizontal or transverse plane divides the body into upper and the lower parts. Sagittal or longitudinal plane divides the body into right and left part. That's a median plane going to the center of the body. Okay. Okay. Now let's see in the question over here, and here's another question, very important topic, the dermatomes. Identify the dermatome mentioned below. All the dermatomes of the body are shown over here, but the arrows pointing out towards the region of the scrotum or the perineum region, right? Now see over here what they are trying to show us. Actually, this color coding will help you if you have some basic idea. Let me tell you why. Answer over here is this region is around S2, 3 and 4. This is the S2 will be the best answer over here. But if you apply, if you are street smart to use the word, you can see there are 4 different colors over here. This green color is referring to the region of the cervical dermatome, cervical spinals. This orange color or light brownish showing us the thoracic part. This blue is showing us the lumbar regions, and this reddish color is showing us the sacral. And there you can see this question they asked, there also red color, so that is a part of sacral. So therefore, if you apply the common sense, you can rule out option number C and D itself, L1, L2. You're left with S1, S2. Remember the perineum over there, supplied by S2, 3 and 4. Right? They reach that part. Therefore, answer is our option number B over here. Answer is option number B over here. Let us see the dermatomes over here to support. Here was the question that was asked. Here was the question, S2 and 3 over here. The different color coding again over here. Right? So you can see that few points to remember over here. You can see the green color, C1 appears missing. C1 has no cutaneous innervation, no cutaneous supply. Right? Then you can see the green one, the cervical is going to the upper limb. Why? Because C5 to T1 forms a brachial plexus. So you can see the T1 is also over here as marked over here. Then you can see the T2 till T12 is to the trunk both anteriorly and posteriorly. Then L1 over here is towards the groin region. And goes down and medially 2, 3, 4, 5, they are present posteriorly also. And then you can see the sacral, the S1 for the little toe. As you can see behind, again going to the buttocks, still S2, 3 and 4. Even S5 will also enter. But here the question they ask for about S2 and S3. The dermatomes are very important. So lumbar plexus goes to the lower limb and the brachial plexus goes to the upper limb. Right? Right. Let's see then the question over here. Okay, and the question on the lower limb. Gluteus maximus, very, very, very huge muscle in the hips or the buttock region, is supplied by. Now this muscle over here is a huge muscle, right? And its main action is that it is the chief extensor of the hip joint. What do you mean by this? Chief extensor of the hip joint, meaning by that when we are sitting on a chair, right now I am sitting in a chair, on a chair, then my hip joint is flexed. If I move my whole lower limb behind, that is the extension of the hip joint. So if you stand and you move your whole lower limb posteriorly, one limb obviously, you'll feel the contraction of the gluteal muscles, basically the gluteus maximus. That is action. But here the question is not the action, they're asking us what is the nerve supply. The nerve supply of this gluteus maximus is the inferior gluteal nerve, is the inferior gluteal nerve coming from the sacral plexus. So what we have L4, L5, S1, they are for the superior gluteal nerve root value, L5, S1, S2, they are for the inferior gluteal nerve root value. Right? So that was the question. And do also remember extra point over here that these gluteal nerves, they don't supply any skin area. So here for the answer over here, we'll go to the inferior gluteal nerve, but let us see a bit into the other options. This is option number A, the superior gluteal nerve, it supplies the gluteus medius and minimus with the tensor fascia lata as well. This obturator nerve over here, it will supply the medial compartment of the thigh. It supplies the medial compartment of the thigh. The adductors, the gracilis, the obturator externus. The femoral nerve over here, it supplies the anterior compartment of the thigh. And mind you that this femoral nerve and obturator nerve, they share a common root value of L2, L3, L4. They have a common root value. They are coming from the lumbar plexus, while this gluteal nerve coming from the, you can say, the sacral plexus or the lumbosacral plexus. What sacral is involved over there, right? Fine. Let's see the other question over here, and it's going from the abdomen again. What are all the following structures? They form the stomach bed, except. So stomach, being an intraperitoneal organ, is present quite anteriorly. So there are a lot of structures present behind it. And obviously, most of those structures will be retroperitoneal. Let us see the options. Diaphragm is retroperitoneal, yes. Splenic artery, yes, it is retroperitoneal before it enters the spleen. Pancreas itself is retroperitoneal, though tail is a bit of entering into the spleen, so we can call as a bit of intraperitoneal. Left colonic flexure or left colic flexure is actually when the transverse colon becomes the descending colon, right? So all of these structures are more or less related behind the stomach. But here, what will be the answer? See, the diaphragm is absolutely behind the stomach, right? The splenic artery is also behind the stomach. The tail of pancreas, as the tail of pancreas enters into the hilum of the spleen, so that is not directly related behind the stomach. So its presence is where? Its presence is inside the hilum of the spleen. Remember this. And therefore, this will be your best bet over here. Answer will be over here. So that will be the answer. Left colic flexure will also be slightly related behind the stomach, right? Let us see this image over here. In this image, you can see this outline over here that is representing the outline of the stomach, and the structures are present behind it. So if you look over here, you can see the splenic artery, you can see the left colic flexure, right? But the pancreas, you can see the tail of pancreas entering into the hilum of the spleen, and here you can see the big diaphragm over here. And as the stomach is on the left side, basically going to the left course of diaphragm. So question was a bit tricky, but yes, pancreas is found in the stomach bed, no doubt about it. But the tail of the pancreas raises questions. Right? It is present inside the hilum of the spleen. Therefore, the best bet over here will be option number C. Let's see, and the one over here. If you just look at the image, you can reach the answer. Just looking at the image, don't read the questions. Look at the image. Is it looking familiar? I guess yes, it is. Let's see the question. After carcinoma breast surgery, the patient developed the following deformity. Which of the following is most likely cause? Paralysis of latissimus dorsi, deltoid, long thoracic, and the injury to suprascapular nerve. If you agree with me, if I say option number C, it's a winging of the scapula. Injury to the long thoracic nerve, this nerve supplies the muscle that is the serratus anterior muscle. Paralysis will lead to what we normally call it as the winging of the scapula. This is a medial winging of the scapula. Now, they have intentionally in the question is written carcinoma breast surgery. So remember, in this carcinoma CA breast, nowadays there's also a lot of axillary dissection done. Why? Because you have to remove the axillary lymph nodes. So while doing a dissection in the axillary region, there are few nerves which are at risk of injury. One of those nerves will be this long thoracic nerve. So at the risk of injury, one of the nerves is the long thoracic, and that is what they ask in the question. Apart from this, the other nerve that will be at risk of injury will be the intercostobrachial nerve. If that is injured, it will lead to the paresthesia or dysesthesia into the floor of the axilla or the medial part of the arm. This is T2 nerve, right? Its root value is T2. Also, there can be injury to the nerve to latissimus dorsi. That is the thoracodorsal nerve, right? So these nerves can be injured. Therefore, they ask this question related to long thoracic nerve, showing you the winging of scapula, and hence the answer, right? I hope this answers the question. Let us see the next one. Just looking at the image over here, you can see there's a foot X-ray, and the yellow arrow is pointing towards the bone. The bone is a tarsal bone. There are 7 tarsals. So identify which tarsal it is. In the given X-ray, the arrow marked tarsal bone is. Let us try to understand what are the different tarsals, how to understand them. Let us look here itself. So if this is the medial aspect, that is the lateral aspect, that is the posterior side, that's the anterior side, look carefully. The heel bone is a calcaneum. It goes front and it goes slightly laterally. This is bone, black color is the calcaneus, calcaneum as you might call it. This calcaneum articulates anteriorly with the bone that is the cuboid bone. So this bone will be the cuboid bone, right? Over the calcaneum, which bone is sitting over here, that forms the, what we can say is the ankle joint. This green color which is sitting over the calcaneum is the talus. Talus moves anteriorly and articulates the bone over here, that is the navicular bone. I am marking with different colors. In front of navicular, we have the three cuneiforms, the lateral, the intermediate and the medial. So these are the three cuneiforms over here. In front of it, we have the 5 metatarsals. The first metatarsal, the second, the third, the fourth and the fifth. Remember, the fourth and the fifth, they are articulating with the cuboid bone. First, second, third are articulating with the respective cuneiforms. A mnemonic might help you over here. Remember the CCL over here. Remember, calcaneum cuboid lies laterally. And you can remember the TNM classification over here, the talus, the navicular, they lie medially. Now, if you look at this image once again, then you will realize that this is the first metatarsal over here, right? So therefore, these are the locations of the cuneiforms, Therefore, the arrow is pointing mostly towards the bone that is the navicular. If you see more of it, this bone over here will be the cuboid. This will be the calcaneus and this will be the T4 talus. Answer therefore should be navicular, and that should be one of the options. It is indeed, right? This is how, if you remember the basic orientation of the tarsals, you can reach the answer. Let us see an image as well over here. Remember this image over here and you will get all the facts clear what we have just discussed. So calcaneus over here, talus above it, in front you have the navicular, that was what they asked in the question. Calcaneus articulus is cuboid. Do also remember extra information over here. This is calcaneus cuboid, they form a joint which is normally regarded as a saddle variety of the synovial joint. And the talus and navicular, they form a joint over here, if I may show with this black color over here, and that is regarded as a miniature or a small ball and socket joint. In front you can see these three cuneiforms, right? So do remember to identify the tarsals as well as the carpals too. I hope this answers the question. Let us see the next one. Which are the contents of the carotid triangle of the neck? And the very, very important topic, that is the triangles of the neck. If you look at the triangles where you feel the carotid pulsations, this region is the carotid triangle. If you look at the muscles, then this will be the, if you imagine this is the anterior, this is the posterior aspect, right? Here we have the anterior belly of the digastric and we have the posterior belly of the digastric. These are two belly of digastric, anterior belly and the posterior belly of digastric, right? What actually, apart from it, this region of the hyoid bone, there is one other muscle coming down, that is the omohyoid muscle. It's a superior belly of omohyoid, that's the inferior belly of omohyoid. And don't forget to miss out on this huge muscle, which is the sternocleidomastoid. This over here will be the sternocleidomastoid, right? Now see over here that this region, if I may mark it different color, this is what is your carotid triangle. This is what is our carotid triangle. So what will be the structure? Obviously there is carotid sheath. So common carotid artery and the internal jugular vein will be a core part of the carotid sheath. Then we have two other options, transverse cervical artery and external jugular vein. Do remember that external jugular vein runs over the sternocleidomastoid slowly, and finally what happens is, if I may make it a bit thinner over here, finally it drains into a vein over here, and this vein over here will be the subclavian vein. This vein over here, you have the subclavian vein running over here, right? So the external jugular vein, this is EJV, it is basically present in the posterior triangle. Remember the sternocleidomastoid muscle, in front of it we have the anterior triangles, and behind it we have the posterior triangle. So EJV is present in the posterior triangle. So is about the transverse cervical artery. This transverse cervical artery also is present where in the lower part of the neck, and therefore it goes slightly laterally, right? And therefore it also present mainly in the posterior triangle. It goes towards the scapula, upper part of the scapula. Therefore this also will not be present in the carotid triangle. Then what other things will be present in the carotid triangle? See, there will be few other branches of the external carotid artery that will be present, and transcervical artery is not a branch of external carotid artery. Branches like superior thyroid artery, much like ascending pharyngeal artery or lingual artery. These are the ones which will be present over there. So out of these options, option number first and second, they looks like the best bet over here, which are obviously present. Third and fourth, they don't seem like. Therefore, answer over here will be option number C. Answer will be option number C over here. If you look at the triangles in detail, have a look at this image. Here the image is the mirror image. We have the anterior and the posterior. The basic thing whether it's dividing these two triangles is anterior posterior is this muscle sternocleidomastoid. This red color over here, this is what is representing as the carotid triangle. And this was the location of the external jugular vein over here. Same transcervical artery also goes into the cervical region. That's not present in the carotid triangle, right? So the whole topic of carotid triangle, of the triangles of the neck over here. Anterior triangle will have 4 parts, as you can see over here: one submandibular, submental, carotid, and muscular triangles. The posterior triangle has 2 parts: occipital triangle and supraclavicular triangle. This triangle over here is known as supraclavicular triangle. It's also known as subclavian triangle. Supraclavicular or subclavian triangle. They're the 2 parts of posterior triangle. Right, I hope this answers the question. Let us see the next one. Where are the neurovascular bundle placed in the anterior abdominal wall? Anterior abdominal wall has many layers. Like what? Like it has the skin. It will have the superficial fascia, which itself is divided into a campus and the scarpas. Campus and the scarpas. Luckily or unluckily, basically luckily only, we don't have a deep fascia over here. But then we have the external oblique muscles. We have below it with the internal oblique muscles, and beneath it we have the transverse abdominis muscle. And then we have a fascia over here known as a fascia transversalis. We have a very small extraperitoneal fatty layer over here, extraperitoneal fatty layer as well. And last but not least, the last part of the abdominal wall will be parietal peritoneum. Now remember, mind you, we are taking from the lateral side of the abdominal wall. If you go medially, you will encounter a muscle that is rectus abdominis. And if you go midline, you will encounter the linea alba, right? So in this context, understand that the neurovascular bundle is between the second and third muscle layer. So these are the 3 muscle layers. The neurovascular bundle in the trunk, not just abdomen, in the trunk is present between the second and the third muscle layer. So here you will have the arteries, here you will have the veins, and here you also have the nerves as well. This is a location. So it is between the internal oblique and the transverse abdominis, and that should be our answer. I guess it is option number C over here, between the internal oblique and the transverse abdominis. Now do remember, this was the question from the abdominal wall. They tomorrow ask us about the thoracic wall. They might. Again, the answer will be the same, but the names will change, but the muscles will be second and third. So here in the thoracic wall, the neurovascular bundle will be lying between what are the 3 different muscles: external intercostal, internal intercostal, and innermost intercostal. Innermost intercostal. I hope you got the answer. This is where you have the intercostal artery, intercostal vein, and intercostal nerve. And this is the sequence: vein, artery, nerve in the intercostal spaces between the second and the third layer of muscle. That is another beautiful question. Let's see another one. And here's the image before moving ahead. Here you can see the anterior aspect and the posterior aspect, the 3 muscles: external, internal, and the transverse abdominis over here. Slightly expanded, you'll realize that you can see this artery over here running between the second and the third. The branches will obviously go superficial as well as deep, but the main bundle lies between the second and the third layer. That is what the question is. Let's see the next one. Just look at the image over here. What strikes your mind? The right foot looks normal. The left foot is going into the, what is this? Flexion or extension? Flexion is like this. This is going into extension. So there in the left foot, if you just look at the image, don't look at the question, appears to be the loss of, no, there's this plantar flexion happening, this flexion happening. So there's loss of extension over here. Or you can say loss of dorsiflexion over here. So I repeat myself again. The left foot, it is in the flexion position. Or you can say it is in the plantar flexion position. So there's some loss of extension. That is what you can see in the image. Let's see the question now. This question says a 50-year-old man suffered from a road accident. X-ray confirms that tibia and fibula are fractured. These are both the bones of the leg. The patient is unable to elevate the foot. Loss of extension. Doctor on duty, DOD, thinks of a foot drop. Okay, foot drop. Like a wrist drop, you have a foot drop. However, there is normal eversion. Eversion is normal. They are not showing you eversion, but they are saying this eversion is normal. They might have tested it. identify the nerve injured. So eversion is normal, there's foot drop, so extension of the foot is not happening. Now, what is the nerve involved? Let us see over here. What happens is, from above we have the sciatic nerve that is coming down, which is in this nerve, sciatic nerve. As this nerve reaches the popliteal fossa, it divides into the tibial nerve, which goes down, and a common peroneal nerve which goes laterally. So this is the lateral part, that is a medial part. Then what happens is, common peroneal nerve, it moves anteriorly, winds around the neck of fibula. Let me point this as the neck of fibula. So you should know that common peroneal nerve is one of the most common nerve to be damaged in the lower limb. So it is quite subcutaneous. And then the CPN divides into a smaller superficial peroneal and a deep peroneal nerve. So this is anteriorly nerve going is deep peroneal, and the nerve going laterally is superficial peroneal nerve. And this tibial nerve, if we make it the dots to understand that it's going behind, we can understand going behind. So now look at the compartments. Leg has 3 compartments. This deep peroneal nerve over here is going to the anterior leg. It is supplying the anterior compartment of the leg. This is the extensor compartment. And the muscles in this compartment, they extend the foot. Here you can see there was a foot drop. So these muscles are not happening. So this nerve is obviously not working in that particular patient. We know this. Superficial peroneal nerve goes to the lateral leg compartment, and they are there. We have the peroneal muscles, peroneal longus and brevis. And these are the muscles which cause eversion of foot. They said the eversion is fine. So this, okay, fine. The tibial nerve, on the other hand, it goes to the posterior leg compartment. Posterior leg compartment, right? And then this posterior leg, right, they cause what? They cause the plantar flexion. They cause the plantar flexion over here, right? Or simply we can say that they are the flexors. They cause plantar flexion or the flexor. The flexion was occurring over here. So if you look at over here, the tibial nerve and the SPN are fine, DPN has having some issue. Let us look at the option now. Here they are saying tibial nerve, okay, tibial nerve looks okay, deep peroneal has problem. Saphenous nerve is actually a cutaneous nerve. Both ANC not possible. Therefore, the answer over here will be option number B. Now let's look at this image as well. What's this image showing us? It's simply showing us the common peroneal dividing into superficial and the deep peroneal. And you can see the deep peroneal is innervating all these extensor muscles. These are the 4 muscles in the extensor compartment of the leg, including peroneus tertius. These might have been paralyzed because the nerve is not working, and therefore there's foot drop with a normal eversion. If tomorrow they ask us that, okay, there is also eversion is also lost. In that question, giving you a hypothetical situation, suppose they say that patient has a foot drop, fine. Plus, there's also loss of eversion. Okay, now that is something different. Now, simply from this statement, you might understand that they are referring to the deep peroneal nerve injury, superficial peroneal nerve injury. If you combine them, that is common peroneal nerve injury. This is how you reach the answer. Okay, I hope this answers the question. Let's see the next one. 50-year-old Ramesh came to the emergency of a AIMS department with acute sharp abdominal pain. Okay. Dr. Lakshan duty checked for cremasteric reflex. Cremasteric reflex. Stroking the middle part of the upper thigh, you see the elevation of the testes. So it has to be some male over here. Stroking the middle part of the thigh, you observe the elevation of the testes on the same side. That is cremasteric reflex. And surprisingly, Dr. Lakshay found that it was absent. Tell the nerve that makes the efferent part of the cremasteric reflex. So this is simply asking that, do you know the basic anatomy of the cremasteric reflex? So any reflex will have an afferent component and will have an efferent component. It's stroking the middle part of the thigh, right? Here you have some nerves like a femoral branch of genitofemoral nerve, and you also have parts of ilioinguinal nerve. These are the afferent limbs. But the efferent is the one that is going into the cremasteric muscle. Therefore, the reflex is cremasteric reflex. And over here, it is always the genital branch of genitofemoral nerve, which travels in the spermatic cord. Therefore, this is the efferent part. Let us look at the options. They didn't make in detail, but simply genitofemoral nerve will be our best answer. So, genital branch of the genitofemoral nerve is the efferent limb of the cremasteric reflex. Right? Root value over here will be around L1, L2. This is what is tested by this reflex. Right? Iliohypogastric was L1, this is L1, pudendal is S2, S3, S4 is the nerve of the perineum. Nerve of the perineum. Let's see the image over here for the cremasteric reflex. They're also showing us, they're showing you the segment L1, part of L1 and L2. So here you can see this is the region of the thigh, right? And there's a testis over here. Stroking the skin of the inner side of the thigh, this is by the femoral branch of genitofemoral. A is for afferent limb. It goes to L1, and from there the efferent limb comes out with the genital branch of the genitofemoral, that is the efferent limb, that goes to the contraction of the cremaster muscle. Elevation of the testes is seen inside the scrotum. That is the cremaster reflex. Let's see the next one. Which of the following is derived from the ectoderm? It's a ectoderm derivative question. Which is derived from ectoderm? That's an embryology question. In embryology, the derivatives of the germ layers are very, very important. You have to learn of the ectoderm, both surface and neuroectoderm, mesoderm, endoderm, neural crest cells. Neural crest cells are also part of the neuroectoderm only, right? Because the three germ layers, ecto, meso, endo, neural crest cells are part of ectoderm only. Let us see the options over here. Adrenal medulla. Adrenal medulla is coming from the neural crest cells. Remember, so that looks like a probable answer. Let us see the other options. Till the time we can mark it, okay, it is looking like ectoderm. Thymus. Thymus is coming from the pharyngeal pouches. Which pouch is coming from the third pharyngeal pouch? Pouches are always endoderm. Fine, so it is endoderm. Lining of the body cavities are mainly endoderm. And lining of the respiratory system again will be endoderm. As respiratory or gut, all endoderm. Therefore, again, the answer remains our option number A, adrenal medulla. So, derivatives of ecto, meso, endo, even the neural crest cells and the nucleus, notochord, which gives rise to nucleus pulposus. Remember that too also. The notochord derivatives are sometimes asked, and notochord gives rise to nucleus pulposus. It's part of the intervertebral disc, right? Here the answer is adrenal medulla. If they ask about the adrenal cortex, what do you think about the adrenal cortex? Does it have a separate derivative? Yes. It's coming from the mesoderm. It's coming from the mesoderm. Right? So, answer is option number A. This completes the questions. I hope you performed well. Even if not, no problem. Go through the discussion. See where you missed, where you fared well, where you didn't fare well. Try to revise and ask your queries. That's all. Thank you.
Hello friends, how was the FMGE mock exam? I hope you were able to solve all the physiology questions, and I'm here to discuss the solutions with you. I'm Dr. Anupama Chaudhary Devgan, your physiology faculty. So let's start with the first question. Now this says a 45-year-old male presented to the emergency with severe pain in the right flank. He describes pain as intermittent and colicky, radiating towards the groin. So there is a big hint here. He also complains of frequent episodes of urgency and pain while urinating since last week. So obviously he has some sort of a urinary tract infection, which is probably because of a ureteric stone. This is very typically radiating towards the groin, is very typically seen in a ureteric colic. On examination, the blood pressure is 132/84, heart rate 94, afebrile, tenderness and guarding over the right flank, and there is microscopic hematuria. We are still awaiting the USG report, but what a provisional diagnosis of a ureteric stone. Which of the following statements is going to be correct? So herein you have an integrated question, and you have a clinical scenario which is given to you. You have to identify that this is a patient of ureteric stone, and there is a physiology question. Now, a ureteric stone would mean that there is an increase in the hydrostatic pressure of the Bowman's capsule. Now, what is this hydrostatic pressure of the Bowman's capsule? Is it a force which is favoring filtration or opposing filtration? This, in fact, opposes filtration. So what is going to happen to the GFR? GFR will show you a decrease. Yes, let's have a brief look at what are the forces which are responsible for filtration for GFR. A force which favors a filtration is what is known as PGC. This is the largest pressure, hydrostatic pressure of the glomerular capillaries. This is the largest force out of the four. And a force which is opposing filtration is pi GC, colloid osmotic pressure of the glomerular capillaries. The Bowman's capsule also has a hydrostatic pressure. PBC, and a colloid osmotic pressure, which is pi BC. So from the direction of the arrows, you can make out that the forces which are favoring filtration are PGC and pi BC, and the forces which are opposing filtration are pi GC and PBC. A ureteric stone will increase the hydrostatic pressure of the Bowman's capsule. Why? Because ureteric stone is producing an obstruction to flow. So there is a back pressure which is created. So it will increase the hydrostatic pressure of the Bowman's capsule, and this is a force which opposes filtration. So the GFR will decrease. So the answer to this question would be a decrease in GFR. Let's look at the next question. It says excess fluid in the lungs causes transient apnea followed by rapid shallow breathing, hypotension, bradycardia. Now this is what is known as the J receptor reflex. Now what is the J receptor reflex? What are the J receptors? J receptors are your juxtacapillary receptors. These are present in the alveolo-capillary junction. And what are the stimuli for these G receptors? The stimuli are pulmonary congestion, pulmonary edema, and pulmonary embolism. And as you can make out, it says excess fluid in the lungs. So this is a patient of pulmonary edema, and these J receptors are excited. And what are the responses? Rapid shallow breathing, hypotension, and a bradycardia. So this is typically seen in the J receptor reflex. Now, what is the Cushing's reflex? Cushing's reflex is seen when there is a raised ICP. A raised ICP, intracranial pressure. Whenever there is a raised ICP, it could be due to hemorrhage, intracerebral bleed. This raised ICP will compress the cerebral blood vessels. And once the cerebral blood vessels are compressed, this causes what is known as a CNS ischemia. And this gives rise to the CNS ischemic response. And what is the CNS ischemic response? There is a huge increase in the sympathetic discharge, and that in turn increases the blood pressure. But please understand, whenever the blood pressure rises, baroreceptor reflex will be activated. And baroreceptor reflex now causes what is known as a reflex bradycardia. Baroreceptor reflex, whenever it is activated, it will reduce the sympathetic discharge and increase the parasympathetic discharge. So it results in a reflex bradycardia. Patients of head injury with a cerebral hemorrhage presenting with the bradycardia, that is a dangerous sign, right? That means here is my patient where we need to do something immediately. It's an emergency, isn't it? If you don't treat the patient immediately, maybe by a burr hole or by giving mannitol, you will lose your patient, right? So a patient of head injury with bradycardia is not a good sign. That indicates a raised ICP. What is the Herring-Brewer inflation reflex? Herring-Brewer inflation reflex will be seen whenever the person breathes in air which is about 2 to 3 times the tidal volume. This is going to be seen whenever an individual inspires air which is almost 2 to 3 times the tidal volume. That means about 1000 to 1500 ml. This will stimulate what are known as the pulmonary stretch receptors. Now, where are the pulmonary stretch receptors located? These are not in the lung parenchyma. They are located in the tracheobronchial tree. And what is the response? The response is that this will decrease the depth of inspiration and increase the expiration time. So this is very typically seen in the Herring-Brewer inflation reflex. What is the stimulus? Lung inflation, which is 2 to 3 times the tidal volume. What are the receptors? Pulmonary stretch receptors. What is the response? A decrease in the depth of inspiration and increase in the expiration time. What is the Head's paradoxical reflex? Head's paradoxical reflex is inflation causing a further inflation, right? The Head's paradoxical is lung inflation causing further inflation. I just told you that when there is a lung inflation, which is 2 to 3 times the tidal volume, it causes a decrease in the depth of inspiration. Herring-Brewer's inflation reflex. This is paradoxical reflex, inflation producing a further inflation. Now, this is probably what is responsible for the first breath of the newborn. So that is primarily because of the Head's paradoxical reflex. Why do we call it paradoxical? Because we just discussed the Herring-Brewer inflation. This response is completely opposite to that. So this is a paradoxical reflex. Physiological significance, this is probably the reason for the first breath of the newborn. Let's look at the next question. It says, a 25-year-old patient after head trauma presented to the emergency room. On neurological examination, he was found to have a normal handwriting and could copy shapes of objects. But he could not speak. So that means his comprehension is okay. His comprehension is intact. Repetition is present. He's able to copy shapes of objects. He's able to write, but he's not able to speak. So that means here the lesion is going to be in the motor area of speech, which is the Broca's area. Broca's area is involved in the motor aspect of speech. So this is what is going to most likely to be damaged in this patient. Wernicke's area, a lesion of the Wernicke's area would have also presented with inability to comprehend neither the written or the spoken word. In this case, he's able to comprehend, he's able to repeat, copy shapes of objects. So therefore, Wernicke's area is intact, aqueous fasciculus is intact. Internal capsule produces a dense hemiplegia of the opposite side. So that is not the site of lesion here. Here the lesion is the Broca's area. Let's look at the next question. Which of the following statements is not true for the given left ventricular pressure volume loop? So just a brief look at the left ventricular pressure volume loop. Now at the point C, which is given over here, this is at the end of diastole. Diastole is a period of filling. Left ventricular volume is at 120, pressure is at 5, and at this point the mitral valve closes, producing the first heart sound and onset of systole. C to D here is isovolumetric contraction phase. There is a sharp rise in the LV pressure with no change in volume. At point D, the moment the LV pressure exceeds the diastolic blood pressure of the aorta, at this point the aortic valve opens. And now starts the phase of ejection. From D to A, here is the ejection phase. At the end of the ejection phase, the aortic valve closes, producing the second heart sound. End of systole. Now, between A to B is isovolumetric relaxation, sharp fall in the LV pressure with no change in volume. At point B, given in this loop, there is opening of the mitral valve, and between B and C is going to be the filling phase. So this is your left ventricular pressure volume loop. So let us see, look at the options. It says mitral valve closes at point C of this loop, which is true. Segment AB represents the isovolumetric relaxation phase, which is also true. Ejection fraction for this loop is around 55 to 60%, which is, if you can see, how do you see the ejection fraction? Ejection fraction is stroke volume divided by end diastolic volume. And as you can make out from The width of the loop is the stroke volume, which is approximately 70 ml here. End diastolic volume is 120. So this is also true. 70 divided by 120 is approximately 60%. Second heart sound is heard at point D, which is incorrect. It is heard at point A of this loop. So this is your LV pressure volume loop. Let's look at the next one. Which of the following physiological compensatory mechanisms do not occur in response to high altitude hypoxia? Is there a... Now, high altitude, when you go to high altitude, there is what is known as hypoxic hypoxia. So there is a decrease in PO2, which will stimulate the respiration, and there is a tendency to develop respiratory alkalosis. So pH increases. Decrease in pH is not seen. There is in fact an increase in pH, though the compensatory mechanism will try to lower the pH, but it is not able to, in fact, it is not able to bring it back to normal even. So acidosis is out of question, right? So this is going to be increase in pH. Is there going to be increase in hemoglobin concentration? Definitely, because hypoxia is a very potent stimulus for erythropoietin secretion from the kidney. And that increases the RBC mass and increases the hemoglobin. Is there going to be release of VEGF? What is this? This is vascular endothelial growth factor. Yes, because hypoxia is a potent stimulus for the secretion of VEGF. Mitochondrial numbers will increase. Yes, this is the response at the cellular level to increase the utilization of oxygen. Let's look at the next question. What is the resting membrane potential of a neuron? This is simple. This is a simple recall question, minus 70 millivolts. For large motor neurons, the RMP is going to be minus 90 millivolts, but most neurons, minus 70. Which of the following hormones act through the JAK-STAT pathway? JAK-STAT pathway, the hormones acting will be growth hormone, IGF-1, prolactin. These will act via the JAK-STAT pathway, even leptin. These are the hormones which do not need second messengers. So my answer to this question is going to be growth hormone. Let's see the next question. Which of the following is a wrong statement related to the functions of the thyroid hormones? They increase the resting respiratory rate. True. They increase metabolic activity. There is going to be increase in the resting respiratory rate. The thyroid hormones increase diastolic and decrease systolic. This is incorrect. In fact, they increase systolic and decrease diastolic. Because you must understand, thyroid hormones cause an increase in metabolic activity and they cause a vasodilation. So if there is an increase in vasodilation, this will reduce the total peripheral resistance and reduce the diastolic blood pressure. So diastolic blood pressure reduces, not increases. Increases appetite and food intake, which is true. Stimulate both synthesis and degradation of proteins, which is also true. The overall effect is slightly more towards degradation, catabolic effect, but it causes both. So answer to this question, which of the following is a wrong statement, would be B. Let's look at the next one. Which of the following proteins is present in tight junctions? Now, tight junctions, the proteins which are present are claudins, occludins, and JAMs. What is JAMs? Junctional adhesion molecules. So answer to this question becomes very easy. This is claudins and occludins. Connexins form gap junctions. Desmocollins form desmosomes. Cadherins are your cell adhesion molecules. Cell adhesion molecules. Let's look at the next question. Which of the following stimulates the gallbladder and pancreatic secretion? This should not be a problem. CCK. CCK is secreted by what are known as the eye cells, and the role of CCK is to cause a gallbladder contraction. It also increases the pancreatic enzyme secretion. Number 3, it potentiates the action of secretin. And number 4, it also produces satiety. Gastrin, on the other hand, is secreted by the G cells in the antrum, and gastrin increases HCl secretion. Besides that, gastrin also has a trophic action. What is trophic action? It promotes the growth of the gastrointestinal mucosa. S cells will secrete secretin, and the role of secretin is to increase the bicarbonate content in bile and pancreatic juice. It makes the bile and pancreatic juice alkaline. Somatostatin is secreted by delta cells, and the role of somatostatin is to decrease the gastric motility and secretions. So these are your different GI hormones. Let's see the next question. Which sleep waves are seen in focused attention? Now, remember D-tap, as you go from D to B, delta to beta, there is an increase in the frequency and a decrease in amplitude. So just to remember what are the frequencies of these waves, remember 4, 8, 12 and 30. Frequency of delta is less than 4 Hertz, theta is 4 to 7 Hertz, alpha is 8 to 12 Hertz, and beta is 13 to 30 Hertz. Now, when do I record alpha? Alpha is when a person is at rest, eyes are closed, and mind is wandering. That is when you get the alpha rhythm. Beta will be seen when he opens his eyes. Eyes are open. But the moment he focuses on something, beta is replaced by gamma oscillations. Gamma oscillations are very high frequency activity, 30 to 80 Hertz. Theta is generally recorded in moments of disappointment, frustration, and in children when they are crying. So my answer to this question becomes gamma. Please remember alpha, eyes closed, mind wandering. Eyes open, alpha is replaced by beta. And if you focus on something, beta will be replaced by gamma. Next, what causes maximum airway resistance to the flow of gases through the endotracheal tube? Now, that means we are basically looking at the large airways. What is going to be the most important factor which will affect the resistance to flow here is going to be diameter. We know that resistance is inverse to the 4th power of radius. More the radius, less the resistance, less the radius, more the resistance. Let's look at the next one. Which of the following hormones regulate the serum calcium levels? Now, serum calcium levels are going to be controlled by actually all three: calcitonin, vitamin D, as well as parathormone. So my best answer here will become A. Even though calcitonin has got a very limited role, most of the calcium metabolism is regulated by parathormone and vitamin D. But calcitonin does have a role. Calcitonin inhibits the activity of osteoclasts. It decreases bone resorption. But like I said, not very important from a physiological point of view, but definitely it does have a role. Next, which of the following hormones act on anterior pituitary to release prolactin? Now, it says to release prolactin. Prolactin is normally kept inhibited by the prolactin inhibiting factor from the hypothalamus. But which of the following hormones can act on the anterior pituitary to release prolactin? And that is thyroid releasing, thyrotropin releasing hormone, and that is TRH. TRH can act on the lactotropes of the anterior pituitary and increase prolactin. And this has got a very important clinical implication. Patients of hypothyroidism, they have elevated TSH and TRH, and very commonly this patient can present with galactorrhea or milk secretion from the breast. Hypothyroid individuals can present with galactorrhea. The reason is TRH will increase prolactin secretion. Let's see the next question. Which of the following events normally occurs during the PR interval? So P is atrial depolarization and QRS complex is ventricular depolarization and T wave is ventricular repolarization. PR interval is from the onset of P to the onset of Q. If Q is not present, then from onset of P to onset of R. But if Q is present, then onset of P to onset of Q. That is called PR interval. Q is normally not seen. It is so, or is not very conspicuous. So PR interval is taken from onset of P to onset of R. Now, are the ventricles contracting? No. Ventricles will begin to contract just after the peak of R. Ventricles have to depolarize first and then they will contract. So they begin to contract just after the peak of R wave. Cardiac action potential passes through the AV node? Yes. Atrial depolarization, now the impulse is traveling towards the ventricles. So it is passing through the AV node. This is true. Mitral and aortic valves are closed. The closure of mitral and aortic valves will be seen either in an isovolumetric contraction phase or an isovolumetric relaxation phase. Isovolumetric contraction phase will start after the R wave. Relaxation will start after the T wave. So this is also not correct. Second heart sound is heard. Second heart sound will be heard at the end of T. So this is also not correct. My answer to this is B. Question number 16. Which of the following is not a part of the countercurrent in the kidney? Descending thin segment, thick ascending limb, collecting duct, and vasa recta. Vasa recta are your countercurrent exchangers, so definitely. Descending thin segment and thick ascending limb form your countercurrent multipliers. Collecting duct is not a part of the countercurrent system. So answer to this is C. Let's look at the next question. Which of the following neurotransmitter is responsible for anterograde relaxation? Anterograde relaxation of the smooth muscle of the GI tract during peristalsis. Whenever food is present in the small intestine, there is a ring of contraction behind the food and relaxation in front, which causes forward propulsion or peristalsis. What is responsible for a ring of contraction behind the food will be mainly substance P and acetylcholine. But relaxation in front of the food is going to be produced by nitric oxide and VIP. These are potent, smooth muscle relaxants. So my answer to this question is vasoactive intestinal polypeptide. So these were the physiology questions in your FMGE mock exam.
I am Dr. Harmeet Goyal, Obs Gynae faculty at LN. I will be discussing the Obs Gynae questions which you have got in grand test on today, that is 2nd July 2023. So let us start with the discussion. Question number 1. Identify the image. So very, very clearly you should see what is the image. Okay. Then once you make your provisional diagnosis in mind, then look at the options. So this is an image of a pregnant lady where the baby is shown in transverse lie. That is the malpresentation. Remember, when there is a malpresentation like breech, which is the most common malpresentation, transverse lie, the second most common malpresentation, there the placenta does not get a proper space to get implanted in the fundus. Okay. Or you can say when there is a low-lying placenta, this favors malpresentation. Okay, same thing. Okay, so let us see in this question. सबसे पहले in this question they have just pointed out and they have made this block. So let me check where is the level of the placenta. Here they are just pointing and this is low-lying placenta. Normally placental attachment is in the fundus. Okay, but here there is a transverse lie and I can see the placental attachment and they have made a block as well. So according to me, this is placenta previa. Okay, let me check the options given to me. It is not vasa previa. Vasa previa occurs when there is filamentous insertion of placenta. Now, can we see where the baby is inside? Where is the filamentous insertion of placenta? No, we cannot see with our naked eyes unless until there is a delivery conducted and we can examine the placenta and the fetal membranes. Okay, or we already suspect a vasa previa and we have done a Doppler ultrasound. Only then we can make a diagnosis of vasa previa. Vasa previa is also a type of APH where blood is fetal in origin. Okay, this is not placenta accreta and this is not abruptio placentae. In abruptio placentae, what happens? There is separation of placenta and there is formation of retroplacental clot. So placenta is usually fundal, but here placenta appears to me low-lying. Okay, so placenta here is low-lying. So it is none other than placenta previa. So the answer to this question is placenta previa from this image. For the last 2-3 exams in FMG, they are asking either abruptio placentae image or they are asking placenta previa image. So here in this question, the answer is placenta previa. Why it is not vasa previa? Because there is no placenta in front of us. Okay, it is not placenta accreta. Placenta accreta is not like this, and this is not placental abruption because there is no clinical history given. And in placental abruption or abruptio placentae, there is premature separation of normally situated placenta and there is formation of retroplacental clot. So it is placenta previa image based MCQ. Now, patient with breast cancer treated with tamoxifen. Okay, what is tamoxifen? Tamoxifen is SERM, that is selective estrogen receptor modulator. Selective estrogen receptor modulator it acts as agonist on endometrium. On uterus, it acts as an agonist and antagonist when it has to act on the breast. So it is given for the breast cancer as a palliative treatment. It's given as a palliative treatment for breast cancer. But since it is an agonist on endometrium, so risk of which cancer is increased? Endometrial cancer. So endometrial sampling or endometrial biopsy has to be done timely when you are putting a patient on tamoxifen. This is very, very important. So what is tamoxifen? It is SERM, selective estrogen receptor modulator. It acts as an agonist on endometrial cells but act as an antagonist on breast tissue. So it is used as a palliative treatment for breast cancer, but in long run it can cause endometrial cancer. So endometrial sampling or endometrial biopsy is important when you are putting a patient on tamoxifen. Clear? Next, which is the most common obstetric or gynecological condition in which procedure is shown? Now what is shown? It is shown that there is common iliac artery. It divides into, common iliac divides into iliac arteries, which divides into external and internal iliac artery. Internal iliac artery gives anterior and posterior division. So let me just write down. This is abdominal aorta. Abdominal aorta at L4 divides into common iliac arteries, which divides into external iliac artery and internal iliac artery. Internal iliac artery gives anterior division and posterior division. And uterine artery is a branch of anterior division of internal iliac. Okay, from abdominal aorta there is renal artery at L1 and ovarian artery at L2. So when there is atonic PPH, in atonic PPH when happening, first step is medical steps. Second steps are mechanical steps and third is the सर्जिकल स्टेप्स. ठीक है, मैकेनिकल में हम क्या यूज करते हैं? वी यूज ऑक्सीटोसिन, वी यूज मेथर्जिन, वी यूज प्रोस्टाग्लैंडिन्स, and if all fails we go for a mechanical compression where we use Bakri balloon tamponade. If that fails we go for a surgical steps. So it appears to me surgical steps, and it is better that although इसमें काफ़ी jumbled up हो जाता है, but from the question वहीं पे we will discuss, then the things become more clear. So इस arterial जो है branches हैं, what do you see this instrument? This instrument is a forceps, or it's a type of right angled artery forceps, and it is just to like pick up the artery which you are going to ligate. So here arterial ligation is being done, that is systemic devascularization. Systemic devascularization, where first is uterine vessels ligation, then ovarian vessels ligation, and if it's failed then anterior division of internal iliac artery ligation is being done. If that fails then you go for life-saving hysterectomy, where you are removing only uterus, leaving the cervix, vagina behind. That is, only the uterus is removed. So here this is systemic devascularization is shown, and in this image, what I judge from the images, it is anterior division of internal islet ligation which has been done. So this is done for atonic PPH. It's not dysfunctional uterine bleed. It is not bleed for cancer cervix or cancer vulva. It is atonic PPH management, surgical step of atonic PPH management. Next, which of the following is most cost effective? So this is a PSM based question. Cost effective screening method for cancer cervix. We as a gynecologist use pap smear. PSM people use VIA for mass screening with the help of health worker. With the help of health worker or midwives. Okay? So which is cost effective? Cost effective is VIA, that is visual inspection under acetic acid. So you apply. There has to be a white light source. White light source, a good source of light should be there, that is a lamp. Okay, light source. Then you lie down the patient and then onto the cervix you apply freshly prepared 3 to 5% acetic acid. The normal cells will take up the stain, but abnormal cells do not have no glycogen. So they appear as aceto-white areas. So this is VIA, visual inspection under acetic acid. Next, which of the following parameter decreases with pregnancy? Okay, WBC increases, ESR increases, total protein synthesis is increased, but because of dilution of blood which is happening in the second half of pregnancy, hemoglobin concentration falls. Okay. RBC is rising to 20% and plasma volume is rising to 50%. So there is hemodilution and there is physiological anemia of pregnancy. So overall hemoglobin concentration falls. Next, 55-year-old post-menopausal women comes to OPD with single episode of bleeding per vagina. Transvaginal scan shows endometrial thickness of 4 mm with a focal area of increased thickness. Whenever on TVS there is endometrial thickness 4 mm, but there is focal thickness. Okay? In that case, always remember, I have already discussed in my classes, you have to go for hysteroscopic guided biopsy. Okay, hysteroscopic guided biopsy, or you can do hysteroscopic guided endometrial aspiration. So this is what is a very standard investigation. Nowadays trend is very commonly they ask question from AUB or they can ask from post-menopausal bleeding. AUB is abnormal uterine bleeding. DUB term is no longer used. Dysfunctional uterine bleeding. So abnormal uterine bleeding or post-menopausal bleeding, investigation is hysteroscopic plus endometrial aspiration. 28-year-old gravida 3 para 2. That means when she is pregnant, we use the term gravida. So she has 2 deliveries, 35 weeks of pregnancy, painful uterine contractions, dark altered blood, altered vaginal bleeding, which is dark color, tender uterus, BP high. So it is PIH with abruptio placentae. Diagnosis: PIH with abruptio placentae with fetal distress, because normally fetal heart rate is 110 to 160 beats per minute. Less than 110 is fetal bradycardia, which is fetal distress. More than 160 is fetal tachycardia. Both means fetal distress. In PIH, pregnancy-induced hypertension, what happens? There is, because of vasoconstriction, happening, there is premature separation of normally situated placenta. So this leads to abruptio placentae. So patient is losing blood inside. There is formation of retroplacental clot. Because of this, there is fetal distress. So what is the management in this case? Emergency cesarean section, not because of PIH, not because of abruptio, but because of fetal distress. So I am going to do the management as cesarean section. So this is placental abruption. Diagnosis I have made, PIH with abruptio placentae with fetal distress. So management is cesarean section. Students को लगता है कि जो single liners हैं वो easy है, नहीं. Clinical questions are more easy, and trend is the clinical questions, because as a doctors you are going to manage the patients in the hospitals. Fine. So this knowledge is very, very important. And in the clinical question in Obs Gynae subject, there is lot many hints. 29-year-old, Gravida 3, Para 2, 32 weeks of pregnancy. She has come in the emergency department with vaginal bleeding. So vaginal bleeding is present, and there is tachycardia, pulse rate is 100 beats per minute, BP is maintained, fundal height is 32 weeks, fetal heart rate is 100. Which of the following management you are going to do? Actually, conservative management will not work because it is fetal distress. And since there is bleeding, so it might be placenta previa, it might be abruptio, but tender uterus is not given, history of fall is not given, PIH is not given. So I may take it as placenta previa, but she is bleeding and there is fetal distress. Bleeding can be controlled by conservative management, which is called as McAfee-Johnson's management. Okay, but there is fetal distress. So I am going to take the patient for emergency cesarean section, and I don't have time to give the steroids. For steroids to act, it requires 24 hours. So can I wait if the fetal distress has occurred? No, I cannot wait. So I am going to do an emergency cesarean section and keeping the pediatrician ready, because this is going to be preterm delivery. Fine. And problem is lung maturity. Now next, question number 9. What are the components of modified biophysical profile? Components in modified biophysical profile. Biophysical profile or Manning score is a special ultrasound. Here in biophysical profile or Manning score, which you do in high risk pregnancies, like you do in post-dated pregnancy, you do it in PIH, you do it in IUGR, you do it in diabetes, you do it in chronic hypertension, etc. So what are the parameters that we see in biophysical profile ultrasound? There is NST, amniotic fluid, fetal tone, fetal breathing movement, and gross body movement. So the radiologist is doing an ultrasound for 20 to 30 minutes. Each parameter he check and he gives 2 score. Normal score is 10/10. Okay. When he does not have time, okay, or we don't have time for an half an hour ultrasound, so we tell the radiologist to get NST and amniotic fluid index done. This is called as modified biophysical profile. So this question has been asked in AIMS PG 2015. So NST plus amniotic fluid index is called as modified biophysical profile. Fine. Next, following are the indications for vacuum assisted delivery. Vacuum extraction indications they are asking. Nowadays, Omni cup, which is a small size cup, is used. Okay? And there is inbuilt vacuum pressure, and it is very easy to conduct vacuum delivery with Omni pump. Okay. So what is the indication for vacuum assisted delivery? Prolonged second stage of labor, fetal distress, maternal distress. So prolonged second stage of labor and non-assuring fetal heart rate on CTG. So this is what it means, fetal distress. Face presentation is a contraindication. After coming head of breech is a contraindication. Prematurity is a contraindication. So what are the contraindications for vacuum? Number 1, prematurity. Number 2, bleeding tendencies in neonate. Number 3, face presentation. Number 4, after coming head of breech. After coming head of breech. This is again very important question. Next. 22-year-old married female brought to the emergency. Okay, with a history of fainting. Whenever a term brought is written, that means general condition of the patient is poor. Okay, she has fainting episodes, sudden lower abdominal pain. She has amenorrhea 6 weeks. Amenorrhea 6 weeks, pain, abdomen, fainting, pallor, shock. What this signifies? This is rupture ectopic pregnancy, and management is resuscitation. First of all, resuscitation, followed by immediate laparotomy and salpingectomy, because when the patient has gone into shock, it is badly ruptured fallopian tube. Now, which part of the fallopian tube pregnancy, ectopic pregnancy, ruptures earliest? Earliest to rupture is ischemic, less than 6 weeks. Late to rupture is interstitial ectopic pregnancy. Interstitial ectopic around 3 to 4 months pregnancy. Then pregnancy in the ampulla. Ampullary ectopic pregnancy ruptures at 8 to 10 weeks. Now, which is dangerous ectopic pregnancy? Answer is interstitial ectopic pregnancy is dangerous because it remains undiagnosed for a longer duration, and when there is bleeding, it can be uncontrolled bleeding. Sometimes cases have reported where life-saving hysterectomy has been done. Fine. Next, twin peak sign is seen. Twin peak sign, okay, there is diamniotic and dichorionic twins. All dizygotic twins are diamniotic dichorionic and their membranes on ultrasound are 4 layered, 2 amnion and 2 chorion, and they have separate placenta. So, chances of survival better than monochorionic twins. So, twin peak sign on ultrasound is seen in diamniotic dichorionic twins, and it is also called as lambda sign. This membranes on ultrasound is a twin peak sign, okay, and T sign on ultrasound is seen in monochorionic twins, which is a type of monozygotic twins. Fine. Chances of survival is much better in dizygotic twins, which is always diamniotic dichorionic, and they have separate placenta, so complications are less. 80% of twins are dizygotic twins, 20% are monozygotic twins. Next, which of the following is most common metastasis of choriocarcinoma? Lungs. X-ray chest finding shows cannonball appearance. Cannonball appearance. Okay. Which is the type of contraception in cases of choriocarcinoma? Follow-up cases is OCPs. What is the tumor marker of choriocarcinoma? Beta HCG. What is the main drug to treat choriocarcinoma? Is methotrexate. Okay. What is the most common mode of spread of choriocarcinoma? Hematogenous. Next, 27-year-old female, gravida 2 para 1 L1. This is second time pregnant, 1 baby, 1 live issue. Admitted in the labor room, intern asked to calculate the Bishop score for her. On examination, cervix is 4 cm dilated, 2 cm long, soft, anteriorly placed, head is at +1 station. So, what is modified Bishop score? Modified Bishop score includes cervical dilatation, effacement, consistency of cervix, position of cervix, and station of presenting part. Okay. So, when you calculate, you will see from the book or from the notes which I have given. So, Bishop score will come out to be 11. You can calculate. Now, quadruple test. Quadruple test is done in aneuploidy screening. What is term aneuploidy? Aneuploidy means abnormality in chromosomal number. Like trisomy means extra chromosome. Extra chromosome. Trisomy 21, Downs. Trisomy 18, Edward. Trisomy 13, Patau. Okay. 1 chromosome extra is trisomy, 1 chromosome less is monosomy. Like Turner is 45XO. Now, quadruple test is done around 16 to 18 weeks. Maternal blood sample is taken and you take alpha fetoproteins, beta HCG, unconjugated estriol, and inhibin A. So, alpha fetoproteins is decreased, HCG rises, estriol decreases, inhibin A rises. So, wrong answer is inhibin B. Inhibin B is not a marker for quadruple test. Fetal head is in which position in face presentation? So, if the fetal neck is completely flexed, complete flexion, it is vertex, and denominator is occiput and diameter is suboccipito-brachmatic, which is 9.5 centimeters, so normal vaginal delivery. If it is complete extension, it is face denominator is mentum and the diameter is submentobrachmatic, which is 9.5 centimeters, normal vaginal delivery. If it is complete extension, it is broad, which is largest diameter of fetal skull, mentovertical, 14 centimeter, management is LSCS. Okay. So if I have to make a diagram, this is occiput, this is bregma, this is mentum. So this diameter mentovertical, this is broad, suboccipitobrachmatic, this is vertex, this is anteroposterior diameter, and this is face, submentobrachmatic, which I have written. Complete flexion, vertex, partial extension, broad, complete extension, face, and diameters also I have written. This is for face, this is for vertex, and this is for broad. Fine. Next, Mrs. Amrita, 28-year-old primary gravida. This is comes in the OPD for routine checkup. Last menstrual period is 25th October. What is the expected date of delivery? Expected date of delivery, we use Niggles formula, that is add 9 months plus 7 days, or 7 days count back 3 months. So if you add 7 here, it is 1st of August. Okay, so I have added 9 months and 7 days. So expected date of delivery is 1st of August. So how many pregnant ladies deliver on EDD? Only 4% of the pregnant ladies deliver on expected date of delivery. Now total duration of pregnancy is 40 weeks. We do not let the pregnancy go beyond 40 weeks because there is risk of meconium aspiration syndrome. So 280 days is a total pregnancy term, which is 40 weeks. Fine. So this is Niggles formula to calculate expected date of delivery. Next, which of the following is not a part of diagnostic criteria for PCOS? In the PCOS, we take as Rotterdam criteria. Rotterdam criteria says there is hyperandrogenism. That is lab or clinical. Clinical is there is acne, hirsutism, baldness, ठीक है, oily skin, that is the features of hirsutism. Number 2, there has to be an ovulation and menstrual disturbance like oligomenorrhea, hypomenorrhea, secondary amenorrhea. Okay. Number 3, ultrasound shows polycystic ovaries. So out of 3, 2 criteria are taken into consideration. So this is Rotterdam criteria, where hyperandrogenism, this is must for diagnosis. Then there is an ovulation leading to menstrual disturbance. Then there is polycystic ovaries. Necklace pattern on ultrasound is not included in the criteria. Fine. Next, 28-year-old female presents with complaints of itching. When itching is present, there is no bacterial vaginosis. In case of bacterial vaginosis, there is no itching, but there is clue cells. There are clue cells. There is foul smelling vaginal discharge. pH is more than 4.5 and there is Emsel's criteria used. So when there is itching, it is not bacterial vaginosis. There is scanty curdy white discharge. Okay. So curdy white discharge is seen in Candida. So answer is Candida albicans. Rest is wrong. Okay. No. Saline microscopy shows fungal hyphae. This is also correct. Fluconazole is given as a drug of choice. This is also correct. So one answer which is wrong is pap smear shows clue cells. Clue cells are seen in bacterial vaginosis and itching is absent, and it is not curdy white discharge, it is foul smelling discharge. Fine. Next. Women comes to you with IUCD insertion. You acquire about the menstrual period and she comes after few days for an IUCD insertion. Okay. Which of the following is not true? Best time to do IUCD insertion is during menstruation or within 10 days of menstrual period. Correct. Can you insert in the first week after delivery? Yes, we can insert. Can we insert after a legal abortion? Yes, you have to insert immediately. The high risk of perforation in post-perpurial? Wrong. Nowadays, post-placental insertion is done within 10 minutes of delivery. If the expulsion rate was high, then why the insertion will be done? So this is practiced in most of the government institutions, that within 10 minutes of placental delivery, you have to do the IUCD insertion. Okay. Next. 35-year-old female comes to the gynae OPD with complaints of menorrhagia. On examination, uterus is asymmetrically enlarged and non-tender. So there is history of menorrhagia. Uterus is asymmetrical enlarged. Asymmetrical enlarged usually goes in favor of fibroid uterus and it is non-tender. So, symmetrical enlarged, tender. This goes in favor of adenomyosis. This goes in favor of adenomyosis. Okay. If it is irregularly enlarged, non-tender and menorrhagia. Most common symptom of fibroid uterus is menorrhagia. Okay, submucosal fibroid and intramural fibroid. Whereas adenomyosis, it is dysmenorrhea, which is most common. Okay, so answer here is fibroid uterus. Next, a couple comes to your OPD for not being able to conceive despite regular unprotected coitus. What will be the first investigation you will do? In a couple who is having regular coitus and trying for a conception and not able to conceive, although when the patient comes, we do multiple investigations, but this is an AIMS PG question. AIMS PG question. What is the first investigation to be done? I have always told you, first investigation to be done is always semen analysis. Okay. So first investigation to be done. Why? Because when we look at the causes of infertility, male factor infertility is 25 to 40%. Female factor is 40 to 55%. Both are 10% and unexplained is 10%. So in both and unexplained, there is also contribution to the male. So there can be both male and female can have the cause of infertility. So almost 40% cases, the male is responsible, and once you start the investigation, it is a non-invasive investigation, semen analysis, and we get much of the information. Okay, so why not investigate the male? In the female, there is no single investigation which can rule out all the possible causes of infertility. So each part of the female genital tract has a separate causes, so investigation are separate. For uterus, we go for ultrasound, we go for HSG, we go for 3D ultrasound, we go for, like hysteroscopy, which is gold standard. Then for tubal patency, we do a basic investigation, HSG, and confirmatory is laparoscopic chromotivation. Okay, for ovulation, we go for an ultrasound, but there are serum progesterone, basal body temperature, other methods are also available. And once we are not able to find out cause, we before we label it as unexplained infertility, 40 to 50% cases of unexplained infertility, the cause is endometriosis. And for that, gold standard investigation is laparoscopy. So laparohistro are our investigations which are invasive investigations. Once we get to know Asherman syndrome is there, or septate uterus is there, or there is a bicornuate uterus, okay, or there is cornual block, or there is a fimbrial block. So there is a role of a laparoscopy. Endometriosis, laparoscopy is a gold standard investigation. So in female, single line, कोई single investigation नहीं है, battery of investigation which is invasive and non-invasive. So why not investigate the male partner first? Hence my answer is semen analysis. 16-year-old girl with primary amenorrhea. 16-year primary amenorrhea, well-developed secondary sexual characters, okay, and good axillary pubic hair. So she has primary amenorrhea at 16 years. So we should investigate, okay. At 16, we should investigate. So breast development is present. Axillary pubic hair are also present. Primary amenorrhea, breast normal, axillary pubic hair normal. That means ovarian function is normal. And androgens are also present and functioning. Okay, because hair growth, androgens are responsible. Breast development, estrogen is responsible. Okay, ultrasound reveals absent uterus. So uterus is absent. So what is it? Ovaries present, uterus absent. So it is Mullerian agenesis. Gonadal agenesis. There is no breast development. This is Turner. No breast development. Okay. But ultrasound, uterus is hypoplastic. Here it is written as uterus absent. Androgen insensitivity syndrome 46XY, and the gonad is undescended testis, and here axillary hair will be absent. So it is not androgen insensitivity. Sphere syndrome is 46XY. It is also pseudohermaphrodite. Here uterus, cervix, fallopian tube, vagina present, because Sertoli cell did not secrete Mullerian inhibiting substance, so Mullerian duct derivatives are present. So they have undescended testis and external genitalia female. So it is not sphere syndrome. Okay, so it is Mullerian agenesis. Next, most common ovarian tumor. Most common clinically detected ovarian tumor is always dermoid cyst, which is mature teratoma. It is occurring in the reproductive age group, but it can occur in any of the female. This is a tumor. It undergoes most common cause of torsion or twisting because it has a pedicle. It is mostly a benign tumor, and risk of malignant transformation is just 1%. Okay, it's most common ovarian tumor to be associated with pregnancy. Most common ovarian tumor to be associated with pregnancy. Now, what is most rapidly growing ovarian tumor is yolk sac tumor. Largest ovarian tumor, mucinous cyst adenoma. Feminizing ovarian tumor, granulosa cell tumor. Most common epithelial ovarian tumor, serous cyst adenoma. Ovarian tumor occurring in dysgenetic gonads is gonadoblastoma. Ovarian tumor occurring in Turner syndrome is gonadoblastoma. Okay. Most malignant ovarian tumor is immature teratoma. So I hope this is clear and you will get confidence, because Obs Gynae is a subject where you can get almost full marks compared to other clinical subjects. Fine. Now, 50-year-old female presents with episodes of hot flushes. Hot flushes means it is menopausal symptoms. She complains of episodes which are intolerable. Which of the following treatments is most effective in this condition? Always when there is a hot flushes, which is most common menopausal symptoms, that is called as vasomotor symptoms, which is most common, and this occurs because of estrogen withdrawal. This occurs because of estrogen withdrawal. So there is estrogen replacement therapy. Estrogen replacement therapy. Next, 55-year-old woman comes to gynae OPD, complains of happiness and something coming out of vagina. Something coming out of vagina is always genital prolapse. Okay. And on examination, you find that external os lies outside the introitus. Which degree of prolapse it is there? It is 3rd degree cervical descent. When they write uterus is out of vagina, then it is prostodentia. But they are talking about cervix, so it is 3rd degree cervical descent. 29-year-old female with gravida 1 para 0. This is first pregnancy, 24 weeks, antenatal clinic for routine checkup, 75 grams. This is the ideal time to do glucose challenge test. And nowadays there is a DIPSI criteria, Diabetes in Pregnancy Society of India, that is used, and we give 75 grams of glucose and we take 2-hour test glucose and the value is 180. It should be less than 140. Okay. Which of the following complication is not expected in this case? Abortion, preeclampsia, infection, oligohydramnios. In diabetes, there is polyhydramnios because of increased glucose. Baby has polyuria. Because of polyuria, there is polyhydramnios. Oligohydramnios occurs when there is a renal agenesis. So diabetes is associated with polyhydramnios and congenital anomalies. Chances of abortion, preeclampsia, infection are all increased. Next, primary oogonia enter meiosis in utero and becomes primary oocytes. The oocytes get arrested in the development of prophase during the first meiotic division. When does first meiotic division is completed? Always at the time of ovulation and formation of secondary oocyte and first polar body, and second meiotic division is completed at the time of fertilization. Second meiotic division is complete at the time of fertilization. Next, 50-year-old woman complains of amenorrhea for 6 months and there's a prolonged spotting for 3 months. Amenorrhea for 6 months, she is obese, diabetic, and she was younger when she gave a history of PCOD. Uterus is normal size, per speculum examination normal, TVS shows endometrial thickness 8 mm. What would be your next step? Whenever on TVS there is history of bleeding, you can say after 6 months of attainment of menopause and the patient is obese, diabetic obesity, okay, post-menopausal bleeding are all risk factor for endometrial cancer. Okay, so TVS ET is more than 6 mm. You have to always do endometrial sampling or endometrial biopsy. Try to rule out endometrial cancer or hyperplasia. So in this case, endometrial biopsy using a pipil, that can be an office biopsy. So in our country, India, we use Carman's cannula because pipil is not easily available. So we use Carman's cannula to do endometrial sampling or endometrial biopsy. Lactating female comes to you with the complaints of constant dribbling of urine. Okay, she gave a history of difficult and prolonged labor. That means it is somewhere obstructed labor, and obstructed labor leads to vesicovaginal fistula. So after there is an obstructed labor or prolonged labor, vesicovaginal fistula, this is because of ischemic necrosis of urinary bladder. There is a formation of fecal fistula, and this causes true incontinence of urine. That is continuous dribbling of urine. And best investigation in this case will be cystoscopy, because you can see site, size and number of fistula. Site, size and number of fistula. So this is vesicovaginal fistula. Okay. Hope this session of OBS-GYN discussion of the grand test question was useful to you.
Ladies and gentlemen, welcome to the test and discussion of grand test in ophthalmology, and leading the discussion will be your friendly neighborhood ophthalmologist, yours truly, Shashwat. Welcome to the discussion. We'll make it short and sweet. So let's see what we have learned. And the first question is a clinical question which should not frighten you. A 35-year-old patient presents to the emergency department with a history of an open globe injury sustained during an accident at work. On examination, the ophthalmologist suspects the presence of a retained intraocular foreign body, that is dangerous, something inside the eye. Which of the following investigations is the most appropriate and reliable for localizing the foreign body? Remember, we have to take out the foreign body from there, so we need to find out where it is. So should I use a CT scan or an MRI or ultrasonography or an X-ray? That's an interesting question, and the best answer, region, as I'm sure you have mostly answered, is a CT scan. A CT scan, as you can see here, is the most accurate one. You see, one should never ever use a MRI. Why? Because these can be metal. In fact, most of them are metal. It's usually of a hammer and chisel injury, a metal injury can go. And if you put an MRI to a metal, you know what will happen. It will pull the metallic body out, and that will cause a lot of damage. As the intraocular foreign body moves inside the delicate tissues of the eye, it will damage it further. MRI is absolutely contraindicated in a case of metallic foreign body. B-scan, ultrasonography, X-ray are okay, but they are not very precise because they will not tell you the exact location of the foreign body which we need to extract. So what we do is a CT scan. That's the correct answer, which you can see here, which is the most precise localization of a foreign body. So this is an important MCQ to remember, that whenever you suspect intraocular foreign body inside the eye, we look for a CT scan as the ideal investigation of choice. And I think that most of you got this right. Very well. Next question is, a 2-month-old infant is brought to the pediatrician with signs of poor feeding, jaundice and cataracts in both eyes. On examination, a characteristic oil droplet cataract is observed, and that is your giveaway clue. Oil droplet, as we all know and should know. The most likely diagnosis, diabetes, incorrect. Diabetes, you know, has snowflake cataracts. Myotonic dystrophy, incorrect. You know, it's Christmas tree cataracts. Galactosemia is correct, because remember, that is oil droplet cataracts. And Down syndrome does have cataracts, and often many types of cataracts. Down syndrome is not characterized by one particular type, many different types of cataracts, and in fact, the most common is a blue dot cataract. But this is, you can see, a oil droplet cataract. This is galactosemia. Okay, mental retardation, poor feeding, jaundice, all are signs of a poor child born with galactosemia. During cataract surgery, the patient presents with a poor red reflex, making it challenging to visualize the anti-lens capsule for creating a capsular excess. which agent would be the most appropriate for staining the anterior lens capsule in this situation? That's an interesting and a very good question. Remember that when we want to capsulorhexis, remember capsulorhexis is to cut the anterior capsule so that we can take out the cataract and implant the intraocular lens in the capsular bag. So we have to remove a part of the capsule, anterior capsule, which is called anterior capsulotomy, and the best way is to do capsulorhexis. But you see, this we can do only when you have an immature cataract or an early cataract, because the red glow that is coming out from beneath that helps us make a create a rhexis, is it not? So suppose it's a mature cataract, then it's white in color, and then there's no red glow coming from the fundus to help us in creating a rhexis. And then we use a dye to stain the anterior capsule to make it visible for us. And what is this dye? Let's look at the choice: fluorescein sodium, methylene blue, rose bengal, and trypan blue. And the answer is trypan blue. This is an interesting and important question, a new question possibly for many of the FMG friends that are sitting here. Let's look at that. Look at that. What I mean is, if you see, this is the red glow of the coming from the fundal red glow of the choroid, okay? And against this, you can see create a rhexis like this. So you create a rhexis like this. No, this is a normal immature cataract. But you see, what happens in a mature, you see a mature cataract is white in color and it is completely blocking the red glow, so making it impossible for us to see the capsule, is it not? So we have to stain this. Can you see this bluish thing? This bluish thing is the trypan blue that we've injected into the anterior capsule. This stains the capsule, so makes it more visible, and you can see that now, since it is visible, now we can create the rhexis. That is why the answer for the stain is the trypan blue stain. Very interesting question and a new question for FMGs. Very well. A patient presented with anti-uveitis in OPD, which of the following can associate with this condition? That should be an easy one. The choices are of HLA, B complexes, human leukocytic antigen. B8 is incorrect. B8 is often seen in Graves' disease. HLA B27 is the correct answer because this is most commonly associated with anti-uveitis. HLA DR3 often is associated with diabetic retinopathy. Remember DR, memorize it, diabetic retinopathy. And HLA A3 often seen with myasthenia gravis. The answer here is HLA B27, which should be an easy one for you because you remember acute anti-uveitis associated with HLA B27. The most common are causes of HLA B27 leading are ankylosing spondylitis. Remember? So you will find whenever you have a HLA B27 positive uveitis, we have to investigate him mostly for HLA, for ankylosing spondylitis and Reiter syndrome or reactive arthritis. Interestingly, both of them are often found in young males. Please remember HLA B27, and I dare say all of you have got this correct. Very well. Which test is being demonstrated here? And you can clearly see that this strip that is placed in the inferior fornix is got these markings on it, which is measuring the tear flow, and the Schirmer's test, as you see, is the correct answer. There is no need even to look at the other tear film breakup test, rose bengal staining, tear osmolarity test. The answer is obviously a Schirmer's test, which many of you know. When we're trying to measure the amount of tears produced in the eyes, this is the Schirmer's test. And I will, for comparison, this is the rose bengal test you see here. You can see the rose bengal test. And the way it is stained, the dye has stained the conjunctiva red, and this tells you of conjunctival dryness. Okay, remember, rose bengal and lissamine green are the two stains which test for conjunctival dryness. But if you want to suspect that there is a corneal dryness, then we use a fluorescein stain. A fluorescein stain which we have not used in this choice. The answer here was the Schirmer's test. A 42-year male presented with complaints of severe pain and swelling his left eye, as you can see here, and mild fever for the last 2 days. On examination, the following image is noted. Identify the pathology: A. orbital cellulitis, cavernous sinus thrombosis, orbital mucormycosis, and STI. And the answer is obviously orbital cellular. You can take a look at this, where you see the inflamed orbit. And remember, cavernous sinus thrombosis would have usually been bilateral, okay, and very, very dangerous and rare. Orbital mucormycosis, you would have got a darkish scar here, which would have given us the clue. STI, it is not, because STI never involves the part of the lower cheek also. So the answer orbital cellular. What is orbital cellular? It is infection of the orbit. Remember, it is the most common infection of the orbit and refers to infection of the soft tissue behind the orbital septum. Is it not? The definition is very clear: soft tissue of the orbit behind the orbital septum. And the most common cause are usually spread infection from paranasal sinusitis. Okay, it could be ethmoid sinus, particularly in children, where the infection enters via the very porous from the ethmoid. It enters through the medial lamina papyracea wall of the orbit, which is porous, paper-like thin wall. So ethmoid sinus is the most common in children. The most common infection is Staph aureus. Okay, caused by Staph aureus, causes proptosis, chemosis, pain with ocular movements, and it is often these children have to be admitted in the hospital and treated with vancomycin. Remember vancomycin, Staph aureus, most of them are MRSA nowadays, methicillin-resistant Staph aureus, so we have treated with vancomycin. So this orbicellus, kindly remember, this happens to be the most common infection of the orbit, also because it occurs more in children. So this also happens to be the commonest cause of proptosis, unilateral proptosis in a child. Remember, that's two different MCQs. This is the commonest cause of any orbital infection. The most common orbital infection is orbicellitis, and it is the commonest cause of unilateral proptosis in a child. Remember, bilateral proptosis is rarely orbicellitis. That will be because of some metastasis coming to the orbit. Okay, so that's an interesting question. A 60-year-old female present with complaints of frequent change of reading glasses and difficulty in dark adaptation. On examination, intraocular pressure was 32 millimeters of mercury, which means glaucoma, is not. Which of the following is incorrect about the optic disc changes in the given pathology? Okay, so you have glaucoma, and what we have to answer is what is the incorrect here. And marked cupping of the optic disc is correct. You know that the cup disc ratio, as it goes above 0.6, the normally should be between 0.3 to 0.6. Anything that is greater than 0.6 cup disc ratio, you have to start suspecting glaucoma. So this is correct. This is seen in glaucoma. Temporal shifting of the retinal vessels is incorrect because there is not temporal but the nasal shifting that is catches glaucoma. So this is the answer, which is incorrect. Thinning of the neural rim is correct because you all know the neural rim thins down, and that is the sign of glaucoma, thinning of the neural rim, and cup disc ratio more than 0.6 I've just mentioned. So you can see there's the nasal shifting. Normally in glaucoma, the blood vessels would shift nasal, as you can see here. Okay, these vessels have shifted to the nasal side. So the question which says that its temporal shifting is incorrect, and that is what we're looking at. The rest of them definitely are seen in glaucoma. Very well. Then which of the following is the most common organism causing bacterial corneal ulcers in India? Remember, sometimes we focus on India-specific questions, and that's exactly what this question is doing. So we know that the worldwide cause of bacterial ulcers is first and foremost Staph aureus or old-fashioned Staph aureus, but in India, it's not Staph aureus, it is Streptococcus pneumoniae. Strep pneumoniae, also called as pneumococcus, also called as Ulcus serpens, is the most common cause in India, and that's the answer. Strep pneumoniae, you can see that, is also called pneumococcal ulcer because it's pneumococcus, also called a hypopion corneal ulcer because Pranav forms a marked amount of hypopion, also called as Ulcus serpens. Okay, this is also called as Ulcus serpens because of the way it moves across the cornea like a snake, like a serpent. That's called very famous. So multiple questions. Okay, so pneumococcal ulcers are also called as Ulcus serpens. They're also called as hypopion corneal ulcers, and they simply happen to be the most common bacterial ulcers in India. There are a lot of questions here, my friends. You really have to dig in deep nowadays. A 50-year-old tailor comes to the IOPD with complaints of difficulty in threading needles, unable to read the small prints on the measurement charts, and headaches while doing the embroideries and sewing. That's a lot of difficulty for a tailor who is always doing his needling and threading. What is the appropriate power of convex glasses to be prescribed to this patient? Remember, this is a question of presbyopia. 50-year-old tailor is presbyopic, is not able to look at this. What is the appropriate power of convex lenses? So if you remember, the range that we have, 0.5 to 1 diopter is incorrect. This we give to a patient who is around 45. 1.5 to 2 diopters is the correct answer. This one is correct answer. Anything between 1.5 to plus 2 is the required correction for a 50-year-old. 2.5 to 3.5 is too high. It's usually above 60. and minus 1.52 and 1 is absolutely incorrect because this refers to myopic correction. Remember, minus means concave lenses. And here we have got convex lenses. So this is a question of presbyopia. Answers 1.5 to 2 diopters. And you can see presbyopia where? And the thing under the glasses you can see clearly. But for a presbyopic patient, the rest of the page is blurred and only where the convex lens has become clear. So this is presbyopia. Very well. The answer here, please remember, we have to remember this particular figure because around 2 diopters is what is approximate correction for a 50-year-old. It, remember, depends upon the age of patient. So this is a presbyopic question and you have to remember approximate 50 years of age, we need around +2. It starts at 40, where it starts with 1, when 45 it becomes 1.5, at 50 it becomes 2, 55 becomes 2.5, at 60 it becomes 3. So that was presbyopia. A 10-year-old boy presented with complaints of severe itching and burning sensation in the eyes, along with photophobia, ropey discharge and heaviness of the eyelids. Which of the following statements about the patient's pathology is false? You can clearly make out from the picture as well as the itching and the burning sensation is that we're talking about the spring catarrh, or also called as VKC, vernal keratoconjunctivitis. It's also known as cold weather conjunctivitis. Incorrect. It is not seen in cold weather, it's seen in warm weather, hot weather. Warm, dusty, it is seen in the typical summer season. It's not. The typical months in India are from April to October, the hottest months of the year. Its type of hypersensitive reaction is correct. It's more common in males and females is also correct. Boys particularly. Cobblestone pattern of the papilla is seen on the conjunctiva is also correct. So what we wanted is incorrect or false. So this A, it's not cold weather, occurs mostly in the hot summers of India from April to October when these kids start itching their eyes. Okay, for 6 months, it's very bad. You can see the VKC or the spring catarrh here, where you can see the flat cobblestones. We call them as giant papillae or papillae. These are called as cobblestone papillae. Identify the pathology given in the image below is entropion, symblepharon, ectropion, and trichiasis. You can see if you notice carefully on the lower eyelid, so the lower eyelid is not flush against the eyeball, okay? It's slightly rolled out. If you look at carefully, the upper eyelid is fine. Upper eyelid is touching the eyeball, but the lower eyelid, as you can see here, this is the lid margin and it is not touching or rolling against the eyeball. It's got what it's got is rolled out in fact. And that's what the answer is. It is ectropion. When it's outward rolling of the lid margin, this is called ectropion, leads to a lot of congestion. As you can see here, redness, watering, a lot of mucus formation. Patient is miserable, occurs to older patients, particularly with horizontal lid laxity. The answer is ectropion, and I think that, my friends, you would have done well to identify this. So you have to look at these pictures a little more carefully. At 72-year-old male with a history of hypertension presented with sudden painless loss of vision. On the fundus examination, a given image is seen, identify the pathology, and if you look at this, remember, this is possibly the most famous finding of ophthalmology, a famous cherry red spot. And the bright red glow of the fovea surrounded by this whitish glow is the cherry red spot. So the answer is CRAO, central artery. I'm not even reading the rest of the choices. This is a standard question and you should not even look at the rest of the choices. CRAO. And that is correct. You can see, if you look at carefully this picture, you will find this is the plaque, this is the occlusion, this is the embolus which is blocking the central artery. This is the famous Hollenhorst plaque, remember. The most common type of plaque which causes CRAO is a cholesterol clot. Okay, this is called Hollenhorst, and this is the cholesterol clot which is often seen directly in patients. About 30% of cases it is visible. Sometimes, mostly it's invisible, but sometimes if you're lucky, you can see the crystalline, shiny block here caused by a cholesterol clot called Hollenhorst plaque. Which of the following is the main cause of blindness in India? The refractive errors, glaucoma, corneal opacities, and cataracts. And the answer is obviously, the answer is cataracts. The most common cause of blindness in India, the commonest cause of blindness in the world is the same. It's an opacification of lens or capsule called a cataract. And you've seen a mature cataract here. There should be no doubt about this. Okay. Which of the following extraocular muscles perform the function of abduction? Abduction, remember, is to move the eyeball away from the center. When you move it towards the center, it's called adduction. But away, it's called abduction. Inferior rectus, incorrect. Inferior rectus poses depression. Medial rectus, adduction close to the center. Superior rectus is elevation. And lateral rectus is abduction. It takes it away. And you can see that in this diagram, the two medial rectors cause adduction, the lateral cause abduction, elevation and depression. Okay, so that's the standard question. There is no doubt about this. What about this? Identify the pathology given in the image below and what is the appropriate managed treatment for the recurrent appearance of the pathology in the patient. So first we have to identify the pathology, and that should not be a problem here. Look at this carefully, my friends. You find this is pterygium. This is an overgrowth of the conjunctiva over the cornea. It's called pterygium. It's called pterygium because of the shape of the pathology looks like the bird's wing, is it not? So let us see that we've diagnosed pterygium, and the next part of the question is because the recurrent appearance, it's again, we know that we excise it, it comes back again and again and again. So almost 70% recurrence rate. So what should we do? What is the surgery which has the least amount of recurrence? Is it a corneal ulcer, topical ulcer? Incorrect. Pterygium's protection from UV light, pterygium is correct, but the protection from UV light is not the answer here. Pingicula, it is not. So answer is D. Pterygium, surgical excision with conjunctival autograft is correct. So what happens is that you can see the pterygium here, and as you can see, my friends, what we've done, we've taken it out, and from the opposite eye of the same patient, we borrow some conjunctiva and put it over. We can stick it with glue as we've done it here. You can see the pterygium is out, and we put the conjunctiva, harvested from the other eye, stuck it with glue or sutured it. This is called as conjunctival autograft because it comes from the other eye of the same patient. It's an autograft, and this has the least rate of recurrence. I'm glad to tell you that when we do this, then the chances of recurring of pterygium becomes the least. Okay, so this is the answer we're looking for you. And with that, ladies and gentlemen, thank you very much. I really should not talk anymore. And this happens to be short and sweet grand test. I hope you've all done well. Thank you very much and all the best.
Alright, hi guys. So let's do the quick discussion of today's GT. A lot of you have done well, but a couple of you have also made a lot of mistakes as well. So let us see what are the mistakes and what are the silly mistakes that you have made during our today's grand test. So the first question that we have got today is, what is the best treatment for acromegaly? Now always remember from the very basic, what is acromegaly? In a patient with acromegaly, actually there is increase in the level of growth hormone. Now, if growth hormone level is already high, you cannot give something that is already going to increase growth hormone. A very simple agent that we have in the case here is micasermine. Do you guys know that micasermine, it is one of the recombinant insulin-like growth factor 1, and they will ultimately increase the growth hormone level. So if we give micasermine, they will worsen the scenario. Micasermine is given in a scenario wherever there is decreased growth hormone, or if you want to increase the growth. So micasermine, many of you have marked micasermine. So this is absolutely a wrong answer here. You cannot use it for the treatment of the acromegaly. Now let us choose between octreotide and lanreotide. See, if growth hormone level is high, you have to use growth hormone antagonist, or you can use somatostatin analog because somatostatin antagonizes the growth hormone, right? So somatostatin analog. So one of the drugs under somatostatin analog that we have is octreotide and lanreotide. These two are somatostatin analog. You have to choose between the both. So we have lanreotide depot. Depot preparations are always longer acting. So we will be preferring more as compared to the oral preparation. Huh? So there are many uses of this somatostatin analog, like octreotide IV route, say we can give in bleeding esophageal varices. We can also use octreotide. We are not denying the fact that we cannot use, but do remember a very important thing. If you have to choose between oral and depot, go ahead with the depot. And so monthly preparation, weekly preparations are available for the lanreotide. Now what is terlipressin, guys? Terlipressin, it is mainly utilized, it's a V1 receptor agonist that will be causing vasoconstriction. So they can also be utilized for the bleeding esophageal varices. So they are utilized mainly in emergency scenario if there is a patient with a bleeding esophageal varices. Alright, so growth hormone antagonist that we have, we can use drugs like your pegvisomant. This is also one of the agents that can be used. Somatostatin analog like octreotide, lanreotide, pasireotide, I have told you. Then we can also use D2 agonist because dopamine also have inhibitory effect on the growth hormone, and agent like your bromocriptine
can also be used, bromocriptine, cabergoline. But the only problem with this class of agent is that they are causing pleuropulmonary fibrosis, pericardial fibrosis. I mean, fibrotic reaction is a very, very common side effect. So I hope all of you guys have got here that if we want to reduce the growth hormone, we have to use either the growth hormone antagonist, or we are going to use somatostatin analog, or we are going to use dopamine receptor agonist, right? So sometimes they don't only mention this acromegaly, they can give you images like this, where the patient will have, short stubby fingers, or there will be, large jaw, large mandible, all this symptom will be given. But if the examiner is going to give you one more option, what is the best or the treatment of choice? So always remember, treatment of choice, I mean, compared to the medication, we are more preferring the transsphenoidal surgery, where you are going to remove the microadenoma, or the tumor that is there in the pituitary, right, which is the very common cause for this growth hormone excess, which is known as your acromegaly. I hope it is making sense to all of you, and other things I have already mentioned to all of you guys. This is bromocriptine, the spelling you need to just correct it, okay? Next question. There's a 58-year-old patient with a history of DVT, is being treated with unfractionated heparin. However, due to accidental overdose of heparin, the patient developed bleeding. Okay, so accidental overdose of heparin can cause bleeding. Now, two questions that is always asked in heparin. One is known as your heparin-induced thrombocytopenia, that is HIT syndrome. Please remember, this is HIT syndrome. And other thing that you know, that overdosage of heparin. Please do not confuse between the both. Overdose of heparin. Now, overdose of heparin will always be causing bleeding. Overdose of heparin will be causing what? Bleeding. But HIT syndrome is not going to present with a bleeding manifestation. It is one of the immunogenic response. It is one of the immunogenic response, which you have discussed in class as well, that how a platelet factor 4 and heparin is going to form antibody, and they will be attacking the platelets on a immunogenic response. And here there will be thrombosis, actually there will be thrombotic event. All right. Do remember one more question, that in HIT syndrome, this HIT syndrome, the management will be something else. We are going to use a direct inhibitor of the thrombin, direct thrombin inhibitor, direct 2A inhibitor, like drugs like your hirudine, lepirudine, Now, why am I discussing this HIT? Because they have already asked heparin. The next question will be most likely about HIT syndrome. Heparin overdose, how will you treat? Protamine sulfate, we all know that. And every student who is preparing for FMGE NEET PG, they know this one. What we are mainly worried that this time there are high chances they will be asking about the HIT syndrome by giving an image. And the difference that you should know, that this is an immunogenic response, and there will be thrombotic event. There will be no bleeding manifestation. Do remember that here there will be bleeding manifestation. And another thing that you should know, hirudine and lepirudine, bivalirudine, and all of them are direct thrombin inhibitor. All right. And if there is overdose of this one, you are going to treat this one with the protamine sulfate, right? Another question that can be framed from this topic only, that heparin mediated bleeding or heparin induced bleeding, protamine sulfate has been given. What kind of antagonistic activity is being shown here? So protamine sulfate, it will chelate the heparin, inactivate and promote its excretion. So do remember this protamine sulfate, it's an example of protamine sulfate that we have, it's an example of chemical antagonist. So two very, very important topic that can be a very potential MCQ in upcoming examination has been discussed here for all of you guys. So correct answer for this one is none other than your protamine sulfate. I mean, it's very, very easy question. None of you have made mistake in this one. Now let us quickly summarize what are the other antidote in hematology, right? So in hematology, we always see about heparin, and for the heparin, we are going to give protamine sulfate. We are going to give what? Drug by the name of protamine sulfate. Warfarin mediated bleeding, or we will be giving vitamin K1. If there is a bleeding manifestation, we can give fresh frozen plasma as well. Apart from that, apixaban, edoxaban, betrixaban, what are they? They are the 10A inhibitor. So if you want to neutralize, these are the antidote on the right side. We will be giving an agent that will be Andexanet alpha. Deliberately I am writing like small and capital just so you can remember. Andexanet alpha, the one that can neutralize 10A. 10A neutralizing drug will be Andexanet alpha. Dabigatran is a directly acting thrombin inhibitor, but this is an oral agent. And the antidote for this one will be your idarucizumab. We have discussed this already. Dabakedaru, idarucizumab, right? So this is a monoclonal antibody. Remember, this dabigatran, it's an oral agent. but idarucizumab is not oral. It's a monoclonal antibody, so they will always and always be injectable. All the monoclonal antibodies are injectable. Streptokinase overdose, we are going to use epsilon aminocaproic acid. What is streptokinase? It's a tissue plasminogen activator. Okay, it's a fibrinolytic agent, epsilon aminocaproic acid, or we can also use tranexamic acid. Tranexamic acid. I have left one space here just to tell you that if there is a patient coming with the HIT syndrome, that is heparin induced thrombocytopenia, there will be a patient presenting with the rashes, there will be rashes, or you can easily see the bleeding under the skin, it will be very much visible, and there will be history of anticoagulant usage. Now always remember, many of the time students are getting confused between purple toe syndrome, that is mediated by warfarin, and heparin induced thrombocytopenia. So do remember, warfarin, always remember that warfarin that we have, it can also cause purple toe syndrome. Purple toe syndrome or warfarin induced skin necrosis. This will always be, W for warfarin, this will always be seen within 5 days. That is one important differentiation you will see. And this immunogenic response that is mediated by heparin, it will be seen after 5-7 days. Okay. So one is within, W is within 5 days, and look at the history. Patient was given an anticoagulant next day or after 2 days, right? Or patient was given an anticoagulant after a week. If it is after a week, it will be none other than HIT syndrome, and we are going to use direct thrombin inhibitor, that is hirudine, lepirudine, bivalirudine, dabigatran, ergatobatran, right? All of them will be the drugs that can be utilized in the direct thrombin inhibitor in the management of the HIT syndrome, right? So I hope all of you guys have got this one. This was a very important question, and this time one question definitely expected. A patient was diagnosed with CLL and is undergoing chemotherapy for it. Which of the following is true regarding the treatment and its target? Now CLL, in pharmacology, we discussed a very simple thing, that for the CLL, we are going to use a regimen by the name of FCR regimen. And what does FCR regimen stand for? FCR regimen stands for fludarabine. Fludarabine. C stand for your cyclophosphamide. Fludarabine, cyclophosphamide. And R stand for your rituximab. Rituximab. Remember in our classes we used to discuss about a young girl Ritu. Now what is cyclophosphamide? A very important question. Cyclophosphamide is one of the alkylating agent that causes DNA cross-linking, abnormal DNA formation. What about fludarabine? Fludarabine, it is one of the purine analogs, right? It is one of the S-phase inhibitor. S-phase inhibitor, or I would say it's one of the purine analog. This is actually considered as a drug of choice in a patient with the CLL. Single drug, if you are going to see, this will be the drug of choice. But again, we always use a regimen, right? So rituximab is one of the agent that will be anti-CD20 monoclonal antibody. It is one of the anti-CD20 monoclonal antibody, right? So this will be your rituximab. Now these are the 3 drugs that is very, very commonly used. Other purine analog can also be utilized. Now let us read the other options, right, that we have. Pentostatin, remember it is also one of the purine analog, that is adenosine deaminase inhibitor. It's one of the ADA inhibitor, adenosine deaminase inhibitor, and they are also going to inhibit the purine formation. They can also be utilized, but preferred one from the same family will be fludarabine, ADA inhibitor. Now fludarabine, is it CD20 inhibitor? Does it target CD20? The answer is no. It is inhibiting the DNA formation, right? That is how fludarabine is working. S-phase inhibitor or DNA synthesis inhibitor. Semiplimab. Do remember, semiplimab is not used in CLL. Semiplimab, where are you going to use, guys? It is utilized mainly in the squamous cell carcinoma of the skin and also squamous cell carcinoma of the lungs. Now the question comes, what is the mechanism of action of semiplimab? Is this correct? Yes. It is one of the immune checkpoint inhibitor. Yes. It is a PD-L1 antagonist, or I would say immune checkpoint inhibitor. That's correct thing. But do remember, it is not used in the treatment of CLL. So question is asking which one is used and what is it a correct match or not? So is it used? No. Is it having a correct match? Yes, but it's not used. So PD-L1 antagonist, semiplimab, but we are not using them in CLL. So what is the correct answer in that case scenario? So we are having the correct answer, that is your rituximab, right? It's one of the anti-CD20 monoclonal antibody. I hope it is making sense to all of you. This is the only one correct match here. All right, next question. Which of the following is true about aspirin? I mean, come on, aspirin, and you can make a mistake. That is not going to be possible. Aspirin, very commonly asked question here. Reversibly inhibit cyclooxygenase, isn't that, guys? It's an irreversible inhibitor of the cyclooxygenase enzyme. right? Irreversible inhibitor, it's a non-selective, it's not a selective COX-1. We do not have a selective COX-1 inhibitor, please remember that. But aspirin showing antiplatelet activity, aspirin showing antiplatelet action by inhibiting COX-1 enzyme. It's a non-selective COX inhibitor. It's not a selective one. It's a non-selective. That means it can even inhibit the cyclooxygenase of the other areas as well, like cyclooxygenase 1 and cyclooxygenase 2, right? It's a non-selective, COX inhibitor. But antiplatelet activity, it is mainly because of COX-1 inhibitor. Please do remember that. Decrease synthesis of thromboxane and prostaglandin. So you see, whenever cyclooxygenase enzyme is going to act on your arachidonic acid, they will be forming what? They will be forming your prostaglandins. They are also going to form multiple other prostaglandins. So remember, thromboxane is also one of the prostaglandin. Prostaglandin like thromboxane A2. And this thromboxane A2 that we have, thromboxane A2 will be formed. This thromboxane A2 that we have, it is going to cause platelet aggregation, vasoconstriction. So does it inhibit, aspirin, does it inhibit the formation of thromboxane A2? Yes. So decrease the synthesis of thromboxane A2? Yes, because once you inhibit cyclooxygenase enzyme, this prostaglandin like thromboxane A2 will not be formed. Treatment of overdose will be N-acetylcysteine. Come on. N-acetylcysteine is the antidote for paracetamol. So if there is overdose of aspirin, what are you going to use? Every student, those who are attending this session, is already aware, overdose of aspirin, we are going to see that this is acidic drug. So we are going to do forced alkaline diuresis. Forced alkaline diuresis using either sodium bicarbonate, or we can even use carbonic anhydrase inhibitor like acetazolamide, right, brinzolamide. Okay, so these are the correct treatment of aspirin overdose. We are not going to use N-acetylcysteine. Remember, N-acetylcysteine, it is mainly used for paracetamol poisoning, or we also say it as acetaminophen overdose. All right, so I hope all of you guys have got this one. Very, very easy question. Next one, a 60-year-old patient with a history of chronic gout was taking probenecid for a few years. Okay, so what is probenecid? Remember, it is one of the uricosuric agent. It is going to promote the excretion of uric acid. All right, he came to the emergency with abdominal pain in the flank. On radiological examination, the uric acid calculi were found in both kidneys. All right, your senior said that the mechanism of action of probenecid is responsible for the patient's presentation. Which of the following is correct? Now you see, uricosuric agent like probenecid, lesinurad, sulfenperazone, all of them are uricosuric agent. They will be acting by inhibiting organic anion transporter, OAT, organic anion transporter. This is the transporter that is present in the PCT, proximal convoluted tubule, which is causing the reabsorption of uric acid. And once you inhibit OAT, the uric acid will not be reabsorbed. So what will happen to the uric acid? They will come into the renal parenchyma, and the uric acid crystal will get precipitated in the kidney, and they can cause formation of this uric acid calculi. I repeat again, please do remember that this uricosuric agent like probenecid, lesinurad, sulfenperazone, they are acting at the level of PCT, proximal convoluted tubule, by inhibiting organic anion transporter through this only, right? So let us say that if this is the proximal convoluted tubule that we have, so uric acid is getting reabsorbed through a transporter here by the name of OAT, organic anion transporter. Our drug is going to inhibit this organic anion transporter. So which is the drug that is going to inhibit this organic anion transporter? That will be your probenecid. Probenecid, there are others, lesinurad, sulfenperazone, benzbromarone, they are also going to inhibit. Now when the uric acid will not get reabsorbed, then what will happen to the uric acid? They will be coming down and they will be precipitated in the renal parenchyma, and that can cause precipitation of the uric acid, right? Crystal, it is a recombinant uricase. No, it's not a recombinant uricase. What are the recombinant uricase? So the recombinant uricase are RAS buricase, and pegloticase. All right. It is a competitive inhibitor of xanthine oxidase. Xanthine oxidase inhibitor, guys, everyone is aware, it's allopurinol, febuxostat, that is your xanthine oxidase inhibitor. It inhibits the reabsorption of uric acid in PCT. I have been telling you repeatedly, yes, it's an inhibitor of uric acid absorption in the PCT. That's correct. Not at the DCT, at the PCT. So very simple question, right? Another question in gout that they very frequently ask is, what are the drugs that are used in acute gout and what are the drugs that they are going to use in the chronic gout? So two questions in the gout. In the acute scenario, what are your drugs? In the chronic scenario, what are your drugs? In the acute scenario, definitely we are going to use any of the NSAIDs like indomethacin, but examiner also asked in 2016 and 17 that which one will you not use. So all the NSAID can be used except aspirin because they are going to increase the level of uric acid. Then if it is non-responsive, then we can use NR is non-responsive, we can use steroids. If it is still non-responsive, then we can even add a much better anti-inflammatory drug, colchicine. I am using the term much better anti-inflammatory drug. Still I am using as a after steroid because of its side effect. They can cause bone marrow suppression. GI related side effect is very, very common. And that is nausea, vomiting, diarrhea, abdominal pain. GI distress is very, very common side effect. And in a chronic gout, we can use xanthine oxidase inhibitor, drugs like your allopurinol, febuxostat. Then we can also use uricosuric agent. This is a very quick summary actually, uricosuric agent, because most of the question you have seen it already, most of the explanation you have seen it already. So we have drugs like your probenecid, we have drugs like your lesinurad, we have drugs like your benzbromarone, right? Benzbromarone, lesinurad. Then we are also having recombinant uricase, which I have already given you the data in the previous slide, P-glotticase, RAS uricase, P-glotticase, and we also have RAS uricase. All right. Probenecid, lesinurad, benzbromarone, sulfenpyrazone. There is one more here, sulfenpyrazone. All right. So these are the uricosuric agent. All right. So again, what is used in acute, what is in chronic, that is one question, and what are the important mechanism of action, that is another question. I have told you already that this recombinant uricase, it is rapidly going to decrease the uric acid level, and they are the fastest one, that they can cause fastest reduction in uric acid level, especially in patient with the tumor lysis syndrome. This has been another question in FMG itself, FMG 2021, which one is going to reduce the uric acid level rapidly. So that will be your recombinant uricase. So I hope all of you guys have got this one. Let's see the next one. Which of the following drug is used in Parkinson therapy which prevents the dopamine breakdown? Always remember guys that whenever dopamine is released from the presynaptic neuron, right, this dopamine, whatever dopamine is released from the presynaptic neuron, the dopamine will actually be metabolized or broken down by certain enzymes. Like in periphery, they are having multiple enzymes, and one of which very common one is COMT, catechol orthomethyltransferase. Dopamine, when it's reuptaken, inside we are having one more enzyme that is known as your monoamine oxidase, MAO-B. This MAO-B, it is also going to cause breakdown of this dopamine, because this dopamine, whatever that is reuptaken, they will again be recycled back to the dopamine, right? And see, in a patient with Parkinson disease, which drug is going to be utilized that prevents the dopamine breakdown? So preventing dopamine breakdown will be two class of drug. It will be COMT, because COMT inhibitor, you can inhibit this. We are having drugs like your entacapone, opicapone. Opicapone is the newer one. Capone wale drug hai ye. Entacapone, opicapone, tolcapone. Tolcapone we are not using because of high hepatotoxicity, right? But these are the COMT inhibitor. Now, if you inhibit monoamine oxidase B, again the dopamine breakdown will be inhibited, and dopamine breakdown inhibitor in this MAO-B inhibitor will be selegiline, rasagiline, and we have one more, safinamide, the newer one. Safinamide is mainly used for the off phase of on-off phenomena. So as your COMT inhibitor, they are also preferred in off phase of on-off phenomena. So that is another very, very important question. On-off treatment ke liye we prefer always and always COMT inhibitors. Safinamide is also one of the MAO-B inhibitor that is preferred for the same. And you can remember MAO-B inhibitor, I used to say in the class, MAO-B sounds like mera beta shera jaisa. COMT capone wale drug. COMT capone wale drug, right? Now let us quickly see the option. Pramipexole, ropinirole. These are the dopamine receptor agonists. What is pramipexole, ropinirole? They are the dopamine receptor agonists. They are the non-ergot dopamine receptor agonist. Levodopa, again, it's a pro drug of dopamine. It is not the inhibitor of the dopamine breakdown. Amantadine, it promotes the dopamine release. It is one of the NMDA blocker. Promote the dopamine release, inhibit the reuptake. It has multiple mechanisms of action, but none of them is fully proved. Okay. Rasagiline. So as I told you, the one that is going to inhibit the breakdown will be two class of drug. Either it will be MAO-B inhibitor or it will be COMT inhibitor. So here we are having Mira beta Shira Jaisa Rasagiline. Okay. So Rasagiline is the correct answer. It's one of the MAO-B inhibitor. I hope all of you guys have got this one. Let's see the next one. A patient undergoing cholecystectomy was given isoflurane and succinylcholine for anesthesia and muscle paralysis. So what is succinylcholine? It is one of the depolarizing muscle relaxant, and isoflurane inhalational anesthetic agent. He developed life-threatening condition with severe muscle contraction. Okay, so whenever you see muscle contraction, hyperthermia, or there can be other findings also, increase in the creatine kinase, myoglobinuria, all these features will always be suggestive of malignant hyperthermia. So actually examiner is trying to ask you something about malignant hyperthermia. Okay, malignant hyperthermia. Now let us read. Susceptibility is often inherited as autosomal recessive. Please remember, it is an autosomal dominant condition, not a recessive pattern. The inheritance pattern is dominant. I think we already got our answer here, which is not true. So not true is this one. Now let us read other option. Increased calcium release from the sarcoplasm. Yes, right, there will be mutation in R/R, and that is causing massive release in calcium, and that is the cause of prolonged muscle contraction, myoglobin, increase in the creatine kinase. Treatment with dantrolene. Yes, so drug of choice for malignant hyperthermia, it is going to be drug of choice for the treatment of malignant hyperthermia is none other than dantrolene. Okay, now isoflurane is, and all the other fluorine, they can cause malignant hyperthermia. What else can cause? Maximum risk among all the drugs in pharmacology that can cause malignant hyperthermia is going to be succinylcholine, is one of the depolarizing muscle relaxant. So see, maximum risk is associated with the succinylcholine. Inhalational agent, all the fluorine agents, they can cause. Halothane can cause malignant hyperthermia. Isoflurane, enflurane, sevoflurane, they all can cause. Ether is also one of the agents that can cause. Local anesthetic agent that can cause, that will be lidocaine. Local anesthetic agent that can cause will be lidocaine. Now, if you want to use local anesthetic agent in a malignant hyperthermia, you can use prilocaine. So local anesthetic that is preferred in malignant hyperthermia is prilocaine, not the lidocaine. Okay. Now next question is, what is the treatment of malignant hyperthermia? That is dantrolene is the treatment of malignant hyperthermia. It's the drug of choice. I hope all of you guys have got this one. So this is also one of the question. Which inhalational agent? So halothane, all the other fluorines, ether. Local anesthetic agent like lidocaine can also cause malignant hyperthermia. It's the autosomal dominant pattern of inheritance, not the recessive one. Okay, next question. Which of the following drug is expected to have highest volume of distribution? Now, simple meaning of volume distribution is, if the drug is highly lipid soluble, they will have high volume of distribution, as simple as that. If the drug is having lesser plasma protein binding, they will have high volume of distribution. Okay. Now, hydrophilic drug primarily bound to plasma protein. See, if the plasma protein binding is high, it will not have high volume distribution. A lipophilic drug that extensively bind to tissue. Lipophilic drug, yes, it should be lipid soluble. And whenever they say high volume distribution, high VD means, high volume distribution means the drug has actually gone to the tissues, as simple as that. A drug with high molecular weight and low lipid solubility. See, high molecular weight again will have lesser volume distribution, and low lipid solubility again will have lesser, as simple as that. It should be high volume distribution, should have smaller molecule, high lipid soluble, lesser plasma protein binding. A drug that undergoes extensive metabolism by hepatic enzymes. If it is rapidly metabolizing, again it will not be having high volume distribution. Now this is one question here examiner is asking, but which one is expected to have? So a lipophilic drug that is extensively bind to tissues, right? So that is only having a high volume distribution. Examiner is not going to ask you that. Volume distribution का formula is equal to amount of drug that has been given, or drug dose that has been given divided by the plasma concentration. This is one thing. This is the formula हो गया. What is the clinical implication of this volume distribution? If the volume distribution is high, what is the clinical implication? This is the question that is expected. So the clinical implication is that if the volume of distribution is high, do remember the T half-life of such drug will also be high. So T half-life is directly proportional to volume of distribution. because the drug is mainly in the tissue. From tissue they will be slowly coming to the circulation. Next question is that if the volume of distribution is high and overdosage of such drug is treated with antidotes. Overdosage will be treated with antidotes. Why? Because they are in tissue. You need an agent that will go and chelate, right? Do remember the question here is what is not effective? So hemodialysis is not effective. If there is overdosage, hemodialysis is ineffective. All right. Clinical implication is very, very important. For you to remember if the volume distribution is high or if the volume distribution is low. Volume distribution high means the drug has mostly gone to the tissues. Okay. Third clinical implication is that if the volume of distribution is high, in emergency scenario, you always need a loading dose in order to, loading dose is required in order to acquire or in order to reach the therapeutic plasma concentration level. We will be needing a high dose. We call it as a loading dose. Loading dose will be always and always required. So how will you calculate loading dose? It's as simple as that. Volume of distribution, same formula will be utilized for calculation. So loading dose is equal to, the dose that should be given initially to achieve the therapeutic plasma concentration is equal to volume of distribution into plasma concentration. So this is another formula that we have for loading dose. All right. So these three important clinical implication will definitely be asked in any form. It can be in any form. Okay. Next one. Which of the following is a selective estrogen receptor modulator? Easiest question of this paper. Selective estrogen receptor modulator, tamoxifen. Then we are having raloxifene. So tamoxifen, it is considered as the drug of choice in a patient with the ER/PR positive breast cancer. Or in the receptor positive breast cancer, we are using selective estrogen receptor modulator as the drug of choice. The only problem with this class of drug is that they increase the risk of endometrial carcinoma. They increase the risk of endometrial carcinoma because of excessive endometrial proliferation. They increase the risk of endometrial carcinoma. Now, what is galcanezumab? Right? Galcanezumab kya hota hai? Look at the monoclonal antibody name. The name itself having neuron, Ne. All the monoclonal antibody with Ne or Neu or Nu, they will the simple meaning is neuron. Remember like this. So they will be utilizing some CNS conditions. So this galcanezumab, it is one of the CGRP antagonists that is utilized for the prophylaxis of migraine. Anastrozole, letrozole, they are the aromatase inhibitor, not SERM. They are not SERMs, aromatase inhibitor. Trastuzumab, pertuzumab, they are utilized in HER2/neu positive breast cancer. HER2/neu positive breast cancer, we are going to utilize them. Okay. So selective estrogen receptor modulator are going to be tamoxifen, not the trastuzumab or any other option. Okay. Next, a 24-year-old woman came to OPD with complaints of flushing, headache, nausea, vomiting since yesterday. 7 days ago, she had a trip to village and contracted diarrhea. Okay, so she got to a village, she contracted diarrhea. She was given antibiotics 2 days ago. She went to a party yesterday. Okay, so she have consumed antibiotic. Now she is going to a party, and in the party definitely there will be liquor, and definitely she had drank also, of course, 24-year woman. So look at the age. On physical examination, she is tachycardic. Okay, so after diarrhea, if you consume alcohol and the patient is presenting with tachycardia, hypotension, which of the following drug could have led? So diarrhea ke baad you have taken antibiotics. So simple is asking which antibiotic can cause this scenario. So actually the examiner is asking here about a topic known as your disulfiram-like reaction. Disulfiram-like reaction. So we always used to discuss Government Medical College of Madhya Pradesh, Chhattisgarh. So disulfiram-like reaction, question number 1, it is seen due to what? It is seen due to aldehyde dehydrogenase inhibition. Because of this, there will be increase in the level of acetaldehyde, and this acetaldehyde will be a toxic intermediate metabolite causing nausea, vomiting, abdominal pain, flushing, fall in the blood pressure, headache. All the symptoms will be coming, unpleasant feeling. So among all the drugs that we have, metronidazole is the one that is associated with the disulfiram-like reaction, not the other nitazoxanide or diloxanide or paramomycin. So let us quickly also revise what are the drugs that are associated with disulfiram-like reaction. So I used to discuss it that it is Government Medical College. College, maybe we are having 3 colleges, that is cefotetant, cefoperazone, cefomandole. So which cephalosporin is causing disulfiram-like reaction? That has been another question, है ना? So we used to remember like Titan के ऊपर मंडोले है मेरा, टाइटन के ऊपर मंडोले है मेरा, सो ग्रीसोफोलिन एंटी फंगल ड्रग, मेट्रोनिडाजोल एंटी एमिबिक ड्रग है ना, एंड सीफोटिटान, सीफोपेराजोन, सीफोमेंडोल. मोक्सालेक्टाम is a third generation cephalosporin. We are not using it now because of the excessive neurotoxicity, but again in the list it has been given. Procarbazine, an anti-cancer drug, and chlorpropamide, it's a first generation sulfonylurea. It's a first generation sulfonylurea. So they are also associated with the disulfiram-like reaction. So quickly we have seen that what are the drugs that are associated with the disulfiram-like reaction and what is the enzyme inhibitor. Remember, not alcohol dehydrogenase but aldehyde dehydrogenase. Aldehyde dehydrogenase. Disulfiram mein aldehyde dehydrogenase. Please don't make mistake. In the examination, they can give you which enzyme inhibited. So option में there will be alcohol as well. है ना? So aldehyde is the correct answer. And the drug or anti-emetic drug, that will be metronidazole. Next one, a 35-year-old male with a history of asthma present in the emergency department with vomiting, tachycardia, increase in the blood pressure, tremor. All right. Asthma, cardiac scenario, increasing the blood pressure, vomiting. है ना? Upon further inquiry, it was revealed that the patient has been self-medicated with erythromycin for respiratory infection. Guys, easiest question, and expect this kind of question in your next pattern because erythromycin or any other clinical scenario will definitely be there. What is erythromycin? It is one of the very, very potent enzyme inhibitor. Very potent enzyme inhibitor. Examiner is asking which anti-asthmatic drug the patient was most likely taking. Which anti-asthmatic drug the patient was taking. Now, if it is only tachycardia, blood pressure, we can assume, emergency department with vomiting, tachycardia, tremors. Upon it was revealed that he had self-medicating with erythromycin. The patient's symptoms suggest adverse drug reaction. Which anti-asthmatic drug the patient is most likely taking? Salbutamol, ipratropium, theophylline, terbutaline. Now, what is salbutamol? It's a beta-2 agonist. What is terbutaline? It is also a beta-2 agonist. Now, salbutamol and what about ipratropium? Ipratropium, it is one of the M3 antagonist. Now, can salbutamol cause tremor? Can terbutaline cause tremor? Yes, they can cause. Along with enzyme inhibitor, can they also cause a problem? Yes. But if you have to choose between A and D, that is, A and D, that is a beta-2 agonist, and also there is one option left, that is option C. Theophylline is a drug, guys, that is actually following zero order kinetics. It is a drug that follows zero order kinetics. So the rate or risk of toxicity with this drug will be more high. So if you have to choose between AD versus C, you will be choosing here C. Now, I am repeating again. Can salbutamol, terbutaline also present with the tremors? Yes, they will be presenting with the tremor. They can present, but other symptom, right? There will be vomiting, nausea. There can also be other symptom like insomnia. That will be also one of the very common symptom here. And the drugs that is following zero order kinetics is theophylline with them, or any other drug that is following zero order kinetics, the risk of toxicity will be very, very high. And also remember, it is having narrow therapeutic index. So safety margin of theophylline is very narrow compared to salbutamol and terbutaline. Their safety margin is wide. So if you have to choose between A, D, C, you will be choosing C. Now, ipratropium and all, they are M3 antagonists. They are not mainly acting on the heart and not going to present with the symptom that has been included, especially the blood pressure and all. Okay. So correct answer will be theophylline. Two reasons: it's following zero order kinetics, it's a narrow therapeutic index, and the safety margin is very, very narrow. So we will be choosing ahead with the theophylline. Next one, topical application of 400 mg of mitomycin C, it is used for. Now, 2-3 questions that has been asked. One is, what is mitomycin C? Mitomycin C, remember guys, it is one of the topoisomerase inhibitor. Not only that, it is also going to inhibit the S phase inhibitor. These are the mainly anti-cancer activities. Plus, it also inhibit the fibroblastic proliferation. And because of that, they will inhibit the scar formation. They will not let the scar formation, and that is why they are utilized mainly in multiple stenosis, pterygium surgery, and also after myringotomy. So they are having multiple uses. I'll give you entire summarized uses of this topical mitomycin C. correct answer here is subglottic stenosis. Subglottic stenosis. Tympanoplasty में नहीं, myringotomy yes we use, not in rhinocerebral mucormycosis or nasopharyngeal bleeding. In this one we are not using. Topical use will be subglottic stenosis. In fact, any stenosis you can use. Esophageal stenosis, tracheal stenosis, glottic stenosis, subglottal stenosis, and in any other stenosis also you can utilize. Then a quick summary about mitomycin C. As I told you that they are topoisomerase 1 inhibitor, S-phase inhibitor, that is inhibiting the DNA synthesis. They also inhibit the fibroblastic proliferation, and therefore they inhibit the scar tissue. So they are anti-proliferative agent actually. So anti-cancer uses topically. Remember, anal cancer, topical laryngeal cancer we are going to use, and they are also utilizing nasopharyngeal carcinoma, right? Plus they are having multiple use in ENT because here it's a topic of ENT. So let us quickly summarize. As I told you, any stenosis like subglottic, tracheal, esophageal, hypopharyngeal, choanal atresia, and also to keep the myringotomy opening patent after otitis media with effusion. There will be a patient with OMEs, otitis media with effusion. So in that case, if you are going to do myringotomy and if you think that okay, there might be fibrotic tissue formation and it will heal by itself, you can apply this myringotomy. It will not allow, it will keep the myringotomy opening patent. So in all this scenario we can use, and in ophthalmology also for the same reason we can use them in pterygium, refractive surgery, allergic conjunctivitis, dacrocystorhinostomy, DCR, and squint surgeries as well. These are just few uses out of the many important uses has been summarized here. Because of its fibroblastic proliferation, we are using them in multiple ENT and ophthalmology surgery, and also we are using them because of their anti-cancer property, topically anal cancer and laryngeal cancer. We can also use them in nasopharyngeal carcinoma. Alright, let us see one last question. A patient was taking beta blocker therapy for the treatment of hypertension. He was also prescribed verapamil. So beta blocker, verapamil, guys, it's always a very deadly combo. We should not be using this one. Always remember, they can increase the risk of heart block. On the ECG, there will be increase in the PR interval, right? These two actually are always and always contraindicated. Which two? Beta blocker plus calcium channel blocker like verapamil, diltiazem, not the DHP. DHP can be used. CCB like verapamil and all, it is always going to be contraindicated. These two combinations are contraindicated together. Okay, so and again, of course, PR interval high, decrease in the heart rate, or I would say bradycardia, all this problem will definitely be there. So bradyarrhythmia is something that you are going to see here with this class of drug. And another question that has been asked, that with the dihydropyridines and non-DHP, what is the one common side effect? So a common side effect with both of them, it is going to be your constipation. So this was also asked in one of the recent examination. Common side effect, constipation. And when you use beta blocker with the verapamil, that is one of the non-DHP, they will increase the risk of heart block, and therefore their usage together is always going to be contraindicated. Okay, so this was the last question in pharmacology. I hope you guys have enjoyed this session, and I hope that you realize where is the mistake actually going on. Learn from the mistake and try not to repeat the same. I'll see you guys in the next class. Thank you very much.
Hi friends, so today we'll discuss up these microbiology questions, and I hope you find them easy, and in fact I suppose they are easy only. And the first one to come here is this one. A person consumed fast food, that is a Chinese fried rice, a few hours ago. They have not mentioned how many hours, but okay, few hours ago, presented with the symptoms of food poisoning, which the following associates with the presentation which is being like having this food poisoning stuff. So answer to this question straightforward is Bacillus cereus, and you already know that the Bacillus cereus variety, which is the emetic type, okay, which is the emetic type, associates with what? Associates with food poisoning. And to be more precise, the incubation period is around 1 to 6 hours. And the same incubation period, if you can tell, that is the Staph aureus. Okay, Staphylococcus aureus is also having the same incubation period of 1 to 6 hours, and this is also having 1 to 6 hours. So in that they mimic each other. And this emetic type is having this incubation period, where the diarrheal type of it is having 8 to 16 hours incubation period. Okay. So whenever you see Chinese fried rice in the question, immediately your mind should go towards what? Bacillus cereus. And that to which type? Hematic type. Incubation period is around how many? 1 to 6 hours. And it is being done by the heat stable toxin. Okay. This is a heat stable toxin. So you might be getting in the question one more hint that this is a reheated Chinese fried rice. Okay. That particular vendor is having them again and again, heating them. So once it is formed up, then it does not go anywhere because it is heat stable. Okay. So answer to our question is Bacillus cereus. Let's come to the next one. The diagnosis of typhoid fever in 3 days is best made by. So guys, you know typhoid fever is done by Salmonella typhi. This is one of the common fevers which we have. It is having a step ladder pattern. The rose spots are observed in it. And important question is that it is having which type of ulcers? It is having a longitudinal ulcers. Okay. Now talking about the lab diagnosis of it. In the lab diagnosis, you have this mnemonic BASU. Okay. Important to know is that in the first week, you have to go for blood culture. Okay. In the second week, you have to go for agglutination. And agglutination is actually what, guys? It is the Vidal test. Then you have the stool culture. And then you have the urine culture. And of course, we have here urine ELISA also. Okay. But important to know is that this side, it is not the days. It is the week. The first week, second week, third week, fourth week. Most of the students remain confused up that this side the days are written. And it was a like previous question FMG only, and they have marked up the answer as stool culture. But guys, they have asked 3 days, and 3 days comes in the first week itself. The best to go for what is blood culture. But if you get up this option, then this would have been a better answer, bone marrow culture. Overall also, if somebody asks you now, overall, irrespective of any week, there also the answer is what? Blood culture. Okay. So answer safely you can mark up what? Blood. Now coming to this, a 50-year-old man presents to the emergency room with a history of chronic cough for approximately 2 months, bloody sputum, weight loss of approximately 10 kilograms, and had drenching night sweats for the past month. X-ray shows a cavitary lesion in the left upper lung lobe. Sputum is sent for the staining of this fellow and culture you have done. And in the staining, what you observed, a slender beaded acid-fast bacilli, while the culture report is awaited because culture takes time, which are the most likely organism responsible for this condition. As you can see in the picture itself, this is Zn stain. Okay, this is Zn staining actually. And how you identify it? Identify with the help of background. The background is blue, and against this blue background, you can see these pinkish to reddish color acid-fast bacilli. Okay, so as the history also is suggesting of that there is a chronic cough, approximately 2 months. Okay, bloody sputum is coming off, weight loss history is there, drenching night sweats are there, and there is a cavitary lesions, which is post-primary TB feature. We are talking about what? Tuberculosis. Okay, and we already know that TB is done by what? Mycobacterium tuberculosis, and it is how much percent acid fast? 20% acid fast. Okay, it is 20% acid fast. So obviously the answer of ours is what? Mycobacterium tuberculosis. Okay, the child presents with the infective skin lesions of the leg. A pus culture was done which shows gram-positive cocci. Gram-positive cocci in chains. What is the meaning of in chains? In chains means we are talking about streptococcus. So this is very clear. If we are talking about the chains, which organism we are talking about? We are talking about the streptococcus, which was showing up beta hemolytic colonies. So that means we are talking about either the pyogenes or some other fellows which are there in this streptococcus beta hemolytic family. And on the sheep blood agar, it was showing this beta hemolysis. The test to confirm the organism is it bile solubility? Is it optogen sensitivity? Is it bacitracin sensitivity? Or is it catalase positivity? So one thing is for sure that it is not catalase positivity because they are catalase negative. Okay, optogen sensitivity, bile solubility you do mostly for the alpha hemolytic fellows, and here The remaining one is what? Bacitracin. So bacitracin sensitivity is done to diagnose up this particular thing. In fact, this bacitracin testing, which is done on blood agar, is found to be sensitive for Streptococcus pyogenes, and the bacitracin resistant is Streptococcus agalactia. Okay, so this you need to remember. This you need to remember, that you have done this antibiotic testing and it is done on what? Blood agar. Sensitive is pyogenes, resistant is agalactia. Okay, and all others you also know. CAM test is positive in the agalactia, it is negative in the pyogenes, and there is a hippurate hydrolysis test which is again positive in the agalactia and negative in the case of pyogenes. Now, the Clostridium perfringens. The Clostridium perfringens, which one? It is Clostridium vulci. It produces a lethal exotoxin because there is a gram-positive bacteria. Obviously, they will secrete what? Exotoxin, and this is responsible for what? Gas gangrene. You know that, gas gangrene. And the toxin which is responsible here is lecithinase. Okay. This particular one, which is termed as alpha lecithinase, this is the one which is responsible for these detrimental effects in the case of gas gangrene. Okay. Also known as phospholipase C. It is also termed as what? Phospholipase C. Fine. So, and if you know then that reaction, Nagler's reaction. So, Nagler's reaction is also based upon this particular alpha lecithinase action. Okay. You must be remembering now that mnemonic senior NTR, which we have done for this particular Clostridium perfringens, in which this S stands for stormy fermentation, N stands for Nagler's reaction, T stands for target hemolysis, and R stands for reverse CAMP test. Okay. Super antigen, you know, super antigen, there are a number of them, and important ones are staph and strepto. ADP ribosylation you do of what? Of the conjugated diphtheria, diphtheria toxin. Other than that, diphtheria one, what else ADP ribosylate? That is the cholera one. Okay, and protease is also one of the important essential factor which is there in various organisms. In fact, various organisms having protease. Which of the following is used for making a typhoid vaccine? Okay, so typhoid vaccine, obviously typhoid done by Salmonella typhi. So we have vaccines for that. Two types of vaccines are there. One is a typhoid conjugate vaccine and one is made from the VI antigen of it. So obviously it is being written off that this is the VI antigen capsule virulence antigen. From this particular stuff we make the vaccine of it, and it is found to be effective, and mostly it is given after 2 years of the age of the child, and these are important ones. So I just now told you. One is Typhi 21A, which is the live oral vaccine. This is the one which is the conjugate one. This is the conjugate vaccine. And the other one is the VI polysaccharide vaccine, which is VIPS. And just now I told you, more than 2 years of age, these particular vaccines are given and they are effective in preventing up the various typhoid epidemics and endemics. Okay. Not so famous up to. A 24-year-old male presents to the emergency department with a fever, headache and neck stiffness. So obviously you know fever, headache, neck stiffness is a feature of meningitis. So lumbar puncture you have done, you see a gram-negative diplococci in the CSF. Further investigation reveals it's a bilateral adrenal insufficiency, means they are talking about that complication, Waterhouse-Friderichsen syndrome. Okay, Waterhouse-Friderichsen syndrome, in which adrenal hemorrhagic necrosis happens. Okay, adrenal hemorrhagic necrosis happen. So obviously, which is the bacteria which is responsible for it? Answer is this: Neisseria meningitidis. This is the one which is also termed as meningococci. And all these features, fever, headache and neck stiffness, they are there in most of the meningitis. What is special here? Special here is rash. Okay, rash is a characteristic point which is found in the meningococcal meningitis, and all other things you already know that which all findings you will find in this. So obviously it's a pyogenic meningitis, so neutrophils will be increasing off in the CSF examination. You will be finding neutrophils immensely increased. the proteins they are increased of, okay, proteins are increased of, and sugar is drastically down. The sugar is drastically down in the case of pyogenic meningitis. Now talking about this fellow, a mother brought her child with hypo and hyperpigmented patches or scales on her back. The patches were itchy and the child had no fever. Microscopy reveals the following picture, and following picture you can easily make out this is spaghetti and meatball appearance. This is spaghetti and meatball appearance, means there are noodles like, and within that these particular meatballs, and this is being found when you put up these scales which you get from these patches and you put them into 10% KOH, you find this particular stuff. That is the spaghetti and meatball appearance. And this is typical of which particular organism, guys? Answer is Malassezia furfur. Okay. Another example they can put up here is Malassezia globosa. So obviously Tinea capitis is not the answer. Sporothrix is also not the answer. Coccidiomycosis is also not the answer. So answer of ours is Malassezia furfur, and this is spaghetti and meatball appearance, already asked question of FMG. Now, which of the following is used to detect the capsular antigen of Cryptococcus neoformans? Okay, it's a direct question it is. Which of the following is used to detect the capsular antigen? So obviously, you will not obviously stain it up. You will do this test, that is a latex agglutination test, to find out the capsular antigen. Okay, obviously you must be having what? Capsular antibodies with you, and in that you use up which test? Latex agglutination test. What about the Indian ink? Indian ink is a negative stain, we know, and this particular negative stain which is there, Indian ink, is used to demonstrate the capsule, the capsules of Cryptococcus neoformans. Mucicarmine is also can be used to demonstrate the capsule, but mostly it is for the histopath findings. Okay, it is mostly for the histopath findings which are there in the case of Cryptococcus neoformans infection. Methamin silver stain. Methamin silver stain is not used here. Methamin silver stain is used for Pneumocystis carni. Okay, it is used for Pneumocystis xerovasi or Pneumocystis carni. Is it fine? Now, a 35-year-old presents with a rash and the fever after wandering in a forest area infested with fleas. Remember, fleas is written off. A rash starts centrally, spreads out, sparing the palms and soles. See this particular hint. It spares of what? Palms and soles. Which of the following is the likely organism affecting the patient? So answer to this question, guys, is Rickettsia typhi. And if you know that particular table now, epidemic typhus, endemic typhus, so we have already discussed up there that this is a typical case of endemic typhus, which is also termed as murine typhus, and this is being done by Rickettsia typhi, transmitted by a flea. So this is the importance of knowing up that which arthropod spreads it. So flea is the one which spreads it, and that's why we say that endemic typhus is the disease name, which is done by this fellow, Rickettsia typhi. Coxella burnetii, you know, it does Q fever. It is termed as query fever, spreads by aerosol route. Rickettsia prowazekii, that is epidemic typhus, and this epidemic typhus also presents like endemic, that is there. But the arthropod, guys, you must be knowing up, louse is there in this. And Rickettsia rickettsii is Rocky Mountain spotted fever, and this is a tick-borne disease. Okay, this is a tick-borne disease, and it leads to which particular one? RMSF, Rocky Mountain spotted fever. And what is the drug of choice for most of the rickettsial family? The answer is doxycycline. Okay, answer is what? Doxycycline. Now coming to this, all the following are type 3 hypersensitivity except. So serum sickness is a type 3, yes. Arthur's reaction is a type 3, yes. Good-Pasture syndrome is not a type 3 hypersensitivity. Post-streptococcal glomerulonephritis is also a type 3 hypersensitivity. So answer to our question is, guys, C. It is not a type 3 hypersensitivity. Okay. And if we talk about in a while, so type 1 is anaphylactic. Okay. Type 2 is cytotoxic. Type 3 is immune complex mediated. and type 4 is delayed type. Okay, type 4 is delayed type of hypersensitivity. So you can remember them by a mnemonic acid. So type 1 is anaphylactic, type 2 is cytotoxic, type 3 is immune complex mediated, and type 4 is delayed type. And you already know the examples and all. If I'm just anaphylactic means all those which cause like some sorts of allergies, like asthma is there. Okay, you are allergic to certain spores, certain food. Okay, all this they comes in the anaphylactic one. Cytotoxic one is antigen antibody interaction with the complements is there, and complement does the damage. So what all comes in a type 2 hypersensitivity? All your transfusion reactions, blood transfusion reactions, RH incompatibility, erythroblastosis fetalis, they all come in what? Type 2 hypersensitivity. Along with that, a special type is also there, type 5, in which there is Graves' disease and myasthenia gravis. Okay. Type 3, we have these things like serum sickness, Arthur's reaction, post-streptococcal glomerulonephritis. Okay. Along with that, reactive arthritis. These all are there in the type 3 hypersensitivity. And type 4, we have lepromin test, tuberculin test. All those are there in what? Type 4. Fine. So this particular topic is important. A number of questions can come out of it. A child presents with rectal prolapse. Okay, this word itself should tell you what is the answer. Here a history of loose stools. Examination, the child was found anemic. On stool examination, the egg was identified as shown in the image. So this is a typical egg of what, guys? This is a typical egg of Trichuris trichiura. Okay, Trichuris trichiura. And this Trichuris trichiura is also termed as whipworm. It is also termed as whipworm. These particular things on the sides is termed as mucus plugs. So these are the mucus plugs which are observed in it. And this particular worm, this particular nematode does rectal prolapse in children. And because of this frequent rectal prolapse, their rectum becomes what? Coconut cake like. Okay, and they are found to be anemic, and this particular anemia is iron deficiency anemia. This is iron deficiency anemia which is observed in these particular patients. So answer of our question is what, guys? Trichuris trichiura. Now, which of the following is true for interferon beta? Produced by T cells? No, guys, it's produced by fibroblast. They form granulomas? They do not form granulomas. They help in forming granulomas. But the main fellow which does is interferon gamma, which plays a role in forming the granuloma. Okay, that is the gamma. Used in multiple sclerosis? Yes. It is used in the treatment of multiple sclerosis. It acts as antiviral? No, it does not act as an antiviral. So guys, you already know that we have alpha, beta and gamma. These are the interferons and they are being secreted by these fellows. That is the LFT. Okay. Means the leukocytes, they secrete of interferon alpha. The fibroblast, they secrete of interferon beta. And the T lymphocytes, they secrete of interferon gamma. Okay, so this is the sequence which you should know regarding the interferons. And interferons, they does have a role to play in various conditions. Just now it is being told also. They have this antiviral action. Okay. They are produced by virus against them only. This is the main feature of them. Interferons does have commercial uses also. It is used in treating of this multiple sclerosis. They have this role in forming of granulomas like in TB and all, they have this. And it is produced by T cells. Which one? Just now I told up. The T lymphocytes produce interferon gamma. Okay, so this is regarding the interferons which you should know. With this, we end up this particular one. And I hope you have learned new things with this particular questions. Thank you so much.
Hi, evening friends, evening everybody bache. I am Dr. Sushant Soni, MBBS MAMC, MD Pathology Resident Hemato-Oncology, AIMS Delhi. And let us start with our pathology discussion of Grand Test 2. Now, with respect to pathology, it was a very balanced paper. We had about 15 questions in pathology, and this is the kind of paper that we expect in our exam. So let's quickly have a look at the questions. Starting with our first question. That is a 45-year male patient presented with history of cancer. He undergoes chemotherapy, which is known to induce apoptosis. Which finding will not be observed in apoptosis? You very well know that apoptosis is programmed caspase dependent cell death. It is not associated with inflammation. It can be both physiological and pathological. The main differentiating feature between necrosis and apoptosis is necrosis has inflammation, apoptosis does not. The most characteristic feature of apoptosis is chromatin condensation. It is also associated with cell membrane shrinkage and DNA fragmentation, in turn giving it the classical stepladder pattern on gel electrophoresis. Plain and simple. So the answer was inflammation. Apoptosis does not have inflammation. Next question. Next one, and a very important one. A middle-aged female presented to OPD with joint pain, swelling. There is warmth, redness, and tenderness in joints. Fair enough. Which cytokine is least likely to be implicated? So this is a patient presenting to you with inflammation of the joints. Which cytokine will not be implicated? Interleukin 10. Why? Because it is an anti-inflammatory mediator. देखो बच्चे, interleukin 1 followed by interleukin 6. These are the pyrogens, that is they cause fever. Most potent pyrogen 1 followed by interleukin 6. TNF alpha plays a role in sepsis, that is infection of the whole body. Along with it, it is also an acute cytokine. However, interleukin 10 is anti-inflammatory in nature. There are three main anti-inflammatory mediators: interleukin 10, TGF beta, transforming growth factor beta, and lipoxins. Very important, repeatedly asked. Whereas, which plays a role in chronic inflammation? Let's put a line on the side and write it here only. Which are the chronic cytokines? Chronic cytokines are interleukin 2, 12, and interferon gamma. So we have made three lists of cytokines. Acute cytokines 1, interleukin 1, 6, 8, TNF alpha. Chronic cytokines, interleukin 2, 12, interferon gamma, versus anti-inflammatory, interleukin 10, TGF beta, and lipoxins. Next question. Elderly female came to emergency with bruises, petechiae, multiple site bleeding. She also has an advanced case of stomach cancer. On examination, she has prolonged PT and PTTK. PTTK or APTT are the same thing, with reduced platelets. That is, there is total havoc in the coagulation profile. PT and PTK are increased, platelet count is reduced with reduced fibrinogen. So examiner had given you 4 pointers. First was a known case of malignancy. Second was the coagulation profile with reduced fibrinogen, making this as a case of DIC, disseminated intravascular coagulation, DIC. Next, now this was a tricky question, and what we have analyzed is majority of the students went wrong in this question, which an elderly male, 55-year male presented to OPD with abdominal discomfort, fatigue, and tender splenomegaly. He is a case of pancytopenia. Hemoglobin is reduced, so is platelet count and TLC. He is a case of pancytopenia with increased ALT and AST. Which is the most probable diagnosis? Majority of the students marked it as AML, acute myeloid leukemia. No, to make it as acute leukemia, the TLC needs to be high. Everything was okay with AML. Though it is tough to explain elevated ALT and AST, but I would have still gone with AML provided the TLC was markedly elevated with presence of blasts. That is not the situation here. So AML was out. Of course, SLE is out. SLE is seen in late 20s, early 30s, female predominant. So answer in this case was cirrhosis. It was a case of pancytopenia seen in associated with cirrhosis. Due to sequestration of RBCs and spleen, there is splenomegaly, portal hypertension, leading to abdominal discomfort. There is splenomegaly with elevated AST and ALT. Everything was best fitting in as a case of cirrhosis. Next question. Very, very important. I will not be astonished if you again get a question on myocardial infarction. Previous 2-3 years, every time you have a question on this. Which is the earliest light microscopic change associated viviness of fibers? So let's have a look at pattern of light microscopic changes in MI. The earliest microscopic change is vividness of cardiac fibers. Now the damage is taking place, so it is associated with neutrophilic infiltration and necrosis of cardiac muscle. Damage has occurred. It is associated with tissue repair or wound healing. Which is the first cell of tissue repair? Macrophages. Macrophage activation and phagocytosis, followed by early granulation tissue formation and scarring. This is the pattern of light microscopic changes in MI. Time periods associated. Waviness of cardiac fibers, half an hour to 4 hours. Neutrophilic infiltration and necrosis begins at 4 to 12 hours, but peaks at 1 to 3 days. Macrophage activation and phagocytosis, 3 to 7 days. Early granulation tissue formation, 7 to 10 days. And lastly, scarring, which again begins at 2 weeks, but is completed by 2 months. These are the time period changes of MI, myocardial infarction, an important slide. Next, deposition of PRP. Guys, every FMG exam has one CNS question, and don't ask me why, but I have a very strong predisposition that this time this question is going to be on prion diseases. So I have put this question in your paper. The answer is Creutzfeldt-Jakob disease. There are 4 main prion diseases. The most common prion disease being Creutzfeldt-Jakob or the CJ disease. Others are Gerstmann-Straussler, Schenker syndrome. See, you need not rectify them. The option will be there in front of you. Fetal familial insomnia or Kuru disease. Normally, when the MCQs are asked, they are asked either on CJ, Creutzfeldt-Jakob disease or Kuru disease. Clinically, it is associated with rapid progressive dementia. These are the prion diseases. Next, which translocation is associated with follicular lymphoma? I want you to tell me this. Translocation associated with follicular lymphoma is translocation 1480. Simple. Translocation 1114 mantle cell lymphoma. 1114 mantle cell. Translocation 922, also called as Philadelphia chromosome. Protein formed BCR-ABL, seen in CML. Chronic myeloid leukemia. 922 Philadelphia chromosome BCR-ABL, CML. 1418 follicular, 1114 mantle cell lymphoma. Mantle cell lymphoma has which protein expression? It is BCL1 and cyclin D1 positive versus follicular lymphoma, which is BCL2 positive. Lastly, translocations associated with AML. I'll just write 3 translocations. Best prognostic is translocation 1517. Protein formed PML rara. Seen in M3. Others are translocation 821 and inversion 16, which is sufficient. This slide takes care of all your translocations with blood cancer. Next question, a question on amyloidosis. So this paper actually covers your 15 topics. Diabetic patient with chronic renal failure. How many kidneys do we have? Until we have not purchased an iPhone, we have 2 kidneys. So beta-2 microglobulin. Which protein is associated? A-beta-2 or beta-2 microglobulin. Versus A-beta. We have one brain, Alzheimer's disease. Which thyroid cancer is associated with amyloid deposition? Medullary carcinoma thyroid. Where the protein getting deposited is ACAL. Amyloid calcitonin, ACAL. Primary amyloidosis, the protein getting deposited is AL. Amyloid light chain, AL, which is seen in multiple myeloma, versus secondary or reactive amyloidosis, where the protein is AA. Next question. Now, a good question plus was asked in recent FMG. Middle-aged male presented with scrotal enlargement. LDH was high, SCG-AFP within normal limits. Histopath is also given. I am not interested in the image at all. Whenever you are giving the exam, always mark most common in the FMG paper. Most common testicular tumor, seminoma testis. There were 2 more pointers. HCG and AFP are normal. If it is a case of choriocarcinoma, HCG is markedly elevated. HCG is a tumor marker of choriocarcinoma versus if it is a yolk sac tumor, AFP is elevated. Tumor marker of yolk sac tumor is AFP, alpha fetoprotein. Teratomas don't occur in testes. So most common tumor of the test is seminoma. Answer was B, seminoma. Which contributes to immortality? Telomerase. Telomerase, which is telomeres, they are present at ends of chromosome. All of us have telomeres. They are present at ends of chromosome. With mitosis, telomere length reduces. So mitosis stops. Which enzyme maintains telomere length? Telomerase. Cancers are immortal because of increased telomerase activity. They do not allow shortening of telomeres. They prevent shortening of telomeres. As a result of which they will not get shortened, so the cell keeps on multiplying. Hence the answer was B, increased telomerase activity. Next question. Now, an elderly female presented with eczematous changes in the nipple. She reports that her right nipple has flattened, retracted, and is erythematous with discharge from the affected nipple. There is no pain or breast lump, but there is inflammatory changes. There are inflammatory changes, eczematous changes with itching, which are occurring in her nipple. Microscopy shows the presence of large cells, clear cytoplasm, PAS positive. But this is the classical description of Paget's disease of the breast. This is Paget's disease, and grossly, this is what Paget's disease of the breast looks like. It is eczematous red pruritic lesions seen in nipple areola complex due to infiltration of the epidermis by malignant cells. Paget's disease. Next question. A middle-aged female came with complaints of easy bruising, nosebleeds, and headache. Fair enough. Lab investigations show a markedly high platelet count of 8 lakh. Normal platelet count is 1.5 to 4 lakh. Platelets are markedly elevated. RBC and WBC are normal. Diagnosis. All conditions are of blood cancer only. RBC, WBC normal. So, of course, it's not a case of CML. It is a case of affecting something which only affects the platelets. That is ET, essential thrombocytosis, in which platelet count is more than 4.5 lakh per microliter. I sincerely hope that majority of you were right in this. Do not start thinking of PV. In polycythemia vera, hemoglobin is markedly elevated versus primary myelofibrosis, where the RBC morphology associated is teardrop RBCs. It shows the presence of teardrop RBCs or dacrocytes. What does this mean? Dekho bache, because of extensive fibrosis, when RBCs are coming out of the bone marrow, they become teardrop in shape. Teardrop RBCs or dacrocytes, primary myelofibrosis. So this was a case of ET, platelet count was very high. Next and the last question. A young male presented with intellectual disability, behavior problems, and self-injurious behavior. There is low IQ with macro-orchidism and prominent ears. That is large testes, large ears. Along with the examiner told you it's a trinucleotide repeat disease. So everything is there. Low IQ with macro-orchidism, large testes, large ears, making this as a case of Fragile X syndrome. Which is the most common genetic cause of mental retardation? Downs, followed by Fragile X syndrome. In Fragile X, the patient is mentally retarded. Kam gyan hai. So trinucleotides getting repeated are CGG. Versus if it was a case of Huntington's disease, Huntington's, then the nucleotides would have been CAG. Hunter keeps the animal in cage, CAG. So this was CGG. Done. So with respect to pathology, I am sure that all of you would have performed well. Needless to say, bache, bestest of luck for the paper, and we are in this together. Thank you, and take care.